And there it is.
Oh, yeah.
Right. The clear plastic bag hanging on that metal pole, just sort of slowly dripping liquid into a tube that disappears into someone's arm. It's like practically the universal symbol of modern medicine.
It really is.
And you look at it and you probably think, hydration. The tank is low, so they're just giving the patient some water.
Yeah, which is, I mean, it's the most natural assumption to make, right?
Right.
We all sort of carry this mental model of the human body as like a series of rigid pipes. So if a patient is sick or bleeding, well, the pipes are emptying out.
Exactly.
So you just hook up a bag of water to refill the plumbing. It just feels incredibly straightforward.
It does. But then you actually start digging into the science of those fluid bags, and suddenly that whole simple plumbing analogy just completely falls apart.
Oh, completely.
So welcome to the deep dive. Today, our mission is to unpack the fascinating and honestly highly counterintuitive world of 5V fluids.
Yeah, it's a wild ride.
Because what the sources reveal is that this is so much more complex than just, hydration. We're actually going to explore 3 genuinely surprising realities today for you. First, a fluid bag, clearly labeled isotonic, can actually act as a hypotonic water bomb once it's inside you.
Which is terrifying.
Right. Second, normal saline isn't actually physiologically normal at all. And third, the textbook standard for pediatric IV fluids was quietly harming children for 50 years before the medical community caught on.
Yeah, that one it's a really profound shift in perspective when you realize what is actually happening in that plastic tubing.
So where do we even start?
Well, to understand why those 3 things are true, we need to establish a foundational definition for you. At its core, an IV fluid is a sterile water-based solution infused directly into the bloodstream.
Okay, simple enough.
Right, but the single most important concept here isn't the water itself. It's a property called tonicity.
Tonicity?
Yeah. Tonicity basically describes how that specific fluid forces water to move across human cell membranes.
Okay, I want to spend some time here because, to understand how IV bags work, we really have to visualize this microscopic tug of war. It's happening between the fluid we're pumping into the vein and all the billions of cells lining those veins and making up the surrounding tissues.
Exactly. So there are 3 main classifications of fluids you need to know, and they're all based on this concept of tonicity.
Okay.
And we benchmark this against human blood plasma, which has a very specific, tightly regulated concentration of dissolved particles.
Like salt and stuff.
Yeah, mostly sodium, chloride, glucose, and urea. And that baseline concentration is roughly 275 to 295 milliosmoles per liter.
Okay, so 275 to 295 milliosmoles per liter.
That's the target. So the first type of fluid is isotonic.
Iso meaning same.
Exactly. This fluid has roughly the same effective solute concentration as your blood plasma. When you infuse an isotonic fluid into the bloodstream, the surrounding cells neither gain nor lose water. It creates a state of balance.
Got it.
The second type is hypotonic. This fluid has a lower concentration of solutes than the blood plasma.
Okay, so less stuff, more water.
Right. And because of the laws of physics, water naturally wants to balance things out. So the water actually leaves the bloodstream and forces its way into the more concentrated cells.
Oh, wow.
Yeah, and that causes those cells to physically swell up.
That sounds dangerous.
It can be. And then the third type is hypertonic. This has a higher concentration of particles than plasma.
So super salty or sugary.
Exactly. So in this case, water is violently pulled out of the surrounding cells to dilute the blood, causing those cells to physically shrink.
Okay, so to help you visualize this at home, I was actually thinking about an analogy while I was reading the sources.
Oh, let's hear it.
Okay, so imagine the dissolved solutes, like the salt or the sugar particles. Imagine them as the life of a great party.
Okay, I like this.
And the water. The water is the crowd. And, the crowd always wants to leave the empty, boring room and rush into the room where the party is actually happening.
That's spot on.
So if you inject a hypertonic fluid, you are basically throwing a massive, concentrated party right inside the bloodstream.
Right.
So all the water inside the body's tissue says, hey, let's go out there, and rushes out of the cells to join the party, which shrinks the cells.
That paints a very accurate picture of the mechanism. And, for most of the 20th century, doctors basically operated under the assumption that these properties were simply fixed numbers printed on the bag's label.
Like whatever the label says is what you get.
Exactly. If the label said the party was a certain size, well, that was the end of the story.
Yeah.
But modern physiology makes this really sharp distinction that completely changes how we administer fluids.
Okay.
There is a massive functional difference between osmolarity and tonicity.
Okay, I'm going to need a timeout on this one.
Sure.
Because if the bag is manufactured in this highly controlled, sterile factory, how can the label be wrong? I mean, if it says it has a certain number of particles, aren't particles just particles?
Well, that's the trick. Osmolarity is exactly what you just described. It's the total absolute count of dissolved particles in the bag per liter.
Right.
You measure that in a chemistry lab, and the factory label is 100% accurate about that exact number.
Okay.
But tonicity is the effective osmotic pull that actually drives water movement across a living biological cell membrane.
Oh, I see.
Yeah, and those two concepts are not always synonymous because some particles are sneaky.
Sneaky how?
They can just pass right through a cell membrane without any resistance. Urea and ethanol are like classic examples.
Oh, so they don't trap the water.
Exactly, because they cross freely. They don't force water to move at all. They add to the osmolarity number on the factory label, sure. But inside a human being, they have zero tonicity.
Wow. Which actually brings us directly to that first major revelation from the intro, the D5W paradox.
Yes.
I was reading this section and trying to map it out in my head. So D5W is 5% dextrose in water.
That's right. And if you read the bag, its osmolarity sits perfectly in that 275 to 295 range.
So on paper, it's an isotonic fluid.
Exactly. It looks like it should just sit nicely in the blood vessels and maintain balance.
But dextrose is literally just a form of sugar.
Mm-hmm.
And the cells in our body constantly need sugar for energy. So if we pump this supposedly balanced sugar water into a vein, the patient's cells are going to rapidly consume all that dextrose.
Right.
They basically eat the party.
They devour the salates entirely. And once the body metabolizes all that dextrose, what is left circulating in the patient's veins?
Just plain water.
Plain free water. So a fluid bag that was clearly labeled and manufactured as isotonic actually behaves as a hypotonic solution once it interacts with human metabolism.
That is wild.
It drops the concentration in the blood and sends all that free water rushing into the patient's cells.
Which, okay, knowing that we can manipulate water like this, forcing it in or out of cells by changing the guest list to this cellular party, it raises a major clinical question for me.
What's that?
Why would a clinician ever want to intentionally force a patient's cells to swell or shrink? I mean, shouldn't the goal always be to maintain that perfect isotonic balance?
Well, maintaining balance is absolutely the goal for basic resuscitation.
Right.
Like if someone is rushed to the ER with severe blood loss from a car accident or massive fluid loss from a gastrointestinal infection, their blood pressure is plummeting.
So you just need to refill the pipes.
Exactly.
Yeah.
You need to refill the pipes just to keep the heart pumping and oxygen flowing. Clinicians use isotonic fluids here because they want that fluid to stay inside the blood vessels. You definitely do not want it shifting into the surrounding tissues and causing complications.
But the sources discuss the use of hypertonic fluids, and I had a really hard time wrapping my head around this.
Yeah, it sounds backward.
Right. Under what circumstances would you ever want to intentionally dehydrate and shrink a patient's cells?
The primary application is for cerebral edema, which is severe swelling of the brain.
Oh, wow.
Because the brain is a really unique organ. It's completely encased in a rigid, unforgiving bone box. The skull.
Right. There's no room.
None. If brain cells begin to swell due to a traumatic injury or a stroke or a tumor, they have nowhere to expand.
Yeah.
So the physical pressure inside the skull starts building rapidly.
And if that pressure gets too high, it eventually just crushes the brainstem, right? Which controls breathing and heart rate. It's basically fatal.
It is. So to prevent that, a critical care team will push a highly concentrated hypertonic solution, usually like a very strong saline, into the bloodstream.
Ah.
So following your analogy, they throw an aggressive party inside the blood vessels of the brain.
And the water leaves the brain cells.
Exactly. The water that is dangerously trapped inside the swollen brain tissue is drawn across the blood-brain barrier and into the bloodstream to dilute that massive salt load.
That is incredible.
It physically shrinks the brain cells, a cellular process known as crenation, and it relieves that deadly mechanical pressure inside the skull.
The physics of water being used to literally decompress a brain, that is just wild to think about.
It's elegant, honestly.
So, okay, on the flip side, when do we use hypotonic fluids? Like, when do we intentionally swell cells?
Hypertonic fluids come into play when a patient is suffering from profound intracellular dehydration.
Okay.
A prime clinical example of this is diabetic ketoacidosis, or DKA.
Okay, I've heard of that.
Yeah, in severe DKA, the patient's blood becomes so thick with unmetabolized glucose that the blood itself acts like a hypertonic fluid,
Oh. So the blood is sucking the water out of the body.
violently sucking water out of the patient's own tissues. Their cells are effectively shriveling up.
Wow.
So once the medical team stabilizes the patient's blood sugar and initial volume, they will often introduce a hypotonic fluid to gently push free water back into those parched cells to rehydrate them.
But there has to be a dark side to this, right?
What do you mean?
Well, if you are pushing water into a cell with a hypotonic fluid, isn't there a point where the cell just, I don't know, just can't take it anymore, like overfilling a water balloon?
Oh, absolutely. It is a critical risk factor.
Yeah.
If you administer too much hypotonic fluid or if you push it too fast, you can trigger RBC hemolysis.
Hemolysis, meaning what exactly?
It means the red blood cells circulating in the veins swell up with so much free water that their structural membranes simply cannot hold the tension. Yeah, they rupture and burst open directly in the bloodstream, which is a catastrophic event.
Wow. This requires like a surgical level of chemical precision.
It really does.
Which naturally makes me wonder about the history here. I mean, how did humanity figure out this exact benchmark? The 275 to 295 milliosmoles thing. Like, how did we learn to manufacture these safely?
The origin story in the sources is fascinating because it wasn't just a single scientific breakthrough.
Right.
It was a collision of two vastly different worlds over several decades. On one end of the spectrum, you had the 19th century physicists and physical chemists.
Okay.
Men like Wilhelm Pfeffer and Jacobus Henricus van Hoff.
Right.
And they operated in these pristine, quiet laboratories, meticulously studying plant cells and deriving the fundamental mathematical equations for osmotic pressure.
Doing the math.
Exactly, mapping out the invisible laws of how water behaves.
But calculating osmotic pressure in a quiet lab is worlds away from, keeping a dying human being alive.
That is exactly where the clinicians enter the picture. And their environment was the exact opposite of pristine.
Yeah, I bet.
In the 1830s, Europe was devastated by horrific cholera pandemics.
The Blue Terror.
Right, the Blue Terror.
Yeah.
Cholera causes such violent, relentless diarrhea that patients literally dried out.
Ugh, that's awful.
It is. Their blood would lose so much water, it turned into this dark, thick sludge that the heart could barely even pump.
Wow.
And a Scottish physician named Thomas Latta read theories about injecting water and salts directly into the veins. Driven by just sheer desperation, he began experimenting on dying patients.
So he didn't have all those fancy equations.
He didn't have Van Hoff's equations at all. He was basically just trying to mimic the salty taste of blood.
It was raw trial and error on human physiology.
Entirely. Latta and subsequent pioneers like Sidney Ringer and Alexis Hartman, they would inject various concoctions of boiled water, salt, and eventually sodium lactate, just to see what combinations kept people alive.
Without causing convulsions or that hemolysis we talked about.
Exactly. So over decades, the rigorous, pristine physics of the laboratory finally merged with the messy, desperate clinical survival data from the cholera wards.
And that gave us the formulas.
Yep, eventually yielding the precise 5E formulas we rely on today.
But here is where the narrative takes a really sobering turn, I think.
Yeah.
Because we often think of modern medicine as this steady, unimpeachable march of progress. But the sources highlight a terrifying complacency that eventually set in.
They did.
The medical establishment got comfortable and they got some major things wrong. Which brings us to the holiday cigar failure.
Yeah, this is one of the most sobering case studies in modern pediatric medicine, honestly.
It really is.
In 1957, two well-respected doctors, Holliday and Cigar, developed a formula to calculate the daily maintenance IV fluids required for children who couldn't eat or drink.
Okay.
Their formula was mathematically brilliant for calculating the volume of fluid a child needed based on their weight. But the type of fluid they recommended to fulfill that volume was heavily hypotonic.
Right, because they based their fluid composition on the electrolyte profile of healthy breast milk and cow's milk.
Which sounds logical, right?
It sounds totally logical at first glance.
It sounds logical until you realize that healthy milk is processed slowly by the gastrointestinal tract of a healthy infant.
Oh, right.
It is not injected directly into the systemic circulation of a sick, stressed child lying in a hospital bed.
Yeah, that's a huge difference.
When a child is hospitalized with an illness or undergoing surgery, their body naturally panics. It releases a flood of stress hormones, specifically antidiuretic hormone, which screams at the kidneys to stop producing urine and hold on to every drop of water possible.
So the kid's body is already aggressively hoarding water.
Exactly.
And then the medical team pumps bags of hypotonic fluid, which, as we established earlier, leaves behind a massive load of free water directly into their veins.
The result was severe dilution of the blood. The sodium levels in these children would plummet to dangerously low levels.
Wow.
It's a condition called hospital-acquired hyponatremia.
And if the sodium in the blood drops too low, the blood becomes hypotonic compared to the brain cells.
Yes.
So the water rushes into the brain, causing the exact cerebral edema we talked about earlier.
Exactly. And for over 50 years, the undisputed textbook standard for pediatric maintenance fluids was quietly causing neurological damage, seizures, and in several tragic cases, death.
Just from the routine fluids.
Simply from the routine IV fluids ordered upon admission. It wasn't until 2018 that the American Academy of Pediatrics finally, officially reversed this half-century-old standard.
2018, that was practically yesterday.
I know. They issued strict guidelines that isotonic fluids must be the standard for pediatric maintenance.
50 years of standard practice, it is genuinely unsettling.
It is.
And it underscores just how delicate the body's sodium balance really is. Because the sources point out another complication of fluid mismanagement, and I actually had to read this section twice just to process the severity of it.
Oh, osmotic demyelination syndrome.
Yes.
Yeah, if you zoom out and look at the bigger picture of tonicity, osmotic demyelination syndrome is the devastating consequence of trying to fix a complex problem too quickly.
How so?
Well, if a patient comes into the emergency room with severe chronic hyponatremia, meaning their blood sodium has been dangerously low for days and their brain cells have slowly absorbed water and swollen to adapt to this new environment, a clinician might look at the lab results and think, I need to give them highly concentrated hypertonic saline right now to fix this number.
Right. I mean, the tank is low on salt, so just dump the salt back in.
But if you correct that sodium deficit too rapidly, you radically shift the tonicity in the opposite direction.
Oh.
The hypertonic saline violently sucks the water back out of the adapted brain cells. It shrinks the cells so rapidly and aggressively that it physically tears the myelin sheath.
Which is the insulation, right?
Exactly. It's the protective fatty insulation wrapping around the nerve fibers in the brainstem. You are effectively stripping the insulation off the brain's wiring.
That sounds horrific.
It causes irreversible neurological damage, locked-in syndrome, or even death. It is a permanent reminder that in fluid resuscitation, the velocity of the fluid shift is just as dangerous as the shift itself.
Wow. So with all these historical blind spots and microscopic tightropes that clinicians have to walk, you would think we have it all perfectly mapped out now.
You would think.
But I noticed a huge ongoing conflict in the critical care sources. It seems like a modern group of doctors started demanding massive trials to challenge the fluids we use every single day.
Yeah, the science of critical care fluid therapy is far from settled. If you look at the modern landscape, two massive clinical trials have completely disrupted the status quo.
The SAFE trial and the SMART trial.
Exactly.
Okay, let's tackle the SAFE trial first because this gets into the debate between crystalloids and colloids.
Right.
Everything we've discussed so far, saline, dextrose, these cheap bags of dissolved salts and sugars, those are crystalloids.
Correct.
But the sources define colloids as fluids containing massive molecules like human albumin, which is like a large protein derived from blood plasma. But from what I understand, the argument for using these expensive proteins all comes down to the Starling equation.
Yes, it does.
I want to try explaining this, actually, because it really changed how I view the cardiovascular system.
Oh, go for it.
Okay, so we tend to think of our blood vessels as solid rubber pipes, but the capillaries are actually semi-permeable.
Right.
So they're more like porous soaker hoses in a garden. Water can easily leak out of them to the surrounding tissue, causing severe swelling.
Exactly.
But according to the Starling equation, the giant proteins naturally floating in our blood act like water magnets.
Yes.
They are physically too large to leak out through the pores of the soaker hose, so they stay inside the blood vessel and hold onto the water with a pulling force called oncotic pressure.
That is a phenomenal way to explain oncotic pressure.
Thanks.
And that was the fundamental theory behind using colloids. Clinicians argued that if a patient is critically ill and their blood vessels are leaking, we shouldn't just pump in cheap salt water that will immediately seep right into the tissues.
That makes sense.
They thought we should pump in expensive colloid proteins to act as massive magnets, pulling the water back into the pipes and keeping it there.
Okay.
So the SAFE trial was this massive international effort designed to finally prove that colloids were superior for saving lives in the ICU.
But the results didn't exactly match the theory, did they?
They did not. The SAFE trial demonstrated that, for the vast majority of critically ill patients, resuscitation with cheap, basic crystalloid salt water resulted in the exact same mortality rates as the expensive albumin colloids.
Wow, really?
Yeah. While there are still very specific niche uses for colloids, like in certain liver failure patients, the trial proved that for everyday critical care, the basic physics of salt and water are sufficient.
Which brings us to the SMART trial and our final mind-bending fact from the beginning of the deep dive.
Ah, yes.
The myth of normal saline.
Yes. So 0.9% sodium chloride is universally referred to as normal saline.
Right, you hear it all the time.
It is the most ubiquitous, heavily utilized IV fluid on the planet. But from a purely physiological standpoint, it is incredibly abnormal.
Wait, really?
Yeah. Human blood plasma has a chloride concentration of roughly 100 milliequivalents per liter. Normal saline contains 154 milliequivalents of chloride per liter.
That is over 50% more chloride than the human body is designed to handle.
Exactly. And when a trauma patient or a sepsis patient requires massive volume resuscitation and you pump liters upon liters of normal saline into their veins, that immense unnatural chloride dump wreaks havoc.
I can imagine.
The heavy chloride load constricts the blood vessels inside the kidneys, starving them of oxygen, and it actually induces a state of metabolic acidosis.
Oh, wow.
So the SMART trial was designed to confront this exact blind spot. It compared traditional normal saline against balanced crystalloids.
Balanced meaning what?
Fluids like lactated ringers, which are specifically engineered with buffers to closely mimic the actual electrolyte balance of human blood.
And the results of the SMART trial are actively changing how hospitals operate today, right?
Absolutely. The evidence clearly shows that using balanced fluids instead of normal saline leads to significantly fewer kidney injuries, less need for dialysis, and lower overall mortality in critically ill patients.
That's huge.
We are watching a real-time paradigm shift as modern medicine finally questions the normal saline we've relied on for over a century.
It really emphasizes that no medical intervention, no matter how ubiquitous or seemingly simple, should ever be exempt from rigorous questioning. So let's synthesize everything we've covered today. We have dismantled the plumbing analogy. We've seen that IV fluids are absolutely not just water.
Not at all.
They are highly calculated chemical tools governed by the strict physical laws of tonicity. We explored the D5W paradox, where an isotonic label disguises a hypotonic effect.
Yep.
We talked about the life-saving physics of intentionally shrinking brain cells or swelling dehydrated tissues. And we unpacked the historical tragedies and modern trials, from the 50-year holiday cigar pediatric error to the ongoing movement away from normal saline.
Right.
Which all proves medical science is always, sometimes painfully, evolving.
The main takeaway for you as a listener is that the next time you are in a hospital or you see that clear plastic bag dripping on a medical drama, you're going to look at it with completely new eyes.
Definitely.
It isn't just hydration. It represents a microscopic, calculated manipulation of the physical laws of water inside the human body. Every single drop interacting with millions of cells, governed by equations that took centuries to map out.
I love that. And, I want to leave you with one final thought to mull over. Building on these rules of water movement.
Okay.
We have spent this entire discussion exploring how tonicity and hydrostatic pressure force water to move in a gravity-bound human body.
Right.
But what happens when we leave the planet?
Oh, wow.
Right. In the microgravity of space travel, astronauts lose the normal hydrostatic pressure that pulls blood into their legs. Their bodily fluids naturally shift upward into their chest and head, which is why astronauts often have puffy faces in orbit.
Yeah, I never thought about that.
Yeah, and as we prepare for long-duration missions to Mars, aerospace medicine is having to completely reimagine IV fluid resuscitation.
That is fascinating.
How do you manipulate tonicity, and where does the water decide to go when the fundamental pull of gravity is removed from the equation? It turns out the final frontier medicine might just be relearning how to hydrate a human cell in the stars.
Usually when we think about life-saving daily medications, we picture these incredibly sterile laboratories.
Right, yeah, white coats, beakers, that whole pristine vibe.
Exactly. We expect our medicines to be born from, safety and perfectly controlled environments.
Yeah.
But what if I told you that one of the most widely prescribed foundational classes of cardiovascular drugs in modern history didn't start in a pristine lab?
It really didn't.
What if it started with a deadly toxin that triggers, basically, catastrophic internal collapse?
Yeah.
Okay, let's unpack this, because the origin story of the drug that you, or maybe your grandparents, take every single morning involves a highly venomous snake right in the middle of the Amazon.
It is honestly the ultimate medical paradox. I mean, we took the exact mechanism that a predator uses to kill its prey, and we sort of reverse engineered it to keep millions of human hearts beating.
It's wild. And whether you are a nursing student frantically cramming for your next pharmacology exam, or you're just an insanely curious learner trying to understand modern medicine, this deep dive is absolutely for you.
Yeah, today we are looking at ACE inhibitors.
Right. You probably know them as the prill drugs, like lisinopril, captopril, and elapril. They're universally known as, blood pressure pills.
Which is true, but also a huge understatement.
Totally. Our mission today is to look at the sources and uncover why that label is actually doing the drug a disservice. We're going to explore why this drug is truly a heart remodeling powerhouse and how its most annoying, infamous side effects are directly linked to its superpowers.
Yeah, and to really grasp how these medications alter the architecture of the human body, we basically have to travel back to the Brazilian rainforest in the 1960s.
Okay, set the scene for us.
So researchers specifically, a Brazilian pharmacologist named Sergio Ferreira and a British pharmacologist named John Vane, were studying the venom of the Bothrop siraca.
And that's a deadly pit viper.
Exactly, a pit viper. And they noticed this very specific, immediate physiological effect in people who actually survived the snake bites. The venom caused a sudden, massive, and incredibly dangerous drop in blood pressure.
Like it essentially just bottomed out their cardiovascular system.
Right. And Ferreira isolated specific peptides from this venom. He called them bradykinin potentiating peptides, or BPPs.
BPPs?
Yeah, and he discovered that these peptides worked by blocking an enzyme in the human body that normally degrades a substance called bradykinin.
Right, so the venom stops the degradation, and then bradykinin just builds up. And since bradykinin is a massive vasodilator, meaning it, forces your blood vessels to open wide, the victim's blood pressure just completely plummets.
Which was a profound discovery all on its own. But the real scientific lightning bolt struck when researchers realized that this enzyme, the one that destroys bradykinin, actually has a second, completely different job in the human body.
Wait, really?
Yeah. Kininase II, which is the enzyme the snake venom was blocking, is actually the exact same molecule as angiotensin-converting enzyme, or ACE.
Oh, wow. So it's one enzyme doing two totally different jobs.
Exactly.
It destroys bradykinin, but it creates angiotensin II. And angiotensin II is a potent vasoconstrictor that spikes your blood pressure.
Right. So the snake venom was accidentally turning off the body's pressure-raising system while simultaneously cranking up the pressure-lowering system.
That's amazing. So the pharmaceutical industry sees this dual action mechanism, and I'm guessing immediately knows they need to put it in a pill.
They did, but turning venom into a pill proved immensely difficult. I mean, the first candidate was a compound called tepratide.
Okay. Did it work?
It worked beautifully to lower blood pressure in humans in the early 1970s, but there was a massive catch. It only worked if you gave it intravenously.
Ah, right. Because it was a peptide, if you tried to swallow it as a pill, your stomach acids and digestive enzymes would just chew it up and destroy it instantly.
Exactly. And a daily IV drip isn't exactly a practical solution for someone managing chronic high blood pressure at home.
And nobody wants to drag an IV pole around their living room forever.
Definitely not. So in the late 1970s, two chemists at the pharmaceutical company Squibb Miguel Ondetti and David Cushman took on the challenge of creating an oral version.
And they didn't just guess, right?
No, rather than blindly testing thousands of random chemicals to see what might block this ACE enzyme, they pioneered something revolutionary for the time, which was structure-based rational drug design.
Okay, here's where it gets really interesting for me. You can think of what Ondetti and Cushman did, like high-stakes lock-picking.
I like that analogy, yeah.
Back then, standard drug discovery was often like having a giant bucket of random keys and just jamming them into a lock one by one, hoping one eventually turns. But these two chemists took a totally different approach.
They studied the lock itself.
Exactly. They used a model of a related, well-understood enzyme carboxypeptidase A to map out the internal tumblers of the ACE active site. Once they knew the exact molecular shape of the lock, they custom-forged the precise molecular key to fit inside and jam the mechanism.
And that custom-forged key was a small, orally stable molecule that could actually survive the human digestive tract.
Which became captopril, right?
Yes, gaining FDA approval in 1981. It was an absolute triumph of rational drug design, happening years before the advanced computer modeling we rely on today even existed.
But captopril wasn't totally perfect, was it?
No, it wasn't without its flaws. It contained a specific chemical feature, a sulfhydryl group.
Which is basically just a sulfur-containing part of the molecule, right?
Right. And that sulfur group caused some pretty nasty side effects for some patients, specifically skin rashes and a condition called dysgeusia.
Dysgeusia. That's where you either develop a terrible metallic taste in your mouth or just lose your sense of taste entirely. That sounds awful.
It was. So chemists went back to the drawing board to refine that molecular key, and that effort led to the second-generation ACE inhibitors.
By getting rid of the sulfur group.
Exactly.
Yeah.
By removing the sulfhydryl group, they developed drugs like enalapril in 1985, followed by lisinopril and ramipril. They completely eliminated the metallic taste and the rashes.
And as a bonus, these new versions had much longer half-lives. So instead of taking captopril like 3 times a day, a patient could take lisinopril just once or twice a day.
Much better for patient compliance, yeah. And the generic names all end in pril, which is why they are affectionately called the prils in clinical practice today.
Okay, so now that we understand how they built the perfect molecular key to block this ACE enzyme, we need to look at what this enzyme is actually doing to our blood pressure in the first place.
We have to decode the RAIS cascade.
Right, the renin-angiotensin-aldosterone system. This is essentially the body's master control panel for long-term blood pressure and fluid regulation.
Let's walk through this highly calibrated system step by step because it's crucial.
Let's do it.
Step 1, your kidneys constantly monitor your blood pressure and blood volume. If your pressure drops or if the sodium delivery to the kidneys falls, specialized cells in the kidneys release an enzyme called renin.
Okay, so renin is step 1. Then step 2, that renin enters the bloodstream and acts like a pair of biological scissors.
Right, it finds a protein produced by your liver called angiotensinogen, and it snips a piece off,
creating angiotensin a firth, but at this stage, angiotensin I is completely inactive. It just circulates, waiting for instructions.
Which brings us to step 3, the crucial moment. As that inactive angiotensin I flows through your blood, it reaches the lungs.
And the blood vessels in your lungs are heavily coated with ACE, angiotensin-converting enzyme.
Exactly. ACE grabs that inactive angiotensin I and converts it into the highly active hormone angiotensin II.
And angiotensin II is an absolute quadruple threat.
It really is.
First, it immediately constricts your blood vessels, spiking your blood pressure right now. Second, it signals your adrenal glands to release aldosterone,
which forces your kidneys to hold on to sodium and water, increasing your total blood volume and raising the pressure even more.
Right. Third, it stimulates your brain to make you aggressively thirsty.
And fourth, and this is honestly the most critical point for long-term health, angiotensin II promotes pathological growth and scarring of the heart muscle and blood vessel walls over time.
We call this hypertrophy and fibrosis.
Yeah. So when a patient takes an ACE inhibitor, we block step 3. We stop the production of angiotensin II.
The vessels relax, so pressure drops. The kidneys stop retaining all that extra sodium and water.
Although it is vital to note here, because aldosterone levels drop, your body ends up holding on to potassium instead of excreting it in the urine.
Right, that is why hyperkalemia, dangerously high potassium, is a major monitoring concern for anyone taking a pril drug.
Absolutely. But what's fascinating here is how beautifully this illustrates the one enzyme, two jobs concept we saw with the snake venom.
How so?
By inhibiting ACE, the drug stops the dangerous angiotensin II. But because ACE is the exact same molecule as kinase teeth in it, the drug simultaneously prevents the destruction of bradykinin.
So bradykinin builds up, causing extra vasodilation, which pushes the blood pressure down even further.
Exactly.
Okay, let me push back on this whole concept for a second, though.
Sure, go ahead.
Angiotensin II is a highly conserved, natural evolutionary mechanism. It's a system designed to keep our blood pressure up and keep us alive if we get, say, severely dehydrated or suffer trauma and start bleeding.
That's true.
So aren't we just disabling our body's own critical emergency survival system?
It's a great question. Evolutionarily, yes, the RAAS cascade kept our ancient ancestors alive when they were running from predators or surviving droughts.
Right.
But modern humans live much longer, and we deal with chronic conditions like hypertension, diabetes, and obesity. Those chronic conditions leave the survival system permanently switched on.
Aye.
When angiotensin II is chronically elevated for years, that emergency response becomes toxic. Think of it like a fire alarm that just never turns off.
It literally remodels the heart, making it stiff, scarred, and weak.
Exactly. We aren't disabling a necessary survival system. We are turning off a false alarm that is slowly destroying the house.
That makes total sense.
Yeah.
But dealing with the angiotensin side comes with a highly specific, very famous catch on the bradykinin side.
Yes, it does.
Because when you block an enzyme with two jobs, you can't control just one of them.
You're talking about the infamous Prill cough?
Yes, the cough. Let's clear up a massive misconception about this. When bradykinin accumulates, it doesn't just lower blood pressure. It severely irritates the sensory nerve fibers in the airway.
Which causes a dry, persistent, tickling, non-productive cough.
And it affects roughly 5 to 20% of patients, with higher rates generally reported in women and people of Asian descent, likely due to, genetic differences in how bradykinin is metabolized.
Right, but the big misconception is that this cough is an allergy.
Yes, it is absolutely not an allergic reaction.
And that distinction is crucial for clinical practice. Because it's not an allergy, it is a mechanism-based class effect.
So if a patient develops this maddening cough on lisinopril, switching them to an allopril or ramipril will not solve the problem.
Not at all. The entire class of ACE inhibitors has to be abandoned because they all do the exact same thing to bradykinin. You have to switch the patient to a completely different class of drugs, like an ARB.
But the bradykinin buildup can trigger something far more serious than a cough, too. Angioedema.
Yes. This is rapid, localized tissue swelling, often in the face, lips, tongue, or airway.
And there's a dangerous misconception here, too. Patients often think, well, I've been taking lisinopril for 5 years without any problem, so I'm safe.
That's a huge mistake. The risk is highest in the first few weeks of starting the medication, sure, but angioedema can emerge at literally any point during therapy.
Wow, anytime.
Yeah, a patient could take the drug uneventfully for a decade and suddenly wake up with life-threatening airway swelling. Any new facial or tongue swelling on an ACE inhibitor is an immediate, drop-everything medical emergency.
That's terrifying.
It is. We also have to acknowledge a well-documented disparity here. Black patients have a 2 to 4-fold higher risk of developing this angioedema compared to other populations.
It's wild to visualize how this works. Think of the heart and vessels as a town threatened by a catastrophic downstream flood. That's the damage caused by angiotensin II.
Okay, I'm with you.
Taking an ACE inhibitor is like building a massive dam to stop that flood. It saves the town, but the water has to go somewhere.
Right, it backs up.
Exactly. It backs up and overthrows the reservoir, flooding a nearby neighborhood. That overflowing reservoir is the bradykinin causing the cough or the angioedema. The bug and a piece of the feature are mechanistically inseparable.
It's the biological price of admission for altering such a fundamental pathway. Yet these drugs remain among the most widely prescribed in the world.
Why is that?
Because they fundamentally change the trajectory of human organs.
To understand why this drug class represents a massive paradigm shift in modern medicine, we basically have to look at how medical thinking evolved, starting in the late 1980s.
Right, because at that time, doctors viewed heart failure as a one-way street. The heart got weaker, you gave patients diuretics to pee out excess fluid to manage their symptoms, and eventually the heart just gave out.
Then came the consensus trial in 1987. Researchers took patients with NYHA class 4 heart failure, meaning these patients had severe, exhausting symptoms, even while just sitting still in a chair.
The worst of the worst cases.
Exactly. They added enalapril to their standard therapy, and the results showed a shocking 40% reduction in 6-month mortality.
If we connect this to the bigger picture, we really have to ask why mortality dropped so drastically. It wasn't just because their blood pressure was a little lower.
It goes deeper than that.
It comes back to angiotensin II acting as a toxic cellular construction foreman. When the heart is failing, chronic angiotensin II tells cells called fibroblasts to lay down dense collagen.
It replaces flexible, healthy heart tissue with rigid scar tissue.
Yes. And enalapril essentially fired that foreman. It stopped the collagen deposition, allowing the heart to maintain its flexibility and compliance.
Suddenly, heart failure became a disease you could actively treat and slow down at the cellular level.
Exactly. And once researchers realized they could rescue patients in the final stages of heart failure, a new question naturally emerged.
Could we use this exact same mechanism earlier to stop the damage from happening in the first place?
Right. And that led to the SAVU trial in 1992. They gave captopril to patients who had just survived a heart attack and had suffered damage to their left ventricle.
Because when part of the heart muscle dies during a heart attack, the rest of the ventricle tries to compensate by stretching out, right? like a rubber band stretched too many times until it gets flabby and loses its snap.
We call this ventricular dilation.
So what did captopril do?
Captopril halted that structural ballooning. By blocking angiotensin II early, they prevented the heart from pathologically stretching and dilating over time. It stopped the structural remodeling before it could destroy the organ's pumping efficiency.
That is incredible, and that success pushed the boundary even further. If it works for severe heart failure, and it works immediately after a heart attack, what if a patient hasn't had a heart attack at all, but they are just at high risk?
Which brings us to the HOPE trial in the year 2000.
They gave ramipril to high-risk patients, people with vascular disease or diabetes, who did not have heart failure, and who do not even have particularly high blood pressure.
Yet the drug significantly reduced heart attacks, strokes, and cardiovascular death.
The HOPE trial basically proved that blocking angiotensin II cools off vascular inflammation, didn't it?
Yes. Angiotensin II creates oxidative stress inside the endothelial lining of your blood vessels, making plaques unstable and prone to rupturing. Ramipril stabilized those vessels.
Wow.
These three major trials forced a total redefinition of the drug class. ACE inhibitors were no longer just blood pressure pills. They became cardiac and renal remodeling inhibitors that provide massive organ protection entirely independent of the blood pressure numbers.
So what does this all mean? If blocking this RAAS pathway is so miraculous, and it saves lives by protecting the heart and cooling off vascular inflammation, why don't we just hit the pathway harder?
What do you mean?
Like, why don't we use multiple drugs to block the cascade in 2 or 3 different places at once to get double the protection?
It sounds incredibly logical. I mean, the medical community thought more is better, too.
Yeah.
But when they rigorously tested that hypothesis, it failed spectacularly.
Really? How so?
Well, in 2008, the On-Target trial tested an ACE inhibitor, ramipril, alongside an ARB, telmisartan.
An ARB is an angiotensin receptor blocker, right? It works one step further down the chain.
Exactly. Instead of stopping the production of angiotensin II, it just blocks it from binding to its receptor. The theory was, block the production and block the receptors for maximum defense.
Sounds foolproof.
But the reality was double the harm. The combination produced zero added cardiovascular benefit, but significantly increased adverse events.
Oh, wow.
Yeah, patients suffered severe hypotension, kidney impairment, and dangerous hyperkalemia. It became the definitive textbook example of why more drugs blocking the exact same pathway isn't automatically better. You cannot routinely combine ACE inhibitors and ARBs.
And the cardiology world faced another massive shakeup in 2014, didn't they? With the Paradigm HF trial.
Yes, they did. For 30 years, ACE inhibitors sat on the throne as the untouchable holy grail first-line treatment for heart failure.
But this trial tested them against a newer class of drugs called ARNIs, right?
Right.
Angiotensin receptor neprilysin inhibitors, specifically a combination of sacubitril and valsartan.
And the RNIs reduced mortality so much more effectively that the trial was actually stopped early. Today, RNIs have largely dethroned ACE inhibitors in standard heart failure guidelines.
But that transition isn't just a simple swap, is it?
No, and this raises an important question regarding clinical safety, particularly for nurses managing these medication transitions.
Right.
ARNIs don't just block angiotensin receptors, they also inhibit an enzyme called neprilysin, and inhibiting neprilysin also increases bradykinin.
Uh-oh. So if you combine an ARNI with an ACE inhibitor,
You get a massive overlapping surge of bradykinin leading to an extreme risk of life-threatening angioedema. You can never combine them.
so what's the protocol?
Clinical guidelines enforce a strict 36-hour washout period when switching a patient from an ACE inhibitor to an ARNI to let the first drug completely clear the system.
We also have to talk about a massive trap regarding the kidneys. Throughout this deep dive, we've discussed how ACE inhibitors are renoprotective.
Yes, they protect the kidneys, especially in diabetic kidney disease, by lowering the pressure inside the tiny filtering units.
But in one specific condition, that exact protective mechanism becomes destructive.
The condition is bilateral renal artery stenosis, meaning the main arteries feeding blood to both kidneys are severely narrowed or clogged.
And the kidneys need a certain amount of pressure inside their filters to push waste out into the urine, right?
Right. In patients with this condition, angiotensin II acts as a clamp on the exit pipe of the kidney filter, keeping the internal pressure high enough to actually clean the blood despite the really poor inflow.
So if you give an ACE inhibitor to a patient with bilateral renal artery stenosis, you take away that crucial exit clamp.
Exactly. The internal pressure drops to zero, filtration completely stops, and you instantly throw the patient into acute kidney failure.
The mechanism that protects 99% of kidneys will shut down the kidneys in this specific patient. That is wild.
And a similarly devastating biological effect occurs during pregnancy. ACE inhibitors are a well-documented teratogen and are absolutely contraindicated in the second and third trimesters.
Why is that?
A developing fetus literally requires its own angiotensin II for normal kidney development. If a pregnant patient takes an ACE inhibitor, it blocks that fetal development, causing fetal renal failure.
Oh, man.
This leads to dangerously low amniotic fluid, a condition called oligohydramnios, which subsequently causes severe skull and lung malformations in the baby.
It's tragic. A drug that saves an adult's organs can prevent a child's organs from ever forming. We have covered an enormous amount of ground today, traversing from the venomous predators of the Amazon basin to the cellular mechanisms of massive clinical trials. Let's rapidly synthesize the 5 exam-style takeaways from our sources for everyone listening.
Number 1. Same enzyme, 2 jobs. ACE creates the damaging angiotensin II, but it also destroys bradykinin. That dual action is exactly why one single drug provides both the therapeutic benefits and the classic side effects.
Number 2. The cough is bradykinin, not allergy. It's a mechanism-based class effect. You can't just switch a coughing patient to a different prill. You have to change the entire class of medication.
Number 3. Protective beyond pressure. As proven by the Consensus, SAVE, and HOPE trials, these drugs prevent cellular remodeling, stop fibrosis, and reduce mortality in ways that are totally independent of simply lowering the blood pressure numbers.
Number 4. Watch the kidneys, watch the potassium, and watch for pregnancy. They can cause hyperkalemia. They will cause acute renal failure in patients with bilateral renal artery stenosis, and they are strictly teratogenic in the second and third trimesters.
And number 5. Angioedema is a lifelong, unpredictable risk. It is not just a first-week side effect. Any new airway, lip, or tongue swelling in a patient taking a prill drug, even 10 years into therapy, is a drop-everything medical emergency.
As we wrap up this deep dive, I want to leave you with one final thought to mull over. We learned today that captopril, the blueprint for an entire class of life-extending cardiovascular drugs, was reverse-engineered from the venom of a Brazilian pit viper using early structure-based design.
It really makes you wonder.
It does. If one of modern medicine's most foundational, organ-protecting miracles was hiding in the venom glands of a snake, just waiting for the right chemist to unlock its geometry, how many other miraculous, life-saving cures are currently slithering or crawling or growing deep in the rainforest right now, just waiting for us to decode their secrets before their habitats disappear forever?
It really forces us to acknowledge how much of our future medical survival might be deeply tied to the wild, untouched corners of the world.
The ultimate paradox. The venom evolved to cause catastrophic internal collapse, gave us the exact blueprint to keep millions of human hearts beating steadily year after year. Thanks for joining us on this deep dive. We'll catch you on the next one.
You know, you walk into any modern hospital ward, and there is this profound, almost comforting illusion of control.
Oh, absolutely.
Like everything is bright, it's sterile, it's highly categorized. You look down the hallway and you see those brightly colored signs taped to patient doors, right?
Right. The yellow one for this pathogen, the blue one for that one.
Exactly. Maybe a green one near the end of the hall. And it just projects this absolute certainty, this feeling that the medical world has like completely mastered the physical space and everything invisible within it.
Yeah, it creates the atmosphere of this highly organized fortress. I mean, the underlying message of that laminated piece of paper on the door is that the enemy, the pathogen, has been perfectly contained by our administrative protocols.
But when you actually read the literature, you know, when you dig into this stack of sources on isolation precautions in nursing, like we are today, you realize those tidy little signs are covering up a messy, ongoing battleground.
Messy is definitely the word for it.
Right. We treat these protocols like they descended from a mountain carved in stone, but the reality is this landscape is driven by evolving aerobiology, complex fluid dynamics, and frankly, a whole lot of historical trial and error.
Yeah, we are constantly negotiating with biology. The rules we follow today are really just the current uneasy truce we've struck with microorganisms that are actively trying to bypass our defenses.
So our mission today is to decode that rulebook for you, to look past the laminate and understand what is actually happening invisibly in the air and on the clinical surfaces around you.
It's a huge topic.
It is. We're zeroing in on the modern CDC and HIC pack framework. That's the Healthcare Infection Control Practices Advisory Committee.
Yeah.
This is the standard two-tiered system taught in every single U.S. nursing program.
Right. And the foundation of that is standard precautions,
Yep.
which applies universally to every single patient encounter.
Which basically means treating all blood and body fluids as inherently infectious.
Exactly. Hand hygiene, safe injection practices, throwing on gloves for fluid contact. You do that whether the patient is there for a routine appendectomy or, a mysterious fever. It is the absolute baseline of clinical practice.
And sitting right on top of that baseline is the second tier, the transmission-based precautions, heavy hitters.
Right. Contact, droplet, and airborne.
Okay, let's unpack this. Because before we can understand the massive debates currently raging about how these rules are applied, we have to look at the mechanical foundation they're built on.
The physics of it all.
Yeah, exactly. We have to answer the physical question: how does this specific pathogen actually cross the space between a patient and a clinician?
Because pathogens aren't magic, even if they sometimes feel like it. They obey the laws of physics.
Right.
They need a physical vehicle to cross that space.
Yeah.
So let's look at contact precautions first. The vehicle here is direct touch, or a contaminated intermediate surface, a fomite.
So like a bed rail.
Exactly. If you're dealing with MRSA or VRE, those bacteria are heavily colonizing the patient's skin, the bed rails, the IV pole. The moment you walk into that environment, your uniform is at risk of becoming the vehicle.
Which dictates the protocol.
Right. Donning a gown and gloves before crossing the threshold and keeping dedicated diagnostic equipment inside that specific room.
But, reading through the sources, there's this fascinating exception that completely upends this standard routine, and it involves Clostridioides difficile, C. diff.
Oh, C. diff. It is the ultimate trip-up in clinical practice.
Yeah.
It forces a complete behavioral override of the standard hospital routine.
Right, because everywhere else in the hospital, the gold standard, like the absolute reflex, is the alcohol-based hand sanitizer. You finish an assessment, you pump the foam, you rub your hands, you move on.
It's pure muscle memory.
But alcohol does not denature C. diff spores.
Yeah.
It reminds me of working on a car engine. Imagine your hands are just coated in thick, heavy axle grease. If you pour rubbing alcohol on them, you aren't cleaning anything. You're just smearing the grease around your skin.
Right. It doesn't break it down.
Exactly. The only way to get it off is mechanical friction. You need heavy soap, running water, and vigorous scrubbing to physically pry that grease off your epidermis and wash it down the drain. You can't chemically kill the stoles with alcohol. You have to physically evict them.
I love that analogy because it perfectly captures the physical mechanics of the spore. C. diff spores have an incredibly hardy protein coat that evolved specifically to survive harsh chemical environments.
Like the stomach.
Precisely, the acidic human gut. So a splash of ethanol isn't going to breach it. You have to rely on the sheer force of soap and water. It's a vital concept because it breaks that deeply ingrained muscle memory of the healthcare worker.
Now, if a pathogen isn't relying on touch, it might be hitching a ride in a respiratory droplet, which brings us to the droplet precaution category.
Right. The vehicle here is respiratory fluid expelled during a cough, a sneeze, or even just talking. These droplets are relatively large and heavy.
So gravity is doing a lot of the work.
Exactly.
Yeah.
Because of their mass, gravity is the dominant physical force acting on them. They're pulled down to the floor pretty rapidly, typically falling within a 3 to 6 foot radius of the patient.
That implies a safe zone. Like if you are standing 7 or 8 feet away, gravity has already done the protective work for you.
That's the clinical assumption. The required PPE is a standard surgical mask, donned when coming within that physical radius to block those macroscopic droplets from hitting your mucous membranes.
And notably, you don't need any specialized room ventilation.
No, not at all. The droplets are on the floor. They aren't, lingering in the HVAC system.
The sources list the usual suspects for this category: influenza, pertussis, mumps, rubella. But the standout that really caught my attention is Neisseria meningitis, bacterial meningitis.
Oh, yeah, that is a pathogen that instantly changes the temperature in the emergency department.
Because the timeline is so aggressive, right, it can kill a healthy adult within hours. If a nurse or a physician conducts a close-up assessment without a mask and the lab comes back positive for meningitis, that clinician urgently needs post-exposure prophylactic antibiotics.
It's a massive deal.
It's not a situation where employee health says, monitor yourself for a fever, let us know. It's immediate intervention. It really hammers home that these precaution categories aren't just bureaucratic suggestions.
Right.
They map directly onto life or death clinical urgency.
Absolutely. But what happens when the droplet is so small that gravity is no longer the dominant force?
Oh.
That is when we cross into airborne precautions. We are no longer talking about macroscopic fluid hitting the floor. We are talking about microscopic aerosolized particles.
So they don't fall.
No, they float. They ride the thermal plumes and ambient air currents in the room, and they can remain suspended for hours after the source patient has physically left the space.
Wow. So a standard surgical mask is essentially useless against that kind of physics?
It offers virtually no protection. Airborne particles simply flow around the loose edges of a surgical mask or pass straight through the macroscopic pores of the material.
Right.
You need a fit-tested N95 respirator, which uses an electrostatic charge to trap microscopic particles, or a PPR, a powered air purifying respirator. Furthermore, the environment itself has to be engineered.
The patient has to be in a specific room.
Yes, an airborne infection isolation room, or AIR.
The negative pressure room.
Exactly. The HVAC system actively exhausts more air from the room than it supplies, creating a pressure differential. When you open the door, air from the hallway rushes in.
Preventing the contaminated air inside from drifting out and infecting the rest of the ward.
Right. The system is also required to perform a minimum of 6 to 12 complete air changes per hour, physically scrubbing the room's atmosphere.
What's terrifying is that you need that level of engineering because these pathogens are wildly infectious.
What's fascinating here is just how efficiently some of these airborne viruses exploit the air. Look at measles. It has a basic reproduction number, an R0, of 12 to 18. In an unprotected population, one case generates, on average, over a dozen secondary cases. To put that into perspective, in 1985, the CDC investigated an outbreak in Michigan.
Okay.
A child with measles had an appointment in a pediatrician's exam room. They finished the exam and left the clinic entirely. Sometime later, a second child, completely unrelated to the first, was brought into that exact same, now empty room.
Wait, the room is empty. The source of the infection is just gone.
The patient was gone, but the air itself was still contagious. That second child contracted measles simply by inhaling the lingering suspended aerosols in that enclosed space.
Oh, wow.
It's a chilling demonstration of why airborne rooms require high-velocity air changes before they are considered safe to re-enter.
It is chilling. And looking at this modern framework, contact, droplet, airborne, it feels so mechanically logical. You identify the physical vehicle and you block it. But going through the historical sources, it begs a massive question. If this is just applied physics and biology, how did it take the medical establishment nearly 150 years to agree on it?
Well, the delay was driven by a powerful combination of unseen biology and deep professional stubbornness.
Stubbornness?
Oh, yeah. If we look back to the mid-19th century, we see the very first crude attempts at infection control. During the Crimean War in the 1850s, Florence Nightingale didn't actually understand germ theory. She believed in the miasma theory that diseases were caused by bad air.
Right, the classic bad air theory.
But her intuitive response was to aggressively improve ward ventilation and physically separate patients based on their symptoms. It was primitive, but it was effective source control.
Which was happening almost concurrently with Ignaz Semmelweis in Vienna in 1847.
The tragic pioneer of hand hygiene. He demonstrated with rigorous data that maternal deaths from puerperal fever plummeted if physicians simply washed their hands in a chlorinated solution between performing autopsies and delivering babies.
But the medical establishment didn't just ignore his data. They actively destroyed his career over it.
They were deeply insulted. The prevailing mindset was that a gentleman's hands could not possibly transmit disease.
Wow.
The idea that the doctors themselves were the vectors of death was professionally abhorrent. Semmelweis was mocked, sidelined, and eventually died in an asylum.
That is so sad.
It is a stark reminder that solid infection control data often loses out to professional ego and established dogma.
It really does. And, it took until 1970 for the CDC to publish its first formal hospital isolation guideline. They essentially created a menu of precaution bundles. You had strict isolation or respiratory isolation, and nurses would just select the bundle that matched the patient's diagnosis.
Yeah, that was the model for a while.
But that entire paradigm slammed into a brick wall in the early 1980s, HIV and AIDS.
HIV completely shattered the existing logic of isolation. For decades, the philosophy had been identify the sick patient, diagnose them, and isolate them. But HIV presented a terrifying new reality. You had a deadly pathogen where patients could remain asymptomatic and undiagnosed for years. You simply didn't know who was infected.
So because they didn't know who was actually infected with HIV, they had to flip the whole philosophy from isolate the known sick patient to assume every single person is a risk.
Precisely why the CDC introduced universal precautions in 1985, formalized heavily in 1987. Healthcare workers were contracting HIV through accidental needle sticks and blood exposures. Universal precautions established the radical new baseline that all blood and certain body fluids must be treated as highly infectious, always.
But the sources highlight that this didn't entirely solve the problem on the floor.
No, it didn't.
Because at the exact same time, you had infectious disease experts like Patricia Lynch pushing back. She proposed a rival system called body substance isolation, or BSI, arguing that focusing only on blood was dangerously narrow.
Right.
BSI demanded protection against all moist body substances, feces, urine, sputum, from every patient.
Imagine being a charge nurse in the late 1980s or early 90s. You have two competing, fundamentally different sets of protocols being published and debated simultaneously.
That sounds awful.
One focuses strictly on bloodborne pathogens. The other requires gloves for touching absolutely any body fluid. It created massive confusion and compliance failures on the floor.
That sounds like an administrative nightmare. So how did we finally get to the system we use today?
In 1996, Julia S. Garner, leading the CDC's HICPAC, performed a brilliant piece of clinical synthesis.
Okay.
She took universal precautions, merged it with the best elements of body substance isolation, and created standard precautions, the universal baseline we discussed earlier.
Ah, okay.
Then she took the old, clunky, disease-specific bundles and streamlined them into contact, droplet, and airborne. She built a cohesive two-tiered architecture that finally made sense.
It's an elegant piece of rulemaking. But as we know, pathogens don't read rule books.
They certainly don't.
The tension in these sources really spikes when we look at what happens when the system breaks down. And it does break down. Usually it's a failure of human execution or a failure of the scientific model itself.
Human error is the most common vulnerability. A tragic and highly publicized example was the Dallas Ebola cluster in 2014.
Right, I remember that.
Thomas Eric Duncan was the first person diagnosed with Ebola on U.S. soil. The hospital utilized contact and droplet precautions, escalating their PPE as his condition worsened. Yet two of the intensive care nurses treating him, Nina Pham and Amber Vinson, contracted the virus.
And the subsequent investigations revealed that the precaution category wasn't technically wrong, right? The failure was in the execution, specifically the doffing, the removal of the protective gear.
Yes.
It makes me think of an explosive ordnance disposal technician wearing a bomb suit. The suit works perfectly against the blast, but if the technician decides to unlatch the helmet while the shrapnel is still flying around the room, the suit becomes meaningless.
That's exactly it.
With Ebola, if a nurse exposes even a millimeter of bare skin at the wrist while sliding off a heavily contaminated fluid-resistant gown, the virus finds its window.
Doffing is incredibly perilous. You're dealing with healthcare workers at the end of a grueling 12-hour shift, cognitively depleted, physically sweating inside impermeable gear, and operating under immense psychological stress.
Just a recipe for a slip-up.
The Dallas cases forced the entire industry to realize that having the right PPE is insufficient if your donning and doffing technique isn't flawless and actively monitored by a trained observer.
Right.
But beyond human error, there are terrifying instances where the clinicians do everything perfectly, and the mental model of transmission itself is what fails.
Which brings us to the 2003 SARS outbreak in Hong Kong, specifically the Amoy Gardens apartment complex.
Over 300 residents in a single high-rise complex were infected with SARS-CoV-1, and the epidemiological mapping defied everything we knew about standard respiratory droplet transmission.
Because they weren't coughing on each other in the hallways.
No. The virus was moving vertically through the building's infrastructure.
Wait, I remember reading this in the sources and being completely baffled. How does a respiratory virus travel through a building's infrastructure?
Through the plumbing.
The plumbing.
Yes. The floor drains in the bathrooms utilized U-traps, those curved pipes designed to hold a little bit of water to block sewer gases from coming up.
Okay, sure.
But in many apartments, the floor drains were rarely used, and the water in the traps had evaporated. When a resident who was shedding massive amounts of the virus in their feces used the bathroom exhaust fans created a negative pressure environment.
Oh, no.
It literally sucked aerosolized, virus-laden fecal matter out of the dry plumbing pipes and into the apartments.
Literal airborne feces traveling backward through dry plumbing. I mean, there wasn't a precaution category in the 1996 CDC playbook for that.
Because the medical establishment desperately wants categories to be neat. We want respiratory viruses to exclusively utilize the respiratory droplet vehicle. We do not want them utilizing aerosolized sewage.
Here's where it gets really interesting. Because that deep institutional desire for neat, predictable categories brings us to the biggest scientific brawl in modern epidemiology.
The 5-micron controversy.
Yes, during the COVID-19 pandemic.
It was an absolute seismic shift in infection control. It forced a global reckoning regarding how we define the very air we breathe.
For decades, the rigid textbook definition separating a droplet from an airborne particle was based on a strict measurement. 5 microns.
Right.
The dogma stated that if a respiratory emission was larger than 5 microns, it was heavy, and it would fall to the floor within 6 feet. If it was smaller than 5 microns, it was an aerosol, and it would float.
And relying on that rigid metric, in early 2020, the WHO and the CDC confidently classified SARS-CoV-2 as a droplet-spread pathogen.
I remember.
The public health messaging was entirely built on this. Stay 6 feet away, wear a standard surgical mask, wash your hands, and you are protected.
While N95 respirators were fiercely rationed.
Exactly, restricted only for specific aerosol-generating procedures like intubating a patient.
I always assumed that 5-micron rule was the result of some massive, definitive clinical trial. But aerosol scientists, experts like Lindsay Marr at Virginia Tech and Jose Luis Jimenez at the University of Colorado began looking at this and essentially said, this is fundamentally bad physics.
They did a deep historical dive and realized the 5-micron rule wasn't based on modern fluid dynamics. It was a bureaucratic misinterpretation of tuberculosis research from the 1930s.
The 1930s?
Yes. Marr and her colleagues argued forcefully that human beings do not emit perfectly uniform 5-micron droplets. When we speak, when we cough, when we sing, we emit a massive, continuous spectrum of particle sizes.
Right.
And the physics dictate that in poorly ventilated indoor spaces, even particles much larger than 5 microns can dehydrate in the air, shrink, and travel much further than 6 feet.
And the undeniable tragic proof of this bad physics was the Skagit Valley chorale rehearsal in Washington State in March 2020.
The super-spreading event that irreparably broke the droplet model.
You had roughly 60 people gathered in a room for a 2.5-hour choir practice. They were aware of the virus. They actively tried to maintain distance, staying more than 6 feet apart.
Right, following the rules?
Following the rules. There was only one symptomatic person in the room. And out of those 60 people, 52 were infected.
You cannot mathematically or physically explain 52 infections in a room of that square footage using a 6-foot droplet model. It is impossible.
Just doesn't work.
The virus was not falling to the floor. It was accumulating in the air as fine aerosols, drifting across the room like cigarette smoke. The sheer force of the epidemiological math proved the aerosol scientists right.
And it took months of fierce debate, but eventually, by mid-2021, the CDC and the WHO had to bend to the physics. They revised their guidance, conceding that inhalation of fine aerosols was a primary route of transmission.
The medical establishment had to publicly renegotiate its own foundational science in real time.
Yeah.
If we connect this to the bigger picture, it illustrates exactly why a deep understanding of these mechanics is so vital for the clinician and the informed patient. When the underlying science is this messy and subject to revision, misconceptions thrive on the hospital floor.
People cling to simplified rules of thumb that often fail under pressure.
Exactly.
Let's actually clear the air on some of those operational misconceptions right now, because the sources dedicate a lot of ink to how these protocols are misunderstood in practice. Let's start with vocabulary. I hear isolation and quarantine used interchangeably by medical professionals all the time.
The media conflation of those terms during COVID really entrenched that error, but they are clinically distinct.
Okay, how so?
Isolation is for the infected. You isolate a patient who is confirmed sick or symptomatic to keep them away from the healthy population. Quarantine is for the exposed. You restrict the movement of an asymptomatic person who is exposed to a pathogen, waiting to see if they develop the disease.
Ah, okay, that makes sense. Here's a massive point of confusion on the floor regarding room assignments. If a patient is on droplet precautions, they must be in a negative pressure room.
That is a persistent myth, largely driven by the lingering trauma and hypervigilance from the pandemic. Droplet precautions do not require negative pressure.
They don't.
No, a standard private room with normal HVAC ventilation is perfectly adequate. because those heavy droplets are settling out of the air. Reserving negative pressure AIRs is strictly for airborne precautions, where the virus is actively riding the air currents.
Which leads directly to the mask myth. There is a deep psychological reliance on the blue surgical mask to stop anything respiratory.
Well, a standard surgical mask is essentially a splash guard. It's highly effective at stopping large droplets from hitting your nose and mouth, but it does not form a seal against your face.
Right.
If you are dealing with tiny, suspended airborne particles, they will simply follow the air current right through the gaps of your cheeks. If a pathogen is airborne, anything less than a fit-tested N95 is an illusion of safety.
But the pendulum swings the other way too, right? Because of that fear, you see an over-application of airborne precautions. The assumption that any infectious respiratory illness demands an N95 and a negative pressure room.
That better safe than sorry mentality is understandable, but it creates massive operational bottlenecks. Seasonal influenza, for instance, requires only droplet precautions.
Okay.
If a hospital routinely places standard flu patients in airborne rooms, they will rapidly exhaust their specialized infrastructure. When a patient with active pulmonary tuberculosis or measles arrives, the resources they genuinely need to survive won't be available.
Let's look at one final misconception going back to contact precautions. A nurse is rushed, an IV pump is beeping, and they think, I'm just running in to silence the alarm and grab a trach. I'll just throw on some gloves. I don't have 45 seconds to tie a gown.
That shortcut completely neutralizes the precaution. Contact protocols mandate a gown and gloves for a reason. If you lean across a bed to silence that IV pump wearing only gloves, your unprotected scrubs will inevitably brush against the bed rail or the linens. You've now transferred MRSA or VRE to your uniform.
You become the vehicle.
Exactly. You will carry that fomite out into the hallway and introduce it to your next patient.
So what does this all mean? Why did we just spend this entire deep dive obsessing over fluid dynamics, historical U-traps, and the cognitive load of doffing PPE?
It matters because the stakes in modern healthcare are astronomical. Hospital-acquired infections, driven by protocol failures, cost health systems billions and drive the terrifying acceleration of multi-drug-resistant organisms. When a patient acquires VRE or C, diff, because of a broken chain of infection control, it dramatically prolongs their suffering and limits our pharmacological options.
And it extends far beyond the ICU. With the rapid resurgence of measles in under-vaccinated populations globally, a deep mechanical competency in airborne precautions isn't just a niche skill for an infectious disease specialist.
No, not at all.
It is an immediate, highly relevant necessity for every single healthcare worker.
And beyond the clinical mechanics, there's a profound philosophical lesson hidden in these sources. We are conditioned to view medical guidelines as absolute, settled truths.
Right.
But the collapse of the droplet versus airborne paradigm during COVID-19 proved that these categories are merely our best temporary attempts to impose order on a chaotic microscopic reality.
Those brightly colored signs on the hospital doors are essentially just clinical simplifications.
Exactly. This raises an important question, a final thought I'd like to leave you to ponder on your own today.
Okay.
If the strict 5-micron boundary between a droplet and an airborne particle was just a convenient clinical simplification of messy physics, one that spectacularly fell apart when tested by a novel virus, what other rigid life-or-death medical rules are we unquestioningly following today?
Wow.
What other foundational protocols are built on outdated science, just waiting for the next pandemic to expose them?
It fundamentally changes how you look at the physical space of a hospital. Think about that the next time you see a yellow contact precautions sign on a door. The invisible world is significantly messier than we like to admit.
And the rule book is always being rewritten.
Until next time, keep questioning what you think you know.
Usually when we talk about medicine, there's this expectation of precision.
Right.
It's kind of like engineering. You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, well, there it is. The fix is obvious.
Yeah, it is a very comforting way to view healthcare. I mean, we naturally prefer things to be visible and neatly categorized.
Exactly.
And above all, we want the treatments to make intuitive sense. You know?
All right. If you're bleeding, we stop the bleeding. If you're dehydrated, we give you fluids. And if you are struggling to breathe and your oxygen levels are dropping, the most fundamental, universally accepted rule in the book is, well, we give you oxygen.
Which just feels like common sense.
Completely. But today, for this deep dive, if you want to understand the why behind the medical rules, We are looking at a landscape that just completely shatters that intuition.
It really does.
We are exploring a physiological mystery where giving a patient the exact element that keeps human beings alive, oxygen, can actually become a deadly threat.
It operates as a genuine medical paradox. And, this isn't just an abstract brain teaser for medical students either.
Right. Not at all.
This specific paradox dictates the emergency protocols used by paramedics and nurses all over the world every single day when they're dealing with one of the most widespread diseases on the planet.
Right, and we're talking about COPD here. So the mission for today's deep dive is to untangle why the classic textbook explanation for this oxygen paradox was actually just dead wrong for decades.
Yeah.
And we're also going to look at how a group of paramedics in Tasmania helped rewrite the global rules of emergency medicine.
It's an incredible story, but to really grasp how oxygen becomes a weapon, I think we first need a rock-solid definition of the battlefield, right?
Let's do it.
So COPD stands for chronic obstructive pulmonary disease, and the globally accepted standard comes from the Global Initiative for Chronic Obstructive Lung Disease, or GOLD for short.
Okay, GOLD.
Yeah, and they define it as a common, preventable, and treatable disease that's characterized by persistent respiratory symptoms and airflow limitation.
Okay, let's ground that in something concrete for a second. If a patient walks into a clinic, how does the doctor actually prove they have this limitation?
Right, so there's a very specific breathing test involved.
Because you can't just guess, right?
Exactly. It relies on something called spirometry. So the patient blows into a machine, and the diagnostic anchor they're looking for is a post-bronchodilator FEV1 over FVC ratio below 0.70.
Oh, wow. Okay.
Yeah, I know. But that specific threshold confirms, and this is key, not fully reversible airflow obstruction, which is really the biological signature of COPD.
Wait, before we move on, what is that alphabet soup? Fair question. I mean, if I'm blowing into this machine, what exactly is it measuring that proves my lungs are permanently damaged?
Right. So FEV1 is your forced expiratory volume in 1 second.
Okay.
Basically, it's how much air you can violently blast out of your lungs in the very first second of a hard exhale.
Got it.
And then FVC is your forced vital capacity. That's just the total amount of air you can push out overall.
So it's a fraction.
Exactly. If that ratio drops below 0.70, it means you can hold a decent amount of air, but you physically cannot push it out fast. The airways are collapsing or they're obstructed.
And you mentioned the key phrase there is post-bronchodilator.
Yes, that's crucial.
Which means they gave the patient an inhaler, like albuterol, to try and open things up, right? But the
Yeah.
ratio stayed low.
Precisely. The obstruction didn't go away.
I think this is where the mental model for breathing problems usually gets scrambled for a lot of people.
Yeah.
Because most of us, we default to thinking about asthma.
Oh, absolutely.
With asthma, the plumbing is just temporarily squeezed. You have an attack, you take the inhaler, the airways open back up, and the obstruction resolves. You're back to normal.
And that distinction changes everything about how we manage the condition. With COPD, even after you administer the medication, the structural damage remains.
It's fixed.
Yeah, the plumbing itself is fundamentally altered. You have chronic expiratory airflow limitation. You simply can't get the air out. But, figuring out that fundamental truth took the medical community a remarkably long time. I mean, for over a century, COPD suffered from a massive field-wide identity crisis.
You know what's wild about this? This identity crisis isn't even a modern phenomenon. I was reading through the source notes on René Laennec, the French physician, who famously invented the stethoscope back in, 1819?
Yeah, 1819.
She was doing these autopsies and kept noticing these bizarre, overinflated lungs. When he opened the chest cavity, instead of deflating like a normal balloon, these lungs just sat there.
Yeah, they were emphysematous.
Right. They failed to collapse because they were trapping massive amounts of air.
It was a brilliant, really early anatomical observation, but the medical field had basically no idea what to do with that information at the time.
Right.
For the entire 1800s and well into the 1900s, there was no single disease called COPD. Doctors essentially treated the downstream symptoms as completely separate diseases managed in isolation.
So what did that look like?
Well, you had chronic bronchitis, which was defined by a chronic, highly productive cough. And then you had emphysema, defined by that structural destruction of the lungs' air sacs that Laennec actually observed.
And because of that division, doctors forced patients into these highly caricatured stereotypes, right? The ones that were taught in medical schools for generations.
Yeah.
They call them the pink puffer and the blue bloater.
Yeah, those labels were incredibly sticky, despite being, frankly, largely inaccurate.
What were they supposed to mean?
So the pink puffer was supposed to be your classic emphysema patient. They were described as very thin, burning a massive amount of calories just to physically breathe, but they kept their blood oxygen levels somewhat normal, hence the pink complexion.
Okay, and the blue bloater?
That was the chronic bronchitis phenotype, so typically heavier, struggling with severe fluid retention and right-sided heart strain. And they were cyanotic, meaning they had a bluish tint because their oxygen levels were chronically low.
But the problem is that human biology rarely fits perfectly into two neat little boxes like that.
No, almost never.
And from the sources, it seems like these stereotypes actually created a major danger to patients, because the classic pink puffer was almost always assumed to be a heavy smoker, which led to this massive blind spot in medicine.
A deadly blind spot, really. I mean, while smoking is undeniably a massive driver of COPD in high-income countries, treating it purely as a smoker's disease ignores the global reality entirely.
Right, because there's a whole other world out there.
Exactly. Today, one of the leading causes of COPD worldwide is indoor air pollution.
Oh, wow.
Yeah, millions of women in low and middle-income countries develop severe COPD from decades of cooking over unventilated indoor biomass fuel fires.
It's tragic.
They've never touched a cigarette in their lives, yet their lungs show the exact same permanent destruction.
And there's also that genetic condition mentioned in the research too, right? The alpha-1 antitrypsin deficiency.
Yes. That is a perfect example of how complex the disease really is.
How does that one work?
So alpha-1 antitrypsin is a protein produced by your liver, and it travels to your lungs to protect them from your body's own immune system.
Okay.
But in people with this genetic deficiency, they just lack that protective protein. As a result, their own white blood cells essentially start chewing up the healthy elastic tissue in their lungs.
Oh my God.
Yeah. You end up with young, healthy non-smokers presenting with severe emphysema.
So you have all these different causes: smoking, indoor fires, genetics, causing this messy mixture of bronchitis and emphysema. And by the 1950s, British doctors were calling everything chronic bronchitis, and American doctors were calling the exact same symptoms emphysema.
Yeah, it was chaos.
You couldn't even compare clinical research across the Atlantic because everyone was just speaking a completely different medical language.
It required a massive intervention. So the 1959 SIBA Guest Symposium in London was essentially an effort to lock international experts in a room and just force them to standardize the terminology.
Long overdue.
Definitely. And out of that meeting and the subsequent work in the 1960s by an American pulmonologist named William A. Briscoe, we finally got this unifying umbrella term, chronic obstructive pulmonary disease.
It seems like the whole point was to stop stereotyping patients and recognize the shared physical problem. And modern Gold-D reports really push back against those old pink and blue stereotypes now, right?
They absolutely do.
Because real-world patients are usually just a messy mixture of both emphysema and chronic bronchitis.
Exactly. Modern medicine has shifted focus away from just staring at that FEV1 lung capacity number we talked about earlier. Now, they focus heavily on symptom burden and the risk of the patient having an acute exacerbation.
How do they measure that?
They use what are called the ABE assessment groups.
Okay.
These groups evaluate how much the disease is actually impacting a patient's ability to walk up a flight of stairs or get dressed, rather than just categorizing them by a single biological metric.
Which is way more useful for the actual patient. But it raises an interesting question about where the boundaries of this disease actually stop.
Sure.
The sources mention asthma-COPD overlap, or ACO. If COPD is fixed damage, like we said, and asthma is temporary reversible squeezing, how do you have both?
This is actually one of the most fiercely debated topics in pulmonology right now. Some patients present with the fixed, permanent structural destruction of COPD, but they also have eosinophilic inflammation.
Okay, wait, meaning what exactly? What are eosinophils doing in the lungs?
Right, so eosinophils are a specific type of white blood cell that typically ramp up during allergic reactions, which is a classic driver of asthma.
Oh, okay.
So you have a patient whose air sacs are permanently damaged from COPD, but their airways are also swelling up from this allergic, asthma-like white blood cell response.
That sounds miserable.
It is. And the medical community is split on whether ACO is a totally distinct third disease entity or if it's simply a case of an unlucky patient developing two very common diseases in the exact same set of lungs.
Right. So if COPD means the lungs are structurally permanently damaged and the patient cannot effectively exhale, how does giving them oxygen suddenly make that permanent damage worse?
That's the big question.
What is the biological domino effect here? Because it just doesn't sound right.
To unpack that, we really have to look at the first principles of how the human drive to breathe actually works. Because in a healthy person, the primary stimulus that tells your brain to take a breath is not a lack of oxygen.
Which feels entirely backwards to anyone outside of medicine. I mean, we breathe for oxygen.
It goes against every instinct. But your primary drive to breathe is actually triggered by a rise in carbon dioxide.
CO2.
Yes. You have central chemoreceptors located deep in your brainstem, specifically in the medulla, and they constantly monitor the pH of your blood.
Okay.
When CO2 builds up, it turns into carbonic acid, so your blood becomes slightly more acidic. Those receptors in the brainstem sense the burn, basically. They scream at your respiratory muscles, and you take a breath to blow off that CO2.
So where does oxygen come in?
Oxygen is just a secondary backup alarm system. That one is monitored by peripheral chemoreceptors in your carotid bodies, which are in your neck.
This perfectly explains why if you hyperventilate, like taking a bunch of really fast, deep breaths before you jump into a pool, you can hold your breath underwater for a shockingly long time.
Exactly.
Because you've forcefully blown off so much CO2 that your brain's primary acid alarm is totally silent.
Yep.
Your oxygen levels are steadily dropping while you're swimming, but the backup oxygen alarm hasn't kicked in yet to tell you to surface.
That is the exact mechanism. Now, apply that to a patient with severe, long-standing COPD.
Okay.
Because their airways are collapsing and they can't effectively exhale, they chronically retain CO2. Their baseline CO2 levels are always high.
So the alarm is constantly ringing.
Well, at first, yes. But over months and years, the body tries to adapt to this new normal. The kidneys step in and start holding onto bicarbonate to buffer the acid in the blood.
All clever.
It is. But because the pH normalizes, those central CO2 alarms in the brainstem essentially get exhausted. They become desensitized and just stop ringing.
So the primary CO2 alarm is completely broken.
Exactly.
Which means the body has to shift its reliance to the backup system,
Yeah.
the peripheral oxygen sensors in the neck. This is the famous hypoxic drive that nursing and medical schools taught as absolute gospel for decades.
Yes.
The patient is now breathing primarily because their oxygen is low.
And that theory leads directly to the classic textbook warning. The logic dictates that if you have a severe COPD patient in respiratory distress and you slap a high-flow oxygen mask on them, you instantly satisfy that backup alarm.
Oh, wow.
The peripheral receptors tell the brain, hey, we have plenty of oxygen, no need to work so hard.
But imagine the human body is a large building. Normally, the building relies on a highly sensitive smoke detector that's the CO2 alarm.
I like this.
But the smoke detector breaks, so the building management says, well, we'll just rely on the backup heat sensor in the ceiling. That heat sensor is the oxygen alarm.
Right.
Giving high-flow oxygen to this patient is like aiming a blast of freezing, icy air conditioning directly at that backup heat sensor.
That's a great way to picture it. And because you've frozen the heat sensor, the alarm goes completely quiet. Nobody is opening the windows or running the exhaust fans. The patient's breathing rate drops.
But the building is still on fire.
Exactly. Meanwhile, the fire is still burning. The smoke, the CO2 just gets thicker and thicker, building up to toxic levels until the patient becomes dangerously somnolent and eventually stops breathing altogether.
It is a terrifying but highly logical explanation,
It's a brilliantly elegant story.
which makes it incredibly frustrating that it is mostly wrong.
Yeah.
I mean, if that story is so logical, how did we figure out the textbook was missing the real villains?
Well, the neat little hypoxic drive narrative started to fall apart under scientific scrutiny starting in the 1980s.
Okay, what happened?
Researchers like Aubier, and later there was a pivotal study by Robinson and colleagues published in the American Journal of Respiratory and Critical Care Medicine around the year 2000.
What did they do?
They actually put COPD patients in the lab. They gave them oxygen, watched their CO2 inevitably rise, just like everyone knew it would, but they meticulously measured their minute ventilation.
Minute ventilation.
Basically, exactly how much air they were moving in and out per minute to see if they really were breathing that much less.
And the drop in breathing rate didn't match the massive spike in CO2, did it?
Not even close. The drop in breathing, that pure loss of drive we just talked about, only accounted for a tiny fraction of the CO2 retention.
Wow.
The alarm wasn't just shutting off. The researchers discovered that the real culprits driving the CO2 up were largely mechanical and biochemical. The first major villain is ventilation perfusion mismatch reversal, or VQ mismatch.
Okay, let's break down the mechanics of that, because VQ mismatch sounds like a physics exam question.
It does, but the concept is actually a beautiful demonstration of how smart the body is. So, in a damaged COPD lung, There are areas of alveoli, the little air sacs, that are completely destroyed. They don't exchange gas well at all. The body recognizes this dead space. It uses a reflex called hypoxic pulmonary vasoconstriction.
That's a mouthful.
It is, but it basically just means the body clamps down and squeezes the blood vessels shut around those useless, damaged areas, redirecting the blood flow to the healthy parts of the lung where the air actually is.
That's amazing. It's actively rerouting traffic away from the bad parts of the lung.
Exactly.
But then we introduced the high-flow oxygen mask.
Right, you flood the entire lung with oxygen. When those tightly constricted blood vessels around the damaged areas sense this massive, sudden influx of oxygen, they are tricked into thinking, oh, the problem is fixed. This area is ventilated again.
Oh, no.
So they relax, they dilate. Suddenly, a massive amount of blood rushes back into those deeply damaged, structurally useless areas of the lung.
Wait. So giving oxygen relaxes the vessels in a way that actively destroys gas exchange?
Yes.
That's like opening all the toll booths on a major highway when half the bridge is out ahead.
That's exactly what it's like.
You think you're speeding things up by opening the gates, but you're just creating a massive, catastrophic traffic jam right at the edge of the broken bridge.
And to take that toll booth analogy a step further, not only is there a massive traffic jam, but all those cars are trapped in a dead zone where they physically cannot offload their passengers, the CO2.
Because the sacs are broken.
Right. The blood is circulating, but it's flowing through physiological dead space where it can't exchange gas. That internal traffic control system has completely collapsed.
Unbelievable.
That's culprit number one. Culprit number two is even more insidious because it happens on a microscopic biochemical level. It's called the Haldane effect.
So the blood flow is reversed. But how does oxygen physically interact with the blood cells themselves to make the CO2 worse?
It comes down to how hemoglobin operates.
Okay.
Hemoglobin is the protein in your red blood cells that carries oxygen to your tissues, but it also helps transport carbon dioxide back to the lungs to be exhaled.
So it's a two-way transport?
Exactly. However, hemoglobin has preferences. Deoxygenated hemoglobin loves to carry CO2.
Makes sense.
But when you flood the blood with pure oxygen, the hemoglobin binds to that oxygen and actually undergoes a physical shape change.
Really?
Yes, and because of that new shape, its affinity for carbon dioxide just plummets.
So it basically kicks the CO2 out of the car.
It forcibly dumps its entire payload of CO2 directly into the blood plasma. Now you have a massive surge of dissolved CO2 arriving at lungs that are already damaged, already suffering from a traffic jam, and structurally incapable of exhaling it fast enough.
Wow.
The CO2 levels in the blood skyrocket, creating severe hypercapnia. And this happens entirely independently of how hard the patient is trying to breathe.
Okay, so if the primary danger of oxygen isn't just that the patient forgets to breathe, but rather this incredibly complex mix of reversible blood flow and biochemical dumping, how does this change the actual treatment for a paramedic in the field?
That's a great question.
Does it matter why the CO2 goes up as long as you know oxygen causes it?
That tension dominated emergency medicine for a decade. The physiological debate over VQ mismatch and the Haldane effect was fascinating for researchers, sure, but the paramedics in the back of the ambulance just needed to know, what do I set the oxygen dial to right now while this patient is struggling?
Exactly. Tell me what to do.
And that question was definitively answered outside the laboratory, in the real world.
Which brings us to the 2010 Austin trial, published in the British Medical Journal.
Yes.
This wasn't in a sterile lab. This happened in the back of moving ambulances in Tasmania.
Right.
I mean, imagine being a paramedic in the back of a bouncing ambulance trying to manage a crashing respiratory patient, and you are part of a study that is about to change global protocol.
It was a brilliantly designed, high-stakes, landmark study.
What did they do?
Paramedics treating patients with suspected severe COPD exacerbations were randomly divided into two groups.
Okay.
One group provided the old standard of care, unrestricted high-flow oxygen.
Blasting with it.
Right. The other group provided titrated oxygen. They carefully controlled the flow to keep the patient's blood oxygen saturation in a very specific narrow window, 88 to 92%.
Just 88 to 92%, which feels really low to a lot of people.
It does. But the results from those Tasmanian ambulances were staggering.
Yeah.
The group that received the carefully titrated lower dose oxygen had roughly a twofold reduction in mortality compared to the high flow group.
They halved the death rate just by turning the oxygen dial down.
It provided undeniable real-world proof that giving too much oxygen was lethal. It forced ambulance agencies and emergency rooms globally to rewrite their protocols.
Which is fantastic.
But it also revealed a deeply dangerous flip side to this knowledge.
Because if you drill it into the heads of every medical student and nurse that oxygen kills COPD patients, you breed a culture of fear.
Exactly. The pendulum swung entirely too far in the other direction. Providers became so terrified of the hypoxic drive and causing hypercapnia, that high CO2, that they started severely undertreating patients who were actively dying from a lack of oxygen.
Which is horrifying.
Imagine a COPD patient who is having a massive heart attack or a pulmonary embolism. Their oxygen levels are in the 70s. Their heart muscle is dying. Yet you have providers hesitating to give them oxygen because they see COPD on their chart.
Which is a tragic overcorrection, because the golden rule highlighted in the sources is absolute. Hypoxemia, low oxygen, kills faster than hypercapnia, high CO2.
Always.
A high CO2 level might make you sleepy, alter your mental status, and eventually stop your breathing over a period of hours. But a profoundly low oxygen level will cause fatal arrhythmias and stop your heart in minutes.
To combat this fear-based hesitation, organizations like the British Thoracic Society had to write incredibly explicit emergency guidelines.
What do they say?
The mandate is not avoid oxygen. The mandate is titrate, don't withhold.
Titrate, don't withhold.
Right. If a patient is at risk, you use specialized equipment to safely thread the needle. They use things like a Venturi mask, which utilizes different colored valves to draw in-room air and deliver precise, controlled concentrations of oxygen, like exactly 24% or 28%, to safely hit that 88 to 92% target.
You give them exactly enough to keep their organs alive and their heart beating, but not so much that you trigger the VQ mismatch and the Haldane effect.
Precisely.
The protocols have become so precise that some severe COPD patients now carry physical oxygen alert cards in their wallets.
I love those cards.
If they collapse in public, the paramedic can pull out the card and it literally instructs them, my target saturation is 88 to 92%, do not over-oxygenate me. It takes the guesswork out of an incredibly chaotic, high-stakes moment.
When you pull all of this together, the history, the changing demographics, the cellular biology, it paints a picture of a disease whose global burden is only accelerating. The World Health Organization consistently ranks COPD as a top global cause of death. Even as smoking rates decline in some Western countries, our global populations are aging, and urban air pollution is worsening.
It's not going away.
No. The chances that a provider will encounter someone with COPD, or that you, listening to this, will care for a family member with COPD, are incredibly high.
And understanding the why behind the medical rules is what separates a good practitioner from a great one.
Absolutely.
If you only memorize the old hypoxic drive story, the broken fire alarm, you might be paralyzed by the fear of causing high CO2 when a patient is having a heart attack.
Right.
But if you understand the mechanics of VQ mismatch, the shape-shifting of hemoglobin and the Haldane effect, and the hard, real-world data from the Tasmanian ambulance trial, you realize that the clinical rule isn't about fear.
It's about precision.
It's about knowing that titrate, don't withhold, is a tool that allows you to safely walk the tightrope between saving the heart and protecting the lungs.
It serves as the ultimate example of a textbook mechanism being wildly oversimplified for decades, yet the resulting clinical rule, when properly understood and applied, still saves lives every single day.
It really forces us to rethink everything we assume is settled in medicine. We started today talking about the expectation of precision, like reading a broken bone on an X-ray. Give oxygen or don't give oxygen. But today we saw how a reflex as fundamental, as ancient as the human drive to breathe was completely misunderstood by the brightest minds in medicine for nearly half a century.
It's humbling, honestly.
It is. So I want to leave you with a final thought to mull over as you go about your day. If our scientific understanding of something as basic as oxygen could be this muddy and this oversimplified for this long, what other classic foundational rules being taught in hospitals today might be driven by completely misunderstood mechanisms? What other deeply held medical dogmas are just sitting out there waiting for their own Tasmanian ambulance trial to prove them completely spectacularly wrong?
I want you to think back to the very first test you ever took in your entire life. You definitely didn't study for it, And, well, you didn't even know it was happening.
Right, because it happened within literally 60 seconds of you being born.
Exactly. And it was graded on this really rigid scale of 0 to 10.
It is basically the ultimate pop quiz.
Yeah.
And, arguably it's the most high-stakes assessment any of us will ever face, just given what those numbers dictate right after birth.
Yeah. So today we're taking a deep dive into the APGAR score. And whether you're like a nursing student prepping for an exam or just an insanely curious learner, this is going to be your definitive guide to how a newborn is scored in those first 60 seconds. It's such a fascinating topic, too.
It really is. Our mission today is to unpack the surprising, honestly kind of accidental origin of this universal checklist, break down what the 5 criteria actually measure biologically, and, explore how a simple 0 to 10 scale from the 1950s became the center of these massive modern controversies. Yeah, because the APGAR score is almost always taught as this fixed, timeless pillar of medicine. Like you learn the textbook definition, which is a rapid clinical checklist used to summarize a newborn's condition.
Right.
But its identity has shifted so dramatically over the years. I mean, it went from being this marginalized data collection tool to a literal life-saving trigger, and then eventually to a heavily distorted piece of legal evidence.
Which is wild. But before we get into how the test works today, we really need to understand the environment that made it so desperately necessary in the first place. Because if we transport ourselves back to a delivery room in the early 1950s, we are not looking at the hyper-specialized, highly monitored room we expect today.
Not at all. The historical context is, frankly, a bit jarring. Back in the 50s, essentially all clinical attention was trained entirely on the laboring mother.
Just the mother.
Yeah, the obstetrician's job was to deliver the baby and just ensure the mother survived the process, which, was still remarkably dangerous at the time.
Wow, okay.
So once the baby emerged, if it looked pale or limp, or maybe was barely breathing, the medical team would often just set the newborn aside, like sometimes literally on a side table covered with a towel.
Wait, just left on a table? That sounds completely unthinkable now. I mean, you'd expect immediate alarms and a whole rush of pediatricians.
Right, but the paradigm was entirely maternal-focused. And compounding that danger was this complete lack of shared vocabulary for a baby in distress. If a newborn wasn't doing well, a doctor or nurse might just, jot down a vague impression on the chart.
I like what?
Things like poor color, breathing poorly, or literally just looked bad.
Looked bad. That is terrifyingly unscientific. I mean, that tells the next nurse coming on shift absolutely nothing about the baby's actual physiological state.
Exactly. It varied wildly depending on who happened to be looking at the baby, and frequently it wasn't even recorded at all. There was no standardized scale, no objective way to communicate urgency.
And that chaotic, super subjective environment is where we meet our innovator, Dr. Virginia Apgar. She is an absolute legend in medical history.
Oh, absolutely. She was an anesthesiologist at Columbia University's College of Physicians and Surgeons. And in 1949, she became the first woman appointed as a full professor there.
Which, in the mid-20th century medical establishment, is just a monumental hurdle to clear.
Yeah, and her background adds this really fascinating layer to it. She had actually trained as a surgeon in the 1930s, but she was actively steered away from surgery, which was the prestigious male-dominated field, toward the newer, lower-status specialty of anesthesiology.
Her mentor essentially told her that a female surgeon would never find financial backing or patient trust, right?
Exactly. So she took that redirection and just poured her brilliance into anesthesiology. She almost single-handedly built the anesthesia division at Columbia's Sloan Hospital for Women.
Which put her directly in the delivery room for thousands upon thousands of births.
Right. And her entire career as an anesthesiologist was built on vigilance. I mean, when you're keeping someone under anesthesia, your whole job is to watch for the most subtle, minute warning signs of physiological distress.
You're obsessively monitoring breathing, color, pulse.
Yes. So when she saw these pale, limp babies being ignored on side tables, her instinct was to apply that exact same rigorous observational discipline to the very first seconds of life outside the womb.
But according to our sources, she didn't actually set out to invent a global triage tool, right? Like, the most famous newborn assessment in the world started out as a basic data collection spreadsheet for a research paper.
Yeah, she was just trying to answer a really specific scientific question. She wanted to know, Did the anesthesia given to a laboring mother affect how well her baby handled the transition to life?
Okay, so to study that, she needed to standardize her observations.
Exactly. She needed a consistent way to grade the babies so she could compare the data across hundreds of deliveries.
Wait, so you're telling me the most famous newborn triage tool in the world wasn't even meant to be a triage tool? It was just a spreadsheet. That's like a scientist accidentally inventing the modern fire alarm while they were just trying to measure room temperature for like a thermodynamics paper.
That is a great comparison. She was just doing her research. And there's this fantastic origin story that circulates in nursing schools about how she actually finalized the criteria.
Oh, the cafeteria legend?
Yes. The legend goes that a medical student asked Dr. Apgar over breakfast in the hospital cafeteria how one might systematically evaluate a newborn. And she supposedly said, "That's easy. You just take 5 signs and score them," and sketched the whole system out on a scrap of paper right there over her coffee.
Which is amazing. I mean, we don't know for certain if it happened exactly that way, but she did formally publish this system in 1953. And it caught on so rapidly because it solved a massive, complex problem for $0.
Right. It required no specialized equipment. It took under a minute, and it gave every nurse, midwife, and doctor in the room the exact same objective number to shout out.
So she realizes observation is key, but human beings are incredibly subjective. How did she actually force doctors to measure a baby objectively using just their eyes and hands? Let's break down the mechanics of the checklist.
Well, we should probably clear up a massive misconception first.
Oh, right. Because if you ask anyone who works in obstetrics what APGAR stands for, they'll probably list off appearance, pulse, grimace, activity, and respiration. APGAR. Except she didn't name it that.
No, she didn't. The acronym is a total myth, or more accurately, it's a backronym. Virginia Apgar published the original scale under her own surname, purely by coincidence.
A full decade later, right? Around 1963.
Yeah, about 10 years later, a pediatrician named Dr. Joseph Butterfield realized that her name perfectly aligned with the 5 vital signs of birth. So he coined the APGAR mnemonic as a teaching device for his medical students, just to help them memorize the criteria.
That is an unbelievable stroke of historical luck for her legacy. I mean, to have your name literally spell out your invention.
It really is.
So let's look at those 5 vital signs. Each of the 5 criteria gets a score of 0, 1, or 2. And you add them up at the end for a total score out of 10. Let's start with the A in the mnemonic appearance. This assesses skin color, right?
Yes, skin color. Because it's a visual proxy for how well oxygenated blood is reaching the extremities. A score of 0 means the baby is pale or blue all over.
Okay, and 1.
1 point is given if the body is pink, but the hands and feet are still blue. The medical term for that is aquacyanosis. And then 2 points if the baby is entirely pink from head to toe.
So a baby having blue hands, but a pink body, it's kind of like turning on the central heating in a really large house. The core, like the living room where the thermostat is, gets warm super fast, but the radiators in the furthest guest bedrooms take a few minutes to catch up.
That is the exact physiological mechanism at work. Peripheral circulation is the very last thing to fully open up after birth. The newborn's body is naturally prioritizing sending highly oxygenated blood to the brain, the heart, and the lungs.
So the hands and feet can wait.
Exactly.
Which means appearance is the category most likely to produce a perfectly healthy baby who never scores a 10.
Oh, yeah. Generations of nursing students are shocked to learn that a perfect 10 is actually quite unusual. If you were to check your own birth records or, your kids' records, you might see an 8 or a 9.
Most vigorously screaming, incredibly healthy babies score a 9 just because their hands and feet are a little blue for the first couple of minutes.
Right, it's completely normal.
Well, that should relieve a lot of nervous parents reading their charting. So next up is P for pulse, meaning heart rate.
Right. A score of 0 means no heartbeat. 1 point is given if the heart rate is below 100 beats per minute, and 2 points if it is 100 or above. And I really want to emphasize this category because it is the single most heavily weighted piece of clinical information in the entire score.
Because it dictates the immediate response in the room, right? Like, if that heart rate is under 100, you aren't waiting around to finish the rest of the checklist.
Exactly. A low heart rate at 1 minute is the fastest, most reliable trigger for a neonatal resuscitation team to intervene. Long before they evaluate muscle tone or color, if they hear a heart rate dipping into the 80s or 90s, the protocols demand immediate action.
Like clearing the airway and providing positive pressure ventilation?
Yes, immediately.
Okay, moving down the acronym to G-grimace, or reflex irritability. I imagine testing reflexes in a newborn is tricky. You can't exactly ask a 1-minute-old baby to follow a pen with their eyes or, tap their knee with a hammer. You'd have to rely on raw physical stimulus, right? Like tickling their feet.
Close to tickling, yes, but a bit more robust. Classically, the provider will flick the sole of the baby's foot, or they'll observe their reaction when a suction bulb is placed in their nose or mouth to clear fluids.
And how is that scored?
0 points means no reaction at all. 1 point for a weak grimace or a weak cry. And 2 points for a vigorous cry, a cough, a sneeze, or the baby actively pulling their foot away from the stimulus.
So it gives the team a real-time assessment of how intact and responsive the central nervous system is.
Precisely.
Then we have A for activity, which measures muscle tone. 0 points for a completely limp, flaccid baby, 1 point for some slight flexing of the arms and legs, and 2 points for active, spontaneous movement. Now, why is muscle tone such a critical indicator of oxygen?
Because muscle tone is one of the earliest physiological functions to drop when a baby is short on oxygen. The newborn brain is incredibly efficient and honestly ruthless about survival.
What do you mean?
If it senses hypoxia, a lack of oxygen, it will sacrifice skeletal muscle tone just to preserve the remaining oxygen for the vital organs.
Oh, wow. It just shuts off the power to their arms and legs to keep the main generator running.
That's a perfect way to put it. That's why a floppy baby is a universally recognized red flag in obstetric nursing. It tells you the oxygen reserves are critically depleted.
And finally, the R respiration or breathing effort. 0 for no breathing, 1 point for slow, irregular, or gasping breaths, and 2 points for a strong, regular cry.
Which is that lusty, echoing cry every parent in the delivery room is holding their breath to hear.
Yeah.
That sound represents a massive physiological shift. It is literally the sound of fluid being pushed out of the alveoli in the lungs, air rushing in, and the baby's respiratory system taking over the job that the umbilical cord has been doing for the last 9 months.
Incredible. So you tally those up, 0 to 10. Generally speaking, a 7 to 10 is reassuring. 4 to 6 is moderately abnormal. 0 to 3 means serious, life-threatening distress.
Right.
But, it feels completely counterintuitive that a doctor armed with just a stopwatch in their eyes could outperform modern technology. We live in an era of, Apple Watches, instant blood panels, continuous fetal monitoring. You'd assume a visual checklist from 1952 would have been replaced by high-tech lab equipment decades ago.
You definitely assume that. But the clinical data says otherwise. And this brings us to this foundational study published in the New England Journal of Medicine in 2001 by Dr. Brian Casey and his colleagues.
Oh, this is the one where they tested the old-school APGAR score against a highly invasive, high-tech chemical measurement, right? Umbilical cord blood pH. Let's explain what that blood test actually measures, because it sounds like the ultimate objective gold standard.
Biologically, it is. When a baby is deprived of oxygen during labor, their body switches to anaerobic respiration to survive. That process produces lactic acid as a byproduct.
Okay.
So by drawing blood directly from the umbilical cord right after birth and measuring the pH of the acidity, you get a highly precise chemical snapshot of oxygen deprivation.
So it's literally human observation versus a precise chemical blood analysis.
Exactly. And what Dr. Kissey's team found after examining nearly 152,000 births was just staggering. A 5-minute APGAR score of 3 or less predicted neonatal death in the first 28 days of life, better than the high-tech umbilical cord blood pH test.
Wait, really? How does that even make sense? How does a person just looking at a baby beat a definitive chemical analysis of their blood?
It reveals something really profound about the difference between a static data point and dynamic biology. A lab test gives you a number about the chemistry in the blood at 1 exact millisecond in time.
Right.
But a 60-second visual checklist performed by a trained human being captures a holistic picture of transitional physiology. It captures the heart actually pumping, the brain reacting to stimulus, the lungs expanding, the muscles firing.
It synthesizes the entire organism's struggle to adapt to the outside world.
Exactly. Whereas complex chemistry can sometimes miss that bigger picture of resilience.
The word resilience is key there, especially regarding the timing of the score. Because Dr. Apgar originally intended for this to be checked just once, at exactly 1 minute after birth.
Right. But clinicians quickly realized that the 1-minute score essentially reflects how rough the labor and delivery process was. It acts as a baseline trigger. If the score is low at 1 minute, you start clearing the airway, giving oxygen, or beginning compressions.
But the 5-minute score reflects something entirely different. It reflects how well the baby is responding to the help they are being given.
Yes. And today, the medical guidelines reflect that ongoing assessment. If a baby's 5-minute score is still below a 7, the team doesn't just stop scoring. They will assess the baby again at 10 minutes, 15 minutes, and even out to 20 minutes of life, charting the trajectory of the baby's recovery.
That makes a lot of sense. But because this number is universally recorded on every single birth chart, and because it's so easy for anyone to understand, I mean, it's a simple grade between 0 and 10, it inevitably became a weapon outside the delivery room.
Unfortunately, yes. Specifically, it became a focal point in birth injury and cerebral palsy litigation.
For decades, it was a favorite battleground for plaintiffs' attorneys. You can easily imagine the scenario in a courtroom. A lawyer presents a medical chart to a jury of laypeople and says, look, the baby scored a 2 out of 10. That is a failing grade. This is absolute proof of birth asphyxia.
The hospital negligently deprived this baby of oxygen, and that negligence caused this child's permanent brain damage.
Right. And it's incredibly persuasive. We are all conditioned from kindergarten to view a low score as a failure. But you're trying to use a 1-minute snapshot of a rough transition to predict a 60-year lifespan.
It's completely out of context.
It feels like looking at a basketball team having a terrible first quarter, like maybe they're down by 20 points. If you immediately declare that the coach is legally negligent, the players are terrible, and the franchise is permanently ruined, you're ignoring the rest of the game.
That is exactly it. Meanwhile, there are 100 other reasons they might be playing poorly in that specific quarter. The opposing team is shooting unusually well, your star player has the flu, or it's just a random cold streak.
Yeah.
In the medical context, there are dozens of reasons a baby might have a low APGAR score that have absolutely nothing to do with negligent oxygen deprivation.
Such as maternal sedation crossing the placenta, or, congenital anomalies and underlying infection, or just a difficult but entirely non-negligent delivery process. A low score is a symptom, not a definitive diagnosis of the root cause.
Right, and this legal misuse became so widespread and so damaging to the medical community that in 2015, the two biggest governing bodies in the field, the American College of Obstetricians and Gynecologists and the American Academy of Pediatrics, had to formally issue a joint committee opinion.
Oh, wow. What did they say?
They explicitly stated that the APGAR score alone cannot diagnose asphyxia, and it is a poor predictor of an individual baby's long-term neurological outcome.
They essentially had to draw a line in the sand and demand that the legal system stop using a 60-second observation as a lifelong causal verdict.
Yep.
Which actually leads into another major debate surrounding the score. It's fairness to premature babies. If a baby is born weeks or months early, their biology just isn't equipped to ace this test.
Not at all. Premature babies naturally score low because their physiological systems simply haven't finished forming. For example, their nervous system lacks the myelin coating required to send rapid, robust signals to skeletal muscles, so they appear floppy and score poorly on activity.
Makes sense.
And their peripheral circulation is immensely underdeveloped, so they will almost always lose points on appearance.
So a preterm infant might score a 3 or a 4, not because they are in acute life-threatening distress from a botched delivery, but simply because of their sheer developmental timeline. The original APGAR score didn't have a handicap or an adjustment for prematurity. So how does modern medicine account for that without, artificially inflating the score?
Many modern medical centers have adopted what's called a combined APGAR approach. It is a really elegant solution to the context problem. Alongside the numerical score, the medical team notes exactly what resuscitative measures are being given at that exact moment to achieve that score.
Ah, because a baby who is pink, crying, and vigorously kicking all on their own and scoring a 9 tells a fundamentally different physiological story than a baby who is scoring a 9 only because a medical team is actively giving them CPR, intubating them, and pushing epinephrine.
Exactly. The combined score provides the vital context of what it took to get the baby to that state, which perfectly honors Virginia APGAR's original intention.
Right.
She didn't want a tool for judgment. She wanted a tool for intense, rigorous observation of the reality in the room.
Looking back at this incredible journey, it's just amazing. The APGAR score was born from a marginalized female anesthesiologist's desire to bring discipline and attention to a chaotic environment. It was retrofitted with a catchy acronym by a completely different doctor. It stood its ground against modern high-tech lab chemistry, and it's had to be fiercely defended against legal misuse.
And Virginia APGAR's legacy extends far beyond this single score, too. She went on to become a leading advocate for birth defect prevention, doing this groundbreaking public health work regarding rubella and folic acid supplementation through her later career as a director at the March of Dimes.
She even appeared on a U.S. postage stamp in the 1990s and, had a Google Doodle dedicated to her. That is a rare, spectacular degree of public recognition for a clinical scoring rubric that was supposedly sketched out on a scrap of paper over breakfast.
It really is a testament to the enduring power of a simple, brilliantly effective idea.
It really is. And that leaves us with one final thought to mull over today. We've spent this time focused on the APGAR score, but it actually sits alongside other highly specialized human observational tools you might encounter in medicine.
Right, like the Ballard score.
Yeah, the Ballard score, which estimates a premature baby's gestational age just by looking at physical signs like skin texture and ear cartilage. Or there's the Silverman-Anderson score, which grades respiratory distress based purely on observing chest retractions and nasal flaring. It really makes you wonder, in our modern world, where we are utterly obsessed with artificial intelligence, complex predictive algorithms, continuous digital monitoring, and chemical blood labs, what other complex, seemingly unsolvable problems in our daily lives might be solved if we just stopped relying on our technology, stepped back, and created a simple 5-point, 60-second checklist of human observation?
That is a very powerful question to walk away with. Sometimes the most sophisticated and reliable diagnostic tool in the room is simply a trained human being paying very close attention.
The very first test you ever took didn't require a microchip, a battery, or an algorithm. It just required 60 seconds and someone who cared enough to really look at you. Thanks for joining us on this deep dive, and we'll catch you next time.
Imagine for a second that you are, well, in absolute peak physical condition.
Right, like you're a professional athlete at the top of your game.
Yeah, exactly. Maybe even a gold medalist. And you undergo this fairly routine foot surgery, and the operation goes perfectly.
Mm-hmm.
You go home to rest. But then, days later, you find yourself struggling to breathe, literally fighting for your life in an emergency room.
And it's not because of an infection or anything like that.
Exactly. No infection. You didn't tear a muscle.
Oh,
You were
okay.
being taken down by something completely invisible. It's this microscopic threat that formed entirely because you did exactly what you were told to do.
Which is to stop moving.
Right. You stop moving.
It's honestly one of the most counterintuitive paradoxes of the human body. I mean, we are conditioned from childhood to believe that resting is the ultimate form of healing.
Right. You get hurt, you go to bed.
Exactly. But in the context of human circulation, absolute rest can actually be the very trigger for a catastrophic medical event.
And that is the exact paradox we are diving into for you today. Welcome to the Deep Dive. We have this fascinating stack of sources in front of us today. We've got nursing protocols, some wild historical medical cases, and modern clinical trial data.
It's a really comprehensive pile.
It is. And our mission today is to explore this concept, the clot that forms when you stop moving. We are talking about deep vein thrombosis, or DVT. So, okay, let's unpack this.
Let's do it.
Looking at these sources, they draw a very hard line between different types of veins. What exactly is a DVT, and why is it so much more dangerous than just getting a bruise or a surface-level clot?
Well, the distinction is purely anatomical, but it really makes all the difference in the world. A deep vein thrombosis is a blood clot, or a thrombus, that forms inside one of the body's deep veins.
So, like where exactly?
Typically, these are buried deep inside the muscle of your calf, your thigh, or your pelvis. So if you think of the veins just under your skin as small, winding side streets.
Okay, side streets.
Right. If a clot forms there, yeah, it's painful, but it's relatively contained. The deep veins, on the other hand, are the massive high-speed return highways.
Oh, wow.
Yeah, they're responsible for channeling huge volumes of oxygen-depleted blood directly back to the right side of your heart and then immediately into your lungs to get reoxygenated.
Which means if a clot forms on that high-speed highway, there is no detour.
None at all.
If a piece of that clot breaks off, like it embolizes, right? It has a straight, unobstructed shot right into the heart and then into the pulmonary arteries.
Exactly. And when it lodges in the lungs, it completely blocks blood from picking up oxygen.
Right.
That is what we call a pulmonary embolism, or PE.
And that can be instantly fatal.
It can. In modern clinical practice, doctors actually don't even view DVT and PE as separate diseases anymore.
Really?
Yeah, they group them together under the umbrella term venous thromboembolism, or VTE, because honestly, they're just two stages of the exact same disease process. The clot forms in the leg, and it basically finishes its destructive journey in the lung.
Wow. So the entire goal of modern medicine, and really the main through line of all the nursing protocols in our sources today, is early recognition and prevention.
Prevention is everything here.
It's about understanding that something as basic as, bending your knees and walking is literally a matter of life and death. But to figure out how to stop these clots, we first need to understand the blueprint of how they form.
Right.
And reading through these historical documents, I was genuinely stunned to see that the prevailing theory on this isn't from modern times at all. It's from the 19th century.
Yeah, it's pretty wild. Despite all our advanced MRIs and, genetic sequencing, the foundational framework for understanding blood clots was actually established way back in 1856.
1856.
It's incredible. By a German physician and pathologist named Rudolf Virchow. He basically proposed that for a clot to form inside a blood vessel, one of 3 specific conditions had to be met.
And this is Virchow's triad.
Exactly. We still call it Virchow's triad today. It is literally the first thing taught in every single medical and nursing school when covering this topic.
So let's break those 3 conditions down because they really dictate everything else we are going to talk about today.
Okay, so the first pillar of the triad is stasis.
Which means?
This is simply blood flow slowing down to a crawl. The second pillar is endothelial injury, which means physical damage to the smooth, delicate inner lining of the vein itself.
Okay, stasis and injury.
Right. And the third is hypercoagulability. That's a systemic state where the blood's chemistry is altered. So it makes the blood fundamentally primed and eager to clot, even when there is no physical bleeding to stop.
Okay, I want to linger on that first pillar for a second, stasis. Because it really highlights the mechanical engineering of our bodies.
Oh, absolutely.
If you think about the blood in your legs, it has a massive problem to overcome, which is gravity. It has to travel all the way from your ankle back up to your chest. And your heart alone just isn't strong enough to suck that blood upward.
No, it's not. So your body relies on your leg muscles, specifically the calf muscle pump. The soleus muscle in the calf is actually often called the second heart for exactly this reason.
The second heart. I love that. It's basically a biological plumbing system. Every time you take a step, that calf muscle contracts and physically squeezes the deep veins, just shooting the blood upward. And then these little one-way valves inside the vein snap shut so the blood doesn't fall back down. But when that pump is turned off, like when you are immobilized in a hospital bed or sitting at a desk for 12 hours, the blood just pools.
It just sits there.
Right. If a plumbing pipe has a fast-flowing river of water, it stays clean. But if the water stops waiting, all the heavy sediment, the debris, the clotting factors, they all start to settle against the walls of the pipe.
And that sediment settling triggers a microscopic chain reaction. And that cascade is dramatically accelerated if you introduce the second pillar, which was endothelial injury.
So physical damage to the pipe itself.
Exactly. If you undergo surgery like a knee replacement, or if you suffer trauma in a car accident, the lining of your vein is damaged. When that lining breaks, it exposes a protein underneath called tissue factor.
Tissue factor.
Yeah, and tissue factor is basically a biochemical alarm siren. It screams to the rest of the body, hey, we're bleeding, send the clotting crew right now.
Wow.
So even if the bleeding is purely internal, a clot will rapidly build at that exact site of injury.
So, if your pipes are flowing and the pipes aren't physically damaged, you should be completely safe from a clot. Right?
Well, you'd think so.
Right, but that brings up the third part of the triad, hypercoagulability. Because what if the fluid running through the pipes is genetically primed to basically turn into sludge?
Exactly. Sometimes the blood itself is the core problem. Our sources highlight a condition called Factor V Leiden. It was identified in the mid-90s, and it's a genetic mutation that essentially breaks the off switch for blood clotting.
The off switch.
Yeah, so people with this mutation create clots much faster than their bodies can dissolve them. But the thing is, hypercoagulability doesn't have to be genetic. You can acquire it.
How does that happen?
Things like active cancer, systemic inflammation, or severe obesity can all basically dump chemicals into your bloodstream that lower the threshold for clotting.
And looking at this 165-year-old triad, it completely destroys the modern stereotype we have about who actually gets a DVT.
Oh, completely.
I think the average person assumes this is a disease strictly for the elderly or maybe someone confined to a nursing home. But Virchow's triad proves that age is entirely irrelevant if those conditions are met.
The triad does not care how young you are. It doesn't care how fast you can run a marathon. If the scales tip, a clot forms, period.
The story of David Bloom in our sources is just a heartbreaking example of this. He was this incredibly prominent, dynamic NBC News correspondent. And in 2003, during the invasion of Iraq, he was embedded with U.S. forces.
Right.
He was only 39 years old. But he spent days folded up with his knees to his chest inside this cramped Bradley fighting vehicle just bouncing across the desert.
He had almost no ability to extend his legs or activate that calf muscle pump we talked about. The stasis was absolute.
The pump was turned off, the sediment settled, and a massive DVT formed. And it eventually embolized into a fatal pulmonary embolism. I mean, he wasn't elderly, he wasn't sick. It was pure stasis-driven thrombosis caused entirely by his environment.
And we see this phenomenon regularly at the extreme opposite end of the health spectrum, too, like in elite professional athletes.
Right, going back to the surgery example.
Yeah, the tennis legend Serena Williams developed a life-threatening pulmonary embolism following foot surgery in 2011. And she was arguably in the top fraction of a percent of human physical fitness.
Truly peak condition.
But the physical trauma of the surgery created endothelial injury, and the prescribed recovery period created stasis. So 2 pillars of the triad were met, and her incredible fitness just couldn't stop the clot.
Chris Bosh is another prime example from the sources. He was an NBA All-Star, constantly moving, but his career was tragically cut short by recurring blood clots.
Yeah, he had an underlying hypercoagulable state.
So you combine that with the constant microscopic physical trauma of professional basketball and the endless hours sitting on airplanes, and boom, you trigger the triad.
Exactly. And if we connect this to the bigger picture, the realization that prolonged stillness is deadly forces us to look back at medical history with a lot of horror.
Oh, totally.
Because for a very long time, the medical establishment was prescribing the exact thing that was killing people.
The era of strict bed rest. Reading these older protocols, it is wild how universal it was.
It was the standard for everything.
Right. For much of the 20th century, if you had a baby, you were on strict bed rest. Heart attack, weeks of bed rest, surgery, do not move a muscle.
The logic was that a recovering body needed to conserve every single ounce of energy to heal tissue, and moving might, rip open surgical stitches.
It was incredibly intuitive logic at the time.
It was. But the outcomes data eventually revealed an absolute disaster. Doctors were noticing horrifying rates of sudden death in patients who seemed to be recovering perfectly from their initial surgeries.
And they didn't know why.
Not at first. It took decades of autopsies and outcome tracking to realize that the bed rest was allowing massive clots to form in the deep veins. Orthopedic surgeons were actually some of the very first to sound the alarm on this, particularly as joint replacements became more common in the mid-20th century.
Because replacing a hip or a knee is basically a worst-case scenario for the triad, right?
Yeah.
You have massive bone and tissue trauma causing endothelial injury, plus the patient can't walk.
Precisely. The DVT rates in early orthopedic surgeries were astronomical, and this realization forced one of the most profound paradigm shifts in modern nursing and medicine.
Right.
Immobility went from being a prescribed treatment to a recognized pathogen. Today, if you wake up from a major surgery, a nurse is likely going to have you standing up and shuffling down the hallway within hours. Early mobilization is now the ultimate protective standard.
But wait, let me push back on that for a second.
Sure.
If getting up and moving is the cure, if activating the calf muscle pump sweeps the sediment away, why do the nursing protocols in our sources still mandate heavy blood thinners for patients in the hospital?
That's a great point.
I mean, if I am walking the halls, why are they injecting me with anticoagulants? Doesn't the walking basically cancel out the need for the drugs?
It raises an important question, but the flaw in that logic goes right back to Virchow's triad. You cannot view the triad as a single problem with a single solution.
Ah, okay.
Walking down the hallway absolutely solves the stasis problem. But what if you just had major abdominal surgery? You still have immense endothelial injury that is actively calling for clotting factors. Or what if you are hospitalized for cancer treatment? Your blood is still hypercoagulable.
So the movement only fixes 1/3 of the blueprint.
Yes, exactly. Walking cannot fix a chemical imbalance or a torn vein lining, and that is why mechanical prophylaxis like walking and chemical prophylaxis like blood thinners are not substitutes for one another.
They work together.
They do. Medications like heparin or the newer direct oral anticoagulants work synergistically with movement. The movement keeps the blood flowing, and the medication alters the blood chemistry to raise the threshold for clotting, preventing that tissue injury from triggering a massive response.
Okay, so what does this all mean for things like compression socks? Because for years, the conventional wisdom was just to put tight stockings on immobilized patients to keep the pressure up and prevent stasis.
Right.
It seems like a perfectly logical physical solution, right?
It does seem logical, and for decades, graduated compression stockings were used as this blanket preventive measure for almost everyone in a hospital bed. But the medical community eventually learned that you cannot just slap a mechanical Band-Aid on a complex system without testing it rigorously.
And that's where the CLOTS trial comes in.
Exactly. The UK CLOTS trial in the 2000s completely upended this assumption.
So, what did the trial actually test?
They looked specifically at stroke patients. Now, stroke patients are highly vulnerable to DVT because they often suffer from paralysis and simply cannot move their legs.
So, ultimate stasis.
Right. The researchers assumed thigh-length compression stockings would artificially squeeze the veins and prevent clots, but the data showed the exact opposite of what they hoped.
Wait, really?
Yeah. Not only did the stockings fail entirely to reduce DVT rates in these stroke patients, but they also actively caused harm. The constant tight pressure on fragile skin led to terrible ulcers, skin breakdown, and even restricted arterial blood flow.
Oh man, that is a massive backfire. Trying to passively squeeze the leg ended up causing a whole new set of injuries.
It forced a total reevaluation. It taught clinicians that you just cannot apply a universal passive fix to every single patient. Prevention requires an active, tailored approach based on individual risk factors, not just handing out tight socks.
And the urgency of getting that prevention right is magnified by how sneaky these clots actually are. Because even with early walking and even with blood thinners, a clot can still form.
They absolutely can.
And the most terrifying detail in these sources isn't just that they form, but that they often form in complete silence. There is this huge misconception that a DVT will always present as this massive, red, swollen, throbbing leg.
And that expectation is incredibly dangerous. While a classic DVT certainly can cause swelling and pain, a huge percentage of them are completely asymptomatic.
Just zero symptoms.
Zero. Or the symptoms are so mild, just a vague ache or a feeling of heaviness, that a patient will completely dismiss it as a muscle cramp or a pulled hamstring.
Wow.
Very frequently, the absolute first sign that someone has a DVT is when a piece of it breaks off, travels to the lungs, and they suddenly collapse with crushing chest pain and shortness of breath.
The silent nature of the disease is just deeply unsettling. But historically, that silence has also served as a very dark warning sign for other hidden diseases. There was a story in our sources about Armand Trousseau, a French physician in 1865.
Trousseau is a fascinating figure. He was a brilliant diagnostician studying thrombophlebitis, which is basically inflammation and clotting in the veins. And during his practice, he noticed a very strange pattern in a subset of his patients.
What did he see?
They would develop unexplained blood clots that would appear in one leg, resolve, and then spontaneously appear in an arm or the other leg.
Okay, so just popping up everywhere.
Right. These migrating, recurring clots were happening without any obvious stasis or injury.
So he realized he was looking at severe hypercoagulability.
Yes, and he made a groundbreaking connection. He discovered that this specific pattern of migrating clots was often the very first visible symptom of an occult or hidden visceral cancer, most notably stomach or pancreatic cancer.
Because the tumor is changing the blood.
Exactly. The tumor itself was secreting chemicals that threw the clotting cascade into absolute overdrive. Today, this phenomenon is still taught in medical schools as Trousseau's sign of malignancy.
But the truly chilling part of the story is how his research ended.
It is incredibly tragic, honestly. Just 2 years after publishing his findings in 1867, Trousseau felt a strange ache in his own body. He observed his own veins and saw the very pattern of migrating blood clots he had just documented.
Oh my God.
Yeah, because he wrote the paper on it, he knew instantly what it meant. He used his own physical symptom to diagnose himself with advanced pancreatic cancer, and he succumbed to the disease just months later.
The clots were the smoke and the hidden cancer was the fire. It is an amazing testament to the power of clinical observation. But obviously, how we look for that smoke has evolved a lot, because back in the 1940s, a doctor trying to figure out if you had a clot would basically just physically squeeze your leg.
You were talking about Hohmann's sign.
Right, the old bedside test where the doctor forcibly flexes your foot upward toward your shin to see if it causes deep pain in your calf.
Yeah, it was the gold standard physical exam for decades. But modern medicine completely abandoned it, and for very good reason. First of all, it is essentially useless from a diagnostic standpoint.
Because almost anything can make your calf hurt when you stretch it like that, right?
Yeah.
Like a cramped muscle or a ruptured cyst.
Exactly. The sensitivity and specificity are terrible. But more importantly, performing Hohmann's sign is actively dangerous.
How so?
Think about the mechanics. You have a fresh, gelatinous blood clot precariously clinging to the wall of a vein. Then a doctor comes along and aggressively stretches and squeezes the muscle surrounding that vein.
Oh, no.
Yeah, the physical manipulation can actually dislodge the clot right then and there, causing the exact pulmonary embolism the doctor is trying to diagnose.
It's literally squeezing a live bomb to see if it's ticking. So Hohmann's sign is out. Today, clinicians use a much more sophisticated algorithm. Our sources highlight this three-step pathway. First, instead of guessing, they use the Wells score, which is basically a strict mathematical checklist.
Right.
It assigns points for things like recent surgery, swelling, or cancer history to determine the mathematical probability that a clot is present. Then, they use a D-dimer blood test.
The D-dimer is fascinating. When a clot forms, your body immediately starts trying to break it down. As the clot degrades, it sheds these microscopic protein fragments into the bloodstream.
And the test looks for that.
Exactly. The D-dimer test detects that specific biochemical wreckage. So if the D-dimer is completely negative, you can be fairly certain there is no active clotting going on.
But if it is positive, you move to the ultimate tool, which is the compression ultrasound. It uses sound waves to actually visualize the blood flowing through the deep veins in real time. And here's where it gets really interesting, because this advanced ultrasound technology actually sparked a massive ongoing debate in the medical community.
It absolutely did.
Yeah.
Before ultrasound, a clinical DVT was just a DVT, and it was treated aggressively. But ultrasounds became so sensitive that doctors could suddenly pinpoint exactly where the clot was located.
Right.
This created a new anatomical distinction. They asked, was the clot proximal, meaning high up in the large veins of the thigh or pelvis? Or was it distal, meaning it was tiny and isolated solely in the deep veins of the calf?
And that matters because a clot in the calf has a much longer, more difficult journey to get to the lungs than a clot in the thigh, right?
Precisely. The data eventually showed that distal calf clots have a remarkably low rate of embolizing. In fact, the body's natural enzymes often just dissolve them over time without any medical intervention whatsoever.
Wow.
And this realization caused a massive fracture in standard protocols. Historically, the moment a clot was found anywhere, the patient was put on powerful blood thinners for months, but blood thinners carry a significant risk of severe internal bleeding.
So doctors started asking, like, are we risking a brain bleed to treat a tiny calf clot that might never cause a problem?
Exactly. This led to a controversial new approach called watchful waiting for isolated distal clots.
Watchful waiting.
Right. Instead of prescribing dangerous anticoagulants, some clinicians now opt to simply perform serial ultrasounds every few days. They just watch the clot. If it doesn't grow or move upward toward the thigh, they never medicate it.
That's a huge shift.
It was considered medical heresy 20 years ago, and professional hematology guidelines are honestly still actively debating exactly when to treat and when to watch.
It shows just how incredibly nuanced our understanding of blood clotting is becoming. And that nuance isn't just for hospital wards. It applies to all of us living our daily lives. Because the triggers for Virchow's triad are hiding in our everyday routines. For example, economy class syndrome.
Yes. The World Health Organization actually launched a massive study called the RIGHT Project to investigate that specific phenomenon.
And the data they found is just stark. I mean, if you were listening to this deep dive right now while sitting on a flight that is longer than 4 hours, your risk of developing a venous thromboembolism has roughly doubled compared to when you were just waiting in the terminal.
Because your calf pump is off.
Exactly. The pump is off, and the dry cabin air is dehydrating you, making your blood slightly thicker. So it is pure stasis combined with mild hypercoagulability.
And everyday life events affect that hypercoagulability too. Taking estrogen-based birth control pills, undergoing hormone replacement therapy, or simply being pregnant prompts the liver to produce more clotting factors.
Which is natural, right?
It is. It's the body's evolutionary way of preparing for the bleeding of childbirth, but it dramatically increases the risk of a DVT.
And then there are massive, unpredictable global events that throw the entire clotting cascade into chaos. The COVID-19 pandemic is heavily featured in these clinical notes.
The vascular impact of COVID-19 was a terrifying surprise to the medical community in 2020. Clinicians were seeing patients whose lungs were full of microclots and whose legs were developing massive DVTs, even when those patients were already on high doses of preventive blood thinners.
Wait, how is a respiratory virus causing blood clots in the legs?
It comes back to endothelial injury and inflammation. COVID-19 triggered what we call a cytokine storm, a massive uncontrolled inflammatory response by the immune system. The virus and the inflammation aggressively attacked the inner lining of the blood vessels throughout the entire body. So the body misinterpreted this massive systemic inflammation as widespread physical trauma.
Oh, wow. So it thought it was bleeding everywhere.
Exactly. It essentially panicked, thinking it was bleeding out, and dumped massive amounts of clotting factors into the blood. It created a hypercoagulable state so aggressive that standard drugs just couldn't stop it.
That is terrifying. But medical research also delivers incredible positive surprises regarding how our vascular system works. The Jupiter trial from 2009 is a perfect example of this.
No, the Jupiter trial is one of my favorite anomalies in modern medical research.
Tell us about it.
It was a massive multinational study looking at a drug called rosuvastatin. Statins are widely known and prescribed exclusively to lower bad cholesterol. The goal was to see if the statin prevented arterial plaques from bursting and causing heart attacks.
But they accidentally discovered a massive benefit for the venous system.
Yeah. They did. When they analyzed the data, they found that the patients taking the statin had a dramatic, statistically significant reduction in venous thromboembolism.
Which makes no sense.
It confused everyone at first because cholesterol plaques do not form in veins, they only form in arteries. So how is a cholesterol drug preventing DVTs?
Right. What was the actual mechanism there?
It turns out statins don't just lower cholesterol, they're also powerful anti-inflammatory agents. They soothe the endothelium, the inner lining of the blood vessels.
Okay.
By reducing systemic inflammation, the statin essentially calmed the vein walls down, preventing them from sending out those chemical distress signals that trigger a clot. It was a total accident of research that proved how interconnected our cardiovascular systems really are.
It is incredible how a drug built for one side of the circulatory system ended up protecting the other just by calming the environment.
Yeah.
So as we pull all these threads together, the core takeaways from this massive stack of research are incredibly clear.
Very clear.
First, Virchow's triad stasis, endothelial injury, and hypercoagulability is the ultimate blueprint. Every risk factor you will ever face traces back to one of those three pillars. Second, bed rest is no longer the cure. It is a profound risk. Early, active movement is the gold standard of prevention.
Movement is medicine.
Exactly. And finally, you cannot wait for obvious pain to warn you because a clot can be utterly silent until the exact moment it threatens your life.
And as you think about the silent, lingering nature of this disease, I want to leave you with a final concept to ponder that illustrates the true long-term stakes of a deep vein thrombosis.
Okay.
It is a condition called post-thrombotic syndrome. We focus so heavily on the immediate life or death threat of the clot breaking off and traveling to the lungs. But what happens to the leg itself after the crisis is over?
That's a good question.
Even if you were diagnosed early, even if you are given the right blood thinners, and even if the clot completely dissolves, the physical trauma of that clot sitting in your vein can permanently destroy those tiny, delicate one-way valves we talked about earlier.
Oh, no.
And when those valves are ruined, they never grow back. The blood can no longer fight gravity efficiently. It constantly falls backward and pools in your lower leg.
Wow.
For the rest of your life, you can be left with chronic, heavy swelling, persistent pain, and irreversible skin discoloration. It is the permanent structural footprint that a clot leaves behind long after it is gone.
Oh.
And it is the ultimate reminder that the true goal of medicine isn't just to survive a blood clot. The goal is to never let it form in the first place.
So you finish a workout, grab a smoothie, and throw a banana in the blender.
So it sounds like a pretty standard morning.
Right. You drink it, toss the peel, and you probably don't give it a second thought. It's just, basic, mundane nutrition.
Yeah, wholly harmless.
But if you step out of your kitchen and into an emergency room, that exact same mineral is suddenly the primary ingredient used to instantly, irreversibly stop the human heart.
Which is a pretty terrifying pivot when you think about it.
It really is.
Yeah.
So, we are talking about potassium today. Welcome to the deep dive.
Glad to be here.
Our mission today, for you listening, is to unpack potassium imbalance from like a clinical and nursing perspective. We're looking at this comprehensive medical text that covers the physiological first principles, the diagnostic cascades, the history, and really just how this one everyday electrolyte turns deadly.
Yeah, and, while potassium imbalance might sound like standard dry textbook material, the underlying mechanisms here reveal a biological balancing act that is incredibly fragile. It's highly contested, it's easily misunderstood, and it really requires us to completely rethink what it means when a lab test tells you that your blood is perfectly normal.
Yeah, and that paradox you just mentioned is exactly where I want to start. Because to understand how potassium can stop a heart, we have to understand why doctors and nurses struggle to even measure it accurately in the first place.
It's surprisingly difficult.
Right. So the standard normal range for potassium in your blood, which is serum potassium, is usually listed as 3.5 to 5.0 milliequivalents per liter.
Exactly.
And if you drop below 3.5, you have hypokalemia. Go above 5.0, you have hyperkalemia. So on paper, it sounds pretty binary, like you're either in the safe zone or you aren't.
Yeah, but the problem with treating it as a binary is that the normal range is really just a population statistic.
Okay.
It's not this strict physiological cutoff that applies to every single human body in the exact same way.
So it varies from person to person.
Massively. A chronically ill patient, for instance, someone with long-standing kidney disease, they might walk around with a potassium level of like 5.8 for years.
Why?
And they might have zero symptoms, perfectly fine.
I guess because their body has had time to sort of adapt to that higher baseline over months or years.
Precisely. The adaptation is key there. But if you take a perfectly healthy person with a normal heart, and if their potassium suddenly drops from a 4.0 to a 3.0 in a matter of hours...
Like from a stomach bug or something?
Yes, severe vomiting or maybe a new diuretic medication, that rapid rate of change can trigger life-threatening arrhythmias.
Oh, wow.
So the absolute number on the lab report matters significantly less than the rate of change or, the patient's baseline kidney function.
Right. Context is everything. So let's unpack the math behind this, because there's a physical reality here that the sources highlight as a major stumbling block for medical students. And that is the 2% rule.
Right, the 2% rule. This is crucial.
Yeah, so when a phlebotomist draws your blood to check your potassium, they're only measuring about 2% of the total potassium in your body.
Exactly.
And the remaining 98% is just hidden away, like locked inside your cells.
Yeah, and that distinction changes everything about how we interpret lab results. The blood draw is only looking at the serum. It is an incredibly poor proxy for total body potassium.
It's basically like judging someone's entire net worth by only looking at the cash they currently have in their wallet.
That is a great way to put it.
Like, they could be completely bankrupt. Their total body potassium might be entirely depleted from weeks of illness, but the wallet looks full because they just went to the ATM.
Right.
The body just shifted whatever potassium it had left out of the cells and into the blood to compensate, just to keep the serum level looking okay.
Yeah, that analogy captures the illusion perfectly.
Yeah.
I mean, the body will fiercely protect that 2% in the blood to keep the heart beating, even if the cellular reserves are entirely empty.
That's wild.
And the deception actually goes both ways.
Yeah.
You can also have a terrifyingly high serum potassium reading that is completely fake.
Wait, how can a lab result be fake? Like, if the machine reads a high number, the potassium has to be in the blood, right?
Well, it is in the blood when the machine tests it, but it wasn't in the blood when it was actually circulating in the patient.
Oh, weird, okay.
This is a phenomenon called pseudohyperkalemia. So imagine the phlebotomist uses a needle that is too small, or they leave the tourniquet on the arm for way too long.
Okay, so a bad blood draw.
Right. The physical pressure and that tight squeeze can actually cause the red blood cells to physically rupture inside the plastic collection tube.
Oh, I see. And because 98% of potassium lives inside the cells, when those red blood cells burst open in the tube,
they spill all of their hidden intracellular potassium directly into the serum sample.
wow.
So the lab machine analyzes the fluid and spits out a critically high panic value, but the patient sitting in the waiting room actually has completely normal circulating potassium.
Which means if a doctor or nurse just treats the number on the screen and aggressively lowers that patient's potassium, they could accidentally cause a fatal heart arrhythmia.
Exactly. It really highlights why you have to treat the whole patient, not just the lab value.
Man. But it also makes me wonder, if measuring this stuff is so incredibly deceptive and tricky, how did we ever figure out its life and death importance in the first place?
It's a great question. And to understand that, we actually have to step out of the modern hospital entirely.
Okay, where are we going?
The origins of this discovery take us back to London in 1883. A British physician named Sidney Ringer was working at University College, and he was studying isolated frog hearts.
Isolated frog hearts.
Yeah, he was trying to figure out how to keep them beating outside of the body in a saline solution.
Which sounds like something straight out of a mad scientist novel, honestly.
I mean, it was pioneering physiology at the time. Ringer was meticulously testing different mixtures, but the real breakthrough came from a happy accident by his lab assistant.
Oh, I love a good lab accident.
Yeah, right. So the assistant was supposed to use distilled water to make the saline solutions, but instead they just used London tap water.
Wait, London tap water, which is notoriously hard water, meaning it's just full of minerals.
Exactly, full of calcium and potassium.
Ah,
And Ringer noticed that the frog hearts bathed in the tap water solution kept beating for hours, while the ones in the pure distilled water solutions died almost immediately.
that is incredible.
Yeah, so through trial and error, he realized that the heart would only maintain its rhythm if it was bathed in a very specific, delicate ratio of sodium, potassium, and calcium.
Okay.
If he added too much potassium relative to the calcium, the heart went completely flaccid. It just relaxed and stopped beating entirely.
So Ringer essentially founds electrolyte cardiology by accident in 1883.
Basically, yeah.
But the sources mention this massive gap in the timeline here. Like, we used his mixture, what became known as Ringer's solution, for decades in medicine without actually knowing why it worked.
Yeah, the 70-year gap is one of the most fascinating delays in medical history, honestly. I mean, Ringer proved that the ratio governed the heart's electrical behavior through pure empirical observation.
Right, he saw it happening.
Right. But the scientific tools of the late 19th century were just not advanced enough to see the molecular machinery at play.
They didn't have the microscopes for it.
Exactly. The mechanistic explanation required the invention of better technology, and eventually a Danish scientist named Jens Christian Skou in 1957.
Okay, so what was Scow looking at that Ringer couldn't see?
Well, Skou was researching crab nerve membranes, of all things.
Perhaps.
Yeah, he was looking for the physical engine that controls cellular electricity, and he ultimately discovered the sodium-potassium ATPase pump.
Okay, the pump.
Yes, this is an actual molecular machine that sits embedded in the membrane of almost every cell in your body. It uses one molecule of ATP, which is cellular energy, to actively trade 3 sodium ions out of the cell for 2 potassium ions brought into the cell.
Oh, so he found the actual mechanism that maintains that 98-2 ratio we talked about earlier.
He did, yeah. And it actually earned him a Nobel Prize in 1997.
Wow.
But the clinical bridge here is even more profound, because around the exact same time Skou was mapping the pump in Denmark, Willem Kolff was refining the artificial kidney.
The dialysis machine.
Right. So for the first time, doctors treating kidney failure patients who were dying because their bodies couldn't excrete potassium could hook a patient up to a machine, systematically scrub the excess potassium from their blood, and literally watch the patient's electrocardiogram, the ECG, stabilize in real time.
That must have been like magic to see.
It was. They were finally mapping Skou's invisible cellular pumps to the visual electrical tracings of the human heart.
And that connection brings us to the core of the clinical text, right? The cardiac cascade. Because once you know this molecular pump exists, you can understand exactly what happens to a human heart when that potassium gradient just collapses.
Exactly. And the foundation of that collapse is the resting membrane potential.
Okay, break that down for us.
So every single heart muscle cell, every cardiomyocyte, maintains a negative internal charge of roughly negative 90 millivolts at rest.
So the inside of the cell is deeply negative compared to the outside.
Yes. And that negative 90 millivolts exists almost entirely because potassium is highly concentrated inside the cell.
Right, like 140 milliequivalents inside versus just the 3.5 to 5.0 outside.
Precisely. You can think of it like a massive hydroelectric dam.
Oh, like that.
Yeah, that steep gradient, that huge difference in concentration creates immense potential energy.
Right.
So when the cell needs to fire, it opens the floodgates, the ions rush across, and you get a crisp, clean electrical spike that travels in an organized wave across the heart, which causes a heartbeat.
But if the potassium outside the cell starts rising, like if the water level outside the dam gets too high, the pressure difference just drops.
Right. The gradient is compromised.
And this leads to a very specific sequence on an ECG that medical professionals have to memorize, right?
Yeah.
Because it literally predicts cardiac arrest.
Yeah, it's known as the hyperkalemia ECG cascade. As serum potassium rises to about 5.5 to 6.5, the first thing you see are the T waves on the monitor becoming incredibly tall and sharply pointed.
Okay, the peaked T waves.
Exactly. They call them peaked or tented T waves.
And if it continues to climb, hitting like 6.5 to 7.5, the sources say the P wave flattens out and the PR interval gets longer.
Right, because the upper chambers of the heart, the atria, are physically struggling to initiate the electrical signal.
Wow. And then at 7.0 to 8.0, the QRS complex widens.
Yeah.
And the QRS represents the main pumping chambers, the ventricles, right?
That's right. Because the electrical gradient is so severely compromised at that point, the electrical signal physically struggles to travel through the heart tissue.
So it's literally just moving sluggishly.
Exactly. It moves sluggishly. And because it takes longer to finish its path, it literally draws a wider, fatter line on the EKG paper over time.
That makes perfect sense. Like the widening isn't just some random shape. It's a direct visual representation of the electricity slowing down.
Exactly.
And then if you go above 8.0 or 9.0, you get the absolute nightmare scenario. The widened QRS merges with the T wave into what's called a sine wave pattern.
Yeah, it just looks like a smooth, undulating wave on the screen.
Which is terrifying.
It is. And within minutes, that usually degenerates into ventricular fibrillation or just flatline asystole.
So practically speaking, for the patient in the bed, does a medical team wait for the lab results to confirm this cascade?
Oh, they absolutely cannot wait.
Really?
Yeah, emergency departments treat a new peaked T wave combined with the right clinical context as a life-threatening emergency before the blood draw ever comes back from the lab.
Wow, just acting on the visual alone.
You have to. You cannot afford to wait 45 minutes for a centrifuge to spin down a sample when the electrical stability of the entire cardiac system is literally unraveling on the monitor in front of you.
It really emphasizes how fragile this gradient is naturally.
Yeah.
Which makes the hook we started with even more terrifying, honestly.
Yeah.
Because the starkest illustration of this system failing isn't an accident. It's the standard U.S. 3-drug lethal injection protocol developed in the late 1970s.
It is, yeah. The pharmacology of that protocol relies entirely on exploiting the resting membrane potential.
Right.
The third and final drug given is a highly concentrated solution of potassium chloride, administered rapidly and undiluted.
So it artificially drives the serum potassium up so incredibly fast that the heart's electrical conducting system is wiped out instantly.
Exactly. It induces massive hyperkalemia to produce immediate cardiac arrest.
Wow.
It is a dark but irrefutable demonstration of exactly what clinical teams are trying to prevent. And it is the precise reason why, in any hospital setting, IV potassium is classified as a high-alert medication.
Right, because of the danger.
A nurse will never, ever push undiluted potassium rapidly into a patient's vein. It is always heavily diluted and given slowly over hours.
That makes total sense. But intentional streams aside, the sources also dive into how medications interact with this system in deeply paradoxical ways.
Yes.
Like the classic example in the text is the digoxin paradox.
Oh, digoxin is a venerable drug. I mean, it's been used for decades to treat heart failure and rhythm problems. And nursing students are taught very early on that if a patient is taking a daily dose of digoxin, having low potassium makes the drug more toxic and dangerous.
But then the text brings up research from 1973, Charles Bismuth's criteria, showing that in a massive acute overdose of digoxin, the strongest predictor of whether the patient will live or die is actually high potassium,
Right.
which feels completely backwards.
It does feel backwards, but the clinical data backs that up entirely. You just have to look at the mechanism to understand why the context flips.
Okay, so how does that work?
Well, digoxin works by actively binding to and inhibiting that very same sodium-potassium ATPase pump we talked about earlier.
Oh, so a normal dose of digoxin is almost like a minor traffic jam.
Right.
It slows down the cellular pumps just enough to help a failing heart contract a little harder and pump more efficiently.
Exactly.
But if a patient takes a massive overdose, they've essentially thrown a spike strip across a 10-lane highway.
Right.
Like every single cellular pump shuts down.
The pumps are completely paralyzed, so
Yep.
the potassium trying to get back into the cells just piles up in the bloodstream.
Oh, man.
The serum potassium rises sharply above 5.5, and the context totally flips from a low potassium problem to a high potassium emergency.
Wow.
And without administering the specific antidote, which is called DigiFab, to unbind the digoxin from the pumps, the mortality rate is incredibly high.
That is fascinating. And it's not just external drugs causing these extremes, right? Our own internal hormones play this game too, specifically the renin-angiotensin-aldosterone system.
Yeah, aldosterone is a hormone that tells your kidneys to hold on to sodium and get rid of potassium.
Okay.
So if your body develops a tumor that makes too much of it, a condition called Conn's syndrome, you end up urinating away your stores and developing severe hypokalemia. But if you have Addison's disease, where your adrenal glands are damaged and don't make enough aldosterone, your kidneys hold on to potassium, leading to hyperkalemia.
It all just comes back to that delicate balance.
Always.
Which brings us to perhaps the most unsettling part of the source material, honestly. The medical mirages. Because this balance is so precarious, Our attempts to fix it in emergencies haven't always been perfect. Let's talk about the illusion of treatment.
This is a really important concept.
So when a patient comes into the ER with severe life-threatening hyperkalemia, the standard emergency code involves pushing high-V insulin along with glucose and sometimes giving albuterol, right?
Pushing calcium gluconate to stabilize the heart muscle directly so it doesn't fibrillate. Yeah.
Right, so the calcium protects the heart, but with the insulin and glucose, wait, the sources say this doesn't actually remove any potassium from the body?
It doesn't.
So a medical team can run a code, give these drugs, the monitor goes back to green, the lab says their potassium is normal, but the potassium's just hiding.
Exactly. We are essentially bailing water out of a sinking boat and throwing it into a closed cabin.
Oh, geez.
We haven't patched the hole, and we haven't removed the water from the ship. Insulin and albuterol simply rev up the sodium-potassium pumps, so they artificially force the excess potassium out of the blood and shove it temporarily back inside the cells.
You're just buying time.
You are buying maybe a few hours to protect the heart from that deadly ECG cascade.
Right.
But if you don't follow up with therapies that actually remove potassium from the body, like dialysis, diuretics, or gastrointestinal binders, that potassium will seep right back out of the cells into the blood, and the patient will be right back in lethal danger.
So how do we actually remove it? Because historically, the text points out that even our methods for removing potassium have been fraught with massive errors.
Yeah, they have.
Like the Kyaxylate disaster, for example.
Right. So introduced in the 1950s, sodium polystyrene sulfonate, known by the brand name Kyaxylate, is a resin you swallow. It binds to potassium in your gut so you can excrete it in your stool. And for over half a century, it was the absolute standard of care for chronic hyperkalemia, often mixed with a sugar called sorbitol to induce diarrhea and prevent constipation.
But from the 1980s onward, case reports started trickling in, linking this Kyaxylate-sorbitol combo to intestinal necrosis.
Yes.
It was literally causing the tissue of the bowel to die, especially in vulnerable patients who had just received kidney transplants.
And despite those early warnings, it took until 2013 for the FDA to issue a formal, rigorous warning about the risk of bowel necrosis.
2013.
Yeah. Clinical practice finally had to shift to newer, safer gastrointestinal binders like Pataromer. But it's a sobering proof that just because a treatment is considered the undisputed standard of care for 50 years doesn't mean it is perfectly safe.
Or free from devastating side effects.
Exactly.
It really forces you to question your assumptions.
And speaking of questioning assumptions, before we wrap up, the sources highlight some major misconceptions that still float around even among healthcare workers.
Oh, there are plenty. Let's do a quick myth-busting. Misconception 1. Bananas are the ultimate high-potassium food.
Culturally famous, yes. But nutritionally, they are entirely mid-tier.
Really?
Yeah, a medium banana only has about 400 to 450 milligrams of potassium. If you are actually trying to replenish dietary potassium, you should be eating potatoes with the skin on, white beans, spinach, or avocados. All of them significantly beat the banana.
Wow, good to know. Okay, misconception 2. High potassium always causes obvious symptoms like muscle cramps before it gets dangerous.
Dangerously false.
Yeah.
Many patients with severe hyperkalemia levels well above 6.5 or 7.0 feel absolutely nothing.
Nothing at all.
Or maybe just a vague, non-specific sense of fatigue right up until the exact moment their heart goes into a sudden, lethal arrhythmia. It is a silent killer.
Which is why routine lab monitoring is so critical. You simply cannot wait for symptoms.
Exactly.
For anyone listening who isn't running a code in an ER, this might feel a bit abstract, but the reality is that potassium imbalance sits at the intersection of almost every common chronic condition in modern healthcare.
Absolutely. Millions of people are taking medications every single day that alter this invisible gradient.
Right.
If you take an ACE inhibitor for your blood pressure, or an ARB, or a potassium-sparing diuretic like spironolactone, those drugs actively raise your serum potassium.
And if you take a loop diuretic, like furosemide, it actively flushes it out of your system.
Right.
So every time a doctor adjusts your meds, they're doing a complex potassium risk assessment in their head. It's the very reason they obsess over your routine blood panels.
It really is.
But beyond the medications and the ECG changes, I want to leave you with one final provocative thought from the source material to mull over on your own.
Oh, the interconnectedness of the human body goes far beyond just the kidneys and the heart.
Exactly. We didn't even have time to dive deeply into acid-base balance, but here is the core idea. Potassium and hydrogen, the tiny ion that makes your blood acidic, compete for the exact same doors into your cells.
Right. It's a constant microscopic trade-off.
When one goes in, the other has to come out to maintain the electrical charge. Think about the implications of that. A change in your breathing rate, say hyperventilating during a panic attack,
Yeah.
alters the acidity of your blood.
Yeah.
And just by shifting the acid in your blood, you can literally alter the electrical charge of your heart, because your body will evict potassium from your cells just to make room to hide the excess hydrogen.
It's wild.
We tend to treat the body like a series of separate, neat compartments. You know, the lungs over here, the kidneys down there, the heart in the middle. But at the molecular level, they're all playing the exact same high-stakes game of musical chairs.
It's a beautiful, terrifying system. I mean, the flutter of a lung can dictate the rhythm of a heart.
It really is. So the next time you peel a banana or look at a routine lab report, take a second to appreciate that you aren't just looking at a mundane checkbox. You are looking at the raw electrical voltage that keeps you alive. Thanks for joining us on this deep dive. Imagine stepping into a hospital room back in September of 1948. You're looking at a 29-year-old woman, and she is just completely bedridden.
Right. She had severe rheumatoid arthritis.
Yeah, her joints are so destroyed, so inflamed that she can barely even move. Then her doctor walks in with a syringe containing this brand new, highly experimental compound. He gives her an injection, and, well, within days, she is actually walking around the ward.
Which is almost unbelievable when you think about it.
Totally. By her third dose, she has essentially checked herself out and is literally downtown going shopping. I mean, it looks like absolute magic, right? Like a switch was just flipped.
It really was. I mean, the profound, dramatic transformation of that single patient, it completely shifted the entire trajectory of modern medicine. It established a whole new baseline for what doctors thought might be possible with autoimmune diseases.
And that transformation is exactly what we're exploring today. Welcome to the Deep Dive. Our mission today is to, well, pull back the curtain on that quote-unquote magic compound, corticosteroids.
It's a massive topic.
It is. We've pulled together a really fascinating stack of sources for you today, ranging from medical history archives detailing that exact 1948 discovery to, modern pharmacology textbooks, and even some recent critical care trial data.
Yeah, we're covering a lot of ground.
We are. We're going to look at the massive power these drugs hold, the incredibly dangerous side effects they can unleash, and the absolute golden rule of medicine when it comes to managing them. Basically, why you never, ever stop taking them abruptly.
That is so crucial.
But before we get into the dark side of that miracle, we really need to clear the air. Because when we say the word steroids, we have to erase a very specific pop culture image from our minds. We are not talking about bodybuilders.
Oh, absolutely not.
There is no muscle building, no roid rage happening here at all.
Yeah, and that misconception trips up a lot of people, even nursing and medical students in their very first weeks of training. Anabolic androgenic steroids are synthetic derivatives of testosterone. They are specifically engineered to build muscle mass and, well, enhance physical performance. Corticosteroids, on the other hand, operate in a totally different biological arena. They are anti-inflammatory, immune-modulating hormones that are related to cortisol. They manage the body's stress response, metabolism, the immune system. Basically, they prepare the body to survive severe physiological stress, not to, win a weightlifting competition.
So to understand what these drugs are actually doing in hospitals today, we have to go back to the frantic race to isolate them in the 1930s and 40s. Because scientists knew the adrenal gland, those two little triangular organs sitting on top of your kidneys, they knew it was doing something vital to keep us alive.
Yeah, if they removed the adrenal glands from an animal in the lab, it died. They just didn't know what the chemical was.
Right. It was one of the great medical mysteries of the early 20th century. You had this intense race between two brilliant scientists working mostly independently, Edward Calvin Kendall, who was a biochemist at the Mayo Clinic, and Thaddeus Reichstein, a chemist at the University of Basel in Switzerland.
And they were painstakingly trying to isolate active compounds from the adrenal glands of oxen and sheep.
Which sounds exhausting.
Oh, it was grueling bench chemistry, just pulling out these distinct microscopic steroid molecules and labeling them alphabetically, compound A, compound B, compound C, and so on.
And Kendall eventually isolates this compound E, which later gets named cortisone. But having the chemical in a vial doesn't cure anyone. The clinical spark, the actual application to human disease, that came from a rheumatologist named Philip Showalter Hench.
Yes.
And his observation is just brilliant because it's so strange. He noticed that his severe arthritis patients would suddenly go into spontaneous remission if they got pregnant or, weirdly enough, if they develop jaundice.
Which led to his substance X theory. Hench theorized that pregnancy and jaundice were causing the body to flood itself with some unknown circulating hormone, likely from the adrenal gland, that was powerfully suppressing the disease.
That makes sense.
Right. The logic being that if the body could naturally turn off the inflammation of arthritis under certain conditions, maybe doctors could induce that state artificially. So he badgered Kendall to synthesize enough of this compound E to test it on a human. And that brings us right back to that 29-year-old bedridden woman in 1948.
She gets up and goes shopping. It makes international headlines. Cortisone is just universally hailed as a miracle cure. And looking at the historical timeline in our sources, they won a Nobel Prize for this almost immediately.
What's fascinating here is the sheer speed of that recognition. In 1950, Hench, Kendall, and Reichstein jointly won the Nobel Prize in Physiology or Medicine.
Why, 1950?
Yeah, less than 15 years from the early, messy isolation work in the lab to the most prestigious science prize in the world. I mean, a bench-to-bedside timeline that fast is practically unheard of today.
But the euphoria crashed hard. Within just a couple of years, doctors started seeing the horrifying backlash of this supposed miracle. Patients who stayed on high doses of cortisone long-term, they started developing physical deformations.
Yeah, the side effects were severe.
Their faces rounded out into a moon face shape. Their skin thinned like paper, bruising at the slightest touch. Their bones became brittle. They developed severe diabetes, psychiatric disturbances ranging from mania to depression. And most terrifyingly, if they suddenly stopped taking the drug, they would collapse into shock. Some of them died.
The initial rollout of cortisone perfectly illustrates a recurring pattern in medical history. A transformative discovery is completely oversold as a cure-all, and then harsh clinical reality sets in, forcing a recalibration. The central tension of corticosteroids was established right then in those early years. It is an extraordinarily powerful tool that, if mismanaged, is lethal.
Okay, let's get our definition straight. Because diving into the pharmacology textbooks, defining what a corticosteroid actually is depends entirely on who you ask in the hospital. If you ask a bedside nurse versus a pharmacologist, you get two different answers.
You really do. The textbooks use corticosteroid as an umbrella term. It includes two distinct families of hormones produced in the adrenal cortex. First, you have glucocorticoids, which handle glucose regulation, metabolism, and suppressing inflammation.
Okay, that's group one.
Right. And second, you have mineralocorticoids, like the hormone aldosterone. Mineralocorticoids govern sodium and water retention. They are the master regulators of your salt and fluid balance. Because both are manufactured in the adrenal cortex via the same biological pathway, technically they are both corticosteroids.
But when a nurse tells a colleague, like, hey, my patient in bed 4 is on steroids, they're almost never talking about the salt balancing ones.
Exactly. At the bedside, the everyday clinical definition of steroids almost exclusively points to the glucocorticoid family. We're talking about synthetic drugs like prednisone, dexamethasone, and hydrocortisone. These are the heavy hitters prescribed for asthma flares, autoimmune diseases, or severe allergic reactions.
And what about the others?
Mineralocorticoids, like fludrocortisone, are prescribed far less frequently, usually just for specific conditions where the body literally can't retain sodium, like Addison's disease.
Okay, let's unpack this. To really grasp why that one injection in 1948 acted like magic but then turned so dangerous, we have to understand how these drugs fundamentally hijack the body's natural systems. And looking at the physiology guidelines, the easiest way to visualize this is to think of the thermostat in your house.
I love that analogy. The hypothalamic pituitary adrenal axis, the HPA axis, it operates on the exact same principles as a home heating system.
So the HPA axis is your body's built-in corticosteroid factory. The thermostat on the wall is your hypothalamus in the brain. It senses the temperature, or in the body's case, the stress level. And when things get tough, it sends a chemical signal.
Right.
That signal is a hormone called corticotropin-releasing hormone, or CRH. The CRH travels to the furnace controller, which is your pituitary gland. The pituitary receives that signal and sends its own chemical messenger down to the basement.
And that messenger is adrenocorticotropic hormone, or ACTH.
All right, ACTH. And the furnace in the basement is your adrenal glands. The ACTH tells the adrenal glands to turn on and pump out the heat, which is the hormone cortisol. Once the house is warm enough and the stress is managed, the thermostat on the wall senses the heat, stops sending CRH, and shuts the whole system down. It's a classic negative feedback loop.
And your body runs this furnace continuously. Under normal non-stress conditions, a healthy adult's adrenal glands produce roughly the equivalent of 5 to 10 milligrams of synthetic prednisone a day.
Oh, wow. So we always have a baseline.
We do, and this production follows a strict daily rhythm, peaking in the early morning hours to essentially wake your body up and prepare it for the day. Then it drops to its lowest point late at night so you can sleep.
So when we give a patient a synthetic corticosteroid pill, we are basically pumping massive amounts of artificial heat into the house. And the clinical versatility of this artificial heat is staggering. Let's look at how this plays out in modern medicine, starting with the disease that started it all, rheumatoid arthritis. Here, the drug is used as a bridge therapy.
Right. Rheumatoid arthritis is an autoimmune disease where the body's own immune system aggressively attacks the joint linings. When a patient is in agonizing pain, the long-term disease-modifying drugs can take weeks or months to start working.
That's a long time to wait in pain.
Exactly. So corticosteroids serve as the bridge. A doctor gives a dose, and within 24 to 72 hours, it violently suppresses that immune activity. It halts the destruction temporarily, buying time for the slower-acting medications to finally take over.
But you don't always want to flood the whole system. Let's look at asthma. This is where the delivery method completely changes the strategy. You can keep the treatment localized.
Yeah, matching the route of administration to the clinical need is vital. For everyday asthma maintenance, a patient uses an inhaled corticosteroid. The medication goes directly into the airway tissue, suppressing the inflammation right where the problem is occurring.
Which is great because it stays out of the rest of the body.
Right, because it's inhaled, very little of the drug absorbs into the systemic bloodstream, which minimizes side effects. But if a patient comes into the emergency room with a severe acute flare-up of chronic obstructive pulmonary disease, COPD, that localized inhaler is useless.
They need the whole house heated systemically.
Yes. They require a short, powerful burst, usually a 5-day course of oral corticosteroids like prednisone, to systemically crash the inflammation and open those airways up.
Now, here's where my brain starts to struggle with the logic in our sources. Septic shock.
Oh, yes.
We've got a patient in the intensive care unit who is fighting a massive life-threatening bacterial infection. Their blood pressure is crashing. And the protocol suggests giving them an immune-suppressing drug. I mean, that sounds like throwing water on a drowning man. Why would we turn off the immune system when there's a massive infection?
It seems completely counterintuitive, doesn't it? But the key here isn't the immune suppression. It's a concept called adrenal reserve. In severe septic shock, the physiological stress is just off the charts. The patient's blood pressure bottoms out, and their organs are failing.
Right.
In some cases, the sheer magnitude of the illness outstrips the adrenal gland's physical ability to manufacture enough cortisol to keep the cardiovascular system running. The furnace simply can't keep up with the cold. The patient is running on empty.
I see.
So doctors will administer low doses of intravenous hydrocortisone, not to suppress inflammation, but to literally replace the survival hormone the body has run out of.
Okay, so you are just trying to keep the blood pressure up by replacing the baseline cortisol they are missing.
Yeah.
But the critical care data we looked at shows this isn't a universally accepted practice, right?
The practice is heavily debated. Over the last 2 decades, multiple large-scale clinical trials have yielded really conflicting results on whether this low-dose hydrocortisone strategy actually improves overall survival in septic shock.
Really? How so?
Well, some trials show it helps stabilize blood pressure faster, but others show no significant mortality benefit and perhaps even an increased risk of secondary infections. Consequently, the international guidelines remain conditional. It is a highly nuanced decision made at the bedside by the clinician.
That makes sense. It's a desperation move when the body's own factory is failing. But these drugs aren't just for immune suppression or stress response. Our sources highlight a fascinating use in obstetrics. Antenatal steroids for premature labor. We give an injection to a pregnant person, and it fundamentally changes the physical structure of the fetus's lungs.
Yeah, we use specific corticosteroids, usually betamethasone or dexamethasone for this. If a patient is at high risk of delivering prematurely, a single course of corticosteroids is administered to the mother. The drug crosses the placenta and actually accelerates the production of lung surfactant in the fetus.
And surfactant is the stuff that stops the lungs from collapsing, right?
Exactly. It's the slippery substance that keeps the tiny air sacs in the lungs, the alveoli, from collapsing when we exhale. By speeding up that lung maturation, you drastically reduce the risk of respiratory distress syndrome when the premature baby takes its first breaths.
That's incredible.
It proves that glucocorticoids do far more than just quiet immune cells. They can trigger rapid, life-saving developmental changes.
Seeing how powerful this hormone is across all these different scenarios, The logical pushback from a patient or, you listening to this would be, if a short 5-day course of prednisone makes my severe COPD feel amazing, why not a 2-month course? Why can't I just take this drug until I am 100% cured and then just toss the bottle?
Answering that brings us to the single most important clinical rule in our entire deep dive today, the tapering rule.
The golden rule.
Yes. If a patient takes exogenous corticosteroids, meaning synthetic hormones from a pill, an IV, or an injection, at doses above that natural 5 milligram physiological baseline for longer than roughly 2 to 3 weeks, they must be tapered off slowly. The dosage has to be gradually reduced over time. They can never, under any circumstances, be stopped cold turkey.
Going back to our thermostat analogy, this makes perfect sense. If you start taking high-dose pills every day, you are flooding the house with artificial heat. You are essentially outsourcing your cortisol factory to a plastic pill bottle.
Right.
The HPA axis, the thermostat on the wall, senses all this synthetic cortisol floating around in the blood and registers that the house is boiling. It completely shuts down. The hypothalamus stops sending CRH. The pituitary stops sending ACTH. And without that chemical signal telling them to work, the adrenal glands down in the basement don't just pause, they physically shrink. They atrophy from disuse.
Yeah, the architecture of the adrenal cortex literally wastes away. The body becomes completely biologically dependent on the pill bottle for its daily cortisol. If a patient suddenly stops taking that medication, they trigger a catastrophic twofold medical emergency.
What happens first?
First, the underlying disease they were suppressing, the crippling arthritis or the inflamed airways, can violently flare back up because the anti-inflammatory shield has been dropped. But the second problem is much more immediate and far deadlier.
The Addisonian crisis.
Yes, an acute adrenal crisis.
Right.
Because the adrenal glands have been dormant and shrinking for weeks or months, they cannot simply be flipped back on like a switch. Full structural and functional recovery of the adrenal glands can take weeks, months, or in severe cases of long-term use, up to a year.
A year?
Yeah.
No.
So stopping the pills abruptly means the body suddenly has absolutely zero cortisol to manage baseline stress or maintain blood pressure.
Without any cortisol, what is actually happening to the patient in that moment?
It is a profound, life-threatening state of shock. The cardiovascular system loses its tone, so blood pressure plummets dangerously low. The patient experiences overwhelming fatigue, severe nausea, vomiting, and acute abdominal pain.
And it messes with their salt balance, too.
Exactly. Because the synthetic drug often had some mineralocorticoid activity as well, stopping it throws the body's salt balance into chaos. The patient's sodium levels crash, and their potassium levels spike to ranges that can cause fatal heart arrhythmias. Left untreated, an adrenal crisis can kill a patient in a matter of hours.
And reading through the nursing pharmacology texts, the scariest part is the illusion of health. Feeling fine while on the drug gives you absolutely zero indication of what's happening internally.
None at all.
A patient could feel fantastic, totally symptom-free, but their adrenal glands are completely dormant. You cannot trust how you feel to decide when to stop the medication.
That illusion of health is why prescribing these drugs requires such meticulous management. Short courses, typically under 2 weeks, generally don't require a taper because the adrenal factory hasn't had enough time to completely shut down and physically atrophy.
Right.
But anything beyond that 2 to 3 week window requires a carefully mapped tapering schedule. You have to slowly lower the artificial heat to coax the thermostat into turning the body's natural furnace back on.
Because the stakes are a matter of life and death, precision timing dictates everything. And here's where it gets really interesting, especially when we look at recent medical history. Let's talk about the COVID-19 pandemic, specifically the recovery trial out of the UK. This was a massive, highly publicized moment for corticosteroids.
It was huge. The recovery trial provided one of the most consequential therapeutic breakthroughs of the entire pandemic regarding the steroid dexamethasone. Researchers discovered that administering low-dose dexamethasone significantly reduced mortality, it saved lives, in hospitalized COVID-19 patients who were so sick they required supplemental oxygen or mechanical ventilation.
But the nuance in that trial data is crucial. Didn't it also show that if you gave dexamethasone to mild cases, like people early in the infection who didn't need oxygen, it offered no benefit? And the data suggested it might actually harm them.
Yes. The paradox of the recovery trial is a masterclass in understanding how immune suppression works. In severe late-stage COVID-19, the virus itself is often no longer the primary threat.
Right, it's the body's reaction.
Exactly. The danger is the body's own immune system overreacting and destroying the lung tissue, the infamous cytokine storm. Dexamethasone damped down that fatal late-stage inflammation.
And early on.
Early on in the mild phases of the disease, the virus is actively replicating. You desperately need your immune system awake, aggressive, and fighting to clear the virus. If you introduce a powerful immunosuppressant like a corticosteroid too early, you disarm the body's natural defenses, allowing the virus to replicate unchecked.
Context is everything. The benefit of the drug depends entirely on the exact phase of the disease, not just the name of the disease itself. Giving it on day 2 is dangerous, but giving it on day 10 is life-saving.
Timing and disease pathophysiology dictate the outcome entirely.
Let's clarify one more thing, because if I'm a nursing student reading a chart, I might see a patient taking ibuprofen, which is an NSAID, and another taking prednisone, a corticosteroid. Both are classed as anti-inflammatories. Both bring down swelling. How do we distinguish how these neighbors operate?
Mechanistically, they operate in completely different biological universes.
Right.
Oh, yeah. NSAIDs, like ibuprofen or naproxen, work near the surface level of the inflammatory cascade. They act by blocking specific enzymes called COX enzymes. By inhibiting COX, they stop the body from producing prostaglandins, which are the chemicals that cause localized pain and swelling. It's a very targeted, localized blockade.
Okay, so how do corticosteroids do it?
Corticosteroids go infinitely deeper. They are lipid-soluble, meaning they pass right through the outer membrane of a cell. Once inside, they bind to specific glucocorticoid receptors in the cytoplasm, and then that entire complex travels straight into the nucleus of the cell to physically alter gene transcription.
I love visualizing it this way. NSAIDs are like putting up a physical roadblock on a street to stop traffic. Corticosteroids bypass the street entirely, walk into City Hall, sit down at the mayor's desk, and completely rewrite the city's zoning laws.
That's a perfect way to look at it. By altering gene transcription in the nucleus, corticosteroids are literally commanding the cell's DNA to stop manufacturing inflammatory proteins while simultaneously turning on the genes that produce powerful anti-inflammatory proteins.
Wow.
It is a profound systemic cellular override. It dictates cellular behavior from the genetic code upward.
Which brings us to a huge misconception that we really need to stamp out before we wrap up. We've talked about how powerful this cellular override is. Does a corticosteroid actually cure an autoimmune disease?
No, it does not. And it is vital for clinicians to communicate this clearly to patients. Corticosteroids do not cure the underlying pathology of diseases like rheumatoid arthritis, lupus, or severe asthma.
They just mask it.
They merely suppress the symptomatic expression of the disease. They hold the monster in a cage. If you taper off the steroid without introducing another medication that actually modifies the disease process, the monster's still there and the symptoms will return.
So to bring all of our sources together for you listening, we've covered a massive amount of ground today. We learned that these synthetic marvels don't invent a new biological function. They hijack, amplify, and prolong the stress response your adrenal cortex already manages.
Right.
We saw their origin in the desperate bench chemistry of the 1940s. We explored their staggering versatility, from acting as a bridge in arthritis to rescuing failing blood pressure and septic shock to rapidly maturing fetal lungs. And we hammered home the absolute non-negotiable necessity of the tapering rule to avoid a fatal adrenal crisis.
And the reason this information is so critical, whether you are a medical professional managing a ward or just a curious learner, is that corticosteroids remain one of the most widely prescribed drug classes on the planet.
They're everywhere.
From treating eczema and severe allergies, to preventing organ transplant rejection, to managing viral pneumonia, their footprint in medicine is inescapable. But that power requires vigilance. Managing a patient on long-term steroids means meticulously monitoring blood glucose, because these drugs spike sugar levels.
Right, diabetes risk.
It means protecting bone health to prevent osteoporosis. It means looking out for those Cushingoid physical changes, the redistribution of fat to the face and the center of the body. Ensuring patient safety with corticosteroids is one of the highest stakes responsibilities in everyday clinical practice.
So what does this all mean? It means we are wielding a double-edged sword that interacts intimately with our most ancient biological rhythms. And I want to leave you with one final thought to mull over, something that builds on exactly how these drugs work. We learned earlier that corticosteroids operate by going deep into the cell's nucleus and altering gene transcription. We also learned that our body's natural HPA axis, our internal thermostat, has a strict circadian rhythm, peaking our natural cortisol early in the morning and dropping it at night.
Yes, our natural biological responses are heavily dictated by the clock.
It makes you wonder, if our natural hormones are tied so strictly to the time of day, could the exact hour you swallow a synthetic corticosteroid pill fundamentally alter which immune genes are turned on or off?
That is a great question.
By choosing to fight against or align with that natural morning peak, can a drug's effectiveness, or even its side effects, be manipulated simply by looking at a watch before taking the dose?
The intersection of circadian rhythms and drug timing is called chronopharmacology, and it is honestly one of the most fascinating frontiers in medicine today. It is a perfect question to keep exploring.
Think back to that 29-year-old woman in 1948, walking out of the hospital to go shopping. It looked like magic.
Yeah.
But as we now know, in medicine, there is no magic, only incredibly powerful mechanisms that demand our deepest respect, careful timing, and relentless understanding. Thank you for joining us on this deep dive into corticosteroids.
Keep questioning the mechanisms, and goodbye until next time. Why does a 2-month-old baby get a whooping cough vaccine, but has to wait a full calendar year to get the measles vaccine?
Yeah, that's a massive gap that confuses a lot of people.
Right. And if you have ever worked in a pediatric clinic, or, if you are a nursing student cramming for your boards right now, or honestly, even if you're just someone who is endlessly curious about public health, you have probably stared at the childhood immunization schedule.
Absolutely.
And it looks incredibly intimidating. I mean, it's like a chaotic, color-coded tax form crossed with like an engineering blueprint. You've got the primary grids, the catch-up blocks, the footnotes.
It really is just the absolute definition of information density. I mean, people look at it and they just see a wall of dates and acronyms.
Exactly. And today, the mission for this deep dive is to decode that timeline. The timeline that every nurse, every clinician, and really every curious learner should know.
Because we aren't just going to look at what is on that chart. We are going to look at why it is there.
Right. Because when a parent asks you, why does my baby need this specific shot today? Answering, because the chart says so, just doesn't cut it.
It really doesn't. And to really get to the why, we have to fundamentally redefine what that schedule actually is.
Okay, so what is it then?
Well, a lot of people, even some practicing clinicians, assume the schedule is just a biological speed run. Like the fastest, safest way to get a kid vaccinated.
Right, like just check the boxes as fast as possible.
Exactly. But what you are looking at is actually a massive, highly complex optimization problem. It is basically a piece of health systems engineering.
Health systems engineering, I always thought of it as purely medical. What makes it an optimization problem?
Because you are balancing multiple, sometimes completely competing immunology is the foundation, of course.
Yeah, the biology part.
Right. But layered directly on top of the biology, you have manufacturing supply realities, you have insurance billing codes.
Oh, wow, I didn't even think about the billing codes.
Yeah, and you have the physical limit to how many clinic visits a family can realistically manage without just, dropping out of the system entirely. Plus, the actual epidemiology of what diseases are circulating right now in a specific region.
So biology is really just the starting point. It's like the outer boundaries.
Exactly. Everything inside those boundaries is negotiated. It's engineered. And that is why the U.S. schedule looks different from the U.K. schedule, which looks different from Nigeria's.
That makes a lot of sense. So to understand how we ended up with this multi-page, hyper-engineered chart, we should probably look at how we went from just a single shot to this massive, globally coordinated system.
We definitely should. Because for most of the 20th century, the schedule wasn't really a schedule at all.
It was barely a short list, right?
Yeah, barely. You had smallpox, then you had DTP, which is diphtheria, tetanus, pertussis, and then polio. That was pretty much the entire landscape.
And the underlying logic for all of this traces all the way back to 1796 with Edward Jenner.
Right, the cowpox experiment.
Yeah, he inoculated an 8-year-old boy named James Phipps with cowpox to protect him against smallpox.
And that single intervention established the core biological premise that really drives everything on today's chart, which is you introduce a controlled artificial exposure to train the immune system.
Before it inevitably encounters a wild, dangerous exposure.
Exactly. But the schedule as a system, that doesn't really happen until after World War II. That's when things just explode.
Right, because we get the DTP combo in the 40s and 50s. Jonas Salk develops the inactivated polio vaccine in 1955.
And then Albert Sabin brings out the live oral polio vaccine around 1961. So suddenly pediatricians just have a lot of tools.
Which I imagine create a massive amount of chaos.
Oh, total chaos. Someone had to sequence all of these new vaccines so they wouldn't conflict biologically or completely overwhelm families with endless doctor visits.
So who stepped in to fix that?
In 1964, the U.S. established the Advisory Committee on Immunization Practices, or ACIP.
Okay, ACIP.
Yeah, and their explicit job was to standardize these recommendations. Because Before that committee existed, timing was essentially just left up to the judgment of individual doctors.
Which sounds like a logistical nightmare. And globally, the World Health Organization steps in a decade later, right? In 1974.
Yes, with the expanded program on immunization, the EPI, and the realization the WHO had at that moment is fascinating.
What did they realize?
Well, they had just run this massive, successful campaign against smallpox. But they looked around and realized that 6 other diseases, diphtheria, pertussis, tetanus, measles, polio, and tuberculosis, were still killing millions of children in low-income countries.
And the vaccines for these already existed.
Exactly. The bottleneck wasn't the laboratory science anymore. The bottleneck was the schedule and the delivery infrastructure.
You know, organizing a schedule sounds like it should be a simple logistical puzzle, like setting up a train timetable.
A train timetable.
Yeah, like you just figure out when the tracks are clear and you send the trains through one by one so they don't crash.
It's a good analogy, but it breaks down pretty quickly when you look at the biology. It's actually more like trying to plant a complex garden where the soil chemistry is violently changing every single month.
Oh, wow.
Yeah, you're navigating a biological landscape inside the infant that is entirely dynamic.
Okay, let's get into those changing soil conditions then. The tug of war happening inside the infant's immune system, because you have to start by looking at what the baby inherits from the mother, right?
Right. During the 3rd trimester, a fetus receives a massive transfer of IgG antibodies across the placenta from the mother.
And IgG stands for immunoglobulin G.
Correct. Which are essentially small, highly specific proteins that act as lock and key defenders. And because they are small enough to cross the placenta, they provide passive immunity to the newborn.
Wait, hold on. A mother's antibodies are a good thing, right? They protect the baby, so why would we care if they interact with a vaccine? Isn't the baby protected either way?
It seems counterintuitive, I know. Those borrowed antibodies are crucial for keeping the newborn alive. But vaccines are essentially target practice for the baby's own immune system.
Okay, target practice.
Yeah, and if you introduce a live vaccine, like the MMR for measles, mumps, and rubella too early, the mother's aggressive IgG antibodies will instantly neutralize the vaccine virus.
Should just wipe it out.
They clear it out completely before the baby's own T cells and B cells ever get a chance to even see it and build their own long-term memory.
Oh, I see. So the mother's security force is so good, it basically kicks the training dummy out of the building before the baby's security force can even look at it.
That is a perfect way to describe it. That is the exact mechanism of maternal interference. And it is precisely why the MMR vaccine waits until 12 to 15 months of age.
Because you have to wait for that borrowed immunity to completely fade.
Exactly.
But I've seen situations where there is a measles outbreak and public health officials suddenly recommend giving infants a dose at 6 months. How does that work if the mother's antibodies are still hanging around?
Well, in an outbreak setting, the risk calculation changes. You give that early dose at 6 months to try and squeeze out whatever protection you can as those maternal antibodies begin to wane.
Just in case they faded enough to let the vaccine work.
Right. But here is the critical rule for anyone studying the schedule. That early dose does not count toward the routine series.
Ah, because you can't guarantee it actually trained the baby's immune system.
Exactly. You still have to give the standard doses later on once you are absolutely sure the maternal antibodies are completely gone to guarantee durable immunity.
Okay, so that covers maternal interference. But once that borrowed immunity fades, you hit the opposite problem, right? A massive vulnerability gap.
Yes. The newborn's own adaptive immune system isn't fully mature yet.
And pertussis, or whooping cough, is basically the most terrifying example of this gap.
It really is. Infants under 2 months are highly vulnerable to the pertussis bacteria. They have no protection of their own, and the infection can cause fatal apnea.
Which means they don't just cough, they simply stop breathing. It's terrifying. And that is exactly why the DTaP vaccine, which is diphtheria, tetanus, and acellular pertussis, starts exactly at 2 months.
So 2 months is the magic number.
It is the very moment the infant's immune system can finally mount a meaningful antibody response to the acellular components of that vaccine.
Now, when you say acellular, what does that actually mean in terms of what the baby's immune system is looking at?
It means we aren't using the whole pertussis bacterial cell. We are just using purified pieces of specific proteins.
Okay.
So the infant's immune system has to be mature enough to piece that puzzle together and recognize those proteins as a threat.
So it's kind of like showing the immune system a wanted poster with just a few distinct facial features
Yeah.
rather than showing them the actual criminal.
That's a really good way to put it. but, because of that terrifying 2-month gap before the baby can even process that wanted poster, public health relies on a neighboring concept called the cocooning strategy.
Right, this is where you vaccinate the pregnant mother. Exactly. You give the mother the Tdap vaccine, ideally between 27 and 36 weeks of gestation.
So she builds up immunity right before birth.
Right. By boosting the mother's immunity then, she produces a fresh, massive surge of antibodies that pass across the placenta. You are actively building a bridge of borrowed immunity over that dangerous, unvaccinated window for the newborn.
That is so smart. But if we're timing the schedule around the mother's fading antibodies and the baby's own vulnerable gaps, why are some shots given over and over again?
You mean the boosters?
Yeah, like the DTaP is given at 2, 4, 6, and 15 to 18 months, and then another booster at 4 to 6 years. That is 5 total doses just to establish memory.
Well, a young immune system often needs repeated exposure to a specific antigen to build long-lived memory cells. And immunity to different pathogens just decays at different rates.
So the pertussis protection fades quickly.
Yes. The cellular pertussis vaccine requires constant reinforcement to keep the antibody levels high enough to prevent disease.
But the MMR is different.
Right. Meanwhile, a live attenuated vaccine like MMR replicates inside the body just enough to provide a massive, robust training session, which is why it only requires 2 doses for lifetime protection.
Okay, so immunology clearly sets the outer boundaries of this schedule. But when you look at the sources for this deep dive, the exact rules within those boundaries weren't just calculated in some pristine lab.
No, not at all.
They were forged by real-world trials, errors, and frankly, some massive historical disasters.
It is so vital to view the schedule as a living document. It is constantly reacting to post-marketing surveillance.
Post-marketing meaning after it's already approved and out there.
Exactly. The CDC and FDA co-manage a system called VAERs, which is the Vaccine Adverse Event Reporting System. It tracks safety signals after a vaccine is in wide use.
And the rotavirus vaccine is a perfect example of this living document in action, isn't it?
It really is. On the modern schedule, the rotavirus vaccine like Rototech has a very strict, weirdly specific rule.
What's the rule?
The first dose absolutely must be given before 15 weeks of age.
15 weeks? That's so specific. Why?
That 15-week cutoff is a direct response to a previous failure. In 1999, an earlier version of a rotavirus vaccine called RotaShield was actually withdrawn from the market.
Oh, wow. Why was it pulled?
The VAER system detected an elevated risk of something called intussusception.
Wait, intussusception, what exactly is that?
It's a severe condition where one part of the intestine slides inside another part, kind of like a folding telescope.
Ah, that sounds incredibly painful.
It is. It creates a dangerous bowel obstruction. And the surveillance data showed this risk was specifically elevated when the vaccine was given to older infants.
So rather than scrapping the whole idea of protecting babies from rotavirus, they engineered a timing solution.
Exactly. By restricting the first dose of the newer vaccines to infants under 15 weeks, they completely eliminated that specific age-related risk profile.
That's incredible. But, the rigorous federal surveillance systems that caught that issue, they were born out of a much darker history.
Yes, they were.
I'm thinking of the Cutter incident of 1955.
Yeah, that is one of the most significant pharmaceutical disasters in American history.
Set the scene for us. What happened?
So, Jonas Salk's inactivated polio vaccine was licensed in 1955. It was a huge deal, a moment of global triumph. But just 2 weeks later, disaster struck.
2 weeks.
Just 2 weeks. A batch produced by Cutter Laboratories in Berkeley contained live, incompletely inactivated poliovirus.
Oh, no. And they gave it to people.
Roughly 200,000 children received these defective doses.
That is staggering.
The outcome was catastrophic. It caused roughly 40,000 cases of abortive polio.
Wait, abortive polio? What does that mean? Like the virus just went away?
It means the infection caused mild illness like fever, sore throat, muscle weakness, but it stopped short of entering the central nervous system to cause full paralysis.
Okay, but still, 40,000 kids getting sick from a vaccine.
Right, the fact that it was causing any disease at all meant the vaccine contained live, dangerous virus. And tragically, it didn't stop at abortive cases.
What else happened?
It caused over 150 cases of paralytic polio in children and their family contacts, and 10 deaths.
That is horrifying. A vaccine meant to stop paralysis actually causing it?
It was a profound trauma for the public health system. But this disaster directly catalyzed the creation of far stricter federal manufacturing oversight.
So it changed the laws.
Yes, it led to the Division of Biologic Standards, which is the direct ancestor of our modern FDA vaccine regulatory apparatus. The safety net around today's schedule exists because of the lessons learned from that terrible failure.
It's amazing how much history is baked into that chart. But it's not just about timing and oversight either. Sometimes the schedule shifts because of pure chemistry.
Chemistry.
Yeah, like how the vaccine is physically constructed.
Oh, right. This brings up the concept of conjugate vaccines.
Which is fascinating. Walk us through that.
Take the Hub vaccine, which protects against a bacteria that causes a deadly form of meningitis in infants. Or the pneumococcal vaccine, PCV.
The sources for this deep dive mention that the bacteria that cause these diseases have an outer coating made of polysaccharides, right?
Yes, which are basically complex sugars. And early vaccines just use this sugar coating to try and train the immune system.
And how did that work out?
They completely failed in infants. An infant's immature immune system just could not see or mount a response to that sugar coating.
So the chemistry of the antigen wasn't clicking with the biology of the baby?
Exactly.
So if the baby can't see the sugar coating, what do? Do you strip the coating off? Or do you wrap it in something else?
You attach it to something they actually can see. In the late 1980s, scientists figured out how to chemically link or conjugate that weak sugar antigen to a strong, recognizable protein carrier.
Okay, so they glued it to a protein.
Exactly. When you inject this conjugated molecule, the infant's immune system immediately spots the carrier protein, attacks it, and in the collateral damage, it learns to recognize and fight the sugar coating too.
That is so clever. It's like a chemical disguise that forces the baby's immune system to learn.
A chemical disguise. That is exactly what it is.
That is incredible.
Huh.
But because the schedule is this complex, ever-shifting document full of chemical disguises and strict cutoffs, it leaves a lot of room for skepticism.
It really does.
And that skepticism has fueled major debates and dangerous misconceptions that nurses face every single day.
Which means we have to address the most consequential medical fraud in recent vaccine history.
You're talking about Andrew Wakefield's 1998 paper in The Lancet.
Yes, the infamous paper claiming a link between the MMR vaccine and autism.
The reality behind that paper is staggering when you look at the details in the source material.
It really is. First of all, it was based on a case series of just 12 children.
Just 12 kids.
Yes, and Wakefield had undisclosed financial conflicts of interest. He was actively being paid by lawyers who were preparing litigation against vaccine manufacturers.
That is a massive conflict of interest.
And worse, the data itself was manipulated to fit a predetermined conclusion.
So it was just outright fraud. And The Lancet eventually fully retracted the paper in 2010.
Right, and Wakefield was struck from the medical register and lost his license.
And since then, massive studies involving well over 1 million children across multiple countries have found absolutely zero association between MMR and autism.
Zero. But the psychological damage was durable, and it was devastating. Following that publication, MMR uptake in the UK plummeted from about 92% to under 80% in some areas.
And diseases don't care about retracted papers.
No, they don't. As a direct mathematical result of that drop in vaccination, measles, which had been nearly eliminated in the UK, returned. It was declared an endemic disease again in 2008.
That is so tragic. Which brings us to another huge misconception parents have. The too many too soon argument.
Oh, we hear this one a lot.
Yeah, parents look at that massive grid of shots and worry that the sheer volume of the modern schedule is going to completely overwhelm their baby's tiny immune system.
Visually, it is a very understandable fear. It looks like a lot. But biologically, it fundamentally misrepresents how the immune system works. In 2013, the Institute of Medicine conducted a massive formal review of the entire childhood schedule. They looked for cumulative safety issues and found absolutely zero evidence supporting the idea of immune overload.
But how is that possible, though, with so many more shots on the schedule today compared to, say, the 1980s?
Because of the purification processes we just talked about, like the cellular vaccines.
Oh, right, because we aren't using the whole cell anymore.
Exactly. Vaccine researchers like Paul Offit have pointed out that the total number of distinct antigens across the entire modern schedule is only a few hundred.
A few hundred. Is that a lot?
It's a tiny fraction of the antigens a child is exposed to by getting a single common cold.
Wait, really? A single cold?
Yes. The infant immune system's theoretical capacity to respond to distinct antigens is in the thousands simultaneously.
So a kid crawling on the floor, licking a plastic toy, and fighting off a runny nose is putting far more stress on their immune system than the entire vaccine schedule combined.
Precisely. which is why the trend of the delayed schedule is so deeply problematic.
This is where parents want to space out the vaccines to be gentler on the child.
Right. It sounds so reasonable on the surface.
Yeah,
Let's just take it slow, do one shot at a time.
but it's not actually safer.
There is zero demonstrated safety benefit to delaying doses. But mathematically, delaying doses does one very concrete thing. It physically extends the window of time that a child is completely susceptible to diseases like pertussis and head meningitis.
So you are basically artificially prolonging that dangerous gap we talked about earlier.
Exactly. You're just leaving them vulnerable for longer.
What about the natural immunity argument?
Ah, yes.
You know, the idea that getting the actual disease makes your immune system fundamentally stronger than a vaccine ever could.
Well, for some diseases, surviving a natural infection does provide robust immunity. But that argument completely ignores the terrifying cost of acquiring that immunity.
Right, because you actually have to survive the disease first.
Yeah. Exactly. Look at wild measles. If you catch wild measles, you face roughly a 1 in 1,000 risk of acute encephalitis, which is severe brain swelling that can cause permanent damage.
1 in 1,000 are not good odds when we're talking about severe brain damage.
They really aren't. And rarely, wild measles can cause something called SSPE, subacute sclerosing panencephalitis.
That sounds intense. What is that?
It is a fatal degenerative brain disease. And the truly terrifying part is that it doesn't even show up until 7 to 10 years after the original measles infection.
Wait, so a child could catch measles, survive it, seem completely fine, and a decade later develop a fatal brain disease because the virus was just hiding in their central nervous system.
Yes, that is exactly what happened.
Oh my God.
So when people talk about natural immunity, they are ignoring that vaccination provides comparable long-term protection without those massive catastrophic risks.
And when we zoom out from the individual child, these choices to delay a vaccine or rely on natural immunity, they don't just affect that one family, right?
Yeah, not at all.
They dictate the safety of the entire community.
This brings us to the math of the herd. Herd immunity.
Let's get into the math.
The schedule's coverage targets are meticulously calibrated based on how contagious a specific disease is. We measure that contagiousness with something called the basic reproduction number, or R0.
R0, and that is essentially how many people one infected person will spread the disease to, assuming they are in a completely susceptible population with no immunity.
Correct. And measles is one of the most contagious airborne viruses on Earth. Its R0 is estimated to be between 12 and 18.
So one person infects 12 to 18 other people. That's incredibly fast.
Because it spreads so easily, epidemiologists calculate that you need roughly 95% of the population to be vaccinated to reliably prevent the virus from transmitting.
95% is a really high bar, and we saw what happens when we dip below it during the Disneyland measles outbreak in 2014 and 2015.
Yeah, that was a wake-up call. There were 147 confirmed cases traced to exposure at the theme park, spreading across multiple states and even into Canada and Mexico.
And the crucial takeaway from that outbreak is that it happened because of localized pockets of under-vaccination.
Exactly. Think of the virus like a spark in a forest. If 95% of the trees are damp, meaning they are vaccinated, the spark just fizzles out.
But if your statewide average is 95%, yet one specific community or school district drops to 80%.
That is a dry patch of freeze. That is where the spark catches, herd immunity breaks down, and the disease rips through the population.
That makes total sense. You know, this tailored approach to epidemiology is also why the schedule is not identical worldwide.
Right.
Because I hear people say, well, in Europe they do it differently, so our schedule must be wrong.
It's a common misconception. The schedule molds to the environment it's in. For example, countries with endemic tuberculosis give the BCG vaccine right at birth.
But the U.S. doesn't do that.
No, the U.S. schedule omits the BCG vaccine entirely because TB incidence here is so low that the risk-benefit analysis shifts.
So it's hyper-localized.
Exactly.
Yeah.
Different rotavirus strains, different yellow fever risks. Public health officials constantly tweak the schedule based on what is actively threatening the population.
Speaking of tweaking the schedule for efficiency, what about combo vaccines? Like the MMR or DTaP, you sometimes hear the myth that these combo shots are just bundled together for pharmaceutical profit.
The reality is much more practical than that.
Yeah.
Combination vaccines exist to reduce the number of physical injections and the number of clinic visits required.
Which goes back to the logistical constraints we talked about at the beginning.
Yes. The data clearly shows that when you reduce the logistical burden on families, you significantly increase the likelihood that a child actually completes the full series.
And as we just discussed with the forest fire analogy, completing the series is what keeps those vital herd immunity numbers above 95%.
Exactly. It all connects back to the math of the herd.
Let's bring this all back to you, the listener. If you are a nurse working in a clinic tomorrow, this schedule is your daily tool.
It's what you live by.
Right, you are calculating missed windows, figuring out the catch-up grids, but more importantly, you are sitting across from hesitant parents.
And when you understand the biological reasoning, why maternal antibodies mean MMR waits until 12 months, why the rotavirus cutoff exists because of V8-year surveillance, why delaying doses just extends the window of vulnerability, that is how you build trust.
Because answering "it's on the schedule" isn't enough anymore. When you can explain the mechanics of the acellular pertussis vaccine or how chemical conjugation works, you demystify the entire process.
And the impact of understanding that why cannot be overstated. This complex, intimidating chart is really a marvel of public health engineering. The CDC estimates that vaccination of cohorts born in recent decades has prevented hundreds of thousands of deaths and millions of hospitalizations in the U.S. alone.
It really is an incredible achievement. But as we wrap up this deep dive, I want to leave you with a thought about the future.
The future of this schedule.
Yeah. We started by comparing the schedule to a static engineering blueprint. But, as we've seen, it's actually a living ecosystem.
Absolutely.
With vaccine technology rapidly evolving right now, especially with the massive advancements in mRNA technology we've seen recently, how will the outer boundaries of immunology and the inner boundaries of logistics shift?
That's a great question.
How will this already dense blueprint stretch and adapt to accommodate entirely new classes of vaccines in the schedule of the future?
The tracks are always moving, the pathogens adapt, the technology adapts, and the schedule has to adapt right along with them.
It's a constant balancing act, so keep that in mind the next time you look at that chart.
So, I want you to picture, just for a second, a microscopic, like incredibly complex biological filter.
Right.
Now, imagine you have about 1 million of these tiny filters packed into a space roughly the size of your fist. And you actually have 2 of these fists, sitting right against your back muscle.
Yeah, your kidney.
Exactly, your kidneys. And those million tiny filters are called nephrons. And here is, the most crucial, totally uncompromising biological reality we are starting with for today's deep dive. You are born with your entire lifetime budget of these nephrons.
That's it. That's all you get.
Right. And once they're destroyed, they do not grow back. Like your liver can regenerate, which is amazing, but your kidney tissue just doesn't.
No, it really doesn't.
So today, our mission for this deep dive is to explore this silent attrition of these filters. We're looking at chronic kidney disease, or CKD, from the angle of the slow loss of filtration.
Which is such an important way to look at it.
Yeah, because we want to understand not just what it is, but how it quietly reshapes the whole body, the stages of how it progresses, and honestly, this massive medical controversy surrounding how we even define when those filters are failing.
It really is a fascinating history because, it is a fixed anatomical budget. From the day you are born, you are basically spending down that reserve.
Right.
But before we can even talk about how to track that progression, we kind of have to establish what chronic kidney disease actually is clinically.
Let's do it. What's the definition?
So, according to clinical guidelines, it's defined as abnormalities of kidney structure or function.
Okay, kind of broad.
Yeah, but practically speaking, that usually means looking at your glomerular filtration rate, or GFR.
And that's just a measure of how much blood your kidneys can filter per minute.
Exactly. And usually a GFR dropping below 60 is the trigger. Or it could be the presence of physical damage markers. So if protein is leaking into your urine, which is called albuminuria.
Right.
But, and this is a massive caveat, whatever abnormality is happening, it must be present for 3 months or longer.
Okay, let's unpack this right here.
Yeah.
Because I feel like in a lot of diseases, a time frame like 3 months is just, an arbitrary line drawn in the sand for insurance coding or something. Why is that 3-month rule the whole ball game here?
That is a great question, because in nephrology, that time frame is the absolute defining line between a temporary crisis and a permanent reality.
Oh, wow. Okay.
Right. So if your kidneys suddenly shut down because you got severely dehydrated, or maybe you had a really bad toxic reaction to a medication over a weekend.
Which happens.
It does.
Yeah.
That is acute kidney injury, or AKI. Your filtration rate might just completely plummet. But with IV fluids and some time, maybe in a few days or a couple of weeks, those cells can recover.
So the filtration bounces right back up.
Exactly, it bounces back. However, if that decreased function persists for 3 continuous months, that tells us the tissue isn't just stunned.
It's gone.
It is scarred over. It is permanently destroyed.
It's like the difference between, a stalled engine that just needs a jump start and an engine where the metal has completely rusted through.
That is a perfect analogy, yeah.
But to really understand how doctors track this slow rusting today, we have to look back at how chaotic the medical landscape used to be, right? Because from our sources, before 2002, there was no standard way to talk about this early, slow loss.
Oh, it was essentially the Wild West of diagnostics.
Oh, Wild West.
Truly. Nephrology simply didn't have a shared standardized language for early kidney disease.
So doctors were just using these vague, interchangeable terms like chronic renal insufficiency or chronic renal failure or mild renal impairment.
Which means absolutely nothing specific.
Right, which meant that you could go to one clinic, a doctor looks at your lab results and labels you as a sick patient with kidney disease.
Yeah.
Then you drive across town for a second opinion. That doctor looks at the exact same numbers and says, oh, you're relatively healthy, you just have a little mild impairment.
Exactly. And you can imagine the ripple effects of that chaos. I mean, if primary care doctors can't agree on who actually has the disease, researchers certainly can't compare their clinical trials to figure out how to treat it.
Obviously not. You're comparing apples to oranges.
Right. So in 2002, there was this massive intervention. The National Kidney Foundation convened a group called the KDO-QI Work Group.
KDO-QI, right.
Yes.
No.
Chaired by Dr. Andrew S. LeVay. And they basically stepped in to force a standardized vocabulary on the medical community. They introduced a strict 5-stage system based entirely on estimated GFR.
Wait, I have to challenge that. You're telling me an entire diagnostic system for millions of people wasn't based on some, sudden breakthrough biological discovery.
Nope.
It was just a committee sitting in a room and drawing arbitrary lines in the sand.
Yeah.
How did the medical community accept that without a complete revolt?
Oh, well, there was pushback. Absolutely.
I bet.
I mean, anytime you take a smooth, continuous biological decline and artificially chop it up into distinct stages, you're going to get friction.
Right, because biology isn't stepping stones, it's a ramp.
Exactly. But the medical community ultimately accepted it because the alternative was just so much worse. They desperately needed actionable mile markers along that attrition curve.
Just to have a shared language.
Yes. And we need to talk about what's actually driving that attrition. For about 2/3 of all cases in the developed world, it comes down to just 2 culprits.
Diabetes and hypertension. High blood sugar and high blood pressure.
Right.
And both of those diseases essentially act as mechanical and chemical wrecking balls to the nephrons.
That's a great way to visualize it.
Yeah.
So inside each of those million nephrons is a microscopic tuft of capillaries. It's called a glomerulus.
Okay, the glomerulus.
And if you have chronic high blood pressure, you are basically blasting high-pressure fluid through delicate vessels that were simply not designed for it.
Oh, man.
So the vessels stretch, they scar, and eventually they just collapse.
And then with diabetes.
With diabetes, the high blood sugar makes the blood literally stickier and highly inflammatory, which thickens and damages the vessel walls until they just can't filter anything at all.
But I mean, if we know exactly what causes it, and we have this established 5-stage system based on a blood test that literally any primary care doctor can run.
Right.
Why is this disease still caught so late? Why are people showing up in emergency rooms needing dialysis when we've been tracking these stages for decades?
Because that brings us to one of the most remarkable and frankly dangerous facts about human anatomy.
Which is?
The hidden functional reserves.
The hidden functional reserve. Wait, let me make sure I'm hearing this correctly from the source material. You're saying a patient can be actively losing hundreds of thousands of nephrons and their routine physical would still say they're perfectly fine.
Yes, absolutely. You can lose up to 50% of your total nephrons before standard blood tests show a drop in your overall kidney function.
Up to 50%. How is that even biologically possible? I mean, if half the filters are gone, the filtration rate should instantly drop by half, right?
You would think so, but it's because the surviving nephrons compensate.
Right.
They undergo something called hyperfiltration. Think of it like a massive multi-lane highway.
Right, I'm with you.
If there's an accident and 3 lanes are suddenly closed, the traffic doesn't just stop. The remaining open lanes have to absorb all of those cars.
Oh, I see.
So the traffic speeds up, the friction increases, and the sheer volume of pressure means the pavement in those remaining lanes is going to degrade and crumble much faster than it normally would.
Wow. So the surviving nephrons are physically swelling and like increasing their own internal pressure to take on the workload of the dead ones.
Exactly.
They're literally destroying themselves just to keep the overall blood chemistry looking stable on a lab test.
That is exactly what's happening. And because of that hyperfiltration, chronic kidney disease is a completely silent disease until quite late, usually stage 4.
Which busts a huge misconception. People assume that if their kidneys are failing, they'll feel sick.
Right. They think their back will hurt, or they'll have trouble urinating, or they'll feel nauseous.
But they don't. You could be in stage 2 or stage 3, walking around feeling totally fine.
Completely asymptomatic, which means we are entirely reliant on the math of these blood tests to catch it early.
But even the basic blood test is highly misunderstood, isn't it? I mean, when people get routine labs, they usually look at their creatinine level.
Yes, serum creatinine.
And creatinine is just a natural waste product from normal muscle breakdown, right? And healthy kidneys filter it out. So if your kidneys are failing, creatinine builds up in your blood. It seems like a pretty straightforward metric.
Well, it seems straightforward until you account for human diversity.
How so?
Let's look at the mechanics of creatinine. Because it's a byproduct of muscle mass, the raw amount of creatinine in your blood is heavily, heavily dependent on how much muscle you actually have.
Oh, right. So if you take a 25-year-old bodybuilder who lifts weights 3 hours a day, and then you compare him to an 85-year-old frail woman who is mostly sedentary, they have vastly different amounts of muscle tissue generating that waste.
Precisely. So if we just look at the raw creatinine number, they might have the exact same level in their blood.
Really?
Yes. But for the bodybuilder, that's just because he has massive muscles constantly generating waste, and his kidneys are actually working perfectly to clear most of it.
Okay, but for the elderly woman?
For her, she barely has any muscle mass to generate waste. So if her creatinine is reaching that same high level as the bodybuilder, it means her kidneys have almost completely stopped filtering.
Wow. Which is exactly why you can't just look at the raw number on a lab sheet. You have to use those complex equations we mentioned.
Right. The estimated GFR or eGFR.
You have to adjust for age and sex and body size to figure out what the kidneys are actually doing.
Exactly. And as our understanding of this disease evolved, the medical community realized that even the eGFR wasn't telling the whole story.
So they changed it again.
Yeah, which led to the creation of the modern heat map. In 2012, a global kidney organization called KDOGO updated those original 2002 guidelines.
Okay.
They kept the 5 GFR stages, but they added a second axis to the chart. Albuminuria.
All right, albumin. That's a protein in the blood. And from what I read, in a healthy kidney, it's just too big to pass through the microscopic filter into the urine.
Correct. It's like trying to push a bowling ball through a screen door.
Good luck with that.
Right. So if albumin is showing up in the urine, it means the physical structure of the nephron filter is actively tearing.
So KDOGO categorized this leakage, right, from A1 to A3.
Yes, because research showed that leaking protein is a massive predictor of kidney failure, completely independent of what your filtration rate is.
It's a structural warning sign.
Exactly. So now doctors use a grid. They cross-reference your GFR with your protein leakage to assign a color-coded risk level: green, yellow, orange, red, and deep red.
And this heat map totally explains why stage 1 CKD is so unique. Well, in stage 1, your GFR is completely normal,
Right.
90 or above. The filters are keeping up with the traffic.
Right.
So the only way you can even be diagnosed with stage 1 is if those early damage markers like albumin are showing up. The structural damage has started, even if the overall filtration rate hasn't dropped yet.
That is spot on. But, once that hidden reserve finally runs out and the GFR starts dropping into stage 3 and stage 4, the damage refuses to stay confined to the kidneys. It triggers a really devastating systemic domino effect.
Because the kidneys don't just act as passive filters, right? They are active chemical managers for the entire body.
They do so much more than just make urine.
So what does this all mean? Let's look at the cascading failures, starting with the bones, which I found fascinating in the sources. When your filtration rate falls below, say, 45 or 50, the kidneys begin to fail at 2 vital jobs.
Right, activating vitamin D and excreting phosphate.
It is a textbook example of how one failing organ takes down the whole neighborhood.
It really is. When your kidneys can't excrete phosphate, it builds up in your blood. And at the exact same time, because your kidneys aren't activating vitamin D, your gut basically stops absorbing calcium from your food.
So your blood is suddenly high in phosphate and critically low in calcium.
Exactly. And your body detects that imbalance and completely panics.
Because calcium is important for, everything.
Yep.
Heart rhythms, muscle contractions.
Everything. So the rising phosphate triggers your parathyroid glands, these 4 tiny glands in your neck, to go into overdrive.
Okay.
They start pumping out massive amounts of parathyroid hormone, and the primary emergency job of that hormone is to find calcium and bring it into the blood to restore the balance.
But wait, if you aren't absorbing it from your food because of the vitamin D issue,
Yeah.
where does the hormone get it?
It goes to the body's largest calcium vault.
The skeleton.
It pulls it straight out of your bones.
It literally robs your skeleton.
It relentlessly leaches calcium from your bones, a condition called renal osteodystrophy. Your bones become structurally hollow, they fracture easily, but the tragedy doesn't actually stop with the bones.
Because where does all this stuff go?
Exactly. Now you have all this extra calcium and phosphate floating around together in your bloodstream, and they physically bind together to form calcium phosphate crystals.
And those microscopic crystals, they don't just dissolve, do they?
No, they don't.
They get deposited directly into the walls of your blood vessels.
Right. You are quite literally calcifying your own cardiovascular system from the inside out. Your flexible arteries turn into rigid, stiff pipes.
Which explains one of the most profound shifts in how medicine views this disease.
Yeah.
Back in 2004, the New England Journal of Medicine published this landmark study by Go and colleagues. They looked at over 1 million adults, and what they found completely disrupted the narrative.
It really shook the field.
They proved that as GFR declines, your risk of cardiovascular death spikes astronomically.
It's a very sobering clinical reality. For the vast majority of patients with moderate CKD, the dominant cause of death is a massive cardiovascular event.
Like a heart attack or a stroke.
Yes. And that happens long before they ever progress to end-stage kidney disease requiring dialysis.
So wait, they die of a heart attack before their kidneys actually fail.
Usually, yes.
That reframes the entire condition. We think of it as a kidney problem, but it's really a whole body vascular disease. The kidneys are just the first domino.
That is exactly how nephrologists counsel patients today. When you're in stage 3, the clinical focus has to be on aggressively protecting the heart, just as much as saving the remaining nephrons.
But, okay, if this eGFR number is dictating everything, I mean,
Right.
if it tells a doctor your heart attack risk, if it decides whether you get referred to a specialist, or if you can get put on a kidney transplant wait list, the math behind it has to be completely bulletproof.
You would hope so.
But it wasn't, was it? For a long time, these equations were actually the center of a massive medical and ethical controversy.
Yes. This is a critical piece of modern medical history. For nearly 2 decades, the standard eGFR equations used in laboratories worldwide, like the MDRD equation, and later the CKD EPI, they included a specific race correction factor.
A race coefficient.
Right. If a patient was identified on their chart as Black, the algorithm automatically multiplied their estimated GFR by roughly 1.16 to 1.21.
Meaning the math literally output a higher, healthier-looking kidney function number for a Black patient compared to a non-Black patient who had the exact same raw creatinine blood test results.
Correct.
So to look at this impartially, what was the original rationale for doing that?
Well, the original clinical rationale was based on early cohort studies that suggested Black populations, on average, had higher measured creatinine generation.
Which they tied to muscle mass.
Right. Researchers at the time hypothesized it might be tied to differences in average muscle mass. So the algorithm was an attempt to mathematically adjust for that to get a more accurate estimate of true biological filtration.
But the criticism of that approach was intense.
Yep. Oh, absolutely.
Because it assumed that race, which is, largely a social and cultural construct, was a concrete, universal biological variable that you could just plug into a chemical equation.
Yes. And the real-world consequences of that math were severe. Because the algorithm artificially inflated the apparent kidney function of Black patients, it made them look healthier on paper than their kidneys actually were.
Oh, wow. So what did that mean, practically?
It meant they crossed the clinical thresholds for specialist care and transplant waitlist eligibility months or even years later than white patients with the exact same lab values.
Years later.
Yes. It was a mathematical function that actively delayed life-saving care.
It's staggering to think about a background laboratory algorithm having that kind of power over human lives, just sitting there on a lab printout.
It really is. But after years of sustained advocacy and really rigorous debate within the medical community, in 2021, a joint U.S. task force formally recommended retiring the race coefficient entirely. A new race-free equation was adopted by U.S. labs. It's a rare instance in medicine where a deeply embedded diagnostic formula was overthrown and retired, not just for statistical recalibration, but because of its real-world systemic impact.
That is incredible. But, that actually isn't the only debate over how we calculate who has this disease. Here's where it gets really interesting.
The aging debate.
Yes, there's a massive controversy regarding the elderly, because we know that your glomerular filtration rate naturally declines as you age just through cellular senescence.
Right. The nephrons simply age, just like your skin or your joints.
So a healthy 20-year-old might have a GFR of 120, but by the time they were 80, even without diabetes or hypertension, their GFR might naturally drop to 55, just from the normal wear and tear of living for 8 decades.
That's entirely possible, yes.
So if the hard diagnostic cutoff for stage 3 CKD is a GFR of 60, aren't we taking an 80-year-old with a GFR of 55, pointing at them and saying, you have a chronic disease?
That is the big question.
Aren't we just pathologizing normal human aging? I mean, we're causing unnecessary anxiety, maybe changing their medications, sending them to specialists, all for something that is entirely natural.
You've just summarized a major debate in geriatric nephrology right now. Is it overdiagnosis?
Yeah.
But KDI Go, the guideline organization, has a very firm counterargument, and it's rooted in the data.
Okay, what's their defense?
They point out that even if a GFR of 55 is normal for an 80-year-old in the sense that it is statistically average for their age group, that lower filtration rate still carries a measurably elevated cardiovascular risk.
Really?
Yes, and a much higher risk of drug toxicity.
Oh, because their kidneys can't clear the medications out of the bloodstream as quickly.
Mm.
So a normal dose could become a toxic dose.
Exactly. So KDI Go argues that giving it a formal diagnostic label of CKD is clinically vital because it waves a red flag for the physician.
A warning label.
Right. It tells them to monitor the heart closely, to lower the dosages of standard medications so toxins don't build up, and to avoid prescribing certain drugs altogether that could push those fragile aging kidneys over the edge into acute failure.
So even if the decline is natural, it is still dangerous enough to require that warning label.
That's their stance, yes.
When we zoom out from these clinical debates and look at the sheer scale of the disease, it is staggering.
It is a public health crisis operating entirely in the background. Because CKD tracks alongside the massive modern epidemics of type 2 diabetes and hypertension, the numbers are just astronomical.
Let's hear them.
According to public health data, roughly 1 in 7 adults in the U.S. currently has chronic kidney disease.
1 in 7 adults. And because of that hidden reserve and the hyperfiltration we talked about earlier, the vast majority of the people walking around in stage 3 have absolutely no idea they are slowly losing their nephron budget.
They are completely asymptomatic, and the societal and economic cost of this silent progression is unparalleled.
I really want to highlight the economics of this, because it led to one of the most unique healthcare policies in American history.
The 1972 Medicare carve-out.
Yes. So dialysis, which is the mechanical treatment you need when you reach stage 5 and your kidneys completely fail, is unfathomably expensive.
Yes.
Back in 1972, when dialysis machines were relatively new, incredibly scarce, hospital committees, sometimes they were literally called God panels, were deciding who lived and who died based on who could afford it and who had access.
It was an ethical nightmare. The financial burden of dialysis would instantly bankrupt almost any individual family.
So in 1972, the U.S. government under Nixon created a completely unique universal coverage carve-out.
Right. Medicare covers end-stage renal disease for dialysis regardless of your age.
Regardless of age.
If your kidneys fail, the government pays for the treatment.
It is one of the only disease-specific universal coverage policies in the country, and it underscores just how critical it is to prevent progression in the early stages, because the sheer amount of resources required at stage 5 is monumental.
Which means we really need to correct one final major misconception here.
Oh, about dialysis being a cure.
Yes. People hear about dialysis and they view it as a cure. They think you go to the clinic, they hook you up to the machine washes your blood, and you go home functioning at 100%.
Like getting an oil change for your car.
Right, but dialysis is absolutely not a cure. It is an incredibly exhausting, grueling mechanical process where your blood is pumped out of your body, pushed through a synthetic filter membrane, and pumped back in.
Yeah, even running perfectly.
Even running perfectly, dialysis only replaces about 10 to 15% of your normal, healthy kidney function.
10 to 15%. It just barely clears enough toxins to keep you alive.
Barely. It manages the most severe symptoms, but you are still living with profound physiological deficits. It does not restore the kidney tissue, it doesn't activate vitamin D, and it doesn't regulate your blood pressure hormones effectively.
Right, all those systemic things we talked about.
The only clinical intervention that even approaches normal function is an organ transplant, which is why kidneys make up by far the largest share of the transplant waitlist globally.
Which brings everything we've talked about right back to you, the listener. The reason we are diving into the mechanics of this disease isn't just to memorize clinical stages or understand the history of medical algorithms.
No, not at all.
It is about understanding the biological budget you possess right now. Those million microscopic filters in each kidney are taking the physical brunt of every prolonged blood pressure spike and every chronic blood sugar elevation.
Every single one.
Protecting those tiny capillary tufts early on, before the hidden reserve runs out and the highway collapses, is quite literally the only way to safeguard the nephron budget you were born with.
It is entirely about recognizing the silent, invisible damage before the physical alarm bells finally ring. And, if we connect everything we've unpacked today, from the silent hyperfiltration to the complex debates over how we diagnose the elderly, it leaves us with a really profound question to consider regarding our own health.
Oh, I like this. What if the way we define normal aging is really just our failure to differentiate between inevitable wear and tear and preventable disease?
Exact.
How much of what we accept as simply getting older, the fatigue, the stiffness, the vascular changes, is actually a silent, systemic decline that we could have caught and slowed down years earlier with a simple blood test?
A slow loss of filtration hiding in plain sight.
You start with 1 million filters per kidney. The goal is to hold on to as many as you can for as long as you can. So if you take a standard aspirin right now, your body will it'll flush it completely out of your bloodstream in about 20 minutes.
Right, 20 minutes.
And this is the crazy part, that single pill will physically alter your blood cells for the next 10 days.
Yeah, it's wild to think about.
And then on the flip side, you have a potent painkiller like methadone. It might stop relieving your pain after just like 6 hours, but it secretly lingers in your body for days.
Which is a huge hidden mismatch.
A mismatch that has actually fueled a major public health crisis. I mean, we take these instructions on our pill bottles totally for granted, right? Take once a day, take every 4 hours.
We just blindly follow the label.
Exactly. But those simple labels are hiding this really complex, invisible world of mathematical decay.
Yeah, and it is entirely invisible to the patient. But understanding that underlying math isn't just academic trivia for nursing or medical students to memorize for some exam. It is the quantitative backbone of safe medication. Whether we're calculating insulin schedules, setting antibiotic dosing intervals, or, trying to figure out why missing a dose of one drug is a non-event.
Well, missing another is like a total medical emergency.
Exactly. It all comes back to a concept called drug half-life. And, knowledge is most valuable when it's understood and applied. And today we're looking at how clinicians actually apply this math to keep you safe.
Yeah, we've got a fascinating stack of clinical pharmacology notes, historical medical papers, and pharmacokinetic research right in front of us. And the mission for this deep dive is to demystify those numbers on the side of your pill bottle.
Absolutely.
We're going to explore steady states, dosing intervals, and really why timing a dose is quite literally everything. So, okay, let's unpack this, because before we can understand how drugs work in your body, we actually have to look at where this concept even came from.
Yeah, the history is super interesting.
Right, because looking at the sources, it apparently wasn't even cooked up in a pharmacy.
No, not at all. The origins actually lie in early 20th century physics, specifically the study of radioactivity.
Wait, radioactivity, like glowing green rocks?
Well, yeah. I mean, if you look at the research of Ernest Rutherford and Frederick Soddy around 1902 to 1907, they were studying how radioactive isotopes decay over time.
Okay.
And they were the ones who first defined the concept of a half-life, or T1/2, as you'll often see it written in clinical math.
Which sounds completely unrelated to, swallowing a Tylenol for a headache.
Yeah.
How did we jump from glowing uranium to pain relief?
Well, exactly how radioactive elements decay turns out to be the exact same mathematical model for how your body eliminates most foreign substances.
Seriously?
Yeah. Rutherford and Soddy basically discovered exponential decay. So the core definition of a drug's half-life is simply the time required for the concentration of a drug in the blood plasma to fall by 50%.
Okay, so just having it.
Right. If the mathematical curve for a radioactive isotope decaying in a lab looks like a clean downward exponential slope,
Hmm.
well, the curve of a drug clearing from your bloodstream looks mathematically identical.
So let me make sure I've got this.
Mm.
If I have like 100 milligrams per liter of a drug floating in my bloodstream and its half-life is 4 hours,
Yep.
I'm just having that number every 4 hours.
Yeah.
Like at hour 4, I'm down to 50 milligrams.
Yeah, exactly.
And then at hour 8, I'm at 25 milligrams,
Yeah.
then 12.5, then 6.25, and it just keeps dropping by half.
That is the fundamental mechanism, yeah. But translating that physics equation into human biology, that actually required a massive conceptual leap.
I bet.
We really owe that to a Swedish physiologist named Torsten Terrell.
Right.
So in 1937, Terrell published this two-part paper that radically reframed how we even think about medicine.
How so?
Well, before his work, the medical community's primary question was totally binary. Just, does this drug work?
Simple enough.
Right. But Terrell shifted the paradigm entirely by asking, where is this drug, quantitatively, at every single moment after it enters the body?
Oh, wow. Which is such a brilliant shift in perspective.
Yeah.
But the sources actually note his work was largely ignored for decades. Why wouldn't doctors jump all over this?
I mean, the sheer complexity of the math was a massive barrier.
Oh, because they didn't have computers?
Exactly. Terrell was building these intricate mathematical compartment models to track the drugs movement, and he was doing the matrix calculus by hand.
Yikes.
Yeah, decades before computers were available to run those simulations. He fundamentally changed the model of the human body from, like, a static vessel to a highly dynamic system.
And there was another guy too, right? Widmark.
Oh, yeah, Eric Widmark, another Swedish scientist, a chemist. He was actually doing similar mathematical modeling for blood alcohol concentrations even earlier,
Oh.
in the 1910s and 20s.
That's fascinating.
And Widmark's equations are still used by forensic toxicologists today. But Terrell was really the one who formalized the idea of the body as a system of interconnected tanks.
I really love that visual. Because we so often think of our bodies as just a single bucket. You swallow a pill, it drops into the bucket, the water sloshes around, and eventually the bucket empties.
Right, the bucket model.
But Tyrrell is saying, no, you are a complex plumbing system. You've got the stomach tank flowing into the blood tank,
Yeah.
which then leaks into the fat tissue tank, which filters through the liver and kidney tanks. And each of those pipes has a completely different flow rate.
It's a great analogy. That interconnected plumbing system is the very foundation of what we now call pharmacokinetics, which researchers like Gerhard Levy and Milo Gibaldi finally brought to the bedside in the 60s and 70s.
Okay, and tell me if I'm wrong here. If I'm an ICU nurse juggling 5 different patients,
Right.
I am absolutely not doing natural logarithms by hand at the bedside.
Definitely not.
Right. I'm not calculating when a drug will clear from my patient's blood tank with a matrix.
Yeah.
So how is this actually applied in the real world without a graphing calculator?
Clinicians actually rely on a foundational shortcut called the rule of 5.
The rule of 5.
Yeah. It is the single most clinically useful application of all this exponential math. The rule of 5 basically states that it takes roughly 5 half-lives for a drug to reach what we call steady state during continuous dosing.
Okay.
Or, conversely, to be effectively eliminated from the body after you completely stop taking it.
Let's walk through that because, 5 feels like an arbitrary number. Why not 3 half-lives or 10?
It comes down to where that exponential curve flattens out into clinical insignificance. So, as we established, after 1 half-life, you have 50% of the drug remaining.
Right.
After 2, you have 25%. After 3, 12.5%.
The halving math again.
Exactly. By the time you reach the 4th half-life, you're down to 6.25%, and at the 5th, you're at 3.125%.
Oh, okay.
At that point, roughly 97% of the drug has been cleared. And for the vast majority of clinical applications, that remaining 3% is functionally negligible. The body has effectively eliminated it.
And the sources say this same rule of 5 applies in reverse. Like when you are trying to build a drug up in your system.
Yes, the math completely mirrors itself. When you take a medication repeatedly at a fixed interval, the concentration in your blood doesn't just keep climbing infinitely, right?
Unless you're overdosing.
Well, yes, but at a normal dosage, it rises toward a plateau. That plateau is the steady state. It's the point where the amount of drug you're putting in exactly equals the amount your body's eliminating during that same time frame.
Got it.
And because of that exponential math, it takes about 5 half-lives of regular dosing to reach that steady state plateau.
Wait, I have to push back on this because it feels completely counterintuitive.
How so?
Well, if I want to get to that steady state plateau faster, can't I just take a much bigger dose?
Yeah.
Like if my doctor says take 10 milligrams a day and I double it to 20, shouldn't I hit the plateau in half the time?
That is a super common misconception, actually, but the math doesn't support it at all. Yeah. A larger dose does not reach steady state faster. It merely reaches a higher steady state.
Oh, wow.
So if you double the dose, your blood concentration will ultimately plateau at a higher level, but it will still take exactly 5 half-lives to get to that new, higher plateau. The time to steady state is entirely governed by the drug's half-life, completely independent of the dose size.
Okay, but wait. If a drug has a really long half-life, and it always takes 5 half-lives to reach a therapeutic steady state, isn't the patient just suffering in the meantime?
That's the real problem.
Yeah. Because if I have a serious condition today, I do not want to wait a week for my medicine to finally reach the effective level.
This raises a really important clinical question, and it's precisely why clinicians utilize what are called loading doses.
Loading doses.
Right. The sources highlight digoxin as a prime example of this. Digoxin is a medication used to treat heart failure and irregular heartbeats. And in a patient with normal kidney function, its half-life is roughly 36 hours.
36 hours. Let me do the rule of 5 math on that really quick. 36 hours times 5 half-lives. That's 180 hours.
Yep.
That's 7.5 days.
Which is completely unacceptable for a patient experiencing acute heart failure symptoms.
Right.
If a physician just prescribed standard daily doses, that patient would be waiting over a week for the drug to slowly climb that exponential curve just to reach a therapeutic steady state.
So what do?
To bypass this, clinicians administer a large loading dose upfront. This massive initial dose basically front-loads the body. It instantly forces the blood concentration up to the therapeutic plateau on day 1.
That makes sense.
And then from then on, the patient just takes smaller maintenance doses. And those are mathematically calculated to replace exactly whatever the body eliminated over the past 24 hours, keeping them perfectly balanced on that steady state plateau.
Okay, that makes perfect sense for getting the drug into the system.
Mm-hmm.
But the sources highlight this really terrifying scenario where this exact same math can silently change and cause major harm. So digoxin is cleared almost entirely by the kidneys, right? What actually happens if that patient suddenly gets a severe kidney infection or an acute kidney injury?
Well, the foundational math just collapses. If the kidneys lose their filtering efficiency, digoxin isn't excreted at the normal rate anymore. Its half-life stretches from 36 hours to somewhere between 3.5 and 5 days.
Oh, wow. So the patient's internal clock just slowed way down.
Exactly. And this is where it becomes a literal matter of life and death. The maintenance dose hasn't changed. The patient is still taking the exact same daily pill that was perfectly safe last week.
But the body isn't clearing it.
Right. Because the half-life has drastically lengthened, the body is no longer clinching the daily input, the steady state is totally lost, the drug begins to accumulate slowly and silently climbing toward toxicity.
All because the underlying physiological decay rate changed.
Exactly.
That is wild to think about. The danger is completely invisible to the patient.
Yeah.
But here's where it gets really interesting, though.
Oh, yeah.
The rule of 5 works beautifully, assuming the drug actually follows these exponential rules. But the sources point out that some drugs are absolute rule breakers.
Very true. The clean exponential decay we've been discussing assumes the drug follows what we call first-order kinetics, meaning a constant fraction of the drug is eliminated over time, always 50% per half-life.
Right.
But there is a rebel category of substances that follow zero-order kinetics.
Zero-order kinetics. And the sources say this means instead of a constant fraction being cleared, the body clears a constant amount per hour, regardless of how much is in the system.
Exactly.
Which perfectly explains the classic drinking myth. People think they can just drink a pot of coffee or take a cold shower to sober up faster after a heavy night out.
Yeah, that doesn't work. Ethanol, or alcohol, is the quintessential zero-order kinetic substance. To understand why you can't just speed it up, you have to look at the actual cellular mechanism.
Okay.
So your liver uses specific enzymes, primarily alcohol dehydrogenase, to metabolize ethanol. But there is a finite number of these enzyme molecules. Right. Once they are all actively processing alcohol, the system is fully saturated. It is operating at absolute maximum capacity.
It's like a toll booth on a highway.
Yeah.
If the toll booth can only process, say, 1 car per minute, it doesn't matter if there are 2 cars in line or 200 cars in line. The throughput is a flat, constant rate. The heavy drinker just has to wait in line.
That analogy perfectly captures the bottleneck. Because the elimination rate is a flat, say, roughly 1 standard drink per hour rather than a percentage, the concept of a fixed half-life doesn't even exist for ethanol.
It makes total sense.
The time it takes to have your blood alcohol concentration changes wildly depending on your starting level. And alcohol isn't alone in this. High-dose aspirin and the anti-seizure medication phenytoin also follow zero-order kinetics.
Oh, wow.
Which is why a neurologist has to be incredibly careful adjusting phenytoin doses. A tiny increase in the dose can suddenly overwhelm the liver's enzymes, backing up the toll booth instantly and causing massive toxicity.
And it isn't just about how the drug is cleared, right? It's also about where the drug decides to hide. This brings us back to Terrell's interconnected plumbing system.
Right, the multi-compartment model.
Drugs don't just hang out in the bloodstream waiting to be filtered. They distribute through the body in phases, which the sources call multi-compartment kinetics.
Yeah, when a drug first enters the bloodstream, we typically see a very rapid drop in blood concentration, but this isn't elimination. This is distribution.
Okay.
The drug is moving out of the blood and permeating into tissues and organs. We call this the alpha phase. Once the drug has settled into those tissue compartments, we enter the beta phase, or the terminal elimination phase.
And that's when the liver and kidneys kick in.
Exactly, where they actually start removing the drug from the entire system.
Wait, so when I look up the official half-life of a drug in a medical textbook, which phase am I actually looking at?
You are almost always looking at the terminal beta phase.
Yeah.
However, that single number can drastically understate a drug's persistence in the human body, particularly if we are dealing with a lipophilic drug.
Lipophilic, meaning fat-loving.
Correct. Lipophilic drugs are highly fat-soluble. They easily slip across cell membranes and pack themselves into your adipose or fat tissue.
So they just sort of camp out there.
Yeah, and blood flow to fat tissue is relatively low compared to major organs like the heart or brain. So once a lipophilic drug gets into the fat, it essentially gets locked in a physiological vault.
A vault.
Amiodarone, which is a powerful antiarrhythmic drug used for irregular heartbeats, is a notorious example of this. Because it accumulates so heavily in fat vaults, its terminal half-life isn't measured in hours. It is measured in weeks and sometimes months.
Months? You mean a single dose takes months to clear?
Oh, yes. A patient who has been taking amiodarone and then stops can have detectable levels of the drug and remain at risk for its toxic side effects for up to 100 days after their final dose.
That's horrifying.
The drug just slowly and continuously leaks out of the fat tissue back into the bloodstream. If a patient develops, say, pulmonary toxicity from the drug or needs to stop it prior to a major surgery, the medical team is dealing with a substance that effectively refuses to leave the premises.
So asking what is the half-life and asking how long do I need to worry about this drug are 2 entirely different questions.
They require completely different clinical mindsets.
So amiodarone proves that a drug can physically linger in your body long after you stop taking it. But there's an even more dangerous scenario in the sources. What happens when the drug is physically gone, but the effect remains?
Oh, yes. To understand this, we have to separate 2 foundational concepts in pharmacology: pharmacokinetics and pharmacodynamics.
Okay.
Pharmacokinetics is everything we've been discussing, what the body does to the drug, how it absorbs, distributes, and eliminates it. Pharmacodynamics is what the drug does to the body, the actual physiological change or clinical effect it triggers.
And these 2 timelines can diverge.
In extraordinary ways.
Okay, this is the aspirin paradox I mentioned at the very beginning of the show. The sources say aspirin's plasma half-life was only 15 to 20 minutes.
Right.
Following our rule of 5, the drug itself is effectively eliminated from the blood in an hour or 2. Yet, it prevents your blood from clotting normally for a week to 10 days.
Yep.
If the drug is physically gone from my blood in 20 minutes, how on earth is it still working a week later? Where is it hiding?
It isn't hiding at all. The drug really is gone. The prolonged effect is due to the specific mechanism of action it deployed during the brief 20 minutes it was actually present.
Okay.
Aspirin permanently inactivates an enzyme called COX-1 inside your blood platelets.
Wait, it permanently breaks the enzyme?
Yes, the inhibition is irreversible. And because platelets lack cell nucleus and DNA, they cannot synthesize new COX-1 enzymes to replace the broken ones.
So they're just useless.
Those specific platelets are permanently impaired from clotting for the rest of their natural lifespan, which happens to be about 7 to 10 days.
It's less like a lingering guest in your house, and more like someone who walked by, threw a rock through your living room window, and immediately ran away.
I love that.
The drug is completely gone in seconds, but the broken window remains until your body physically builds a new one.
That is an excellent way to visualize irreversible enzyme inhibition. But if we connect this to the bigger picture, this mismatch between a drug's physical presence and its clinical effect isn't always a convenient feature.
It can be bad.
It can be profoundly dangerous. U.S. public health agencies have flagged this exact pharmacokinetic-pharmacodynamic mismatch as a key driver of the opioid overdose crisis, specifically regarding methadone.
How does the mismatch work with methadone? I know it's used for severe pain and opioid use disorder, but why is the timing so deadly?
It comes down to the patient's subjective experience versus the objective math. Methadone's analgesic effect, the actual pain relief the patient feels, lasts only about 4 to 8 hours.
Okay, but what is its elimination half-life? Like, how long is the drug actually in the blood tank?
The elimination half-life is highly variable, but it ranges anywhere from 8 to 59 hours.
Oh, no. I see where this is going.
Imagine a patient managing chronic pain. After 6 hours, the pain relief wears off. They are hurting, so they assume the drug is gone, and they take another dose.
Naturally.
6 hours later, the pain returns, they take a third dose. But because the physical elimination half-life can be up to 59 hours, the body hasn't even come close to clearing that very first dose.
They're just stacking new doses on top of a rising mountain of the drug in their bloodstream.
Precisely. They are unknowingly driving their plasma concentration higher and higher. The pain relief is gone, so their brain tells them the drug is gone, but the physical chemical is accumulating, silently pushing them toward the threshold of respiratory depression.
That's terrifying.
Patients and sometimes even prescribers fail to account for the fact that the drug's physical mass is still heavily present long after the clinical relief has faded.
That is incredibly tragic. But it really crystallizes why clinicians have to understand this math at a deep level. It's not just numbers on a page, it's human behavior interacting with invisible decay rates.
Absolutely.
Now, because this half-life number can be so misleading, there are intense, high-stakes debates happening right now in intensive care units about how to even measure it.
Yes, particularly in anesthesiology. In 1992, researchers Hughes, Glass, and Jacobs published a landmark paper introducing a concept called context-sensitive half-time.
Context-sensitive half-time, meaning the half-life literally changes depending on the context of how you give it.
Specifically how long you give it. They were studying continuous intravenous infusions, which are standard during long surgical procedures.
Like an IV drip.
Right. And they found that for certain lipophilic drugs, like the opioid fentanyl, the effective half-life actually lengthens the longer the IV drip runs.
Wait, how does running an IV longer change the drug's decay rate? Does the liver just get exhausted from processing it?
It goes right back to Terrell's interconnected tanks. When you start an IV infusion, the drug fills the blood tank and begins flowing into the peripheral tissue tanks, like muscle and fat.
Yeah.
If it's a short procedure, you turn off the IV, the blood level drops, and the patient wakes up. But if you run that continuous infusion for 6 or 8 hours, you eventually saturate those peripheral tissues. They are completely full.
So what happens when you finally turn off the IV after 8 hours?
The concentration of the drug in the blood drops rapidly, but now, because the peripheral tissues are fully saturated, a massive concentration gradient is created.
Meaning?
The drug begins flowing backward, it leaks out of the fat and muscle tissues and back into the bloodstream.
Oh, wow.
These saturated tissues basically act as a slow-release internal reservoir, artificially sustaining the drug levels in the blood. So, after a brief infusion, fentanyl clears very quickly. But after a prolonged infusion, its effective half-time can actually become significantly longer than a drug like morphine.
Which completely blows up the standard drug chart. I mean, a textbook might say fentanyl is short-acting, but in the context of an 8-hour surgery, it suddenly acts like a long-acting drug.
And this realization revolutionized how anesthesiologists choose between different drugs for prolonged procedures. It also ties directly into how we monitor patients in the ICU, a practice known as therapeutic drug monitoring, or TDM.
TDM, right.
For drugs with a very narrow therapeutic index, meaning the margin between a safe dose and a toxic dose is incredibly thin, like the antibiotic vancomycin or the psychiatric medication lithium, we have to draw the patient's blood to physically check the concentration.
But based on everything we've talked about, the timing of that blood draw has to be mathematically perfect.
The timing is everything. Clinicians typically want to measure the trough level, which is the lowest concentration of the drug in the blood, drawn immediately before the next dose is administered.
Okay.
But a common critical error is drawing that trough level too early, before 5 half-lives have passed and steady state has actually been achieved.
Because if you haven't hit the 5th half-life, the patient is still climbing the curve. The plateau hasn't leveled out yet.
Exactly. The number you get from the lab might look reassuringly low, but it's a phantom number. It doesn't represent the true steady state.
So the doctor might increase the dose.
Right. And if a physician increases a dose based on that premature, falsely low number, they could push the patient directly into toxicity once the true steady state finally arrives.
So what does this all mean for you, listening to this right now? Well, it means this complex, invisible math governs your everyday life and your everyday safety.
It really does.
If you were ever told by a surgeon to stop taking your blood thinner, like a Pixaban, exactly 3 days before a scheduled procedure, you now know that isn't a random guess.
No, not at all.
That is a clinician doing a rule of 5 calculation on your behalf to guarantee your blood will clot normally when the scalpel hits.
It also explains your daily habits. When sleep experts advise no caffeine after 2 p.m., they are referencing pharmacokinetic decay.
Wait, really?
Yeah. Caffeine has a half-life of roughly 5 hours in a typical adult. So if you drink a cup of coffee at 2 p.m., by midnight, 2 half-lives have passed.
Which means, based on our math, 25% of that caffeine molecule is still physically circulating in your brain, actively binding to receptors and keeping you awake.
And what's fascinating is that caffeine's 5-hour half-life is just a population average. The sources note that it is highly variable.
Variable how?
Well, if you are pregnant, the half-life extends significantly. If you are a smoker, the half-life actually shortens due to enzyme induction. It is wildly dependent on your personal genetics and liver function.
Which leads to a really fascinating thought to leave you with today. Because right now, the entire medical system relies on these generic textbook half-life, these population averages printed on package inserts.
Right.
But what if, in the near future, we don't have to guess? What if you could swallow a smart pill or wear a biometric patch that constantly samples your interstitial fluid and calculates your personal pharmacokinetic decay rates in real time?
That would represent a monumental paradigm shift in pharmacology. I mean, imagine a clinical landscape where the rule of 5 isn't based on a historical clinical trial of strangers, but becomes perfectly customized to your exact metabolism, your precise kidney function, and your genetic makeup on any given Tuesday.
It would be revolutionary.
We could effectively eliminate the guesswork of dosing, preventing toxicity before it ever happens.
You would have a real-time dashboard of your own interconnected tanks right on your wrist. It is incredible to think about. Well, next time you look at a pill bottle and see take every 4 hours, you'll know there's a whole world of physics, saturated tissues, and exponential decay hiding behind that simple label. Thank you for joining us on this deep dive. Keep questioning the everyday, keep learning, and we'll see you next time. Imagine you are an ER nurse.
Okay.
And 2 patients just roll through the double doors from this massive car crash.
Oh, wow. Right into the deep end.
Right. So one of them is screaming at the top of his lungs, and there is just a geyser of blood shooting from a mangled leg. I mean, it looked like a scene straight out of a horror movie.
Naturally.
But the other patient is sitting perfectly still. They look, mostly fine, actually. But when they try to talk, there is this incredibly subtle, like high-pitched squeak every time they take a breath.
Oh, yeah. That's bad.
Right. Because if you run to the screaming patient first, your quiet patient will be dead in 3 minutes.
Yeah, it is the absolute ultimate trap for a novice responder. I mean, your eyes are just completely hijacked by the dramatic bleeding.
Of course they are. It's human nature.
Exactly. But your training has to override your instincts.
And welcome to today's deep dive, everyone. We are looking at a really fascinating stack of sources today. We've got clinical protocols, medical history, triage frameworks, and the actual philosophy driving modern nursing exams.
It's a lot of ground to cover.
It really is. Our mission today is to unpack the intensely high-stakes world of prioritization. So, if you are studying for your medical boards right now, obviously you know how critical this is.
Oh, yeah, it's everything.
But even if you are just someone who's, fascinated by how human beings make rapid-fire, literal life-or-death decisions under extreme pressure, this deep dive is absolutely going to change how you look at problem solving.
I completely agree.
Because we are exploring how nurses fuse clinical knowledge, meaning the physiology of what could kill someone, with workflow management, meaning what to physically do first. And they do this in a single split-second judgment.
Right. They basically have to instantly merge the what's wrong with the what now.
Exactly. Okay, let's unpack this, because where do we even begin with a concept this massive? Like, was there a specific moment in history where someone finally sat down and wrote out the rules for who gets saved first?
Well, to find the origin of that, we actually have to step far away from, modern sterile hospital rooms.
Okay, where are we going?
We have to go back to the battlefields of the 1800s.
Wow, really?
Yeah. So the foundational word we use today is triage, right? Which comes from the French verb tria, which simply translates to sort.
To sort, okay.
Right. And the person credited with weaponizing this concept, and I use that word intentionally, was a man named Dominique Jean Larrey.
Larry, wait, he was Napoleon Bonaparte's chief surgeon, correct?
He was, yeah. So during the Napoleonic campaigns, particularly during that brutally freezing retreat from Russia in 1812.
Right, the famous retreat.
Exactly. Larry observed this incredibly chaotic and highly ineffective medical response because before him, wounded soldiers were treated based on their military rank.
You're kidding?
No, seriously, like a general with a twisted ankle would absolutely get a doctor's attention before a private with a musket ball in his chest.
That is insane.
Or, alternatively, surgeons just treated whoever was physically dragged off the field first.
Just totally random.
Total chaos. So he essentially walked into that chaos and instituted a pure threat-level system.
Right, so he stripped away rank entirely.
Entirely. Larry began sorting the wounded strictly by the severity of their physical injuries, and he also realized that speed itself was a medical intervention.
Because you can't just wait around.
Right, so he pioneered these horse-drawn flying ambulances to actually retrieve the wounded while the battle was still raging, rather than waiting for the shooting to stop.
Wow. But, the sources point out something really fascinating about his underlying motivation for all this.
Yeah, it's not what you'd expect.
Right, because we tend to view doctors through this lens of pure humanitarian mercy, right? But Larry's triage system, it wasn't born out of a bleeding heart.
Not at all. It was born out of cold, hard military logistics.
Which makes sense for Napoleon's army.
Yeah. The explicit goal was to evaluate soldiers, find the ones who were treatable, patch them up, and then shove them back onto the front lines as quickly as possible.
Because they needed a functioning army.
Exactly. Preserving the strength of the fighting force was the priority, not necessarily, comforting the dying.
It's a pretty radical shift in thinking when you compare it to how normal society operates. Like, we are deeply conditioned by what I call the deli counter system.
Oh, right. First come, first served.
Exactly. You take a ticket, you wait your turn, and universally, everybody considers that fair. But Larry essentially walked up to the deli counter, ripped the ticket dispenser off the wall, and declared that fairness just doesn't matter when survival is on the line.
That is a great way to put it. And that military arithmetic, it migrated into civilian medicine over the next century, and it really became the absolute prime directive of modern nursing prioritization.
Which is?
Treat what will kill the patient soonest first.
Which sounds completely obvious until you are actually standing in a chaotic room with 5 injured people.
Oh, 100%.
Because knowing that you must treat what kills fastest is one thing.
Yeah.
But how do clinicians actually measure that? I mean, how do you look at a complex human body and instantly calculate the countdown timer on their life?
Well, you rely on the ABCs.
Okay, the famous ABCs.
Right. But to understand how those became the gold standard, we really have to look at how disjointed trauma care was up until the late 1970s.
Wait, the 70s? So who actually standardized this?
Yeah.
Was it like a gradual evolution, or did someone finally sit down and write a manual?
It was actually born out of a specific harrowing tragedy.
Oh, really?
Yeah. In 1976, there was an orthopedic surgeon named Dr. James Steiner. He was piloting a small plane with his family over Nebraska, and the plane crashed into a cornfield.
Oh, my God.
Yeah. His wife was killed on impact, and he and his children sustained severe, complex injuries.
That's horrifying.
It is. And when they eventually flagged down help and arrived at a local rural hospital, Dr. Steiner was just appalled by what he saw.
I can only imagine. I mean, you survive a plane crash, you think you're finally safe, and then you realize the hospital doesn't even know what to do with you.
Right. The medical staff there, I mean, they were well-meaning, sure, but the care was disorganized and completely inconsistent. They just didn't have a systematic way to evaluate multiple trauma victims.
So they were just winging it.
Basically. And Steiner realized that surviving the physical accident was merely phase 1. Surviving the chaotic hospital response was phase 2.
Wow.
So that experience drove him to collaborate with colleagues to create the Advanced Trauma Life Support Program, or ATLS. And that is really where we get the widespread formalization of the ABCs.
Airway, breathing, circulation.
Yes. The logic is brutally straightforward.
Right, because without an open airway,
oxygen can't get in, right, making your lungs useless. And without breathing, oxygen doesn't get into the blood. And without circulation, a beating heart, that oxygenated blood never reaches your brain.
it's a domino effect.
Exactly. And modern nursing actually expands this sequence to A, B, C, D, E.
Okay, what are the D and E?
They add disability, which means conducting a rapid neurological check to see if, the brain is swelling, and then exposure.
Exposure, meaning you have to physically undress the patient.
Right, because you cannot treat a hidden femoral artery bleed if the patient is wearing thick, blood-soaked winter clothing. You expose the skin to find the hidden threats and then immediately cover them up to prevent hypothermia.
Because hypothermia worsens bleeding.
Right. Dramatically worsens it, yes.
Okay, let's bring this back to that car crash scenario from the beginning, because it highlights how this framework prevents nurses from being distracted by the visual drama.
Oh, the screaming guy versus the quiet guy.
Yes. We have the patient with the mangled, bleeding leg and the quiet patient with the squeaky voice. Tell me about the physiological mechanics of that squeak, what the sources call stridor. Why is that the immediate threat?
Okay, so stridor happens when the airway, like the trachea or the larynx, is severely swollen or obstructed.
Okay.
Imagine a wide pipe that suddenly swells shut until only a tiny pinhole remains. The lungs are desperately trying to suck air through that tiny rigid gap, which creates that high-pitched squeaking vibration.
So it's literally an alarm bell that the pipe is about to close entirely.
Exactly. When you hear stridor, you are listening to an airway that is perhaps minutes or even seconds away from complete irreversible closure.
And once that happens, the patient suffocates.
Right. Whereas the patient with the mangled leg, while visually terrifying, is dealing with a circulation issue.
The C and the ABCs.
Yes, unless it is a catastrophic, geyser-like arterial hemorrhage that will drain their blood volume in 60 seconds, a standard venous bleed gives you a slightly longer window to apply a tourniquet.
Meanwhile, the quiet patient is suffocating right in front of you.
Exactly.
It is just a profound mismatch between what looks most urgent and what actually is. But you know what I find incredible in our sources?
What's that?
That even these life or death foundational rules are subject to change based on new data.
Oh, right. What's fascinating here is the 2010 pivot by the American Heart Association.
Yes, the CPR change.
Right. For decades, CPR was drilled into everyone's head as ABC, airway, breaths, compressions. You tilt the head back, you give 2 rescue breaths, then pump the chest.
But they completely flipped it, right? To CAB compressions first. Why did they do that?
Well, researchers analyzed real-world cardiac arrests, and they found a fatal flaw in human behavior. Bystanders were wasting massive amounts of precious time trying to figure out the exact right head tilt maneuver.
Or they just didn't want to do mouth-to-mouth on a stranger.
Right. They were too hesitant. And during that hesitation, 0 blood was moving to the brain.
They were basically losing the patient while trying to follow the acronym perfectly.
Exactly. The AHA realized that the blood already has enough residual oxygen in it to sustain the brain for a few minutes, provided you physically pump it.
So they changed the rule.
They did start mashing on the chest immediately. Millions of medical professionals and everyday citizens had to entirely relearn the most famous medical acronym backwards just to eliminate that human hesitation.
That perfectly illustrates how prioritization is this, like dynamic science. Okay, so the ABCs solve the first 3 minutes of an emergency.
Right.
But a nurse's shift is 12 hours long.
Oh, absolutely.
Once a patient isn't actively dying, how do you prioritize the next 11 hours and 57 minutes of care? Because to figure that out, modern nursing borrows heavily from psychology, specifically Abraham Maslow.
Yes. Maslow's 1943 paper, A Theory of Human Motivation, was a seismic event in psychology.
A total game changer.
Totally. At the time, Maslow was deeply frustrated. He felt his field was trapped in this false binary.
How so?
Well, on one end, you had Freudian psychoanalysis, which was oppressively focused on neuroses, pathology, and the broken mind.
Right, digging through childhood trauma to figure out why you're miserable.
Precisely. And on the other end was behaviorism. Think of B.F. Skinner and his rats pulling levers for food pellets.
Right, classical conditioning.
Maslow argued that behaviorism treated humans like empty, mindless stimulus response machines. It entirely ignored our rich inner lives.
So what did he do?
He wanted a third force, which became humanistic psychology. Instead of studying the broken or the conditioned, Maslow decided to study the healthiest, most high-achieving people he could find. Minds like Albert Einstein and Eleanor Roosevelt.
He wanted to reverse engineer what makes a human being thrive.
Exactly. So he proposed that human motivation is driven by an ascending hierarchy of needs.
Right, starting from the bottom.
At the very foundation are our physiological requirements: oxygen, water, food, sleep.
The absolute basics.
Once those are secure, we seek safety and security, then love and belonging, then esteem and respect.
And at the very top.
Finally, at the pinnacle is self-actualization, the desire to reach our absolute ultimate potential.
And nursing education actually adopted this as a filtering mechanism.
It did, yeah.
It gives students an intuitive way to rank competing demands. The golden rule the sources mention is airway and breathing before feelings.
It creates a really clear boundary. Imagine a patient recovering from a major surgery. They are highly anxious, crying, and begging you to explain their biopsy results.
Which is a huge emotional need.
Huge. But you notice their oxygen saturation monitor is dropping to 88%.
Oh boy.
Right. Maslow's logic dictates you must aggressively fix the physiological oxygen problem before you even attempt to address the psychosocial anxiety problem.
Because a patient who is actively suffocating cannot cognitively process your emotional reassurance anyway.
Exactly. It just doesn't work.
And within that framework, there is another incredibly useful tool, the actual versus potential rule.
Yes. It solves the dilemma of competing physical needs. Generally, a problem that is currently happening outranks a potential risk.
Right, so like...
Well, if you have patient A who is experiencing moderate pain right now, and patient B who is simply at a high risk for falling out of bed but is currently tucked in safely, you go give patient A their pain medication first.
But the sources note that a potential risk can instantly hijack the priority list.
Oh, entirely. If you are walking toward patient A with that pain medication and you hear patient B trying to climb over their bed rails,
the potential problem just transformed into an immediate physical threat.
Exactly. Patient B jumps to the front of the queue and you drop what you're doing to prevent the fall.
Okay, here's where it gets really interesting for me. Because if you say the name Maslow, everyone immediately pictures the pyramid.
Oh, yes, the famous pyramid.
It is arguably the most famous visual in the history of psychology. It's in every intro textbook, it's on dorm room posters, it's in every corporate HR PowerPoint presentation you've ever sat through.
So true.
But our sources reveal a massive historical blind spot. Maslow never drew the pyramid.
It is such a stunning piece of historical revisionism. You can read his entire 1943 paper, top to bottom, and you will not find a single triangle.
So where'd it come from? Who drew it?
The pyramid was actually invented in the 1960s by business management consultants.
You joking?
Nope. They took Maslow's nuanced, fluid ideas and flattened them into a rigid, color-coded triangle to sell corporate motivation training to executives.
Wow. Which means nursing students are often memorizing a second-hand, oversimplified corporate management diagram to make medical decisions.
Yes.
That seems, honestly, slightly dangerous.
Yeah.
What gets lost when we force complex human needs into a corporate triangle?
Well, we lose the fluidity of the human experience. I mean, Maslow himself didn't believe we move through these stages like a video game, unlocking one level before we are allowed to access the next.
Right, life isn't that linear.
It's not. Furthermore, late in his life, he actually added a tier above self-actualization called self-transcendence.
That's that.
It's the desire to connect to something greater than the self, which of course was completely left off the corporate pyramid.
Of course. And there are pretty severe critiques of using this strict hierarchy in a hospital setting, right?
The critiques are substantial. Cross-cultural research demonstrates that the hierarchy carries a heavy Western individualistic bias.
How so?
It places personal self-actualization at the absolute peak, whereas many Eastern or indigenous cultures might place collective harmony, elder respect, or relational needs far higher than individual achievement.
That makes total sense.
Moreover, people who are deeply food or safety insecure don't just stop loving their families.
Right. You don't pause your need for connection just because you missed lunch.
Exactly. And if a clinician applies this flattened pyramid too rigidly, it can actively endanger patients.
Give me an example of that.
Consider a deeply suicidal patient. Under a strict, literal interpretation of Maslow, physiological needs always come first, right?
Right.
So if that suicidal patient complains of mild nausea, a rigid follower might conclude they must treat the physiological nausea before dealing with the psychological safety risk.
Which is obviously a catastrophic failure of judgment.
Hmm.
A suicidal patient's psychological safety must absolutely override a minor physical complaint.
Exactly. The hierarchy is meant to be a heuristic, a general rule of thumb, not an unbreakable law of nature. Context is everything.
Which actually brings us to the most extreme context possible. We've talked about the ABCs for a single patient and Maslow for managing a small group on a hospital floor. But what happens when the entire medical system breaks down?
Oh, right.
When you are dealing with a mass disaster like a train derailment or a structural collapse, and you have 40 patients but only 2 medics.
Yeah, that's when you enter the realm of disaster triage. And this requires a complete inversion of the ethical compass we just discussed.
In what way?
Well, in the U.S., responders often use a system called START, simple triage and rapid treatment.
And the sources mentioned this was developed by Ho Hospital and the Newport Beach Fire Department in California. How does it physically work in the field?
It is designed for terrifying speed. A responder must evaluate a victim in under 60 seconds.
60 seconds, that's nothing.
It's incredibly fast. They use the RPM check, respiration, perfusion, and mental status.
Break down perfusion for a moment. How do they check that in under a minute?
They check capillary refill. So they press down hard on the patient's fingernail until the nail bed turns white. Then let go and count how many seconds it takes for the pink color to return.
Oh, okay.
If it takes longer than 2 seconds, it means blood isn't circulating properly to the extremities, indicating severe internal bleeding or shock.
Wow. Just from a fingernail.
Yeah. And based on that quick RPM check, the patient receives a colored tag.
Right, the tags.
Red means immediate. They have life-threatening injuries but can survive with rapid intervention. Yellow is delayed, meaning serious but stable. Green is for the walking wounded.
Okay.
And then there is the black tag.
Yeah. This is the part of the sources that genuinely stopped me in my tracks. The black tag is for the expectant, meaning their injuries are so catastrophic that they are incompatible with survival given the limited resources.
That's right.
Wait, so the absolute sickest patients, the ones who normally would get an entire team of surgeons and every machine in the hospital, are deliberately treated last or entirely abandoned.
They are provided palliative comfort if possible, but no life-saving resources are expended on them.
That is a total ethical flip. I mean, we expect the most desperate person to get the most help.
In a functioning hospital, yes, but in a disaster, normal hospital ethics will lead to a systemic massacre.
A systemic massacre, wow.
It is a grim mathematical reality. If you have 10 salvageable patients who need immediate tourniquets and chest seals, and one profoundly crushed patient who is unlikely to survive even with maximum surgical intervention.
Pouring all your time and bandages into that one unsalvageable patient guarantees the other 10 will bleed to death waiting for you.
Exactly.
So the explicit stated goal of disaster triage is unequal care.
The goal is to maximize total survival. You are forced to deliberately withhold resources from the most desperate cases to save the most salvageable lives. It is literally the trolley problem brought out of the philosophy classroom and dropped into the real world.
But this isn't just something that happens in earthquake rubble, right? Because this kind of algorithmic sorting happens inside modern, well-led hospitals too.
It does, yes. Modern emergency departments rely on standardized scoring algorithms to remove human hesitation. They use frameworks like the Emergency Severity Index or ESI, which is a 5-level system.
How does that work?
Level 1 requires immediate, all-hands-on-deck resuscitation. Level 5 is, a minor rash or a prescription refill.
But relying on math and algorithms to prioritize human life has a really dark side.
Yes, it certainly can.
The sources highlight a highly controversial example from the COVID-19 pandemic in 2020.
Right. During the early surges, hospitals were terrified they would run out of mechanical ventilators, so several U.S. states began drafting crisis standards of care protocols.
Which are basically algorithms to decide who gets a vent.
Exactly. Algorithms designed to automatically calculate who would get a ventilator and who wouldn't if the system reached total capacity.
Now, we are looking at this purely through the objective historical record provided in the sources. What exactly went wrong with these algorithms? Because the sources single out drafts from Alabama that actually sparked a massive federal response.
Right. So the early drafts of these scoring algorithms effectively deprioritize people with intellectual and developmental disabilities or individuals with certain chronic conditions.
Wait, how do they do that?
Well, the math was set up in such a way that these patients would be placed at the very bottom of the ventilator waitlist, effectively denying them life-saving equipment based on their pre-existing baseline.
It's like setting up a VIP lane at a nightclub. But the algorithm secretly decided beforehand that anyone wearing glasses isn't allowed in the VIP lane. Like the bouncer at the door isn't biased, he's just blindly following the math. But the math was rigged by the club owner.
That is a perfect metaphor, and it triggered immediate federal civil rights complaints to the U.S. Department of Health and Human Services.
I can imagine.
Several states were forced to drastically revise their protocols under federal scrutiny. It was a stark reminder that pure algorithms don't eliminate human bias, they simply hide it.
That's a chilling thought.
It is. An algorithm can quietly encode discriminatory value judgments about whose life is deemed worth saving, washing the bias in this, veneer of objective mathematics.
So what does this all mean? We have traced an incredible evolution today. I mean, we started with early 19th century battlefields where prioritization just meant stopping the bleeding fast enough to hand someone a musket.
Right.
Then we moved to the ABCs and Maslow's borrowed pyramid to balance physical and psychological needs.
Yep.
Then we looked at the brutal utilitarian math of disaster triage and algorithms, and it all culminates in where the profession is going right now. The sources note that the 2023 Next Generation NCLEX, which is the major exam all nurses must pass, has shifted its entire philosophy toward a dynamic clinical judgment model.
Yes. The exam has evolved beyond asking students to just memorize a checklist. It now tests whether a nurse can recognize subtle cues, analyze them, prioritize hypotheses, take action, and then immediately evaluate the outcome in a constant dynamic loop.
Because the patient's status is always changing.
Exactly. Prioritization is no longer viewed as a one-time decision you make at the door. It is a continuous act of reasoning.
And this matters so far beyond the hospital walls. I mean, the frameworks we discussed today, deciding who or what gets resources when there simply isn't enough to go around, they govern our entire society.
Oh, definitely.
They dictate how 911 dispatchers decide which caller gets the closest police car. They govern how the national organ transplant waiting list is managed. Even tech companies use these exact scarcity frameworks to decide which software bugs to fix first. Prioritization is just the universal discipline of making defensible decisions under pressure.
Which leads to a really profound takeaway when we reflect on this material.
Hey, what's that?
Well, we look at extreme frameworks like start triage, where medics are forced to brutally abandon the most desperate, complex cases, the black tags, for the greater good. But if you turn that lens inward, it makes you wonder how often we unknowingly make that exact same black tag calculation in our own everyday lives.
Wow, how so?
Think about your workplace, your community, or even your own personal emotional energy. How often do we look at the hardest, most complex, most deeply entrenched problems around us and quietly decide to just walk past them?
We just put them in the black tag pile.
We do. We sacrifice the hardest challenges simply because we feel we don't have the time or the emotional bandwidth to fix them, choosing instead to focus on the quick, easy wins. We might be applying disaster triage to our daily lives, abandoning the things that need us most without even realizing it.
That is a really lingering thought. We walk into life expecting the clarity of an X-ray.
Yeah.
We want the world to be clean, binary, broken, or not broken. But the reality is that we are constantly navigating these diagnostic muddy waters. And when the machine is broken and chaos is the only constant, the most important skill you can possibly develop is deciding exactly where to look first. Thank you for joining us on this deep dive. We'll see you next time.
Imagine you're lying in a hospital bed. Someone walks into your room wearing scrubs, checks your vitals, maybe adjusts an IV line, or, helps you with a meal.
Right, and you probably assume that the person doing those tasks is simply doing their job. Right, like just following a straightforward schedule from their manager.
Exactly. But the jarring reality is that the person turning that dial might not actually be legally authorized to decide when or why you get that intervention.
Yeah, it's wild. And if they make a critical mistake, the nurse down the hall who you haven't even seen today could literally be the one who loses their entire career.
It's just a massive high-stakes transfer of legal risk that patients are completely blind to.
Oh, absolutely blind to it. But for the healthcare workers involved, navigating who is allowed to do that and who ultimately carries the liability, well, that dictates every single minute of their shift.
And that is the mission for this deep dive. Today, based on our source material, we're looking at the concept of delegation in nursing.
Yeah, we're going to unpack the framework known as the 5 rights, explore the incredibly strict boundaries of the nursing scope of practice, and, reveal how this invisible process is the true linchpin of patient safety.
Okay, let's unpack this. What makes delegation in a hospital so uniquely dangerous? Because, in the corporate world, delegating just means handing a spreadsheet off to a junior analyst.
Right,
And
exactly.
if they mess up, you just fix the spreadsheet. No harm done.
Yeah, but in healthcare, you're dealing with a highly regulated legal framework where actual human lives are on the line. Delegation in nursing is defined as a licensed nurse transferring the performance of a selected nursing task to a competent individual.
The performance of the task.
Yes, but the crucial part of that definition, like the absolute center of gravity for this entire topic, is that the nurse retains full accountability for the outcome.
So they transfer the physical act of doing it, but never the ownership.
Exactly. You delegated the doing, but you kept the liability.
I want to pause on that because our sources make a massive deal out of differentiating delegation from an assignment.
Oh, yeah. They're very different things.
Right, because if an RN hands off 4 patients to another RN at the end of a shift, they aren't retaining accountability for those patients overnight, are they?
No, not at all. That is an assignment. The National Council of State Boards of Nursing makes a very sharp distinction here.
Okay, how so?
So an assignment is the routine distribution of work within a caregiver's own existing scope of practice. When an RN gives patients to another RN, they are passing the baton to someone with the exact same license, training, and legal authority.
Got it. So it's horizontal.
Yes, exactly.
Yeah.
Delegation, by contrast, crosses the scope of practice boundary. It moves vertically.
Like downward.
Right. It's an RN handing a task down to an LPN or a UAP, which is an unlicensed assistive personnel, like a CNA or a patient care tech.
And those people don't have the same legal standing.
Exactly. Those individuals are not legally authorized to perform that task based on their own independent professional judgment.
Okay, so an assignment is like splitting a group project with a classmate where you both get the same grade.
Sure, yeah.
But delegation is like a master architect hiring a builder. The builder swings the hammer, but if the roof collapses, it's the architect's license on the line because, well, they designed the structure and approved the builder in the first place.
That architect analogy maps perfectly onto the legal reality.
Yeah.
The architect made the initial assessment that the ground was stable and the builder was competent.
Right.
If the builder builds exactly what they were told and it fails, the architect is accountable for that flawed initial decision. And that brings us to the ultimate conceptual wall in nursing.
Which is?
Nursing judgment itself can never be delegated, period.
Let me push back on that for a second, though. Let's say you have a CNA who has worked on a cardiac floor for 20 years.
Okay, very common.
Right. They know the rhythms, they know the patients, they've literally seen it all. Meanwhile, you have a day one, brand new RN. Why can't that seasoned CNA exercise some clinical judgment? Experience has to count for something.
Well, experience makes them incredibly valuable, obviously, but it does not alter their legal scope of practice.
The law is the law.
Exactly. Assessing a patient's baseline, evaluating how their condition is evolving, and synthesizing data into a clinical plan of action, those are protected acts of nursing judgment.
So they belong strictly to the RM.
Yes. The state legislature binds those specific acts to the registered nursing license. You can delegate the collection of data, but you can never delegate the interpretation of that data.
Wow.
Yeah, the moment someone tries to pass clinical reasoning over that conceptual wall, you have a catastrophic delegation failure.
Okay, but knowing that this wall exists, how do nurses actually navigate it in the real chaotic minute-to-minute world of an emergency room or a busy med-surg floor?
It's definitely not easy.
Because you can't exactly pause a code blue to go consult a legal textbook, you know?
No, you definitely can't. They were living on a specific framework.
And what I found wild in our sources is that this framework didn't just appear out of nowhere. It was forged in the middle of a massive historical crisis.
Yeah, through the late 1980s and into the 90s, the American healthcare system was undergoing a seismic structural shift. Managed care was aggressively pushing down reimbursements.
So hospitals were losing money.
Right, and they were facing severe nursing shortages alongside these massive cost-cutting pressures. So, to keep the doors open, hospital administrators drastically restructured care delivery.
What did they do?
They flooded the floors with unlicensed assistive personnel to absorb tasks that were previously done exclusively by RNs.
Which sounds like an absolute legal nightmare if the boundaries aren't clearly drawn.
Oh, it's chaos. The Nurse Practice Acts across various states had been written for an older, more traditional staffing model.
Right, where RNs did mostly everything.
Exactly. Suddenly, RNs were being asked to manage these large teams of unlicensed workers, and state boards had very little concrete guidance on what a nurse could legally hand off without abandoning their legal duty of care.
So everyone was just guessing.
Basically, nurses were terrified of losing their licenses, and management was demanding clinical efficiency. That friction forced the NCSBN to publish a foundational position paper in 1995, clearly defining delegation.
And that is where they introduced the famous mnemonic, the 5 rights of delegation.
Yes. And what's fascinating here is how the authors engineered this framework. They deliberately modeled the 5 rights after an older, already famous pedagogical tool in nursing.
Oh, right, the rights of medication administration.
Exactly. The rights of safe medication administration, right patient, right drug, right dose, and so on. They borrowed that structure because it was incredibly effective at taking an abstract legal principle and distilling it into survival math.
It gave them the quick checklist.
Yeah, a rapid mental checklist they could run through in a high-stress environment. And then 10 years later, the American Nurses Association joined in with a joint statement, fully aligning the ethical standards of the profession with the disciplinary authority of the state boards.
Let's get into the mechanics of these 5 rights, because seeing how they apply to real patients completely changes how you view hospital care.
It really does.
So the first one is the right task. The source material notes these should be standardized, low-risk, predictable tasks. But honestly, isn't a blood pressure check just a blood pressure check?
Do you think so, Ray?
Yeah, I mean, the cuff inflates, it spits out a number. Why does this require a legal framework?
Well, a blood pressure check is mechanically identical every time, but the clinical context alters the legality of delegating it.
Okay, give me an example.
Taking routine vitals on a stable patient who is ready to be discharged is a textbook delegable data collection task. But imagine that same patient is suddenly shivering, their skin is pale, and their heart rate is spiking.
Uh-oh.
Right. In that moment, taking the blood pressure is no longer just gathering data.
Because recognizing that the patient might be going into septic shock requires interpreting what those numbers mean in real time.
Exactly. Interpreting a deteriorating trend and deciding if immediate medical intervention is required, that is a protected act of nursing judgment.
So the CNA can't do it then?
The CNA can physically wrap the cuff around the arm, sure, but the RN must be the one deciding what that falling blood pressure signifies. The task might look the same, but the risk profile has entirely shifted.
Which naturally bleeds into the second pillar, which is the right circumstance. The same task might be perfectly legal to delegate on Tuesday, but grounds for losing your license on Wednesday if the patient's condition changes.
Circumstance dictates everything. Consider checking a blood glucose level with a simple finger stick. On a stable medical floor, trained UAPs do this constantly.
Very routine.
Super routine.
Yeah.
But what if the patient is in the middle of a diabetic ketoacidosis crisis?
Oh, wow.
Yeah, their blood sugar is wildly fluctuating, their metabolic state is actively evolving, and they're probably on an insulin drip.
That simple finger stick is suddenly the linchpin of a life-or-death medication adjustment.
Exactly. It requires RN-level pattern recognition to safely manage that dynamic situation. You can't delegate it.
Right.
Another classic example is ambulating a patient, walking them down the hall to the bathroom.
Seems simple enough.
Totally standard task for a nursing assistant. But if that patient is 6 hours post-hip replacement and they are exhibiting signs of new orthostatic hypotension, meaning their blood pressure bottoms out when they stand up, the circumstance demands that an RN manage that mobility.
Here's where it gets really interesting, though. Let's say you have the right task and a stable circumstance. You still have to navigate the third right, which is the right person.
Yes, the person matters immensely.
Because verifying competency isn't just looking at someone's job title.
Yeah.
Taking vitals isn't a universally applied skill, right?
Not at all. You might have a CNA who is perfectly checked off and highly skilled at taking standard vital signs on an arm. That does not legally authorize them to pull vital signs from a complex, invasive arterial line.
Oh, that makes sense.
The label of the task, Get Vitals, sounds identical, but the specialized skill and knowledge required are vastly different.
The sources gave a striking example of this happening in long-term care facilities with tube feedings. It seems like a massive trap for nurses.
It really is. It is frequently cited in state board disciplinary reviews. In many jurisdictions, a trained UAP is allowed to administer an established routine tube feeding to a stable resident.
Because it's predictable.
Exactly, it's predictable. But almost none of those jurisdictions permit an unlicensed person to initiate a brand new feeding, or troubleshoot a clogged tube, or manage a resident who suddenly starts aspirating fluid into their lungs.
And nurses fall into this trap because they mentally collapse all those nuances into one generic bucket labeled tube feeding.
Yes, that happens all the time.
They just assume if the UAP can do part of it, they can handle the whole process.
And by doing that, they violate the standard of care by handing off the troubleshooting, which requires clinical judgment. And that brings us directly to the communication aspect. The fourth right is right direction and communication.
This one seems straightforward, but I imagine in a fast-paced environment, it gets incredibly sloppy. Like, why can't a charge nurse just look at a tech and say, hey, keep an eye on the guy in room 4, he's acting weird?
I mean, people do say that, but from a liability standpoint, keep an eye on him is legally indefensible.
Yeah, because it's too vague.
Way too vague. It provides no parameter for success or failure. Proper direction means specifying exactly what task to do, precisely what data to collect, and setting crystal clear parameters for when to report back.
So how should they say it?
You have to tell the UAP, check his blood pressure every 15 minutes.
Yeah.
And if the top number drops below 90, come find me immediately.
Ah, I see.
You don't leave them guessing whether they should report it now or just write it on the chart at the end of their shift.
Which implies that the nurse actually has to follow up. You can't just throw tasks over the fence and assume they get done.
You definitely cannot.
And according to the sources, that is the single most violated rule. The fifth right supervision and evaluation.
Supervision is the critical mechanism that turns delegation from a dangerous one-off transaction into a continuous safety loop. The delegating RN must follow up.
They have to close the loop.
Exactly. They have to verify the task was completed correctly, evaluate the patient's resulting condition, and remain physically or practically available to intervene if something goes wrong.
And if they don't?
Handoffs without follow-up are, by definition, an abandonment of supervision. It is the leading reason state nursing boards discipline licenses for negligence.
Wow. You know, the 5 rights sound like a highly logical, foolproof checklist on paper, but they aren't executed on paper.
Far from it.
They're executed in an environment of intense friction. Which brings us back to the economic reality you mentioned about the 90s. This isn't just a safety framework, it's a financial battlefield.
It absolutely is. Delegation is celebrated as a clinical efficiency tool because it frees up the RN to focus on high-level judgment. But hospital administrators know it is undeniably a cost containment lever.
Because unlicensed staff are cheaper.
Significantly cheaper than paying registered nurses. That financial reality creates a massive conflict between management's budget and the nurse's legal license.
So an understaffed hospital has a huge financial incentive to stretch delegation to its absolute breaking point, pushing nurses to hand off more than is actually safe just to survive the shift. How do nurses fight back against that kind of systemic pressure?
Well, labor unions within the nursing profession developed a specific tool for this called the Assignment Despite Objection Form, or ADO.
What does that do?
So when a nurse is handed a patient load that is mathematically impossible to manage without wildly over-delegating tasks and abandoning proper supervision, they fill out this form.
It's like a paper trail.
Exactly.
Yeah.
It allows the nurse to formally document in real time to management that they are accepting the assignment because refusing it outright could be construed as patient abandonment.
Right, which is also bad.
Very bad. But they are going on the record stating the conditions do not allow for safe adherence to the 5 rights. It is a paper shield against liability.
That friction between safety and efficiency leads to 2 distinct failure modes. The first is over-delegation. We've touched on this, handing off tasks with hidden clinical judgment or failing to supervise.
Right, and that gets your license suspended.
But the second failure mode completely flipped my understanding. Under delegation.
Yes.
If a nurse decides the environment is too chaotic and they just do everything themselves out of an abundance of caution, isn't that inherently safer for the patient? I mean, they're controlling the entire process.
It seems highly logical, and honestly, many nurses fall into this trap out of a fear of liability.
Or like a super nurse complex.
Exactly, a sort of martyr complex where they feel giving away tasks is a sign of weakness. But underdelegation is actually a catastrophic failure of care management.
Walk me through the mechanics of why that fails.
It comes down to a sheer lack of bandwidth.
Hmm.
If a highly trained critical care RN spends 2 hours of their shift performing routine bed baths and pulling standard vital signs tasks, a CNA could execute perfectly. That is, 2 hours they are actively neglecting something else.
Like what?
The complex assessment, medication titration, and clinical reasoning tasks that only their license allows them to do.
Oh, wow. I didn't think about it that way.
By hoarding the low-risk tasks, they are literally starving the patient of high-level medical judgment. Furthermore, it drives severe burnout. A nurse cannot function as a one-person healthcare system.
The psychological pressure of this environment breeds some incredibly pervasive myths. I want to rapidly dismantle a few of the core misconceptions detailed in the research because understanding why these myths persist really crystallizes how delegation impacts the care you receive.
Let's do it.
Myth number 1, once I delegate it, it's not my responsibility anymore.
This myth is born from corporate conditioning, where delegating a project removes it from your desk.
Right.
In nursing, it is the single most litigated misunderstanding. Accountability never transfers. The state board views the RN as legally answerable for the initial decision to delegate, the competency of the person they selected, and the adequacy of the supervision they provided.
So you delegated the doing, you kept the liability. Okay, myth number 2. There's a fixed list of delegable tasks. I think the general public assumes there is just like a laminated poster in the break room dictating exactly what a tech can and cannot do.
A static list cannot account for dynamic human biology.
So it changes based on the patient.
Absolutely. A complex wound dressing change might be safely delegable for a healthy patient on Monday and completely non-delegable for the patient in the next bed who has a compounding infection. The 5 rights demand a fresh, situational analysis for every single patient interaction.
That makes sense. Myth number 3, delegating means you can't handle the workload, so you're sloughing it off on the techs.
We see this deeply ingrained in nursing culture, but it is entirely false. Appropriate strategic delegation is a mandatory clinical competency.
It's part of the job.
It is a leadership skill. As we discussed with underdelegation, failing to distribute the workload is what actually jeopardizes the patient's life.
And finally, myth number 4, if the UAP makes a mistake and drops a patient, the UAP is solely liable for the lawsuit.
Liability in these cases is bifurcated. It is not an either-or situation.
So they both get sued.
Pretty much. The unlicensed assistant is absolutely accountable for performing the task correctly as they were trained to do. However, the delegating RN carries separate liability for poor judgment in deciding to hand off the task, or for failing to supervise the assistant. Both individuals can find themselves facing legal consequences for a single mistake.
Wow. If we pull back and look at the macro impact of this, why is this invisible legal dance so critical for the future of healthcare?
If we connect this to the bigger picture, we are standing on the edge of a massive demographic cliff.
The baby boomers aging.
Yes, we have a rapidly aging global population, surging rates of chronic, complex diseases, and persistent systemic nursing shortages that are only projected to worsen.
So the math simply dictates that a shrinking pool of registered nurses is going to have to manage an expanding ocean of patients.
Precisely, which means the proportion of daily, hands-on patient care performed by unlicensed assisted personnel is going to skyrocket.
That's concerning.
Getting this delegation process right, ensuring that nurses can safely scale their clinical judgment across teams of unlicensed staff, is the only way modern healthcare survives. If the 5 rights framework collapses, the quality and safety of the entire system collapses with it.
So what does this all mean for you, the listener? To recap our deep dive, you can transfer the performance of a task, but you can never transfer the ownership of a medical license.
Never.
The 5 rights task, circumstance, person, direction, and supervision are a living, breathing risk assessment process, not just a static checklist you memorize in school. And most importantly, the critical act of interpreting data and making clinical judgments remains the exclusive, legally protected domain of the nurse.
And looking forward, this framework faces an existential challenge. Critics are actively debating how the 1995 rules apply to modern technology.
Oh, interesting. Like what?
As healthcare rapidly decentralizes into models like telehealth and remote home health monitoring, how will the system guarantee that crucial fifth right, or supervision?
Oh, because they aren't even in the same room.
Right. How does a delegating RN truly evaluate the competency and actions of an unlicensed home health aide when that nurse is staring at a computer screen 50 miles away from the patient's living room?
That is a phenomenal, unsettling question, and solving it is going to dictate the safety of healthcare for the next generation. The next time you or a loved one are sitting in a clinic and someone walks in to check your vitals, remember the intricate legal machinery operating right in front of you. Keep questioning the invisible systems around you. Thanks for joining us on this deep dive. Okay, let's unpack this. Have you ever watched one of those really intense medical dramas on TV?
Oh, absolutely. Like all the time.
Right. So you know the exact scene I'm talking about. A patient crashes, the heart monitors start blaring that terrifying high-pitched tone, and a doctor yells, "Get them on oxygen!"
Yeah, and then someone immediately sprints over to the wall.
Exactly. A nurse reaches over, grabs that little plastic dial, and just, cranks it all the way up. We have literally all seen it 100 times. It looks like they're just turning up the volume on a speaker.
It does. And I mean, it feels incredibly intuitive when you watch it on a screen. If
Right.
someone is struggling to breathe, the immediate logic is just, give them more air as fast as humanly possible.
Which makes sense on the surface. But today, we've gathered this massive stack of medical history, physiological research, and clinical trials custom-tailored just for you. Because our mission in this deep dive is to completely dismantle everything you think you know about oxygen.
Because it's really not just air, but better.
No, it's not. That dial on the hospital wall, it is not a volume knob. It's actually a medication dosage. And today we're exploring the fascinating engineering, the physiological stakes, and the hidden science behind oxygen delivery devices. From the humble nasal cannula all the way up to those heavy-duty trauma masks.
Yeah, and the core premise of modern respiratory care, like the absolute foundation of it, is that oxygen is formally classified by regulatory bodies as a prescription drug.
Wait, a drug? Like literally classified as a drug?
Literally, just like any antibiotic or painkiller you might pick up at a pharmacy. Oxygen has a highly specific dose. It has a designated route of administration and very strictly defined clinical indications for when you should actually use it.
That's wild.
Right. And it also has highly documented, terrifying risks of an actual overdose.
An oxygen overdose. I mean, that phrase alone feels like a contradiction, We're taught from kindergarten that oxygen is life.
Yeah, it's the good stuff.
Right. But to really understand how we deliver oxygen safely today, we have to look at the tragic history of what happened when early doctors treated it like this limitless magical vapor instead of a precise drug.
Exactly. And to see where that limitless mindset really started, we have to go back to the brutal realities of World War I.
Okay, so the trenches.
Yeah, you had soldiers suffering from these horrific chlorine gas attacks. And the chemical would severely damage the alveolar capillary membrane in the lungs.
Which causes what, exactly?
Basically, acute pulmonary edema. Essentially, the lungs would just fill with fluid. The soldier is drowning from the inside, which leads to massive, fatal drops in blood oxygen.
God, that's horrific.
It's a nightmare. But a Scottish physiologist named John Scott Haldane stepped into this. Around 1917, he developed some of the first practical systems for delivering oxygen continuously to these soldiers.
Oh, so instead of just waving a tube in their face and hoping for the best.
Right, exactly. A sporadic whiff of gas wasn't going to cut it.
Which makes total sense in a battlefield triage situation. I mean, if a soldier is effectively suffocating on their own lung fluid, continuous oxygen sounds like a miraculous lifesaver.
Oh, it absolutely saved lives. Haldane's work laid the critical foundation. But the true nuances of oxygen therapy didn't really start to surface until an American physician named Alvin Barak came along.
Okay, when was this?
This was working from the 1920s through the 1940s. Barak invented the oxygen tent.
Like an actual tent over the bed?
Yeah, imagine a large, clear plastic canopy suspended over a patient's hospital bed, tucked under the mattress to seal it, and he would just pump oxygen into this closed environment.
Seems pretty straightforward.
It was, but Barak noticed a big issue. These tents were hot, they were claustrophobic, and incredibly difficult to regulate.
Oh, I bet. If you open it, all the gas escapes.
Exactly. Every time a nurse unzipped the tent to check the patient, the oxygen concentration plummeted. But more importantly, Barak began to suspect that bathing someone in pure, unregulated oxygen for days on end might actually carry some hidden dangers.
See, if Barack was noticing these red flags way back in the 1930s, I have to wonder why the broader medical community didn't immediately start treating oxygen with strict precision.
Well, it's about what you can see versus what you can't.
Right, because, and let me use an analogy here. If I have a dying houseplant, right, and I know it needs water, I might assume, well, a little water saves it, so an industrial fire hose must be even better.
That's a great way to look at it.
But a fire hose is just going to blast the dirt away, rip off the leaves, and completely drown the plant. So why did it take so long for medicine to see the fire hose effect with oxygen?
Because the fire hose effect with oxygen isn't always immediately visible on the outside of the body. The damage happens at a microscopic cellular level.
Oh, wow. Okay.
Yeah. So the medical community didn't truly grasp the severity until a massive cautionary tale unfolded in the 1940s and 1950s.
What happened?
At that time, incubator technology for premature babies was rapidly advancing, and doctors desperately wanted to give these tiny, fragile infants whose lungs were severely underdeveloped the absolute best possible chance at survival.
Which, of course, you want to do everything you can.
Naturally. So they placed them in these new incubators and just flooded the sealed environments with unmonitored high-concentration oxygen.
They turned on the fire hose, thinking they were giving the babies a pure, healing environment.
And it caused a catastrophic epidemic. It's a condition called retrolental fibroplasia, which modern medicine now knows as retinopathy of prematurity.
Retinopathy. So it affected their eyes.
Yes. When you flood a premature infant's bloodstream with excess arterial oxygen, it actually halts the normal growth of blood vessels in the retina.
Oh, no.
And then when the baby's eventually taken out of the incubator and returns to normal room air, that sudden drop in oxygen triggers an explosive abnormal growth of leaky, fragile blood vessels.
And that damages the eye.
Severely. These vessels scar and physically detach the retina. This well-intentioned practice ended up permanently blinding thousands of infants across the U.S. and the U.K. Thousands. Before researchers finally linked that unmonitored high-concentration oxygen to the blindness.
That is absolutely devastating. I mean, they were focusing so intensely on saving the infant's lungs, and that literal overdose of a quote-unquote healing gas permanently took away their sight.
It's horrific. And it remains one of medicine's most cited heartbreaking examples of the principle that more is not necessarily better. It definitively proved at a massive cost that oxygen has a strict therapeutic window. Too little is lethal, but too much is highly toxic.
Right. So if giving patients, especially fragile ones, unregulated oxygen caused epidemics of blindness, the immediate panic for doctors must have been, well, how do we measure and control an invisible gas?
Exactly. They needed precision.
And that necessity for control birthed what is essentially the most important split in modern oxygen devices, right? The split between low flow versus high flow systems.
Answer the one.
So how did they actually solve that engineering nightmare?
Well, they actually had to abandon traditional medical thinking entirely. To understand this leap, we have to look at 1960s Edinburgh. A physician named Dr. J.M. Campbell was watching a terrifying clinical pattern unfold in his wards.
What kind of pattern?
Patients with COPD, chronic obstructive pulmonary disease, were coming into the hospital with severe breathing flare-ups. Doctors would give them empirical oxygen from standard leaky phase masks.
Just standard procedure, right?
Right. But instead of getting better, some of these COPD patients would slip into carbon dioxide narcosis. They'd get confused, excessively sleepy, their breathing would slow down, and they would literally slip into respiratory arrest.
Wait, so the standard masks were essentially suffocating them with the very thing meant to save them.
Exactly, which is why Campbell looked outside of medicine and went back to an 18th century physics principle called the Venturi effect.
Okay, I want to make sure we really grasp this, because this is cool. Think of putting your thumb tightly over the end of a running garden hose. You narrow the opening, and the water suddenly shoots out much faster.
That is a perfect visualization.
Yeah.
If you force a gas or fluid through a narrowed section like a bottleneck, the velocity drastically increases, and the pressure actually drops.
And that drop does what?
That localized pressure drop creates a vacuum effect. It can literally suck in surrounding air. So Campbell used this 200-year-old physics concept to build a revolutionary medical mask.
Okay, how did the mask work?
He engineered a device where pure oxygen shoots through a tiny narrow jet into the mask. And because it's moving so fast, it acts like a vacuum, pulling in a very specific, mathematically predictable proportion of room air through little open windows on the side of the plastic valve.
So the mask itself is actively mixing the pure wall oxygen with ambient room air before the patient even takes a breath.
Exactly. And because of the strict physics of the Venturi jet, the ratio of pure oxygen to drawn-in room air is perfectly constant. Yeah, Campbell's invention, the Venturi mask, can guarantee an exact percentage of oxygen, typically anywhere from 24% to 60%, depending on the specific color-coded valve you snap onto it.
And it doesn't matter how the patient is breathing.
Not at all. It delivers this exact concentration, regardless of how fast, how slow, how shallow, or how deep the patient is breathing. It was a monumental shift to what respiratory therapists call fixed performance devices.
Which means we need to break down a massive misconception that I found lurking in a lot of the nursing school cheat sheets and textbooks we reviewed for this deep dive.
Oh, the flow rate issue.
Yes, we need to clearly separate flow rate from FiO2 because these two terms get used interchangeably on medical shows all the time, but they measure completely different things.
Right. Flow rate is incredibly simple. It's just the speed at which the gas is physically coming out of the wall of the tank. We measure it in liters per minute.
So if you turn the dial to 2, exactly 2 liters of pure oxygen flow through the plastic tubing every minute.
Exactly. But FiO2 stands for fraction of inspired oxygen. That is the actual final concentration of oxygen that successfully makes it down into the patient's lungs.
Okay, here's where it gets really interesting. Because a lot of charts will confidently tell you that 2 liters on a nasal cannula equals exactly 28% oxygen. But in reality, that is a total myth, isn't it?
It is a massive oversimplification. It completely ignores human behavior. Low flow devices, like that standard 2-prong nasal cannula you see on every single hospital TV show, those are variable performance devices.
Variable meaning it changes based on the person.
Yes. Because a flow rate of 2 liters per minute is far below the actual speed at which a human being inhales. When you take a breath, you inhale at peak flows of maybe 20 to 30 liters per minute.
Whoa, okay, that's way faster.
Right. So when the patient inhales, they aren't just breathing the 2 liters of pure oxygen trickling from the tube. They're forcefully sucking in massive amounts of surrounding room air to make up the difference.
I love this. Think about the last time you ordered an iced Americano at a coffee shop. Right?
Okay, I'm with you.
The flow rate of oxygen coming out of the wall, that is your shot of espresso. It is a fixed, steady amount of the strong stuff. But the final strength of your drink, the FiO2, depends entirely on how much milk you pour into the cup with it. And in this scenario, the milk is the ambient room air.
That's brilliant. And what's fascinating here is how wildly that milk volume changes from minute to minute.
Right. Because if a patient is relaxed, they're sleeping and breathing slowly through their nose, they get the espresso with just a little splash of milk. It's a strong, high-concentration drink.
Because they aren't pulling in much room air.
Exactly. But if a patient is in severe respiratory distress, panting fast and shallow, or breathing heavily through an open mouth, they are gulping down huge amounts of room air. They are flooding their espresso with milk.
Yeah, the drink gets incredibly weak.
Meaning the actual oxygen concentration hitting their lungs plummets, even though the dial on the wall hasn't moved an inch.
Exactly. 2 completely different patients placed on the exact same 2-liter nasal cannula can receive drastically different oxygen concentrations in their bloodstream. They dilute the oxygen themselves with every single breath.
That is wild.
And that's why Dr. Campbell's Venturi mask was such a medical breakthrough. It provided high enough total flow to exceed the patient's inhalation speed, taking the unpredictable variability of the patient's breathing pattern completely out of the clinical equation.
Okay, so if a standard nasal cannula is so unpredictable and a patient comes into the emergency room needing a huge amount of oxygen, why can't we just crank the dial up to 15 liters on that standard nasal cannula? Like, just force way more espresso through the tube to overpower the milk.
Because you slam into the hard physical limits of human anatomy. A standard nasal cannula practically tops out at about 6 liters per minute.
Which gives you, what, like 40%?
Under perfect breathing conditions, roughly a 44% IO2. If you turn the dial up past 6 liters on those tiny prongs, you don't meaningfully increase the oxygen concentration in their lungs. You just recreate a Category 5 hurricane inside their nasal cavity.
Oh, that sounds agonizing.
It really is. The sheer velocity of the dry, cold gas strips all the moisture from the mucous membranes. It causes severe burning discomfort, mucosal damage, and almost inevitably leads to massive bloody noses. The human nose physically cannot handle that localized flow.
Okay, so when the basic cannula maxes out and hits that anatomical ceiling, we need an engineering hack.
Exactly.
And that is where the non-rebreather mask enters the picture. This is the intimidating, heavy-duty mask you see strapped to trauma patients on TV. It covers the entire nose and mouth, and it has that distinct kind of deflated-looking plastic bag hanging off the bottom of it.
Right, the reservoir bag. And that bag is a stroke of pure engineering genius. The core physiological principle to remember here is that reservoirs increase deliverable FiO2 without requiring you to push the flow rate to anatomically impossible levels.
So how does that actually play out when you strap it to a patient?
Well, when a respiratory therapist connects a non-rebreather to the wall oxygen at, say, 15 liters per minute, that pure gas doesn't just blast into the patient's face. It routes down and fills up the reservoir bag first.
Oh, so it's a storage tank.
Yes. While the patient is exhaling, or simply pausing for a fraction of a second between breaths, that bag is actively inflating, stockpiling pure oxygen. Then, when the patient takes their next deep, desperate breath in, they draw directly from that bag of stored 100% pure oxygen.
Rather than pulling an empty room air from the hospital room.
Exactly.
But wait, if they're breathing in and out of a closed mask, what keeps them from just exhaling their own carbon dioxide right back into the bag and then rebreathing it?
That is where the non-rebreathing name comes from. The mask utilizes a series of simple but brilliant one-way flutter valves. They look like little rubber discs.
Oh, I've seen those on the sides of the masks.
Yeah. So there is a valve situated between the mask and the reservoir bag that only pops open when the patient inhales. And there are valves on the outside of the mask itself that pop open outward when the patient exhales, venting the carbon dioxide into the room.
That's so clever.
It physically prevents the exhaled CO2-laden air from traveling back down into the clean reservoir. It's incredibly efficient, allowing a non-rebreather to deliver somewhere between 60% and 90% oxygen concentration.
Wait, I need to flag something. You just said 60 to 90%, but the wall is pumping 100% pure oxygen into the bag. Why isn't the patient getting 100%?
Because it is physically impossible to get a perfect airtight seal between a mass-produced, rigid piece of plastic and the unique geometry of a human face.
Oh, of course.
Yeah, noses, sharp cheekbones, facial hair, jawlines, they all create tiny microscopic gaps. So when a patient takes a massive, forceful breath in, the vacuum pressure pulls some ambient room air in around the edges of the mask, diluting the stored oxygen.
The milk always finds a way to sneak into the espresso.
It always does.
Okay, I want to play devil's advocate for a second, looking at all this engineering. If the non-rebreather is so powerful and it gives the maximum possible oxygen, why not just use that on everyone who looks even a little breathless?
Just default to the strongest tool.
Yeah. Like if someone comes into the ER wheezing, just slap the non-rebreather on them, give them maximum oxygen, keep them totally safe, and figure out the exact diagnosis later. Why not default to maximum power?
Because, as we learned from the tragedy of the premature babies in the 1950s, maximum oxygen is never totally safe. And to see how dangerous that play-it-safe mindset is for adults, we have to look at the modern data.
Oh, right. I want to dig into that 2010 pre-hospital trial from Tasmania, the one published in the BMJ. Because reading through the stack of clinical trials we gathered for this, that specific data point completely stopped me in my tracks.
It's a huge study.
It proved that playing it safe with oxygen is actually lethal. Walk me through what those paramedics actually did in the back of the ambulance.
So the researchers set up this brilliant real-world trial. They took ambulance crews responding to patients suffering from severe COPD exacerbations and split them into two strict protocols.
Okay.
One group of paramedics followed the old-school traditional rule. They applied high-concentration oxygen via a non-rebreather type mask for the entire ride to the hospital, assuming more oxygen was safer.
And the second group?
The second group used targeted oxygen therapy. They utilized nasal cannulas or Venturi masks, specifically titrated to keep the patient's oxygen saturation monitor strictly between 88% and 92%.
A substantially lower, highly controlled target.
Exactly. And the result sent shockwaves through the medical community. The patients who received the lower, strictly targeted oxygen had substantially lower mortality rates.
Wow.
The data clearly showed that proactively giving COPD patients high-concentration oxygen in the ambulance actually killed more patients than it saved.
That is insane. I was looking at the notes you pulled on why this happens, and I have to admit, the physiology completely threw me. Because I've always heard this old medical rumor, a textbook myth really, that giving COPD patients oxygen, quote-unquote, kills their hypoxic drive.
Right, you hear that all the time.
The theory goes that they retain so much carbon dioxide chronically that their brain gets used to it and they only remember to breathe because their oxygen is low. So if you give them pure oxygen, you remove the alarm bell and they just stop breathing. Is that what killed those patients in Tasmania?
No, and that concept of the hypoxic drive is a massive controversy. Frankly, it's a gross oversimplification that still haunts nursing and medical schools today.
Oh, really?
Yeah. It is critical to state that withholding needed oxygen from a severely hypoxemic patient, someone with critically low blood oxygen, is incredibly dangerous. You must oxygenate them. The real reason excess oxygen harms COPD patients isn't because they forget to breathe.
And what is it?
It involves two complex, beautifully intricate physiological mechanisms. The first is called VQ mismatch.
Okay, think of VQ mismatch like a smart highway system routing traffic. If you've ever had a bad chest cold or a localized lung infection, your body was actually doing this without you even realizing it.
Exactly. If a specific part of your lung is damaged or blocked by mucus, it isn't getting good airflow. And your body is incredibly smart. It realizes there's no point sending blood to a dead zone.
So it reroutes it.
Yeah, it actively constricts the blood vessels in that damaged area, diverting the blood flow, the traffic away to the healthy parts of the lung where the oxygen actually is.
It closes the broken bridge and reroutes the cars. But what happens when you strap a non-rebreather on that patient and flood the entire lung with pure oxygen?
You completely override the lung's own defense mechanism. The pure oxygen forces its way into the poorly ventilated, damaged areas of the lung.
And the body reacts to that.
Yes. The local blood vessels sense the sudden spike in oxygen and dilate, they open back up. The body thinks the bridge is fixed, so it sends blood back to the damaged area. But here's the fatal flaw. That area still has terrible airflow mechanics, meaning it cannot effectively exhale carbon dioxide.
Oh, no.
So you end up sending massive amounts of blood to parts of the lung that trap CO2 inside the body.
You literally trick the highway system into sending traffic into a dead end. That's wild.
And what is the second mechanism driving this CO2 trapping?
It brings us back to the Haldane effect.
Yeah.
Remember John Scott Haldane from the WWI trenches?
The continuous delivery guy.
Right. He discovered a fascinating quirk of blood chemistry. Hemoglobin is the protein in your red blood cells that acts like a molecular delivery truck. It can carry both oxygen and carbon dioxide.
Okay.
But when hemoglobin binds tightly to oxygen, it actually changes its physical shape.
Mm-hmm.
So when you flood the bloodstream with pure oxygen, the hemoglobin becomes so saturated that it chemically drops its grip on carbon dioxide.
Wait, really? Yeah, dumping all this extra trapped CO2 directly into the blood plasma.
So the patient isn't passively forgetting to breathe. The high concentration oxygen is actively forcing their own blood chemistry to dump toxic levels of trapped CO2 back into their system.
Exactly. And that sedates their brain and causes respiratory arrest.
That is, I mean, if we connect this to the bigger picture, it proves exactly why matching the specific device, the cannula, the venturi, the non-rebreather to the specific physiological need is literally a matter of life or death.
It's crucial. And this debate over hyperoxia, giving too much oxygen, isn't isolated to just COPD either. We see the exact same stakes in emergency resuscitation.
Really? Where else do we see this?
A landmark 2010 study by Dr. Stephen Kilgannon looked at post-resuscitation care. If a patient suffers a cardiac arrest and paramedics successfully restart their heart with CPR, the old reflex was to blast them with 100% oxygen to protect the brain.
Which again sounds perfectly logical.
Right. But Kilgannon's data proved that high arterial oxygen after a cardiac arrest actually causes severe oxidative tissue injury, and it leads to substantially worse neurological outcomes.
Wow. So even when a patient is literally brought back from the dead, the reflex to maximize oxygen is scientifically proven to be the wrong move.
Absolutely. And we watched these intense device selection debates play out on a global, terrifying scale during the COVID-19 pandemic, too.
Oh, right, because oxygen was the primary treatment.
Exactly. Early on in the crisis, there were massive arguments over using high-flow nasal cannulas, or HFNCs. These are highly advanced systems that heat and humidify the oxygen, pushing massive flow rates up to 60 liters per minute.
60 liters? That's insane.
It's a ton. And doctors desperately wanted to use them because they provided enough respiratory support to keep failing COVID patients off invasive, traumatic ventilators.
But there was a massive catch with pushing 60 liters of gas a minute into someone's nose, wasn't there?
Yeah, the fear was aerosolization. The sheer velocity of the high-flow gas could potentially catch the viral particles in the patient's respiratory tract and blow them across the hospital room in a fine mist.
Oh, massively increasing the infection risk for the nurses and doctors standing nearby.
Exactly. It was a brutal triage debate playing out in real time in ICUs globally. Do you use the specific device that might save this patient's lungs but risk aerosolizing a deadly virus into the ward?
And when you look at those global stakes, it wasn't just about infection control either. It was about sheer logistical volume. I mean, I am thinking of the devastating oxygen crisis in India during the spring of 2021.
That was truly heartbreaking.
The surge of COVID cases was so immense that hospitals were physically draining their bulk liquid oxygen tanks. When a hospital runs out of the sheer volume required to run thousands of high-flow systems, patients die. Choosing between placing a patient on a 2-liter nasal cannula, a 40% Venturi mask, or a 15-liter non-rebreather, it stops being just a technical clinical decision. It becomes a massive public health and emergency logistics puzzle, and healthcare workers are solving it minute by minute, trying to stretch a finite resource.
It really is the front line where applied physics meets public health infrastructure. You are trying to control an invisible, highly reactive gas within a biological system that is constantly deteriorating and changing.
So what does this all mean? We started this deep dive by stating that oxygen is not just air, but better. It is a highly regulated, potent prescription drug.
Exactly.
The flow rate coming out of the wall is not the same thing as the fraction of inspired oxygen actually reaching the lungs. Oxygen has a very real, very dangerous therapeutic window. And that simple piece of plastic sitting in a sterile wrapper on a hospital tray, it isn't just a mask. It's a highly engineered tool designed for a very specific clinical mission.
And using it correctly requires a deep, interconnected understanding of fluid dynamics, pulmonary anatomy, and intricate blood chemistry.
I can guarantee you the next time you walk through an emergency room, or you see an ambulance rush by with its lights on, or you just sit on your couch watching a medical drama on TV, you are going to look at those clear plastic tubes completely differently.
You definitely will.
You won't just see a prop anymore. You now know the secret language of the devices. You know whether that TV doctor is accidentally ordering a variable, unpredictable espresso shot or a precision-engineered 28% mix.
Which raises an important, lingering question to leave you with today.
What's that?
Despite all this incredible engineering we've explored today, our highest delivery, most advanced oxygen masks on Earth still max out because ambient room air inevitably sneaks in around the edges of the face seal.
The milk sneaking into the espresso.
Right. But what happens when we push the human body into extreme environments where room air itself is toxic or entirely non-existent?
Yeah. If our entire modern medical foundation relies on the physics of diluting pure oxygen with ambient room air, how do we completely rethink and re-engineer these delivery devices for a medical emergency during a saturation deep-sea dive or, in the rapidly approaching future of deep space medicine?
So I want you to picture a 17th century doctor just standing in this dim candlelit room trying to physically pump the blood of a live sheep into a human patient.
I mean, it sounds like a horror movie.
It really does. And it was absolute unmitigated chaos. I mean, the results were exactly as disastrous as you would imagine.
Right, yeah.
But contrast that horrifying image with today, because when you think of modern nursing, there is this expectation of absolute unbending precision. It's like an assembly line of safety. Barcode scanners, exact milligram dosages, double-locked medication cabins. Everything is just highly, highly controlled.
Oh, absolutely. And it's a system designed entirely around eliminating variables. Because, we crave predictability in medicine, especially when we're dealing with something as volatile as human biology.
Exactly.
The early days of transfusion were quite literally a shot in the dark. They didn't even fully grasp what the fluid they were transferring actually contained.
And that terrifying contrast is the mission of today's deep dive into our sources. We are taking a really comprehensive look at the modern science of blood transfusion.
Yeah, it's a huge topic.
It is. Specifically, we're unpacking the safety protocols, the severe physical reactions, and the absolute non-negotiable rules for the nurses administering it. Because this isn't just like a routine hospital checklist for you to fill out.
No, definitely not.
It is a high-stakes, risk-bearing treatment. A nurse's vigilance at the bedside is the literal difference between life and death.
And it requires that level of vigilance because, on the surface, A blood transfusion sounds deceptively simple.
Right, like a plumbing fix.
Exactly. You have a leaky system or an empty tank, and you just put fluid back into it to bring the pressure up.
Hmm.
But the reality is that transfusion is a really complex, constantly shifting science. We're transplanting liquid tissue from one human being to another.
Liquid tissue. That's a crazy way to think about it.
But that's what it is. And the rules of what we give, when we give it, and how we monitor the body's reaction to it, they've radically evolved.
So to really grasp those modern rules, we sort of have to look at how we even figured out what blood, is. Because for the longest time, a transfusion just meant take blood from person A, put it into person B, and cross your fingers.
Yeah, and the foundational breakthrough there didn't even happen until the turn of the 20th century.
Really? That late?
Yeah, in 1900 and 1901. There was an Austrian physician named Karl Landsteiner, and he was mixing serum and red cells from his colleagues in a lab.
Just casually mixing his coworker's blood.
Basically, yes. And he noticed that certain combinations caused the blood to clump up or agglutinate. It was essentially turning into a thick sludge.
Oh, wow.
Right. And that single observation led him to discover the distinct blood groups we now know as A, B, and O. And then his colleagues identified the AB group shortly after, in 1902.
Which finally explained why some of those early desperate transfusions miraculously saved the patient, while others killed them almost instantly.
Exactly.
The blood was literally clumping up inside their veins.
It was a monumental discovery. But the tragedy of foundational science is that the recognition often lags decades behind the application. Landsteiner didn't win the Nobel Prize for this until 1930.
Wait, nearly 30 years later?
Yep, nearly 30 years.
That is wild. But, okay, even with the blood types figured out, the physical logistics of moving blood from one body to another, it just sounds like a surgical nightmare back then.
Oh, it was incredibly grueling. So around 1906 and 1907, an American surgeon named George Quile was performing direct artery-to-vein transfusions.
Direct, like no tubes or bags.
Well, you couldn't just use a needle in a bag. You had to physically slice open the blood vessels of the donor and the recipient and stitch or clamp them together with tubing.
Oh, my God.
Yeah. It required extreme surgical skill. You couldn't really measure how much blood was actually being transferred. And it was really only viable in the absolute most desperate emergencies.
Just two people literally tethered together in a surgical theater. I mean, that is not a sustainable medical practice.
No, not at all. The real game changer, the thing that actually made modern blood banking possible, happened in 1914.
Okay, what happened then?
Two physicians, Luis Agode in Argentina and Albert Huston in Belgium, independently figured out a chemical workaround.
Oh, okay.
They realized that if you add sodium citrate to blood as it leaves the body, it prevents it from clotting.
How does that actually work, though? Does it, freeze the cells or something?
It's all about calcium. So the human body's clotting cascade relies heavily on calcium to form those biological nets that stop bleeding.
Right.
Sodium citrate binds to the calcium in the extracted blood. It essentially locks it up so the blood can't clot. Suddenly, you didn't need the donor in the room anymore.
You had a chemical pause button.
Exactly. You could store the blood in a glass bottle and use it days later.
Which obviously changes the entire landscape of global medicine, especially with the world wars kicking off right around then.
Definitely. World War I saw the first organized use of stored blood on the battlefield by Oswald Robertson.
Mm-hmm.
And then World War II drove this massive institutionalization of the field.
Okay.
Charles Drew, who was an African-American surgeon and researcher, he developed large-scale methods for processing and storing blood plasma. He directed the massive Blood for Britain program in the early 1940s, and he really helped structure the American Red Cross's blood banking system.
Let me pause on that for a second, because our sources highlight a massive shift in how we actually deliver this blood today.
Right.
Because back on those battlefields, they were giving people whole blood, literally everything that came out of the donor's arm. But if you or I end up in the hospital today after a car crash, we aren't getting whole blood, are we?
In civilian medicine, almost never.
Wow, okay.
And that represents a fundamental shift in our definition of a transfusion. Today, when we say blood transfusion, it almost universally means component therapy.
So they break it down.
Yeah. When you donate a pint of whole blood, the lab spins it down in a massive centrifuge. They separate it into its parts. Packed red blood cells, fresh frozen plasma, platelets, and cryoprecipitate.
So it's more like a customized biological recipe. Like if I'm bleeding out, I might get red cells for oxygen, plasma for volume. and platelets for clotting, but they're all coming from different bags.
Exactly. Whole blood is mostly reserved for military trauma medicine out in the field and, some very specific pediatric cardiac surgeries.
Oh, interesting.
Yeah. Though I will say there is a bit of a current revival in researching low-titer O whole blood for severe pre-hospital hemorrhage. But generally, component therapy remains the absolute default.
Yeah.
We give the patient only the specific part of the blood they are missing.
That makes a lot of sense from an efficiency standpoint. But the sources point out another massive shift, and this one is about when we decide a patient actually needs that blood.
This is a huge one. For most of the 20th century, the medical culture was incredibly liberal with blood.
Yeah.
The operating assumption was basically, when in doubt, transfuse. Doctors wanted to keep a sick patient's hemoglobin levels really high, usually near 10 grams per deciliter.
Because intuitively, I mean, if you are sick or injured, having a full tank of oxygen-carrying red blood cells just feels like it would help you heal faster.
It feels incredibly intuitive. But, biology rarely cares about our intuition.
Fair enough.
In 1999, there was a landmark study published in the New England Journal of Medicine called the CHIRI-CEC trial, and it completely upended this logic.
What did it find?
Well, it compared that liberal strategy to a restrictive strategy, where doctors forced themselves to wait. They only transfused when a stable patient's hemoglobin dropped all the way down to 7 grams per deciliter.
That sounds incredibly risky, like letting a patient get that anemic before intervening.
The results were staggering, though. The restrictive strategy proved that giving less blood produced equal or sometimes significantly better outcomes for the patients.
Wait, better outcomes by withholding a treatment? Why?
Because a transfusion is essentially a liquid organ transplant.
Oh, right. You said that earlier.
Right. When you infuse foreign biological tissue into a sick patient, you are introducing a massive inflammatory and immune burden. It causes immunomodulation, meaning it can actually suppress the patient's own immune system, which increases the risk of infection.
Wow.
It also risks volume overload, which stresses the heart. The CHIRI-CEC trial forced the medical community to realize that blood is a risk-bearing treatment, not just some harmless tonic. Today, that restrictive threshold fundamentally dictates how a nurse interprets a patient's lab results.
So if we are injecting foreign tissue that carries that much inflammatory risk, the biological matching process has to be, flawless.
It's absolutely flawless.
Let me try an analogy here to unpack the biology of compatibility, because antigens and antibodies can get pretty abstract quickly.
Let's hear it.
Okay, imagine the antigens on the surface of your red blood cells are like a team uniform. You're wearing an A uniform or a B uniform. And the antibodies floating around in your blood plasma, the liquid part, are like bouncers at a very exclusive club.
That's actually a highly accurate way to visualize it. The antigens are the physical identifiers, and the antibodies are the immune system's security force.
So if you have type A blood, you're wearing the A uniform. Your plasma has anti-B bouncers constantly on patrol.
Correct.
If a red blood cell wearing a B uniform gets infused into your bloodstream, those anti-B bouncers are going to aggressively attack it.
And they don't just, escort it out, they destroy it entirely.
Jeez.
The medical term for that destruction is hemolysis. The recipient's bouncer antibodies latch onto the incompatible donor cells and literally rupture the cell membranes.
And what does that physical destruction actually do to the patient lying in the hospital bed?
It triggers a systemic catastrophe. When those millions of red cells rupture simultaneously, they dump their contents, specifically free hemoglobin, directly into the bloodstream.
And that's bad.
Very bad. Inside a cell, hemoglobin carries oxygen. But free-floating in the blood, it is incredibly toxic.
Oh, wow.
It travels to the kidneys and physically clogs the delicate renal tubules, causing sudden acute kidney failure. Furthermore, all that massive cellular debris activates the body's clotting cascades inappropriately.
Wait, so the blood starts clotting everywhere?
Exactly. It leads to a condition called disseminated intravascular coagulation, or DIC. The body forms microscopic clots in all the small blood vessels, which consumes all your clotting factors, meaning you simultaneously start bleeding uncontrollably from everywhere else.
That is horrific. Clotting and bleeding at the same time.
It triggers systemic shock, and this entire cascade can be fatal within minutes of the incompatible blood hitting the patient's vein.
Within minutes? That is terrifying. And that's just the ABO uniform system, right? The sources also heavily emphasize the RH factor.
Right, the RH factor, which is the positive or negative attached to your blood type. About 85% of people carry the RHD antigen on their cells. They are Rh positive. The remaining 15% are Rh negative. But the Rh system behaves completely differently than the ABO system. If you are Rh negative, you don't naturally have anti-Rh bouncers already patrolling your blood from birth.
Oh, really? So if I'm Rh negative and I accidentally get infused with Rh positive blood, my immune system won't attack it right away.
You get a free pass on the first exposure.
A free pass.
Sort of. You can receive that one Rh positive transfusion without an immediate hemolytic catastrophe. But that exposure teaches your immune system to recognize the foreign antigen. It essentially prints wanted posters and builds an army of anti-Rh antibodies.
So the trap is set for the second time.
Exactly. If you ever get a second exposure to Rh positive blood, that newly built army will instantly attack it, causing massive hemolysis.
Wow.
And this delayed sensitization is also the exact mechanism behind hemolytic disease of the newborn, or erythroblastosis fetalis.
How does that happen with a newborn? Like, how are they exposed?
So if an Rh negative mother is carrying an Rh positive fetus, and their blood mixes during delivery, the mother's immune system will build those anti-Rh antibodies.
Okay, I follow.
If she gets pregnant with a second Rh positive baby, her antibodies can cross the placenta and destroy the fetus's red blood cells.
Oh my God, that's tragic.
It is, but thankfully today, we prevent this entirely by giving the mother an injection called RhoGAM during pregnancy.
RhoGAM.
Yes. It basically cloaks the fetal cells so that the mother's immune system never even sees them, preventing the antibodies from ever forming in the first place.
It's brilliant that we can, like, hijack the immune system like that.
Truly.
Okay, speaking of the immune system, I have to bring up a huge assumption I had before reading these sources. I've watched medical dramas my whole life, right?
Sure.
And the doctors are always shouting, "Get me O negative." So I just thought O negative was the universal donor for everything.
You and everyone else.
Yeah.
That is perhaps the most dangerous misconception in public medical knowledge. O negative is the universal donor for red blood cells only.
Right, because O negative red cells have no A antigens, no B antigens, and no Rh antigens. They are wearing a totally blank uniform.
Precisely. You can put those blank cells into anyone, and no bouncers will recognize them to attack. But for plasma transfusions, the rules run in the exact opposite direction.
Wait, really?
Yeah. Remember, the plasma is the liquid where the bouncer antibodies live. Because an O-negative person has a blank uniform, their body naturally produces both anti-A and anti-B bouncers to protect themselves. Their plasma is fully loaded with both sets of antibodies.
Oh, wow. If you give O negative plasma to a type A patient, you are literally injecting an army of anti-A bouncers directly into their bloodstream.
Exactly.
The donor plasma will start attacking the patient's own organs and blood cells.
It's a completely inverted reaction. So, if O negative is the worst possible plasma to give universally, what blood type makes for the universal plasma donor?
It would have to be someone who has absolutely zero bouncers in their plasma, so someone with type AB blood, because they wear both the A and B uniforms, so their body wouldn't make antibodies against either one.
You nailed it. Type AB is the universal plasma donor.
That is so cool.
Their plasma contains zero anti-A or anti-B antibodies. It is completely safe to give to anyone. It's a total inversion of the red blood cell rules, and it's exactly why blood banks are constantly begging for AB plasma donors.
Okay, if the biology is this unforgiving, like, if a mismatch causes your kidneys to fail and your blood to simultaneously clot and hemorrhage, then the physical act of hanging that IV bag has to be flawlessly executed.
It has to be.
If I'm lying in an ICU bed, I want a supercomputer verifying that blood.
But the sources reveal a pretty shocking plot twist about where these fatal mismatches actually happen.
We all assume it's some deeply complex laboratory failure. You know, someone mislabels a test tube or misreads a chemical assay. But the hemovigilance data systems, like the UK's SHOT program, which tracks serious hazards of transfusion, they repeatedly show that the leading cause of fatal ABO-incompatible transfusions is clerical error.
Clerical error? You mean like a typo? I mean, bedside identification failure.
Yeah.
The lab types the blood perfectly. They prepare the exact right unit. It gets sent up to the hospital floor, and the nurse hangs the correct unit of blood on the wrong patient.
Oh, my God.
Someone skips a step or feels rushed or assumes they know who is in the bed.
That makes all those annoying hospital protocols make sense. Like, every time a nurse asks for your name and date of birth, even though they just asked you an hour ago, it feels like bureaucratic overkill. But that physical check is literally the only firewall between a patient and a fatal hemolytic reaction.
It is the ultimate safety net. And because human error is so prevalent, the Joint Commission mandates a rigorous, non-negotiable two-nurse check.
2 nurses every time.
Every time. 2 qualified staff members must independently physically verify the patient's identity and the product's identity directly at the bedside immediately before connecting the tubing. They must match the name, date of birth, and unique medical record number on the patient's physical wristband against the printed label on the blood bag.
And if they don't match?
If there is a single typo, a single digit off, the blood goes back to the lab.
Then once they pass that checkpoint and the blood actually starts flowing, the tension doesn't drop. The protocols dictate that the first 15 minutes are critical, right?
Incredibly critical. The infusion must start at a very slow crawl, usually around 2 milliliters per minute. And the nurse cannot leave the room.
They just stay right there.
They must remain physically at the bedside, directly observing the patient for that entire first 15 minutes.
Because if the bouncers are going to attack, they're going to do it fast.
Acute hemolytic reactions or severe allergic anaphylaxis will typically manifest within those first few milliliters.
Okay, let's run through the ultimate bedside scenario. You're the nurse, you've done the 2-person check, the blood is running at 2 milliliters a minute. Suddenly, the patient spikes a fever, their teeth start chattering with chills, they complain of a sharp pain in their lower back, which I now know is their kidneys clogging, and they say, I just feel like something terrible is about to happen.
The impending sense of doom.
Right. What is the immediate response?
The very first step, regardless of what specific reaction you think is happening, is always the same. Stop the transfusion immediately. You clamp the line and shut off the pump.
Wait, you don't call the doctor to ask for permission. You don't slow down the drip to see if they stabilize.
Absolutely not. You stop the exposure to the foreign tissue. Next, you must keep the patient's IV access open because you are going to need to push emergency medications. You do this by running normal saline.
Okay.
But here is the critical detail that catches people off guard. You must completely disconnect the blood tubing and use entirely new saline tubing.
Wait, why can't you just hook the saline bag up to the existing tubing and just flush it through?
Think about the physical tubing. It is full of the incompatible donor blood. If you flush that line with saline...
You're pushing the bad blood in.
Right. You're physically pushing another 10 to 15 milliliters of lethal, unmatched blood directly into the patient's vein. So you disconnect the blood, attach fresh tubing with saline, and only then do you notify the physician and the blood bank.
That makes total sense.
And then the remaining blood bag, all the old tubing and fresh blood and urine samples from the patient goes straight back to the lab to figure out what went wrong.
Stop the blood, new tubing, run saline, notify the team. It has to be muscle memory.
Exactly.
But while you're executing that protocol, you also kind of have to be a detective, right? You have to figure out what kind of reaction is happening because the sources detail a massive spectrum of ways the body can fight back.
Yeah, we just described the worst-case scenario. The acute hemolytic reaction, where the red cells are actively rupturing. But statistically, the most common reaction a nurse will actually see is a febrile, non-hemolytic reaction.
Non-hemolytic, meaning the red blood cells are intact, they aren't exploding. So why the fever?
This is an inflammatory response. Blood isn't just red cells. It contains donor white blood cells too.
Oh, true.
While that bag of blood sits in a refrigerator for 3 weeks, those white blood cells slowly die and release cytokines. Yeah, cytokines are essentially inflammatory chemical messengers. When those messengers hit the recipient's bloodstream, they trigger the brain's thermostat, causing fever and intense chills. It's incredibly uncomfortable for the patient, but it rarely damages the organs.
Can we present that?
Yes, we prevent a lot of this today by using leukoreduced blood, physically filtering out the donor's white cells before storage.
Okay, so that's a fever from chemical messengers. What about anaphylaxis? I always associate that with like bee stings or peanut allergies where your throat closes up. How does blood trigger that?
It's an extreme allergic reaction, and it happens astonishingly fast, often after just a few drops of blood. We most commonly see this in patients who have a natural deficiency in an antibody called IgA.
Okay.
If they receive donor plasma that contains normal levels of IgA, their immune system views it as a massive foreign invader and triggers systemic anaphylactic shock airway constriction, plummeting blood pressure.
Wow. And the sources outline another massive diagnostic challenge for the critical care team. 2 reactions that look almost identical at the bedside, but require totally opposite treatments. Cherry, lye, and taco.
This is one of the most dangerous showdowns in an ICU.
Mm-hmm.
A patient is receiving blood, and suddenly they are gasping for air. Their oxygen saturation plummets, their breathing becomes rapid and shallow, and they are in severe respiratory distress. The bedside presentation is nearly identical.
Right.
But the mechanisms are worlds apart.
Let's start with taco transfusion-associated circulatory overload.
Based on the name, that sounds like a plumbing problem, like we put too much volume into the tank.
It is pure hydrostatic pressure. You've infused too much fluid too quickly into a patient whose heart or kidneys can't pump it effectively. This is very common in elderly patients or those with heart failure. The fluid basically backs up into the lungs.
Oh, I see.
It is essentially congestive heart failure triggered by the IV pull. The treatment is to stop the transfusion, sit the patient upright, and administer diuretics medications that force the kidneys to excrete the excess fluid as urine.
Pull the fluid off to relieve the pressure. That makes sense. But Troy transfusion-related acute lung injury is entirely different, and this mechanism absolutely blew my mind.
It's intense, yeah.
Because I assumed Troy was the patient's immune system attacking the donated blood in the lungs, but it's the exact reverse.
It is a devastating biological ambush. In TRAIL-I, antibodies floating in the donor's plasma launch a targeted attack against the recipient's own white blood cells, specifically inside the tiny capillary beds of the recipient's lungs.
So the donated fluid is actively attacking the patient's lung tissue.
Exactly. This attack causes intense, sudden inflammation. The capillaries in the lungs become highly permeable. They start leaking plasma directly into the alveoli, the tiny air sacs where oxygen exchange happens.
So they're drowning.
Basically. The lungs fill with fluid, but not because of volume overload like in taco. They fill with fluid because of inflammatory capillary leakage.
Which means if a nurse misidentifies TRAIL-I as taco and gives diuretics to pull fluid off,
it won't work. Diuretics don't fix an inflammatory immune attack. In fact, giving diuretics to a TRAIL-I patient can dangerously drop their blood pressure, which is already unstable from the systemic inflammation.
wow.
TRAIL-I is a leading cause of transfusion-related death precisely because it is so hard to distinguish and manage at the bedside.
And just when a patient thinks they are out of the woods, the sources highlight that the danger doesn't magically vanish when IV is removed. You can have a delayed hemolytic reaction days or even weeks after going home.
Yes. This comes down to the immune system's long-term memory. It's called an anamnestic response.
An anamnestic response. Can you translate that for us?
Sure. Think of it like a dormant memory waking up. Years ago, a patient might have been exposed to a minor blood antigen, maybe from a previous surgery or pregnancy.
Right.
Their immune system built a few antibodies, but over the years, those antibody levels dropped so low that they didn't even show up on the lab's pre-transfusion screening.
So the lab clears the blood as a perfect match.
The lab clears it, the patient receives the blood, and they feel fine. But a week later, their immune system recognizes that minor antigen, wakes up from its dormant state, and rapidly manufactures a massive new army of antibodies.
Oh, no.
Yeah, they start destroying the transfused red cells weeks after discharge. The patient suddenly develops a fever, jaundice, and dropping hemoglobin at home. It reinforces why a nurse's job isn't just hanging the blood, it's educating the patient on what subtle warning signs to monitor long after they leave the hospital.
Zooming out from the cellular level for a bit, the sources also dig into the broader systemic and historical realities of relying on human donors. And some of those realities fundamentally reshaped how we think about safety, like the debate over the age of blood.
Oh, yeah.
Because we naturally assume fresh is better, right? I wouldn't want milk that's been in a fridge for a month, so why would I want 30-day-old blood?
That bias dominated medicine for decades. Clinicians argued fiercely that older stored blood was less effective and more dangerous. But large randomized trials, specifically the ADLE trial in 2015, put that intuition to the test. They compared fresh blood, which was less than 7 days old, to standard older stored blood.
And what did the data actually say?
The data proved the bias completely wrong. The older stored blood, up to about 42 days, proved to be just as safe and just as effective at carrying oxygen as the fresh blood.
That's amazing.
Is a crucial finding, because if hospitals were forced to only use blood less than a week old, the entire global supply chain would collapse.
Wow. But, not all historical biases in blood banking were just harmless clinical assumptions. The sources bring up Charles Drew again, and a very dark chapter in the 1940s involving the U.S. military.
Right. Charles Drew was the foremost expert on blood preservation, yet he resigned from his leadership role at the American Red Cross in 1942. He resigned because the military insisted on segregating donated blood by the race of the donor.
Which, based on everything we just discussed about antigens and bouncer antibodies, is just biologically absurd.
It is entirely devoid of scientific merit. A type O negative red blood cell is identical regardless of the donor's race.
Drew protested because the policy was purely driven by social prejudice, and it really proves how easily systemic biases can attempt to override hard biological science.
And the systemic vulnerabilities of the blood supply became undeniably apparent in the 1980s, right, with the tainted blood scandals.
That was an unprecedented global tragedy. Before we had reliable scientific screening, specifically the ELISA test for HIV, which was introduced in 1985, donated blood unknowingly transmitted HIV and hepatitis C to thousands of transfusion recipients and hemophilia patients worldwide.
Just devastating.
The biological product meant to save them carried a lethal virus.
It makes you view modern protocols differently. Like, it explains why blood banking today feels like a fortress of questionnaires and advanced nucleic acid testing.
It completely restructured the field. The priority shifted to protecting the recipient at all costs, which led to incredibly stringent donor eligibility rules. It also heavily spotlighted the concept of informed refusal.
Right, a patient's right to simply say, I know the risks, but no thank you. The sources cite Jehovah's Witnesses as a major driver of this.
Yes, Jehovah's Witnesses frequently decline blood products based on religious principles, even when facing severe hemorrhage. And this presents a profound tension in medicine. The physician's drive for beneficence, the desire to save a life, clashing against the patient's absolute right to bodily autonomy.
How does the medical field respond when the standard protocol is just off the table?
It forced innovation. To respect patient autonomy without giving up on their survival, medicine developed incredible advancements in bloodless medicine.
Bloodless medicine.
Yeah, techniques like cell salvage, where a machine vacuums up the patient's own blood during surgery, washes it, and gives it right back. Or using synthetic erythropoietin to stimulate the patient's bone marrow to rapidly produce their own red cells. Necessity really drove the science forward.
If we look at this whole journey, I mean, it's staggering. We started this deep dive picturing physicians haphazardly pumping animal blood into people in candlelit rooms, and we've landed on this incredibly intricate, high-stakes modern science.
It's come a long way.
We've learned that whole blood is mostly a relic, replaced by precise component therapy. We've seen how the terrifying biology of bouncer antibodies means a simple clerical typo by a bedside nurse is the deadliest variable in the hospital. We've unraveled the mechanisms of tri-li and taco and realized that, counterintuitively, giving less blood is often the safest medical strategy we have.
It is a profound evolution. And considering all those hurdles, the immense immune complexities of matching antigens, the constant threat of human clerical errors, the massive infrastructure required to screen and store human tissue, it really raises a vital question about the future.
Which is?
How close are we to an era where we simply manufacture synthetic, universally compatible oxygen-carrying fluids in a laboratory, bypassing the human donor and all these associated risks entirely?
Now that is a thought to chew on. From 17th century sheep veins to 21st century synthetic labs. Thank you so much for joining us on this deep dive into the source material. If you're lying in a hospital bed anytime soon, hopefully you have a totally new appreciation for the science, the history, and the absolute vigilance flowing through those IV lines. Stay curious, and we'll catch you on the next one. So when you think about the human body, it's pretty natural to assume we're just entirely dependent on our brain.
Right, yeah. The brain is the master control room.
Exactly. Like if you sever the connection between your brain and, say, a leg muscle, that muscle is just paralyzed.
It just sits there.
It just sits there waiting for an order that is literally never going to come. But, and this is wild, if you take a human heart, completely sever every single nerve connection and actually remove it entirely from the chest cavity.
It could just keep beating.
Yeah, it'll just sit there on a table, totally disconnected from the nervous system, just beating on its own.
It is honestly one of the most surreal physiological phenomena you can ever witness. I mean, it completely challenges our basic intuition about how the body gets its commands.
For sure.
But, it isn't magic. It's actually this masterpiece of biological engineering and built-in autonomy.
And that autonomy is exactly our focus for you today. Welcome to our deep dive into the source material. We're going to be tracing the heart's internal electrical grid, which is called the cardiac conduction system.
A really fascinating topic.
It really is. Our mission today is to track the exact pathway of electricity from the very top of the heart, the SA node, all the way down to these microscopic things called Purkinje fibers.
Right.
And by the end of this deep dive, you will understand the brilliant physical design of this network. And crucially, if you're in healthcare, you'll know exactly what happens on a heart monitor when that wiring breaks.
Because, unfortunately, that internal wiring does break.
Mm.
And when it breaks, understanding the anatomy of that exact electrical pathway is, well, it's literally the difference between life and death.
Wow.
I mean, the interventions we use, whether that's, pushing a specific medication, implanting a pacemaker, or even charging a defibrillator, they're all dictated by where exactly the electrical signal gets trapped.
That makes a lot of sense. So to really visualize this for you, think of the heart as the ultimate, smart home.
Oh, like that.
Most organs are like regular houses, right? They're totally dependent on the city's power grid, which in this case is our central nervous system.
Right. If the city grid goes down, the house goes dark.
Exactly. But the heart is outfitted with its own off-grid generator. It doesn't actually need the city power to function at all. And in biology, this superpower is referred to as being myogenic.
That analogy perfectly clears up a really common misconception, actually. It's something that even trips up students in nursing and medicine.
Oh, really?
Yeah, because people just naturally assume the brain is constantly telling the heart to beat.
Right.
But it doesn't. That term myogenic, it literally means the origin of the heartbeat is housed entirely within the heart muscle itself.
Incredible.
Right. This independence comes from a highly specialized, dedicated network of cells. Their entire biological purpose is to generate and propagate electrical impulses.
So they aren't waiting around for a command from the brain.
Exactly. They're initiating the commands themselves.
Okay, so if the heart generates its own power, we really have to start the main generator.
Let's do it.
Which brings us to the top right corner of the heart, right where the superior vena cava meets the right atrium. This is the SA node, or the sinoatrial node.
Yep, the primary pacemaker.
And it was actually discovered back in 1907 by two anatomists, Arthur Keith and Martin Flack. And they were doing comparative anatomy, right?
Yeah, they were.
They actually found this tiny mass of specialized tissue by dissecting the heart of a mole, of all things.
A mole, yeah. It's so funny where these breakthroughs come from.
Right, and they correctly deduced that this little cluster was the origin of the heartbeat.
They found the natural pacemaker. And the way this SA node works is through a physiological property called automaticity.
Okay.
And this is driven by something electrophysiologists literally call the funny current.
See, I always find it slightly humorous when, serious biologists name a critical life-sustaining function something like the funny current.
I know, it sounds like a joke.
But it behaves in a way that completely defies how normal cells operate, right?
Precisely. Like in textbooks, you'll see it denoted as IF. And it's called funny because it contradicts all the standard cellular rules.
How so?
Well, normally, a muscle cell just rests peacefully at a negative voltage. It just sits there. It won't do anything until an electrical shock hits it, forces the voltage to flip positive, and then causes it to fire.
Okay, so it waits for a spark.
Right. But the cells in the SA node, they refuse to rest. They have these funny ion channels that are inherently leaky.
Ah, so during the resting phase, they're constantly letting positively charged sodium ions just leak into the cell.
Yes, exactly. So the internal electrical charge of the SA node cell is just slowly, inexorably drifting upward.
It's getting more positive.
Yeah, it gets more and more positive on its own until it hits this critical voltage threshold. And the moment it hits that line, the cell fires a spark.
And then it just resets.
Yep. It resets and the leaking starts all over again.
Okay, so the SA node has the leakiest channels of all, which means it reaches that firing threshold the fastest.
Exactly.
And the source material notes that in a healthy adult, this natural leakiness causes it to fire at a rate of 60 to 100 beats per minute.
Which is your normal resting heart rate.
Right. And because it crosses the finish line first, it essentially resets all the other electrical cells in the heart before they even have a chance to reach their own threshold.
Yeah, that speed is exactly why it's the primary pacemaker. It basically dictates the rhythm for the entire organ.
Okay, let's unpack this for a second.
Sure.
Because if the SA node isn't the only tissue with this automaticity, there has to be a hierarchy, right?
There is.
You have the SA node running at 60 to 100 beats per minute. Further down, the AV node can fire at 40 to 60 beats per minute.
Right.
And at the very bottom, the Purkinje tissue can fire at 20 to 40 beats per minute. I look at that and think, if the SA node is the undisputed boss of this system, isn't that a massive design flaw? Well, if the boss quits or gets permanently damaged by a heart attack or something, the whole company should just go under, right?
It definitely looks like a bottleneck at first glance. But what's fascinating here is that it's not a flaw at all. It's actually a brilliant fail-safe hierarchy.
Oh, really?
Yeah.
The SA node isn't in charge because it wields some magical biological authority, you know. It's simply in charge because it's the fastest. It just outpaces the competition.
Oh, I see.
But if that main generator fails, your body doesn't just shut down. The next fastest system, which is the AV node, detects the silence and just naturally takes over.
But wait, it maxes out at 40 to 60 beats per minute? That is significantly slow.
It is slower, yeah, but it keeps blood pumping to your brain. It buys you time.
It's better than nothing.
Exactly. And if the AV node fails, the ventricular tissue at the bottom of the heart kicks in at an even slower 20 to 40 beats per minute.
So it's like a cascading survival mechanism.
Precisely. Also, we really should clarify the physical nature of these pacemaker cells.
What do you mean?
Well, they aren't just regular working muscle cells that decided to take on a side hustle of generating electricity.
Right, they're specialized.
Yeah, they're a completely distinct population of cells. They actually lack most of the basic contractile machinery.
Meaning they don't actually squeeze very well.
Exactly. Because their cellular real estate is entirely optimized for electrical generation and rapid conduction, not physical pumping.
Wow. Okay, so we have this lightning-fast SA node at the top right of the heart, right? Sparking away 60 to 100 times a minute.
Yep.
Now, if I try to picture that electrical spark moving through the heart, my immediate assumption is that the electricity just instantly zaps the entire organ all at once.
That's what most people think.
But if the top chambers, the atria, and the bottom chambers, the ventricles, received the signal at the exact same millisecond, that would be disastrous.
It would be a complete mess.
It'd be like two people trying to push a revolving door from opposite sides at the exact same time.
I love that analogy. The door wouldn't move, and in the heart, the blood wouldn't go anywhere.
Right?
A simultaneous contraction of the whole heart would result in zero forward momentum. The top chambers would squeeze downward, the bottom chambers would squeeze upward, and they would just compress the blood right in the middle.
Ouch. So you absolutely require a coordinated sequential sequence.
You have to. The top must squeeze blood down into the bottom, and only after that finishes can the bottom squeeze blood out to the lungs and the body.
And that structural necessity brings us to the physical barrier that separates the top and the bottom of the heart.
Right, the annulus fibrosus.
Yeah, which is this dense ring of fibrous tissue that structurally divides the atria from the ventricles.
And critically, fibrous tissue does not conduct electricity.
Oh, that's key.
It's super key. The annulus fibrosus is, it acts like this perfect electrical insulator.
Okay.
So the electrical spark from the SA node washes over the top chambers, causes them to contract, but then it hits this fibrous ring and just stops cold. The signal simply cannot cross the barrier.
Except at one very specific toll booth.
Exactly. The atrioventricular, or AV node.
Right.
Tsunatawara, who was a Japanese pathologist working in Germany, he actually mapped this out back in 1906.
Wow, so long ago.
Yeah. He painstakingly dissected this junction and identified the AV node as the one natural pathway through all that fibrous insulation.
And the functional mechanics of this toll booth are just incredible because its primary job is to be intentionally slow.
Yes.
Like, the electrical signal hits the AV node, and the node actually holds onto it for roughly 0.09 seconds before finally letting it pass through to the ventricles.
It literally pauses the current.
Right. And if you look at an ECG monitor, this deliberate delay is represented by the PR interval.
Correct.
So the AV node is operating like a highly regulated traffic light on a busy freeway on-ramp, purposely holding cars back so they can merge without causing a massive pileup.
That's a perfect way to visualize it, because people often assume slow biological conduction means something is like diseased or inefficient.
Right. Slow usually means bad.
But if we connect this to the bigger picture, in the AV node, that 0.09 second delay is actually its single greatest feature.
Really?
Yeah. It is a mechanical necessity for hemodynamics, which is just the physical flow of blood.
Because that delay is what creates the atrial kick, right?
Yes, exactly.
Can you explain that a bit more?
Sure. So most of the blood flowing into the ventricles actually drops down passively. It's just driven by gravity and pressure differences while the heart relaxes.
Okay.
But that AV node delay pauses the electrical signal just long enough to give the top chambers the physical time they need to finish actively contracting.
Oh, so they squeeze out their final load of blood into the ventricles below?
You got it. That active squeeze, the atrial kick, it basically tops off the tank. It contributes 20 to 30% of the total blood volume that fills the ventricles.
Wow. A 30% boost in cardiac output, relying entirely on a delay of less than 1/10 of a second.
That's pretty amazing.
It really is. If you lose that delay, you immediately lose almost 1/3 of your heart's pumping efficiency.
Exactly.
Okay, so the electrical signal has waited patiently at the red light, the top chambers have emptied, the AV node turns green.
Green light, go.
Now the signal has to penetrate the massive, thick muscle walls of the ventricles. So we transition from a deliberate, careful delay to a requirement for absolute lightning speed.
Speed becomes the absolute priority here because the ventricles are the heavy lifters.
Right, they have a lot of work to do.
A ton of work. Once they get the green light, all those millions of muscle cells need to contract as one unified, incredibly forceful unit to push blood out to the entire body.
And to achieve that synchronization, the signal travels from the AV node into a structure called the bundle of His,
Right.
which was mapped out by Wilhelm His Jr. in 1893, amazingly, while he was still just a medical student.
Pretty good medical school project.
Not bad at all. After passing through this bridge, the pathway splits into the left and right bundle branches, which run right down the septum, the middle wall of the heart.
Yeah.
And finally, it explodes outward into a vast microscopic web called the terminal Purkinje fibers.
And Jan Evangelista Purkinje identified these unique fibers lining the inside of the ventricles way back in 1839.
Wow.
Yeah, decades before anyone understood they were the electrical wiring of the heart.
Mechanically, these Purkinje fibers are fundamentally different from regular cardiac muscle, aren't they?
Yeah.
Because they conduct electricity at a massively accelerated rate.
Oh, absolutely.
Oh.
They function as a biological superhighway.
Okay.
The goal is to distribute the signal to the very bottom apex of the heart and spread it up the outer walls almost instantaneously.
So everyone gets the message at the same time.
Exactly. This rapid transit ensures that the working muscle cells across the entire massive left and right ventricles receive the go command at essentially the same microsecond. It guarantees a sharp, coordinated, simultaneous squeeze.
Okay, here's where it gets really interesting.
Right.
If the bundle branches and Purkinje fibers exist solely to ensure that synchronized squeeze, what physically happens when the wiring breaks on just one side?
Ah.
Say the right bundle branch is conducting perfectly, but the left bundle branch is like completely severed or blocked by damage.
So what you're describing is a bundle branch block.
Mhm.
And the mechanics of how the heart compensates for this are fascinating, but it drastically reduces pumping efficiency.
How does it compensate?
Well, if the left bundle branch is blocked, the electrical signal races down the intact right side at normal superhighway speeds. The right ventricle gets the message instantly and begins to squeeze.
Right.
But the left ventricle, which handles pumping blood to the entire body, is left waiting in the dark.
Because it doesn't have a direct wire anymore, so how does the left side of the heart eventually get the message to beat?
The electricity is forced to take a massive detour.
A detour.
Yeah, it abandons the broken superhighway and has to leak over from the right side, moving cell by cell through ordinary, slow-conducting working muscle tissue.
Wow. So instead of a synchronized pump, it creates this kind of weird rolling contraction.
Yes.
The source material says it's functionally identical to a Mexican wave in a crowded sports stadium. You know, one side stands up and then the movement slowly ripples across to the other side.
That's exactly what it looks like. And that rolling contraction wastes immense amounts of mechanical energy.
I can imagine.
The right side is squeezing while the left side is still relaxed, which pushes the middle wall of the heart out of place, and that reduces the pressure generated. It is a severely inefficient way to pump blood.
And clinically, a left bundle branch block presents a massive trap for nurses and doctors reading ECGs in the emergency room, right?
Oh, a huge trap.
Because if a patient comes in with chest pain and you run an ECG, that detouring electricity drastically distorts the visual readout.
It does.
It alters it to the point where a mere broken wire can actually mimic the exact signs of a massive STEMI heart attack.
It's a notorious pitfall in emergency cardiology.
Why does it look so similar?
Because the left bundle branch block forces the electricity to travel slowly outside the normal pathways, the entire timing and direction of the signal changes.
Okay.
On the ECG monitor, the QRS complex, which is the big spike representing the ventricles firing, it becomes wide, jagged, and bizarre. And that specific distortion alters the repolarization wave that follows it. The resulting baseline shift looks virtually identical to the ST segment elevation you see when a major coronary artery is 100% occluded.
That is terrifying.
It is. Historically, if a patient arrived with chest pain and a brand new left bundle branch block, Triage protocols dictated treating it aggressively as a massive heart attack, simply because the broken wire perfectly masked what the actual heart muscle was experiencing.
Wow. So the internal wiring dictates everything you see on the surface monitor.
Everything.
And really, the way medical science ultimately proved this perfect intended pathway, from the SA node, pausing at the AV node, racing down the bundle branches, was by observing the terrifying things that happen when the system short circuits.
Exactly.
Like, let's look at Wolff-Parkinson-White syndrome, or WPW.
Right, WPW. That's a congenital condition first described in 1930.
Okay.
A patient with this syndrome is actually born with an extra physical band of muscle connecting the top and bottom of the heart.
It completely bypasses the fibrous insulation.
Yep.
And this extra connection is called the bundle of Kent. So the patient has a normal functioning AV node, but they also have this secret backdoor pathway.
Exactly.
They've essentially broken the AV node's structural monopoly.
And remember the physics we discussed regarding the AV node's delay.
The 0.09 seconds.
Right. Well, the bundle of Kent lacks that built-in delay. It conducts electricity extremely fast.
Uh-oh.
Yeah. So when the signal from the SA node fires, it hits the AV node and pauses like it's supposed to. But simultaneously, a portion of that signal shoots right down the backdoor pathway and hit the ventricles early.
Wow.
The ventricles experience what we call pre-excitation.
And having two pathways introduces a huge mechanical risk, doesn't it? Because it allows for dangerous looping rhythms.
It does. It sets up a localized reentry circuit.
How does that loop happen?
Well, because the pathways conduct at different speeds, the electrical signal can travel rapidly down the backdoor pathway, hit the ventricular tissue, turn around and travel backward up the AV node.
Because the AV node just finished its delay.
Exactly. It arrives just as the AV node finishes its delay. The signal then loops back down the back door. It becomes a continuous, self-sustaining circle of electricity.
So functionally, it's like an electrical dog chasing its own tail.
Yes. Driving the heart rate up to maybe 200 beats per minute.
That's incredibly fast.
It is. WPW serves as a perfect natural experiment, really.
Yeah.
It proves exactly why the single-lane bottleneck of the AV node is structurally mandatory. If you bypass the speed bump, you invite life-threatening arrhythmias.
Man. So bypassing the bottleneck is one type of failure. But what about when the main wires are completely severed?
Yeah, they're extreme.
Yeah, the absolute extreme of this is a third-degree heart block or complete heart block.
A third-degree block is a total electrical divorce between the top and the bottom of the heart.
The divorce.
Yeah, the AV node or the bundle of his sitting just below it becomes entirely impassable. The insulation is now 100% complete.
So the top of the heart, the atria, is still receiving sparks from the healthy SA node at a perfectly normal, say, 80 beats per minute. But the signal hits a brick wall. None of it reaches the ventricles.
The SA node is effectively shouting commands into a void.
Wow.
And in response to that silence, the fail-safe hierarchy we established earlier is forced to kick in.
The lower pacemakers.
Exactly. The ventricles, completely physically cut off and left entirely to their own devices, fall back on their own intrinsic backup rhythm. The Purkinje fibers begin firing on their own, but at a sluggish, desperate rate of just 20 to 40 beats per minute.
And the visual representation of this on an ECG monitor is stunning.
It really is.
You see the P waves, which track the top of the heart, marching along at a rapid, perfectly normal pace.
Yep.
They are totally oblivious to the problem below. And then, interspersed randomly, you see the wide QRS complexes tracking the bottom of the heart, just plodding along slowly on their own, completely independent timeline.
You're completely disconnected.
The top and the bottom have nothing to do with each other anymore. It looks like two separate hearts trying to beat inside a single chest.
It's the ultimate diagnostic proof of the pacemaker hierarchy in action.
But if the internal wiring is completely shattered, like in a third-degree block, the patient's ventricular heart rate of, say, 30 beats per minute is dangerously slow.
Extremely dangerous.
They aren't getting enough cardiac output to survive. So the logical mechanical question is, if the natural wires are broken, can we just wire up our own artificial system to override it?
And that exact mechanical question drove medical science in the 1950s.
Oh, really?
Yeah, the breakthrough arrived in Sweden in 1958 with a patient named Arne Larsson.
What happened to him?
He suffered from complete heart block caused by a viral infection. His backup ventricular rhythm kept failing, causing his heart to stop entirely. He was suffering 20 to 30 cardiac arrests a day.
A day?
A day. He was constantly requiring resuscitation.
His biological failsafe was completely collapsing. How did they intervene?
A cardiac surgeon named Erik Senning and an engineer named Rune Elmquist collaborated to build the very first fully implantable artificial pacemaker.
Wow, the very first one.
Yeah, they performed a thoracotomy, surgically sutured wire electrodes directly to Arne's heart muscle, and connected them to a battery pack the size of a hockey puck that they implanted under his skin.
Incredible.
The device was designed to manually deliver a perfectly timed electrical spark at a steady rate, entirely replacing the function of the SA and AV nodes.
The ultimate biomedical engineering hacks. Did it actually work?
Well, the point device actually failed after just a few hours.
Oh no. That is a terrifying reality for the surgical team.
It was, but they had a backup device ready. They implanted it the next morning, and it successfully paced his heart.
That's amazing.
It gets better. Arne Larson ended up living into his 80s.
No way.
Yeah, he underwent over 20 different pacemaker replacements and battery upgrades as technology evolved. He remarkably outlived both the surgeon and the engineer who saved him.
That is such a cool story.
It is.
Yeah.
And philosophically, that 1958 surgery is the ultimate proof of concept. It undeniably proved that the heart is fundamentally an electrically triggered pump. An artificial spark from a battery can completely and flawlessly substitute for a broken natural conduction system.
You know, when we talk about anatomical wiring, it's so easy to picture the heart like a circuit board.
Right.
Textbook diagrams almost always draw these incredibly clear, bright yellow insulated wires connecting the SA node down to the AV node.
Yes, they do.
But within modern electrophysiology, the physical reality of those pathways is actually heavily debated, isn't it?
It is. We really have to question if those simplified textbook diagrams are misleading us.
How so?
The internodal pathways, the routes connecting the top right corner down to the central toll booth, they've been a subject of anatomical debate for decades.
Really?
Yeah. Outside of one specific structure called Bachmann's bundle, which connects the right and left atria, many leading electrophysiologists argue that there are no distinct insulated cables carrying the signal down to the AV node.
But if there are no physical wires, how does the electrical spark get to the toll booth so efficiently?
The prevailing theory is preferential conduction. It means it's not a discrete insulated wire. Rather, it's simply a pathway of least electrical resistance moving through ordinary, albeit highly organized, atrial muscle fibers.
Ah.
Think of it less like an insulated copper wire buried inside your wall and more like a dirt path cutting across a grassy park.
Oh, I see.
People have walked that exact route so many times that the grass is just gone, and it has naturally become the fastest path of least resistance route to the other side.
That makes special sense.
Right. The biological reality is just much messier and far less rigidly defined than a neat textbook diagram implies.
Okay. We have traced the spark from a tiny node discovered in a mole's heart in 1907 through the deliberate physical bottleneck of the avine and down the superhighway of the Purkinje fibers.
We've covered a lot of ground.
So what does this all mean? Why is visualizing this exact sequence so absolutely critical for a nurse or doctor standing at a patient's bedside today?
Because every single cardiac intervention is predicated on this exact electrical anatomy. When a healthcare professional looks at a bedside monitor and decides whether to administer a medication like a beta blocker or whether to prepare a transcutaneous pacemaker, they're functionally diagnosing exactly where the anatomical pathway broke down.
Right.
If the SA node is failing to reach threshold, that requires one specific protocol. If the third-degree AV block is trapping the signal in the middle of the heart, that requires an entirely different, immediate physical intervention.
And understanding this pathway also completely shatters the Hollywood myth of the defibrillator, doesn't it?
Oh, completely.
In the movies, a patient flatlines, the doctor yells, "Clear," shocks the chest, and the machine miraculously restarts the mechanical pumping of a dead heart.
Which is entirely inaccurate based on the physics of the heart.
Because a defibrillator doesn't mechanically restart a stopped heart.
Not at all. When a patient goes into ventricular fibrillation, the conduction system has completely fragmented into this chaotic, disorganized electrical shivering. Yeah, the cells are firing randomly. There's no coordinated heartbeat. So a defibrillator sends a massive, overriding shock of electricity to instantly depolarize every single cell in the heart at the exact same moment.
It forcibly shuts the entire system down.
It clears the board.
So the goal isn't to restart the heart, the goal is to silence the electrical chaos.
Exactly. You silence the noise, praying that the primary generator, the SA node, will step back up to the microphone, assert its natural automaticity, and just resume firing at a coordinated 60 to 100 beats per minute.
Wow.
The entire function of a defibrillator relies on the hope that the biological hierarchy we just mapped out will reassert itself.
It makes you realize how delicate yet fiercely resilient this internal system really is.
It really does.
Before we wrap up, there is one final anatomical paradox to mull over.
Oh, right.
We established at the very beginning that a transplanted heart is myogenic-like. You can take it entirely out of one body, implant it into another, and it will beat completely on its own without any nerve connections linking it to the recipient's brain.
Yes. It functions as a true off-grid generator, relying solely on its internal SA node.
But the autonomic nervous system, specifically pathways like the vagus nerve, is what normally modulates our heart rate.
Right, the nervous system acts as the brake and the gas pedal.
Exactly, telling the SA node to speed up when we're stressed or slow down when we're sleeping. So, if you have a patient with a transplanted heart and those physical nerve connections have been completely and permanently severed by a surgeon's scalpel, how on earth does that transplanted heart know it needs to speed up when the patient decides to go for a run?
That is a great question.
It's a fascinating physiological puzzle to think about the next time you feel your own pulse quicken.
Welcome to the deep dive. You know, today we are taking you into a high-stakes environment where you would normally expect, well, absolute, infallible precision.
Right, because usually when we talk about a medical monitor, there is this expectation that it works like a fuel gauge in a car.
Exactly. You look at a screen, you see a blinking red light or a plunging line, and the machine is basically screaming, like, here's the exact problem, fix it right now.
It's a comforting idea. I mean, we really want technology to be binary and objective, especially in a hospital room.
But then you step into a labor and delivery ward. You look at the monitors tracking a baby's heart rate during birth, and suddenly that fuel gauge analogy just falls completely apart.
Oh, it crumbles. It is the absolute definition of diagnostic muddy waters.
That's right. We are looking at a diagnostic landscape that is, honestly, incredibly murky. Millions of times a year, in essentially every hospital birth, medical teams rely on this tool that is just surprisingly complex to interpret.
The squiggly lines you see on those screens, they are not handing doctors a simple diagnosis on a silver platter. Not at all.
Which is why our mission for this deep dive is so exciting. Today, you, our listener, are going to learn how to read one of the most universally used medical tests in the world.
Fetal heart monitoring, or FHM.
Right. We are going to unpack how labor nurses and physicians use these real-time charts as a kind of code-breaking exercise to figure out if a baby is getting enough oxygen during birth.
And to crack that code, we first need to lay out the terminology cleanly. You will often hear this process called electronic fetal monitoring, or EFM.
Or sometimes CTG, right?
Yes, in some regions it's called cardiotocography, or CTG. But practically speaking, what we are doing is plotting two things simultaneously on a graph over time. The top line is the fetal heart rate, so the baby's heartbeat.
And directly below that, on the exact same screen, is the bottom line, which tracks the mother's uterine contractions.
Exactly. That bottom line is recorded by a pressure sensor placed on the mother's abdomen called a tocodynamometer.
That's a mouthful.
It is. Most nurses just call it a toco for short. By looking at these two lines stacked on top of each other, clinicians can see how the baby's heart responds every time the mother's uterus contracts.
Let's unpack the mindset behind this dual graph setup, because the way the medical community views this tool has undergone a massive, really fascinating paradigm shift over the decades.
It really has. Back in the 1960s and 70s, when this technology first rolled out, doctors treated it as a new diagnostic tool.
The assumption was that this monitor was a crystal clear window right into the baby's brain.
The belief was entirely straightforward. They thought if the line on the paper looked bad, the baby was in immediate, irreversible danger and required surgical intervention.
But today, the stance is completely different. The major governing bodies, like the American College of Obstetricians and Gynecologists, ACOG, and the National Institute of Child Health and Human Development, view this purely as a screening tool.
Yes, a screening tool, not a diagnostic tool.
And I found this fascinating in our research. The medical community now uses this bizarre double negative to describe what they see on the screen.
The phrasing is very deliberate. Today, if a tracing looks abnormal, a clinician won't say the baby is definitively in danger. Instead, the official terminology is that the fetus is not in a reassuring metabolic state.
It's such a strange way to phrase a medical finding. I mean, it's like saying, well, we can't prove the baby is fine, but we also can't prove the baby is in trouble.
Right. It essentially means the squiggly line is just telling the medical team to look closer rather than, initiating an automatic emergency surgery.
That phrasing exists because the false positive rate of this monitor is incredibly high, isn't it?
Exactly. The line itself doesn't make the diagnosis. It simply prompts the human in the room to investigate the broader clinical picture.
So we have this ubiquitous technology that is simultaneously heavily relied upon and, well, incredibly ambiguous. How did we even get here?
It's quite a story. Before we get into decoding the modern squiggly lines, we really need to understand how we started listening to babies in the womb in the first place.
Because the history here is wild.
We have to travel back to 1818. A French obstetrician named Jean-Alexandre Lejumeau was wrestling with this exact problem. Now, René Laennec had just invented the stethoscope a couple of years prior.
The classic wooden tube stethoscope, right?
The very same. Lejumeau apparently heard horse hoofbeats one day and had a light bulb moment. He wondered if he could hear a similar rhythmic sound inside the womb.
Wow.
So he takes this brand new stethoscope, presses it to a pregnant patient's abdomen, and manages to hear the baby's heartbeat.
That must have felt like magic at the time. I mean, suddenly the baby wasn't just a mystery inside the mother. It was a patient they could actually monitor.
It revolutionized the field. For the next 150 years, the standard of care was intermittent auscultation. By the 1890s, Adolphe Pinard introduced the Pinard horn.
Which was essentially a specialized trumpet-shaped fetal stethoscope, right?
Exactly. Doctors and midwives would use it to listen to the baby's heart every 15 to 30 minutes during active labor.
I can't even imagine how labor-intensive that was, having a nurse lean over with a wooden horn every 15 minutes for hours on end.
And, checking the heartbeat by ear meant you could easily miss a baby deteriorating in those 15-minute gaps.
That was the exact fear that drove the technology boom of the 1950s and 60s, I bet.
Spot on. Clinicians desperately wanted a continuous picture. What's fascinating is how parallel the research was to achieve this. In New Haven, Connecticut, a Yale obstetrician named Edward H. Hahn started recording fetal ECG signals.
Let me pause you there just to make sure we're clear. When you say ECG signals, you mean he was measuring the actual electrical impulses of the baby's heart.
Yes, exactly.
Like the large sticky pads they put on a patient's chest in the ER, but somehow doing that for a baby still inside the uterus.
Yeah, Hahn figured out how to capture those tiny electrical signals and graph them continuously. By 1958, he was publishing the first electronic tracings that correlated the baby's heartbeat with the mother's contractions.
That is incredible for 1958.
Meanwhile, down in Montevideo, Uruguay, Roberto Caldero Barcia and his team were doing similar work. They actually coined the early terminology, calling specific heart rate drops DIPI and DIP2.
Which we now call early and late decelerations.
Right. And then over in Germany, you had Konrad Hemmecker developing the commercial machine that eventually became the prototype for what is sitting in hospital rooms today.
All of this innovation was driven by a desperate desire to prevent stillbirths and intrapartum brain injuries, right?
Entirely. Continuous electronic fetal monitoring promised to catch cellular deterioration in real time. Because of that promise, the adoption of these machines absolutely exploded across the United States in the 1970s and 80s.
Hold on. This is the part of the research that literally made me drop my pen. You're telling me hospitals across the country hooked millions of women up to these machines as the new standard of care before they actually proved they saved lives?
Yes. That sequencing problem, the technology outrunning the clinical evidence, is the ghost that still haunts obstetrics today.
It's just wild to think about.
The medical community was so terrified of missing a deteriorating baby that they adopted the technology universally before running the randomized controlled trials to see if it actually improved long-term outcomes.
That is stunning. But to understand why the evidence ended up being so complicated later on, we really need to dive into the physiological mechanics.
Let's do it.
So hospitals rolled these machines out everywhere. For the machine to actually warn doctors of danger, they first had to figure out what a normal baby looked like on paper. How do you even establish a baseline?
It starts with observation over time. A clinician looks at the tracing and establishes the baseline fetal heart rate over a 10-minute window.
Like a 10-minute window.
A normal, healthy baseline averages between 110 and 160 beats per minute. But the absolute most critical part isn't the average number, it's the variability.
Baseline variability. This is the beat-to-beat fluctuation in the heart.
Yes, exactly.
The sources outline that clinicians are looking for what they call moderate variability, which means the heart rate is constantly fluctuating by 6 to 25 beats per minute.
And that constant fluctuation tells us a lot about the baby's central nervous system.
Okay, let me try an analogy here to make sure I'm grasping this. Imagine a baseline heart rate like a lively, engaged conversation at a dinner party.
Okay, I like that.
The volume and the pacing are constantly going up and down as people react to each other, right? That wiggly line on the monitor is the baby's autonomic nervous system having a lively conversation.
Yes, perfectly said.
It's the sympathetic nervous system, the gas pedal, and the parasympathetic nervous system, the brake, constantly adjusting and reacting to the environment.
That is a perfect way to visualize it. If the line is wiggly, it proves the baby's brainstem is well oxygenated and functioning beautifully.
So a flat line on the monitor, a completely quiet dinner party where nobody's reacting to anything, is actually a massive red flag.
Absolutely. The wiggly line is your best real-time reassurance that the baby is doing well. You want to see those continuous micro-adjustments.
Okay, so a wiggly line is a great dinner party. But what happens when the conversation suddenly stops and that heart rate drops?
This brings us to the absolute core of our deep dive, decoding decelerations.
Right, the heart rate drops.
And this is where we have to debunk a major rookie misconception right out of the gate. People naturally assume that a deeper deceleration, like a line that drops really low on the graph, is inherently more dangerous.
Well, I mean, it makes sense intuitively. If the heart rate drops from 140 down to 60, that feels like a bigger emergency than dropping to 120.
It feels that way, but deeper is not always worse. Clinicians do not read these tracings primarily by depth.
Oh, really?
Yeah. They categorize decelerations by their shape, by their timing relative to the mother's contraction, and by the underlying physiological cause.
So timing and shape are everything.
Yeah.
Let's break down the three main types of decelerations you will see on a monitor, starting with early decelerations.
Picture the mother's contraction on the bottom half of the screen as a smooth rolling hill.
Okay, I'm picturing it.
An early deceleration is a perfect, smooth mirror image directly above it. It has a gradual onset, a gradual return, and the lowest point of the baby's heart rate, the nadir, lines up exactly with the peak of the mother's contraction.
So the heart rate dips precisely when the squeeze is the tightest. What is physically causing that to happen?
It's caused by benign head compression. As the mother's contraction pushes the baby's head against the cervix or the pelvic wall, that physical pressure on the baby's skull triggers a vagal reflex.
Wait, like a vasovagal reaction? Like
Yeah.
when an adult faints at the sight of blood because their heart rate suddenly bottoms out?
Exactly the same mechanism. The physical pressure stimulates the vagus nerve, which hits the parasympathetic brake and transiently slows the heart rate down.
I really want to emphasize this for you listening. This is totally normal. Our sources give a great textbook example of this.
It's a great example.
Imagine a patient who is 8 centimeters dilated, deep in labor. The baby's heart rate dips from a baseline of 140 down to 125 beats per minute in perfect lockstep with a contraction, and then comes right back up.
Right, and the nurse watching that monitor doesn't panic.
No medical intervention is needed at all. It simply means the baby is moving down the birth canal.
That head compression is completely safe. The real warning lights start flashing when the timing shifts, which brings us to late decelerations.
Okay, so how does a late deceleration look different on the screen?
Visually, it has the exact same gradual, smooth, rolling hill shape as an early deceleration. The difference is entirely in the timing.
So it's shifted.
Yes. The nadir, the lowest point of the heart rate, happens after the contraction has peaked. It typically lags by 20 seconds or more, and the heart rate doesn't return to normal until well after the contraction is completely over.
I have to ask a question here about the vocabulary. Does calling it a late deceleration mean it is too late to help the baby? Or does it just mean it's more severe?
That is the ultimate trap medical students fall into. Late solely describes the timing relative to the contraction. It means the drop is delayed. It absolutely does not mean too late to intervene.
Got it. Good to know. So if the squeeze of the contraction happens, why is there a delay before the baby's heart rate drops?
That delay points to uteroplacental insufficiency. Think of the placenta like a sponge full of oxygenated blood. During a contraction, the blood vessels feeding that sponge are naturally squeezed, temporarily reducing blood flow.
Like stepping on a garden hose for a minute.
Exactly. If the placenta is healthy, the baby has enough oxygen reserve to ride out that squeeze without a problem.
Makes sense.
But if the placental reserve is already compromised, maybe due to maternal conditions like preeclampsia, low blood pressure, or a placental abruption, that squeeze causes a delayed drop in the baby's actual oxygen levels.
And the baby reacts to that.
Right. The baby's chemoreceptors eventually sense this lack of oxygen, and it triggers a slower, delayed reflex to drop the heart rate to conserve energy.
So if a nurse sees a late deceleration, it's a sign that the baby's oxygen supply line is struggling. But I found this incredibly reassuring when I read it. Seeing a late deceleration doesn't mean the team immediately sprints to the operating room for a C-section.
Not at all. It triggers a standardized nursing resuscitation bundle. The goal is to fix the environment inside the womb to get that oxygen flowing again.
Let's walk through those interventions because the logic behind them is brilliant once you understand the mechanics. First, you reposition the mother, usually rolling her onto her left side.
Yep, the lateral position.
Why? Because you are taking the weight of the uterus off her major blood vessels, which immediately improves blood flow back to her heart and therefore back to the placenta.
Next, you administer SEVI fluids to boost her blood volume and provide supplemental oxygen.
And if she is on a drug like oxytocin to stimulate contractions, you turn it off immediately. You want to stop the uterus from squeezing so the garden hose can open back up.
Exactly. You are attempting to restore placental blood flow. You generally only move to an operative delivery if those patterns don't resolve, despite all those interventions, or if the baby loses that healthy, wiggly baseline variability we talked about earlier.
Okay, so early and late decelerations are smooth, predictable curves tied directly to the rhythm of the mother's contractions. But the third type of deceleration throws predictability completely out the window.
It really does.
What happens when the baby's heart rate drops out of nowhere?
That brings us to variable decelerations.
The name says it all. On the monitor, these don't look like smooth hills. They have an abrupt onset and an abrupt return, usually dropping and recovering in under 30 seconds.
Right. They look jagged, like a U, a V, or a W shape scribbled on the paper.
And their mechanism is entirely different from head compression or placental insufficiency.
Yes, completely different. The variable decelerations are caused by umbilical cord compression. The cord itself is physically being pinched.
Which could happen for a lot of reasons, right? Could be a neutral cord where it's wrapped loosely around the baby's neck.
Yes.
Or it could happen because of low amniotic fluid, a condition called oligohydramnios, meaning there isn't enough water in the womb to cushion the cord from being squished against the uterine wall.
It could even just be the physical position the baby is in as they descend. The crucial nuance here is that most variable decelerations are mild and mechanical. You can often fix them simply by having the mother change positions to let gravity physically unpinch the cord.
But there are atypical variable decelerations, right, where the cord compression is more severe.
Yes, that's where the heart rate is slow to return to baseline, or maybe there's a strange secondary spike in the heart rate right afterward called an overshoot.
Oh, an overshoot.
If you start seeing that, or if the tracing loses that wiggly variability, it tells you the compression isn't just a brief mechanical squeeze anymore. The baby is actually starting to experience evolving hypoxia.
They're slowly losing oxygen. And if we zoom out to the extreme end of the spectrum, there's a fourth, much rarer category called prolonged decelerations.
Yes. These are sudden drops in the heart rate that last anywhere from 2 to 10 minutes.
2 to 10 minutes. Those sound terrifying.
They can be. They usually result from any of the mechanisms we just discussed, but taken to a catastrophic extreme, like a cord prolapse, where the cord drops down past the cervix, or a uterine rupture. Those are true, immediate emergencies.
But what happens when the tracing is just ambiguous? When it's not a clear-cut 10-minute drop, but it's not totally reassuring either. How does a doctor decide what to do?
That's where adjunct tools come in to gather more data. One method is fetal scalp stimulation. During a cervical exam, a clinician will gently rub or stimulate the baby's scalp.
Okay, why?
They are looking for an acceleration, a reassuring rise in the heart rate of at least 15 beats per minute for 15 seconds.
I love the logic of this. If the baby responds to a head scratch by accelerating its heart rate, it proves the autonomic nervous system is intact and well oxygenated enough to react to a stimulus.
Exactly. It provides instant reassurance. There was another adjunct tool developed in 1961 by Eric Saling called fetal scalp blood pH sampling.
The idea was to literally take a tiny drop of blood from the baby's scalp during active labor to directly measure the oxygen and acid levels.
It was a theoretically brilliant concept.
But from what I read, it largely failed to catch on in the U.S. because it was just too technically difficult and invasive to perform in the middle of a chaotic labor.
It struggled with practical execution. Which brings us to the most critical and perhaps most controversial part of this entire deep dive.
Yes, the counterintuitive truth.
The big reveal.
So we have this incredible, universally used technology. We know exactly what these shapes mean. We have standardized nursing interventions ready to go. Continuous monitoring must have practically eradicated birth injuries like cerebral palsy over the last 50 years, right?
This is the biggest bombshell in the entire field of obstetrics. The answer is no.
I am still wrapping my head around this. I'm sorry. We adopted a universal technology to protect babies' brains, and it doesn't reduce cerebral palsy.
Let's look at the data. The largest body of evidence comes from randomized controlled trials conducted in the 70s and 80s once the medical community finally decided to test the technology they had already adopted. The most famous is the 1985 Dublin trial, which enrolled nearly 13,000 women. Later, all these various trials were pooled into massive Cochrane systematic reviews led by researchers Zarko Alfirovich.
And the findings were an absolute earthquake for the medical establishment.
Oh, completely.
These trials found that continuous electronic fetal monitoring does reduce neonatal seizures compared to just listening in intermittently with a stethoscope. But and this is a massive bet, but it does not reduce the overall rates of cerebral palsy.
It does not.
It does not reduce perinatal death, and it significantly increases the rate of C-sections and operative vaginal deliveries like forceps or vacuums.
It is arguably modern medicine's most counterintuitive fact. We adopted a technology population-wide, defended it for decades as the ultimate shield against brain injury, and the highest level of clinical evidence shows it simply does not reduce cerebral palsy.
It's hard to process.
ACOG and the American Academy of Pediatrics have actually published task force reports acknowledging this.
Wait, if we are measuring the baby's actual oxygen responses, how is it possible that this doesn't prevent brain injuries?
Because the positive predictive value of a non-reassuring heart rate pattern for actually predicting cerebral palsy is incredibly low.
Okay, so what does that mean practically?
Essentially, a drop in heart rate doesn't automatically equal irreversible brain damage. Babies are incredibly resilient and have profound physiological mechanisms to survive temporary oxygen deprivation during birth.
That means the false positive rate of this machine is sky high.
Yes, exactly.
The overwhelming majority of these abnormal tracings happen in babies who turn out to be perfectly neurologically normal.
And that leads to the other major failure point, Howman error and the limits of interpretation. It's a problem of inter-observer reliability.
Inter-observer reliability, meaning humans reading the exact same chart disagree on what it says.
Radically disagree.
Yeah.
Different clinicians will look at the exact same strip of paper, the exact same squiggly line, and completely disagree on how dangerous it is. In retrospective studies, even the same clinician looking at the same tracing a month later will sometimes give it a different grade.
And this is true even with the National Institute of Child Health and Human Development. Trying to standardize everything into a strict Category 1, 2, and 3 system?
It doesn't matter.
If the diagnostic tool itself is inconsistently read by the humans looking at it, its clinical value is inherently constrained, no matter how solid the underlying physiology is.
Which leaves us with a paradox. ACOG explicitly states that intermittent auscultation, just listening in every so often, the old-fashioned way, is perfectly fine and evidence-supported for low-risk patients.
So why is continuous monitoring still used on almost everybody who walks into a hospital in labor?
Because obstetrics operates in a highly litigious environment. Abnormal fetal heart rate tracings feature heavily in birth injury lawsuits.
Oh, I see.
So even for low-risk patients, hospitals maintain near-universal continuous monitoring. It is a genuine tension between what the clinical trial evidence actually supports and what institutional habit demands.
It's defensive medicine. They are treating the monitor to protect the hospital against lawsuits, rather than just treating the patient. That is a heavy reality to digest.
It really is.
Well, let's bring this all together for you, because we have covered a massive amount of ground today. If you take nothing else away from this deep dive, remember these core rules of the squiggly lines.
Right.
First, deeper is not worse. Timing and shape define a deceleration.
Early decelerations mirror the contraction and are caused by benign head compression.
Late decelerations lag behind the contraction and signal uteroplacental insufficiency. The sponge isn't getting enough blood.
Variable decelerations are abrupt and jagged, signaling umbilical cord compression.
And above all, moderate baseline variability, that lively, wiggly line that looks like a great dinner party, is the single best real-time sign of a well-oxygenated baby.
And you know, it is always worth remembering that fetal heart monitoring is just the intrapartum tool, the tool used during birth. It pairs beautifully with Virginia Apgar's 1952 Apgar score, which is the postnatal assessment used right after the baby is born.
Together, they give clinicians the full picture of the baby's journey into the world. It really is a complete relay race of care.
It is.
But understanding the history of this tool leaves us with something provocative to think about. We started this deep dive talking about the expectation of medical precision, the assumption that the blinking light on the hospital monitor is an absolute truth.
We want the perfect diagnostic machine, but humans are far too complex for that.
Exactly. As medicine continues to advance, we have to ask ourselves a difficult question. How do we untangle the tools that actually save lives from the tools we only cling to because we are afraid of lawsuits?
That's a huge question.
If the squiggly lines on the monitor are driving up surgical birth rates without actually preventing cerebral palsy, what does the future of childbirth look like? Are we going to keep treating the monitor, or will we find the courage to step back and trust the evidence?
It is a profound question, and one the entire field of obstetrics is still struggling to answer today.
And it's one worth pondering long after this conversation ends. Thank you so much for joining us on this deep dive. Keep asking questions, keep looking past the surface, and we will see you next time.
If you've ever been sitting in a hospital room, either as a patient or just watching a loved one get care, you probably know the ritual. A nurse walks in, they scan a barcode on your wristband, look you right in the eye, and ask you to state your name and date of birth before they hand over, like a single Tylenol.
Yeah, and they do it every single time.
Exactly. It can feel a bit repetitive, like bureaucratic overkill, especially when they just did the exact same thing 3 hours ago and clearly know who you are. But that tiny repetitive exchange is actually a surprisingly fragile safety net.
A very fragile one, yeah.
Right. And it's one with this ghostly, almost unscientific origin story that is currently at the center of a pretty heated medical safety debate. So, welcome to today's deep dive. We are unpacking what the medical world calls the rights of medication administration.
It sounds so formal, doesn't it? But it's essentially a critical checklist.
Yeah, a checklist designed to stand between routine medical care and fatal errors. We are going to explore how this checklist was born, why the original version of it is fiercely debated when things go wrong, and how this seemingly simple concept protects, or I guess sometimes fails to protect, every single one of us.
It's an incredibly important topic because the landscape of patient safety, it really forces us to look at how humans interact with complex systems. We're talking about something that is foundational to modern healthcare training.
It's basically drilled into them from day one, right?
Oh, absolutely. But when you examine the history and the underlying science of these protocols, you start to realize this mental checklist is carrying a weight it was never entirely designed to hold.
Okay, so let's get into what these rights actually are. Because any nursing student knows the classic checklist. It's the right patient, right drug, right dose, right route, and right time. The 5 rights. And reading through the source materials for this deep dive, I just assumed this list was a rigid, official, universal standard. But it turns out this golden rule is actually kind of a moving target.
Oh, it is entirely fluid. I mean, if you go to 5 different nursing schools today and ask how many rights there are, you will likely get 5 different answers.
Wait, really?
Yeah, you might hear 5, 6, 8, 9, or even 12 rights.
12?
Exactly. Over the last 30 years, educators and safety organizations have just organically bolted on new items to patch gaps that the original 5 failed to cover.
That is wild. I mean, the additions are fascinating, though. You have things like right documentation, which makes total sense in a litigious world. But then there's the right reason, meaning the nurse has to understand exactly why this specific patient is getting this specific drug.
Right. They can't just be a delivery system. They need to know the why.
And there's the right response, checking if the drug actually did its job without causing an adverse reaction. And one that really stood out to me was the patient's right to refuse. Because patients aren't just passive objects on a bed, right? They can say no, and the system has to document and respect that.
Yeah, that expansion of the list really reflects a growing recognition of how complex healthcare has become. But, the most surprising element of this whole foundational concept isn't how much it's grown, it's actually where it came from.
This is the part that blew my mind.
Right, because unlike almost every other major medical protocol, there is no founding paper.
No paper at all?
Nope. We don't have a specific randomized controlled trial we can point to and say, this study proved the 5 rights drop error rates by 80%. It just doesn't exist.
So it's basically a medical ghost story. How does an ironclad rule that dictates every single medication pass in every hospital just appear out of thin air? I mean, nursing students memorize this stuff as absolute gospel.
It's wild. I know. It really crystallized gradually in American nursing textbooks throughout the 1960s and 1970s. You have to look at the historical context, right?
Yeah.
Before World War II, the pharmaceutical arsenal was relatively small.
You had, penicillin and aspirin?
Pretty much. But after the war, the number of available drugs just exploded. Suddenly, hospital pharmacology got incredibly complex, incredibly fast. And the nursing profession, they just needed a cognitive scaffold to manage all this new complexity. So this checklist just sort of emerged as folk wisdom, a consensus among educators.
So this isn't a lab-tested formula at all. It's more like a family recipe for safety that just got passed down. Like somebody figured out how to not burn the roast, and then the next generation added a pinch of salt, and eventually everyone treats the recipe as absolute law.
That is the perfect analogy. It was a pragmatic reaction to a growing problem, not a scientifically validated intervention. And safety organizations today, like the Institute for Safe Medication Practices, they are very vocal about this. They emphasize that despite decades of universal teaching, there has never been robust empirical evidence proving that simply reciting these 5 rights measurably reduces errors.
Which is unsettling, honestly.
Yeah.
But even if it is just folk wisdom, the core ideas do make intuitive sense. I mean, stripping away the medical jargon, the guiding question behind the rights is essentially, what could go wrong right now, and have I tangibly ruled it out?
Exactly. It's a defensive mindset.
And when you look at the mechanics of what happens when these rights are violated, the risks are absolutely terrifying. So let's break down that core 5, starting with the right patient. Obviously, you need to ensure you aren't medicating the wrong person, but the sources are very clear that just checking a room number is completely insufficient.
Oh, room numbers are practically useless for identification. Patients are transferred, beds get swapped. Hospitals are incredibly dynamic environments. And you also have a massive issue with look-alike and sound-alike names.
Like 2 John Smiths on the same floor.
Exactly. Furthermore, the patient themselves cannot always be a reliable narrator of their own identity. Think about it. If someone is heavily sedated in the ICU, or they're experiencing dementia, or they're a toddler, or maybe they simply don't speak the dominant language of the hospital, you need objective confirmation.
Right.
That is why 2 unique identifiers, usually a full name and a date of birth, cross-referenced with a barcode scan that is the absolute minimum standard today.
Which leads directly to the right drug.
Yeah.
And this one highlighted a really crazy conflict between pharmaceutical marketing and patient safety. Because drug names aren't designed to be distinct, are they? They are engineered by marketing departments to sound memorable.
Yeah, and that marketing imperative creates massive vulnerabilities.
Yeah.
The classic example in the literature, the one everyone talks about, is insulin. You have Humalog, which is a rapid-acting insulin, and Humulin, which is an intermediate or long-acting insulin.
I mean, they sound virtually identical when spoken aloud in a busy hallway. Humalog, Humulin.
They do, and they sit in similar-looking vials in the refrigerator, but the mechanism of action is vastly different. So if a patient is prescribed the long-acting Humulin, right, to provide a steady baseline of insulin over 24 hours.
Just a slow drip, basically.
Exactly. But they accidentally receive the rapid-acting Humalog. Their blood sugar doesn't just dip slightly, it crashes immediately. They can go into severe hypoglycemic shock, leading to seizures or brain damage, simply because a single syllable was misread.
Just one syllable. That is so scary. Then we have the right dose. And the sources point out that pediatric and oncology dosing are where right dose failures become uniquely catastrophic, because we aren't talking about accidentally giving 2 Advil instead of 1.
No, not at all. The stakes are exponentially higher in pediatrics and oncology because medications are rarely standard, flat doses. You don't just hand them a pill. They are typically dosed based on a patient's weight in kilograms or their total body surface area.
So there's math involved every single time.
A lot of math. And the clinician has to calculate the exact dose while also factoring in things like renal function, which dictates how effectively the patient's kidneys can filter and clear the drug from their bloodstream.
Because if the kidneys are compromised, a normal dose just builds up to toxic levels in the blood, right?
Exactly. The clearance rate is critical. So when a clinician is doing this complex math, a simple decimal point error doesn't mean the patient gets a 10% extra dose. A misplaced decimal means a 10-fold or even a 100-fold overdose.
Oh my God. 100 times the intended dose of chemotherapy just from a misplaced dot on a chart. That is deeply unsettling.
It really is.
Which brings us to the right time. This is another one that seems straightforward, but has complex mechanisms behind it. It's not just about the convenience of the nursing staff doing the rounds, is it?
Not at all. Time is intrinsically tied to pharmacokinetics, which is how the body absorbs and processes a drug over time. Let's say a patient is battling a severe systemic infection and is on IV antibiotics. Those drugs have a specific half-life.
Meaning they wear off at a very specific rate.
Right. They must be administered within a very precise window to keep the concentration of the drug in the bloodstream consistently above the threshold needed to kill the bacteria. If you are late by even a few hours, the blood concentration drops, the bacteria can multiply, and you risk breeding antibiotic resistance.
So timing is literally the medicine working or failing.
Exactly.
Okay, so the last of the core five is the right route. And I have to admit, when I first read the outline for this, I thought, wait, isn't right route just picking whether the patient swallows a pill or gets an IV? How hard is that to check? But diving into the source material, I realized it is incredibly nuanced. It involves the exact physical site and the specific technique.
Oh, it is far more complicated than just oral versus intravenous. Consider an intramuscular injection, right? The medication is formulated to be absorbed slowly by muscle tissue, but if the clinician injects it into the wrong muscle group or, God forbid, accidentally hits a blood vessel instead of the muscle,
Then what happens?
the drug enters the bloodstream immediately. That is a route failure, and it alters the entire absorption profile. You get a massive spike instead of a slow release.
Wow. The sources also gave this example of feeding tubes versus central lines in an ICU, because a patient might be hooked up to a dozen different tubes, right?
Yeah, in intensive care, patients often have multiple access points. You might have a central venous catheter going directly to the heart, and then an enteral feeding tube going directly into the stomach.
And they look similar.
They're all just clear plastic tubing to the naked eye. So if a liquid medication formulated for the highly acidic environment of the stomach is accidentally connected to the port of the central venous line,
Oh, no.
yeah, you are injecting foreign, unsterile material directly into the central circulation. That kind of route failure is almost always fatal.
That is horrifying. And, knowing the theory behind the checklist is one thing, but the reality is that knowing the rules doesn't guarantee safety. We really have to pivot from the theory to the tragic real-world cases, because the history of modern patient safety is essentially written in blood.
Unfortunately, yes. These abstract concepts only became national priorities because of devastating real-world failures.
Right, and the danger of relying on this folk wisdom checklist really snapped into focus in the 1990s. We're talking about highly trained teams at top-tier institutions failing. Let's talk about the Betsy Lehman case in 1994, because that one is just heartbreaking.
It is. Betsy Lehman was a 39-year-old health columnist for the Boston Globe, and she was undergoing treatment for breast cancer at the Dana-Farber Cancer Institute, which is one of the premier cancer centers in the world.
The irony is just agonizing. She spent her career explaining medical science to the public, and her death became this defining moment for a right dose failure.
She was receiving a chemotherapy drug called cyclophosphamide. And due to a transcription error involving that complex math we discussed earlier, she was prescribed an absolutely massive dose, roughly 4 times the intended amount.
But the mechanism of the failure wasn't just one person making a math error in a vacuum, right? What struck me about this case was the diffusion of responsibility.
Yes, exactly.
Because the order was reviewed by multiple clinicians, pharmacists, nurses, doctors. But because it was a complex experimental protocol, everyone just assumed the other person had verified the math.
That's the trap. Individual vigilance failed repeatedly. She received that massive lethal overdose over 4 consecutive days before she died. No one caught it.
It's just devastating. And it shattered the illusion that we could rely entirely on individual human vigilance. It proved that if the system allows ambiguity, even brilliant, dedicated professionals will fail to catch an error.
Absolutely. And we see that same systemic failure moving upstream in the medication supply chain with the case of Emily Jerry in 2006.
She's a little girl, right?
Yeah. Yes. She was a 2-year-old girl who had successfully come through cancer surgery, only to die from a right drug and a right dose failure. And this one happened far away from her hospital bed.
Right, this wasn't a bedside nursing error.
No. Emily's the Fief bag was prepared in the hospital pharmacy by a pharmacy technician. The technician used a sodium chloride solution, essentially salt water, that was at roughly a 20% concentration. The standard, safe solution is a highly dilute 0.9%.
20% versus less than 1%. And to understand the mechanism of why that is so lethal, we have to look at osmosis. If you pump a 20% salt solution into the bloodstream, you create a massive osmotic gradient. The blood becomes so salty that water actually rushes out of the surrounding cells to try and dilute it.
It literally shrinks the cells in the brain, tearing blood vessels and causing massive neurological devastation.
It's a horrific physiological cascade.
Emily died days later. Her tragedy really underscored that the rights of medication administration don't just apply to the nurse at the bedside. The failure happened in the preparation stage, emphasizing that the entire supply chain must have built-in defenses. It actually led directly to state laws mandating the rigorous certification of pharmacy technicians.
It's good that laws changed, but the loss is just unfathomable. But perhaps the most haunting failures we read about were the vincristine deaths.
Oh, the vincristine cases are a perfect example of system design failure. Vincristine is a potent chemotherapy drug designed exclusively for intravenous use. If it is given intrathecally, meaning injected directly into the spinal fluid, the results are catastrophic.
It's invariably fatal, right?
Always.
Yeah.
When vincristine enters the spinal fluid, it rapidly destroys the central nervous system from the bottom up, causing a slow, agonizing ascending paralysis.
Oh my God, that's horrific. But what I found staggering in the sources is the persistence of this specific error. I mean, if every single nurse and pharmacist globally is taught the right route checklist in school, how does this exact same fatal error keep repeating across different hospitals for half a century? The sources said there were over 120 cases worldwide. It defies logic.
It defies logic if you believe that a mental checklist is a robust system. But it is not. If you rely purely on human memory, eventually a clinician experiencing extreme fatigue or stress will grab the wrong syringe and make a lethal connection. The vincristine deaths forced the safety community to realize they needed forcing functions.
Forcing functions meaning a physical design change that removes human memory from the equation entirely, right?
Yes, precisely. The mandate became that vincristine could never be dispensed in a standard syringe. It had to be dispensed in a labeled mini bag.
Because you cannot physically hook a mini bag up to a spinal needle. It requires an entirely different connection port.
Exactly. You took an error that persisted through decades of mental checks, and you solved it by making it mechanically incompatible. A physical system redesign stopped the error where human vigilance had repeatedly failed.
And this brings us to the core of a very fierce internal debate within the medical community, heavily driven by the Institute for Safe Medication Practices, or ISMP. Because if you acknowledge that human vigilance is flawed, you have to rethink who actually gets blamed when a right is violated.
This is the crux of modern patient safety. The ISMP argues that the 5 rights describe the outcomes we want to achieve, the right patient getting the right drug, but they do not represent a reliable system for achieving those outcomes.
So treating them as a personal mental checklist places an unfair burden on one person.
Yes, they call it moral scapegoating. If you blame the nurse at the sharp end of the person holding the needle, you are entirely ignoring the systemic failures at the blunt end.
Okay, let's define that for the listener. The blunt end being the environment that sets that nurse up to fail in the first place. We're talking about poor lighting in the pharmacy, chronically short-staffed shifts, a culture of being interrupted constantly while trying to calculate doses.
Or confusing order interfaces on the computer, or pharmaceutical companies designing look-alike packaging.
Exactly. The blunt end creates the conditions that make a sharp end failure practically inevitable. This sounds exactly like James Reason's Swiss cheese model of accident causation.
It is the defining model, yeah.
I love this analogy. So to apply it here,
Yeah.
think of every safety protocol in a hospital as a slice of Swiss cheese. A mental checklist is one slice. The pharmacy review is another slice. The computer alert is another. They all have holes in them because nothing is perfect.
Right. Humans make mistakes, technology glitches.
But usually, the holes don't line up, so an error gets caught by the next slice of cheese. But if the holes in all the slices align perfectly, say, a short-staffed shift on top of confusing packaging, on top of an exhausted doctor, the error drops straight through all the holes directly to the patient.
That was a brilliant way to explain it. A serious harm event almost always requires multiple system defenses to fail simultaneously. And one of the most famous historical examples of this alignment of holes is the Libby Zion case in New York in 1984.
Right, Libby Zion. She was an 18-year-old college student who went to the hospital with a fever and agitation. And she was tragically given a painkiller called meperidine, which most people know as Demerol.
And this became a fatal right drug failure because Libby was already taking a prescription antidepressant at home, an MAOI called phenelzine.
The mechanism of this interaction is a classic pharmacology nightmare. Phenelzine, the MAOI, works by inhibiting the enzyme that cleans up neurotransmitters like serotonin in the brain. Meperidine, the painkiller, triggers the release of a massive amount of serotonin.
It's a deadly combination.
Yeah, when you combine them, the brain is flooded with serotonin and has no way to clean it up. The result is serotonin syndrome, a cascading physiological crisis causing a fatal fever and seizures.
The pharmacological interaction was the proximate cause of death. But the system failure was far deeper. It was a failure of medication reconciliation, which is the rigorous process of cross-checking a patient's home drug list against new hospital orders. And crucially, this failure was compounded by the blunt end.
The exhaustion, right?
Yes, exhausted, overworked resident physicians making critical decisions in the middle of the night after working unimaginable hours.
That tragedy sparked a massive public outcry. It led to the Libby-Zion Law in New York, which finally placed strict limits on the consecutive hours resident physicians could work. The investigation recognized that the rights violation wasn't just simple carelessness. It was a symptom of a deeper systemic flaw, which was severe fatigue.
You cannot just tell a resident who has been awake for 36 hours to be more careful and expect the error rate to drop. Fatigue impairs executive function just as severely as alcohol intoxication. Recognizing that was a massive paradigm shift in medical safety.
So if human memory is inherently fallible and systemic exhaustion creates giant holes in the Swiss cheese, why hasn't modern technology completely solved this problem? I mean, everything has a barcode now, right?
Technology has certainly revolutionized the process, but it is not a silver bullet. Hospitals introduced barcode medication administration, or BCMA, and the theory is airtight. The nurse scans the patient's wristband, then scans the drug, and the software algorithm confirms the right patient, drug, dose, route, and time.
It sounds completely foolproof. The computer just takes over the mental load.
It does, but introducing technology also introduces new, unforeseen failure modes. Because humans are still involved in the physical administration, and humans under intense time pressure will always adapt. The research highlights a widespread phenomenon known as workarounds.
Oh, workarounds. What does a workaround look like in practice here?
Imagine a nurse on a night shift. The patient is finally asleep. The barcode scanner is tethered to a cart in the hallway, and the cord doesn't quite reach the bed. Scanning the wristband means waking the patient up, turning on the harsh lights, and pulling this clunky equipment into a cramped space.
Which nobody wants to do at 3 a.m.
Exactly. To save time and preserve the patient's sleep, a nurse might print an extra copy of the patient's wristband barcode and tape it to a clipboard, or even to the wall outside the room so they can scan it quickly without entering.
Wait, really? That scanning workaround sounds exactly like buckling a car's seatbelt behind your back just to stop the warning chime because you're in a massive hurry. The technology is actively trying to save you, but human time pressure defeats the safeguard entirely.
That is a perfect analogy. The tool becomes a hurdle rather than a safeguard. And compounded with workarounds is the issue of alert fatigue.
Alert fatigue.
Yeah, modern electronic health records are incredibly sensitive. They pop up with a warning for every minor, potentially irrelevant drug interaction. If a clinician sees 50 yellow warning boxes a shift that turn out to be harmless, they develop muscle memory to blindly click ignore on every pop-up.
Just clicking through terms and conditions.
Exactly. And eventually, they click right past a critical, life-saving red alert.
Which explains why for the most dangerous drugs, the high-alert medications like insulin, opioids, or chemo, they don't just rely on one nurse and a computer scanner anymore. They require extra independent double checks, forcing a second nurse to separately calculate and verify the dose.
Redundancy is the only proven defense. And all of these realizations from forcing functions to alert fatigue have really culminated in a modern healthcare management philosophy called just culture.
How does just culture change the environment on the hospital floor?
It attempts to resolve the tension between individual accountability and system design. Under a just culture framework, individuals are held strictly accountable if they engage in genuinely reckless behavior like charting a medication they never actually gave or coming to work impaired.
Sure, that makes sense.
But crucially, it mandates treating honest, foreseeable human error as a system design flaw to be fixed. If a well-meaning nurse makes a mistake because 2 drug vials look identical and the lighting is poor, you don't fire the nurse.
You change the lighting.
You change the lighting and mandate different packaging. It fosters an environment where clinicians feel safe reporting near misses, allowing the system to learn and adapt rather than burying mistakes out of fear of termination.
That is such a vital shift, because when you look at this entire landscape, from the ghostly origins of the 5 rights in the 1960s to the complexities of alert fatigue and workarounds, it really changes how you experience care as a patient. The 5 rights are a floor, not a ceiling.
Definitely a floor.
The Institute of Medicine's landmark 1999 report estimated that tens of thousands of Americans die every year from preventable medical errors, with medication-related errors making up a massive portion of that tragedy. And that's not an abstract number.
No, those numbers represent a profound loss of life that stems from incredibly complex systemic interactions, not just simple negligence.
They're real people, like Betsy Lehman and Emily Jerry. So, to our listener, the next time you are in a hospital bed and a clinician pauses, looks at your wristband, and asks for your name and birth date before handing you a medication, you realize you aren't just answering a repetitive question, you're actively participating in a decades-old system of redundant defenses.
You are acting as the final critical patch over a hole in the Swiss cheese. The patient is truly the final check in the system.
But there's a final kind of provocative thought I want to leave you with to mull over on your own. We have seen that human vigilance inevitably fails, even among world-class experts. And we have seen that digital barcode systems are regularly defeated by exhausted clinicians who are forced to create workarounds just to survive the pus of their shift. So maybe the ultimate future of patient safety shouldn't be about adding more checks to a mental list or installing louder alarms on a computer screen. Maybe the future requires entirely redesigning the physical tools of healthcare, just like they did with the vincristine syringe, so that making a fatal mistake doesn't just trigger a warning chime, it becomes mechanically impossible. Moving from a culture of be more careful to a system where it cannot be done wrong. Something to think about the next time you hear that familiar question. Can you confirm your name and date of birth for me? Until next time, keep diving deep.
You know that feeling right around maybe 3 in the afternoon?
Oh, yeah. The 3 p.m. slump.
Right. You're sitting at your desk or, out running errands, and suddenly it just hits you. This massive wave of exhaustion.
Yeah, your hands get a little shaky.
Exactly. Shaky hands. You get that hollow pit in your stomach, and your brain is just screaming one single command, which is find a snack right now.
Yep.
And for most of us, we just grab a granola bar, drink some juice, and we bounce back a few minutes later. We just call it a mid-afternoon crash.
Right, it's just a temporary thing.
But when the body's fuel tank actually hits zero, it triggers a physiological cascade that is so severe, it was actually once used to intentionally induce psychiatric comas.
Which is just wild to think about. It is a radical shift from a temporary hunger pang to a full-blown medical crisis. And the margins for that shift, they are incredibly thin.
Yeah, and that's exactly what we're getting into today. Welcome to today's deep dive, where we are unpacking the fascinating high-stakes world of hypoglycemia.
Yeah, for anyone studying nursing or, working in healthcare or just insanely curious about human physiology, understanding hypoglycemia is really a masterclass in how desperate the body gets when its primary energy source disappears.
Totally. And our mission today is to look at the sources and uncover the exact science of spotting and treating low blood sugar fast. We'll be dissecting the famous Rule of 15, exploring some bizarre medical history, and busting myths that could literally save a life.
It's a lot of ground to cover, but it's so important.
Okay, let's unpack this. Looking at the clinical data for this deep dive, it becomes clear that we often misunderstand what a fuel crisis actually looks like.
How do you mean?
Well, I always assumed blood sugar functioned a lot like a speed limit. If the speed limit is 70, driving 69 miles per hour is fine.
Right, sure.
But the second you hit 71, you get a ticket. And we tend to act like a blood glucose reading of, say, 71 milligrams per deciliter is totally safe, but 69 is an immediate emergency.
Oh, I see what you're saying. Yeah.
But reading through the diagnostic criteria in our sources, it operates much more like a syndrome than a hard numerical cutoff. Why is the brain so uniquely vulnerable here?
Well, it's because human physiology does not read speed limit signs. The brain's vulnerability, it really comes down to this massive mismatch between its fuel consumption and its storage capacity.
Okay, mismatch how?
So the human brain only accounts for about 2% of your total body weight, but it demands 20% of your body's glucose.
Wow, 20%.
Yeah. It consumes roughly 120 grams of glucose every single day just to maintain basic cognitive function and, keep your autonomic systems running.
That is an enormous amount of fuel for just one organ.
Yeah.
But the real structural flaw, according to the sources, is the lack of a backup generator, right?
Exactly. Unlike our muscles or our liver, which can store large amounts of glycogen for later use, the brain basically has zero reserve tank.
None at all.
Well, there are these specialized glial cells in the brain called astrocytes, and they hold this tiny microscopic buffer of glycogen. They process it into lactate to feed the neurons during sudden high demand. But that local supply, it's exhausted in a matter of minutes.
Just minutes. Wow.
Yeah. So when blood glucose falls, the brain is immediately starving. It literally cannot wait for the liver to slowly mobilize its reserves. It needs a continuous, uninterrupted delivery system in the blood.
Which perfectly explains why the American Diabetes Association, the ADA, why they moved away from just using a single diagnostic number.
Right, they broke it down into tiers.
Yeah, 3 tiers. So level 1 is a blood glucose between 54 and 69 milligrams per deciliter, which requires intervention but isn't necessarily a huge crisis.
Right.
And then level 2 is below 54, where neurological impairment usually begins.
Yep, that's where things get dangerous.
But level 3 is what changes the entire paradigm. Level 3 is classified as severe, but there's no specific glucose number attached to it. It's defined entirely by functional impairment.
Exactly. Level 3 means the person has an altered mental or physical status that is so severe they require active assistance from another person to recover.
So the number doesn't even matter.
The absolute number on the meter is totally irrelevant to that classification. If a paramedic finds someone unconscious and revives them with treatment, that is level 3 severe hypoglycemia, even if nobody actually had the time to prick their finger for a reading?
That makes total sense because, glucose tolerance is so individualized. I mean, a healthy person might naturally hover around 65 and feel completely fine.
Absolutely.
But someone with poorly controlled diabetes, whose body has physically adapted to a much higher baseline, they might hit that exact same number of 65 and experience severe tremors and confusion.
Right, because their brain perceives a crash since the relative drop is so steep.
Right.
The central nervous system adjusts its threshold based on what it considers to be normal. So the diagnostic focus really shifts from, chasing a specific number to observing the clinical reality.
Which is the presence of symptoms, a low relative glucose level, and then the resolution of those symptoms when glucose is restored. Speaking of those symptoms, if the brain has no backup fuel, the body obviously needs an incredibly sensitive alarm system to warn you before the tank hits zero.
Oh, absolutely.
And the sources divide this warning system into 2 distinct families: adrenergic symptoms and neuroglycopenic symptoms.
Right.
When I was thinking about how this works, it really reminds me of a dying smartphone.
Okay, I like that. How so?
Well, the adrenergic symptoms, the sweating, the shaking, the racing heart, that's the low battery warning flashing on your screen.
Yeah, it makes sense.
But the neuroglycopenic symptoms, the confusion, the slurred speech, the loss of consciousness, that's the app's actively crashing and the screen blacking out because the power supply is actually gone.
That is a highly accurate way to visualize it. The adrenergic symptoms are driven by a massive, sudden surge of epinephrine, which, most people just call adrenaline.
Right.
When the hypothalamus senses a drop in glucose, it triggers the sympathetic nervous system. It's literally an alarm bell. It's designed to make you feel anxious and physically uncomfortable, so you will immediately go seek out food.
So the sweating and palpitations are just side effects of that epinephrine surge.
Exactly. While the neuroglycopenic symptoms, like you said, those are the direct result of the brain actually suffocating for fuel.
Wow.
But what's fascinating here is, there's a critical danger, a saboteur in this system.
Ooh, a saboteur.
Yeah, Washington University endocrinologist Philip Cryer documented this phenomenon. It's known as hypoglycemia-associated autonomic failure, or HAF.
Okay, what does that do?
So if a patient experiences repeated low blood sugar episodes over time, their brain actually habituates to the crisis.
Wait, really?
Yeah, the hypothalamus basically resets its trigger point for releasing epinephrine.
Oh, wow. So the body just physically unplugs its own alarm system.
It creates a state of hypoglycemia unawareness. The threshold for the epinephrine response gets pushed lower and lower until eventually the brain starts starving, hitting those neuroglycopenic levels before the adrenergic alarm ever even goes off.
That is terrifying.
It really is. The patient skips the sweating and shaking completely. They go straight from walking around feeling totally fine to suddenly having a seizure or collapsing.
So if I see someone who isn't sweating or shaking, I naturally assume they're fine.
Yeah.
But the source material says this is actually the most dangerous assumption you can make.
Absolutely. The sickest patients, the ones whose blood sugars constantly dip, they are the exact people who will never feel the crash coming. Just because there's no low battery warning doesn't mean the phone isn't about to die.
That is such a crucial takeaway. Okay, so if a patient's natural alarms are unplugged and the brain has mere minutes of fuel left, outrunning the brain damage becomes a matter of, precise mathematics.
Yes, it does.
Which brings us to the rescue protocol, specifically the Rule of 15. Now, when I first read the protocol for fixing a crash, my first instinct was entirely wrong.
What was your instinct?
Well, if my blood sugar is crashing, my brain screams for the biggest, most decadent chocolate bar I can find.
Oh yeah, of course it does.
But the clinical sources strictly forbid this. Why is reaching for a Snickers a rookie mistake? Is it like trying to sprint through a mud pit?
That is the perfect analogy, yes. Dietary fat and protein, they significantly slow down gastric emptying.
Okay.
They basically close the pyloric sphincter at the bottom of the stomach, and that delays the transit of everything into the small intestine, which is where glucose is actually absorbed into the bloodstream.
So the sugar gets stuck in the stomach when it desperately needs to be sprinting to the brain.
Exactly. If you try to treat hypoglycemia with a candy bar or, ice cream, the fat traps the sugar. Your blood glucose might not rise for 45 minutes or an hour.
Oh, wow. And by then, the neuroglycopenia is advancing.
Right. Speed requires pure, fast-acting carbohydrates, which is the foundation of the rule of 15 for a conscious patient who can safely swallow.
Right, so you get 15 grams of fast-acting carbs, you wait exactly 15 minutes, recheck the blood glucose, and if it's still below 70, you repeat the cycle.
Yep, that's the rule.
And once they're stabilized, you follow it with a complex carb and protein snack, assuming their next meal is more than an hour away.
The math and the timing there are very deliberate. 15 grams is roughly 4 ounces of regular juice, maybe a tablespoon of honey, or 3 commercial glucose tablets.
It's a pretty small dose.
It is a small, precise dose, and we wait exactly 15 minutes because that is the physiological transit time required for simple sugars to clear the stomach, enter the bloodstream, and actually register on a glucose monitor.
So checking at 5 minutes tells you nothing.
Nothing. And waiting 30 minutes risks further decline.
But the natural human reaction, driven by that primal epinephrine panic we talked about, is to just chug an entire liter of juice.
Which is a massive error because treating a low isn't just about escaping the immediate danger, right? It is about managing the aftermath. If you overcorrect with massive amounts of sugar, your blood glucose is going to skyrocket an hour later. Imagine a type 1 diabetic who wears an insulin pump.
Okay.
They miscalculate a dose, they go for a run, and they drop 100 points in half an hour. The rule of 15 provides a small titratable correction. It gently nudges them back into a safe zone without causing this massive rebound spike that throws their entire metabolic management off for the next 2 days.
That makes a lot of sense. It's the universal standard for nurses treating alert patients. But if someone is completely unconscious or so severely confused that they can't follow basic instructions, the rule of 15 has to be abandoned immediately, right?
Oh, immediately. Yes. Trying to force liquid into an uncooperative or unconscious patient introduces a massive risk of aspiration. They could literally inhale the juice into their lungs.
So what do you do?
At that point, you bypass the digestive tract entirely. If you're in a community setting, the treatment is glucagon.
Okay.
Historically, this required an intramuscular injection, which, was highly stressful for untrained bystanders to mix and administer during an emergency. But thankfully, we now have Baqsimi.
Right, the nasal spray.
Exactly. It's an FDA-approved intranasal glucagon spray. It requires no needles, and it works even if the patient is unconscious and not actively inhaling.
That is incredible. And what if they are already in an ambulance or a hospital bed?
In that setting, paramedics and hospital staff will use an intravenous dextrose solution. For decades, the standard was pushing an ampule of D50, which is a highly concentrated 50% dextrose solution.
Okay.
But current evidence-based practice is really shifting toward D10, which is a more dilute 10% infusion.
Right, because I would imagine the D50 was essentially the IV equivalent of chugging the entire liter of juice. It just slams the system.
Exactly. D50 acts like a sledgehammer. It damages veins and almost guarantees severe rebound hyperglycemia. D10 corrects the deficit much more smoothly and safely.
It's hard to reconcile this level of precise evidence-based pharmacology with the historical reality of how doctors used to treat blood sugar.
Oh, the history is wild.
Here's where it gets really interesting. Tracing the history of hypoglycemia reveals this recurring theme, the profound danger of blind medicine. Doctors were constantly doing their best to manage a system they couldn't fully see.
Right.
For instance, hypoglycemia barely existed as a widespread medical issue before Frederick Banting and Charles Best isolated insulin in 1921.
That's true, because before external insulin therapy, humans rarely experienced severe artificial drops in blood sugar. The crisis was essentially man-made, an iatrogenic effect of our attempts to treat diabetes.
But instead of viewing these severe crashes entirely as a side effect to be minimized, Some practitioners actually weaponize the physiology.
Unfortunately, yes.
In 1927, Manfred Sockel began using massive doses of insulin to intentionally force patients with schizophrenia into hypoglycemic comas.
Yeah, insulin coma therapy.
Right. They starve the brain of glucose day after day, sometimes for weeks, based on this totally unfounded theory that the trauma of the coma would reorganize their psychiatric pathways. We used to intentionally induce the exact medical emergency nurses are now trained to prevent.
If we connect this to the bigger picture, it was a brutal era of medicine. I mean, they were purposefully inducing level 3 severe hypoglycemia, risking permanent brain damage and death, long before we understood the cellular limits of astrocytes or neuroglycopenia.
And that blindness extended to diagnostics, too. Look at 1938. Surgeon Alan Oldfather Whipple had a severe problem. He suspected some of his patients had insulinomas.
Right, those rare insulin-secreting tumors in the pancreas.
Exactly, which caused severe hypoglycemic crashes. But he didn't have CT scans or MRIs to prove the tumor existed before cutting the patient open.
And exploratory pancreatic surgery was incredibly dangerous back then, so he needed absolute diagnostic certainty without any imaging.
Which is where Whipple's triad comes in.
Yep. He established the triad we mentioned earlier, documented symptoms, a simultaneous low glucose reading, and complete resolution when given carbohydrates.
If a patient met all three, Whipple knew the physiological mechanics were real and the surgery was justified.
And almost 90 years later, that triad remains the gold standard today because it relies on functional reality rather than just numbers.
It's amazing. But even into the mid-20th century, we were still guessing at the unseen mechanics of the body. In 1959, biochemist Michael Somogyi identified patients waking up with wildly high morning blood sugars.
Okay, yes, the Somogyi effect.
Right, he proposed that they were actually crashing dangerously low in the middle of the night. His theory was that the brain panicked, released a flood of counter-regulatory hormones like cortisol and adrenaline, and caused a massive rebound spike by morning.
Which makes sense on paper.
Right. So doctors spent decades lowering nighttime insulin doses to treat this assumed midnight crash.
And, it was a perfectly logical theory based on the limited data they had. Doctors couldn't stand over a sleeping patient and draw blood every 15 minutes.
Right, obviously not.
But modern technology finally brought us out of the dark. The invention of continuous glucose monitors, or CGMs, allowed us to track interstitial glucose continuously through the night.
And the data proved Somogyi mostly wrong.
It did. The data revealed that nocturnal rebound hyperglycemia is actually quite rare.
Yeah.
Most of those high morning numbers are caused by the dawn phenomenon.
The dawn phenomenon.
Yeah, it's a natural diurnal release of growth hormone and cortisol in the early morning hours that increases insulin resistance. So the treatment wasn't to lower the evening insulin, but to adjust the timing of the basal dose.
Wow.
CGMs allowed us to finally see the true physiological narrative instead of guessing based on the aftermath.
Which brings us to the present day. Even with CGMs and highly refined protocols, the sources emphasize that the science is still evolving, and dangerous misconceptions persist everywhere.
They really do.
Like, the rule of 15 is the standard, but there is an ongoing clinical debate pushing for a rule of 20 for certain populations. The argument is that 15 grams might undertreat larger adults, trapping them in a cycle where they take 15 grams, wait, fail to recover, and have to treat again.
Exactly. It highlights that protocols are baselines, right? Not immutable laws of physics. But the more immediate danger really lies in the myths held by the general public and sometimes even first responders.
So what does this all mean?
Well, the mechanisms behind these myths are crucial to understand. Take the relationship between alcohol and blood sugar.
Oh, this one is huge. Wait, so if you see someone stumbling and slurring their words after drinking, it might not just be intoxication.
Exactly. If you're out with friends, or if you're a paramedic responding to a call, and you see someone stumbling out of a bar, slurring their words, acting combative, the immediate assumption is heavy intoxication.
Sure, that's what everyone thinks.
But that assumption can be lethal if the person is actually experiencing profound neuroglycopenia. The physiology here is fascinating. The liver is a multitasking organ, but it is highly inefficient when it comes to prioritizing those tasks.
Okay, what do you mean?
Well, one of its main jobs is gluconeogenesis. The creation of new glucose from non-carbohydrate sources could keep your brain fueled between meals. However, the liver views alcohol as a potent toxin.
So it drops everything else to deal with the threat.
Precisely. Processing ethanol monopolizes the liver's chemical machinery. Specifically, it depletes an enzyme cofactor called NAD plus slack.
Okay.
And without that cofactor, the liver physically cannot run the gluconeogenesis pathway. It completely shuts down the body's backup generator.
Wow. So if someone has been drinking heavily on an empty stomach, their blood sugar can crash hours later.
Yes, they appear drunk because their brain is starving. And if a bystander just lets them, sleep it off on a couch, they are allowing the neuroglycopenia to progress unopposed,
Yeah.
which can lead to a coma.
That is terrifying. And the liver's prioritization of alcohol over glucose production also explains the major misconceptions surrounding glucagon, right?
Oh, absolutely.
People assume glucagon works instantly, like an EpiPen for allergies. You inject it, and the crisis ends. But glucagon doesn't contain any actual sugar.
Right. Glucagon is merely a signaling hormone. Its only function in an emergency is to command the liver to break down stored glycogen and dump it into the bloodstream.
Which takes time.
It takes 10 to 15 minutes for that metabolic process to occur. But more importantly, if the liver's glycogen stores are already completely depleted, say because the patient has been fasting, recently drank alcohol, or had multiple low blood sugars over the last 24 hours, the glucagon has nothing to work with.
Oh, man.
You can shout on an empty warehouse all you want, but it won't produce any inventory.
That mechanical limitation totally reframes the entire clinical picture. And it also broadens the scope of who is at risk. While insulin medications make hypoglycemia far more common in diabetic patients, they are not the only population vulnerable to these crashes.
Not at all. I mean, we see severe reactive hypoglycemia in patients who have undergone bariatric weight loss surgery.
Dumping syndrome.
Yes, dumping syndrome.
Yeah.
Because the anatomy of the stomach has been altered, a high carbohydrate meal empties into the small intestine far too rapidly. And this triggers an inappropriately massive release of endogenous insulin, which then sweeps all the glucose out of the blood, causing a severe crash shortly after eating.
That's wild. And the sources also heavily emphasize the danger of accidental ingestion of sulfonylureas, particularly for pediatric patients.
Yes, sulfonylureas are oral medications that force the pancreas to secrete insulin. And unlike a rapid-acting insulin injection that, peaks and clears the system relatively quickly, these pills are designed for prolonged action. So if a toddler accidentally swallows a grandparent's sulfonylurea tablet, the resulting hypoglycemia can be relentless, lasting for many hours and requiring extended hospital monitoring and continuous dextrose infusions.
It really becomes clear that managing hypoglycemia isn't just about knowing the textbook definition. It's about respecting the sheer mechanical wonder and danger of the body's fuel system.
It absolutely is.
We've traced the brain's unique vulnerability from the ADA's functional definitions through the life-saving precision of the Rule of 15 and past the dark history of insulin comas, all the way to the modern myths that still trick us today.
And for nursing professionals, rapid recognition is just a foundational skill because a miss low can escalate from mild confusion to a seizure in a matter of minutes.
All right.
But the broader impact of this condition extends far beyond emergency medicine. Hypoglycemia is a leading cause of preventable hospital admissions. And the physiological terror of that adrenergic alarm system, it leaves a lasting psychological scar on patients.
I'm glad you brought that up. Looking at the literature, it seems like the sheer terror of this experience causes a behavioral backlash. The sources describe a phenomenon called defensive hyperglycemia.
Yes, this is so important.
Patients who have suffered severe crashes are so traumatized by the feeling of their brains suffocating that they intentionally keep their blood sugars dangerously high. They run their glucose levels at 200 or 250 every day, preferring the abstract, long-term risk of organ damage over the immediate visceral panic of a crash.
The fear is profound. And this raises an important question. It forces us to reevaluate how we view patient behavior in a clinical setting.
It absolutely changes the perspective. The medical community frequently labels patients who run chronic high blood sugars as non-compliant, which carries an inherent judgment.
It implies a lack of discipline or care.
Exactly. But perhaps what we call medical non-compliance is, in reality, a deeply rational, protective human response to the terror of hypoglycemia.
When you understand that the brain will do anything to avoid starvation, a patient's decision to avoid the edge of the cliff makes complete physiological and psychological sense.
It is not just a frustrating number on a chart. It is a constant, exhausting tightrope walk. So the next time you feel that sudden mid-afternoon crash, the shakes, and the urgent need for a snack, take a second to appreciate the incredible high-stakes alarm system firing off to keep your brain online. Until next time, keep digging deeper. I want you to think back just for a second to a time when you were in a really vulnerable situation.
You're right.
Like maybe you were sitting in a hospital ER,
Yeah.
or you were on the phone with a crisis hotline.
Yeah, those really high-stress moments.
Exactly. And do you remember that specific moment when a complete stranger, like a nurse or a counselor, just walked into the room and within minutes you felt this like profound sense of ease?
Like you could just finally exhale.
Yes. You probably walked away assuming that person was simply, a naturally gifted, empathetic soul. Like they just had the magic touch.
Oh, absolutely. We tend to romanticize that kind of human connection, right? We assume it's just instinct.
Right. But the reality is actually far more clinical. That feeling of instant trust isn't magic. It's usually the result of highly engineered, testable mechanics.
It's a very specific skill set.
Yeah, known as therapeutic communication. And that is our mission for this deep dive. We're unpacking the deliberate architecture that healthcare providers use to get patients to open up.
And, the underlying psychology of these techniques is something you can actually apply to your own everyday conversations.
Which is the best part. We got some fascinating sources on the table today, ranging from modern nursing textbooks to historical psychiatric literature from the 50s, all the way to current bioethics journals.
It's a really rich area of study.
It is. So to understand how this architecture works, we have to establish a baseline. Like, therapeutic communication is fundamentally different from just a normal social chat.
Oh, completely.
Because in everyday life, a conversation is reciprocal, right?
Yeah.
Both people are seeking connection or validation, or they're just, passing the time.
Right. But the clinical literature defines therapeutic communication as strictly goal-directed.
Goal-directed.
Yes. I mean, every pause, every shift in posture, every single question is deployed to serve the patient's needs, not the provider's comfort.
So it's not about making friends.
Not at all. It is literally treated as a clinical intervention. You're using communication as a form of medicine to establish rapport, get accurate diagnostic info, and help the patient problem solve.
Okay, so the first major hurdle a clinician faces in doing that is just getting past the patient's internal filter.
Yes, the filter's huge.
Because when someone walks into a clinic, they almost never offer the raw, unedited truth right away.
No, they're terrified. Or embarrassed.
Right. They edit their answers based on fear or just the really intimidating power dynamics of, sitting half naked in a paper gown while someone stands over you with a laptop.
Yeah, it's not a natural environment.
No. So bypassing that filter requires actually manipulating the boundaries of the conversation.
And this is where we look at textbooks on interpersonal relationships in nursing. Like, the widely cited work by Arnold and Boggs focuses heavily on the actual literal framing of questions.
Like the mechanics of the sentences.
Exactly. A core intervention they teach is swapping out closed questions for open-ended ones, because it completely changes the cognitive load on the patient.
How so?
Well, think about it. If a nurse asks, "Are you in pain?" that closed question primes a one-word answer.
Right, yes or no.
And more importantly, it gives a patient who minimizes their discomfort an easy out.
Oh, wow. Yeah, they just say no, so they don't bother the busy doctor.
Precisely.
Yeah.
But if the nurse says, "Tell me what you're feeling right now," they shift the mental task. The patient isn't just answering a binary prompt anymore. They have to narrate an experience.
Yeah, I had to tell a story.
Right. And in that narrative, the patient might casually bring up, debilitating nausea or severe anxiety about paying for their meds' vital clinical data that a yes or no question would have just permanently buried.
It really reminds me of dealing with poorly designed automated tech support.
Oh, gosh, yes.
Like when your internet goes down and the robot voice is like, "Are you calling because your router is blinking red? Say yes or no."
But it's not blinking red.
Exactly. It's completely dead. But the prompt forces you into this binary box that doesn't actually capture your problem.
This is a perfect analogy. A closed clinical question traps a patient in a diagnostic box of the clinician's own making.
It prevents them from revealing what's actually wrong.
You're predetermining the boundaries of their experience before they even get to speak.
That's wild.
Yeah, and another mechanical shift that changes the patient's response is just replacing the word why with what or how.
Wait, really? Just dropping the word why?
Just that one word. Asking a patient, "Why didn't you take your medication?" almost guarantees they get defensive.
Well, yeah, it sounds judgy.
It does. From a psychological standpoint, the word why often triggers the amygdala, the part of the brain associated with threat detection. It literally sounds like an accusation demanding a justification.
So the patient feels like they're being interrogated for a crime.
Exactly.
And they just shut down. Or they make up an excuse.
Right, but if the provider simply asks, what got in the way of taking your medication, they change the neurological response entirely.
Oh, wow. What got in the way?
Yeah. By framing the obstacle as an external what, you bypass the defensive reaction. You engage the prefrontal cortex, which handles objective problem solving.
So the blame is totally removed from the patient.
And placed on the external factor. The patient transitions from being like a suspect defending their character to a partner solving a logistical puzzle.
That structural shift makes total sense. But, okay, there is another tool in the literature that seems completely counterintuitive to me.
Oh, I know where you're going with this.
Yeah, the use of deliberate silence.
Yes, silence.
Like, silence is formally classified as an active clinical technique, not just a gap between sentences.
It's an active, powerful tool, but the education literature shows that novice clinicians are absolutely terrified of it.
I mean, I would be too.
Research on new nurses shows they consistently panic when a patient discloses something really heavy. If a patient says, I'm terrified of dying, the novice will typically tolerate only 1 or 2 seconds of silence before they just jump in and start speaking.
Because the natural human instinct is to fill that dead air.
Right.
When someone tells you they're terrified, you want to instantly fix it. You want to say, don't worry, the doctors are great, you're going to be okay.
And that instinct to fill the space is exactly what clinical education tries to train out of providers.
Really?
Yeah, because that urge usually results in what they call false reassurance.
False reassurance, okay.
Saying everything will be fine when you don't actually know the prognosis, that only serves to relieve the clinician's own discomfort with the awkward silence. It does nothing for the patient's anxiety.
Oh, I see.
False reassurance is basically a conversational dead end. It sends the message that the patient's fear is an inconvenience.
It totally invalidates what they just told you.
It dismisses their reality completely. Patients actually need processing time. The literature suggests a minimum of 5 to 6 seconds of uninterrupted silence after a difficult disclosure.
6 seconds. That is an agonizingly long time to just sit there in silence.
It feels like an eternity. But they need that neurological lag time to process their own emotions, to formulate their next thought, or honestly just to cry.
Wow.
By deliberately maintaining silence, the provider is actively holding space. They're signaling that it is safe for the patient to keep exploring that really difficult feeling.
It's just so striking to me that holding space and trying to get the patient's unedited truth is the gold standard today. Because if you look at the history of the medical establishment.
Oh, it's a totally different world.
Yeah, there was a long period where the prevailing consensus was that truthful communication was actively detrimental to a patient's health.
It's hard to believe now, but the history of therapeutic communication is rooted in this deeply paternalistic era. There's this landmark study published in the Journal of the American Medical Association back in 1961 by a physician named Donald Oken.
The Oken study, yeah.
He surveyed practicing doctors about their communication habits, and he found that roughly 90% of them routinely withheld cancer diagnoses from their patients.
90%. They would literally tell the patient's family, but intentionally lied to the patient sitting right there in the bed.
Yeah, and this wasn't driven by malice. It was just rooted in the bioethical framework of the time.
They thought they were helping.
Exactly. The prevailing wisdom was that patients lacked the psychological resilience to handle terminal news. Doctors genuinely believed that full disclosure would destroy a patient's hope.
And accelerate their physical decline.
Right. Paternalism dictated that the physician's duty to protect the patient from harm was way more important than the patient's right to know what was happening to their own body. Silence and deception were used as protective clinical tools.
Which is just wild to think about. But that paradigm obviously collapsed.
Thankfully, yes.
Because by the 70s and 80s, the sources indicate a total inversion. The rise of the consumer rights movement and modern bioethics established patient autonomy as the paramount right.
It was a massive cultural shift.
Yeah, and replications of Oken's study a couple of decades later showed the numbers had entirely flipped. The vast majority of physicians were suddenly favoring full disclosure.
So the control of the narrative shifted fundamentally from the provider to the patient. But the actual mechanics of how to conduct these therapeutic relationships, that traces back to the post-war psychiatric wards.
Okay, let's get into that.
So Hildegard Pepla, a World War II Army nurse, is really considered a pioneer here. In 1952, she published this huge work called Interpersonal Relations in Nursing.
And she was heavily influenced by Harry Stack Sullivan's theories on interpersonal psychiatry, right?
Exactly. Pepla argued something incredibly radical for the time. She said the nurse-patient relationship itself was the treatment.
Which was huge because nursing at the time was so highly task-oriented.
It was just checking boxes.
Yeah, administering pills, changing dressings, following orders. But Pepla elevated the interaction itself to a therapeutic level.
She did.
And she designed this famous four-phase model for the clinical relationship, right? Orientation, identification, exploitation, and resolution.
Those are the four.
Now, the first two make total sense to me. Orientation is just setting the parameters of care, and identification is the patient starting to trust the nurse.
Right.
But that third phase, exploitation, that sounds incredibly toxic in a healthcare setting. What does that actually mean?
I know the terminology really reflects the era, and it can sound super jarring today. But in Pepla's framework, exploitation refers to the patient's constructive use of the relationship.
Constructive use, okay.
Once trust is established, the patient actively exploits or uses the resources, the time, and the clinical expertise of the nurse to work through their own health challenges.
So they're milking the system for their own good.
Exactly. It is the phase of maximum patient empowerment. They are extracting value from the healthcare system for their own healing.
Okay, that makes way more sense.
And then the final phase, resolution, involves carefully severing that therapeutic tie as the patient gets better and returns to independence.
So the patient is leveraging the relationship for their own benefit. And following Pepla, the sources show a really strong integration of psychological theories into nursing.
Oh, heavily. The work of psychologist Carl Rogers is central here.
Right, from the early 60s.
Yeah, in 1961, he introduced the 3 core conditions for therapy: empathy, unconditional positive regard, and congruence, which basically means genuineness.
Being authentic.
Right. And then nurse theorist Joyce Travelby synthesized these ideas in 1971, coining this amazing concept called the therapeutic use of self.
Which means what, exactly?
It suggests that a provider's disciplined presence is actually a clinical instrument. It requires the clinician to stay self-aware and consciously use their personality, their tone, and their emotional regulation as an intervention.
But relying purely on a provider's emotional intelligence became a huge liability once truth-telling was mandated, didn't it?
Oh, for sure.
Because when doctors were suddenly required to deliver devastating news, doing it without a structured framework led to disastrous outcomes.
Clinicians under pressure would just panic.
Right. They'd deliver the news way too bluntly, or they'd retreat behind this wall of dense medical jargon. They needed to engineer actual protocols for these high-stakes conversations.
Because empathy without structure can easily lead to psychological trauma for the patient.
Exactly.
And that necessity birthed frameworks like the Spikes Protocol, which was published by Walter Bale and his colleagues around 2000. It was specifically designed for oncology, for breaking bad news.
Right, and it's an acronym.
Yes, it walks the clinician through a very deliberate psychological pacing.
So the steps are setting, perception, invitation, knowledge, emotions, and strategy.
That's right.
And the PPS reception seems particularly crucial for pacing the conversation.
Oh, it's vital. The perception step requires a clinician to ask the patient what they already believe is happening before delivering the news.
So asking something like, what have you been told so far about your MRI results?
Exactly. It forces the clinician to calibrate the delivery. Because if the patient firmly believes they are just there for a routine scan, the clinician instantly knows they have to bridge a massive psychological gap.
You have to find out where the patient is on the map before you can safely guide them to this terrible new destination.
That's a great way to put it.
And then the I invitation takes it a step further by actually asking for permission to share the data.
Yes. The clinician asks, are you someone who wants all the medical details, or would you prefer I just focus on the big picture and the treatment plan?
Wow, that is so respectful.
It really is. It respects the patient's autonomy and their cognitive limits in that exact awful moment.
Right.
Then, in the case step knowledge, the provider gives the facts in small, digestible chunks. They avoid jargon, and they pause frequently.
Which prevents that anxiety-driven beta dump that overwhelmed doctors usually default to.
Exactly. Now, there is another high-stakes framework that focuses on instruction rather than bad news, and it addresses the massive problem of health literacy.
Oh, the teach-back method.
Yes. Patients routinely nod along to discharge instructions, like how to manage a surgical drain or take a complex set of pills, without actually understanding a word of it.
Because no one wants to look stupid.
Right. But the teach-back method completely bypasses that fear.
Because instead of a nurse asking, "Do you understand?" which inevitably prompts a defensive yes,
Yeah.
the provider shifts the burden of clarity.
They put it on themselves.
Yeah, they say, "Just so I know I explained this well, can you tell me how you'll take this medication when you get home?"
It's brilliant. It is an evaluation of the provider's communication skills, not the patient's intelligence.
Exactly. If the patient explains it incorrectly, they don't feel ashamed. They just assume the nurse needs to clarify.
It opens the door for correction without damaging that rapport.
It's such a great psychological trick. But, the proven success of frameworks like Spikes and Teachback has sparked a really heated debate in modern nursing education.
The scripting debate.
Yes, because if scripting certain interactions improves outcomes, hospital administrators naturally want to standardize and script as much of the bedside experience as possible.
Which leads directly into the authenticity trap.
Right, because hospital customer service initiatives have heavily promoted programs like ATET, right? Acknowledge, introduce, duration, explanation, and thank you.
Yeah, popularized by the Studer Group. It provides nurses with these highly structured, almost verbatim scripts for interacting with patients.
And hospital systems love it.
Because it's measurable. And it often yields short-term gains in patient satisfaction scores. But critics in publications like the Journal of Clinical Nursing argue that aggressive scripting creates hollow empathy.
Hollow empathy.
Yeah. It violates Carl Rogers' core rule of congruence. If a provider recites a scripted line like, "I understand this must be very difficult for you," but their tone and body language don't genuinely reflect that sentiment,
Patients instantly detect it.
they absolutely know it's fake.
It feels like getting one of those automated apologies from an airline app when your flight is canceled,
Yes.
as opposed to a human being actually looking at you and genuinely acknowledging how frustrating it is.
Huge difference.
This tension between genuine connection and professional distance really brings up the clinical distinction between empathy and sympathy.
Which is a crucial distinction.
Because in a casual setting, we use those words totally interchangeably. But the nursing literature draws a hard boundary.
They represent two entirely different psychological mechanisms. Empathy requires accurately perceiving a patient's emotional state and reflecting it back to them. You validate their experience without absorbing their distress as your own.
It operates like a mirror.
Exactly. Sympathy, on the other hand, is feeling sorry for the patient. It is rooted in pity.
And pity creates weird dynamics.
It inherently establishes a power imbalance. When you pity someone, you distance yourself from their suffering, creating this wall between provider and patient.
So sympathy isolates, but empathy connects.
Bingo.
Speaking of communication misconceptions, we have to address this pervasive myth that appears in, every corporate seminar and self-help book ever written.
Oh, I bet I know which one.
The idea that 93% of communication is nonverbal.
Ah, yes. The Morabian myth.
It implies that the actual words you use barely matter compared to your vibe or your body language.
And nursing education actively works to debunk this because it is a deeply dangerous misapplication of a very narrow psychological study.
So where did it come from?
Well, back in 1967, a psychologist named Albert Morabian conducted research where subjects listened to a recording of a single neutral word like the word maybe,
Okay.
but it was spoken in a tone of voice that clearly conflicted with the word's meaning, while they looked at a facial expression that also conflicted.
Oh, got it. So if someone is aggressively shouting the word fine, you believe the shouting, not the vocabulary.
Exactly that. Morabian's formula only applies to situations where emotional cues are incongruent. It absolutely does not mean that 93% of all human communication is nonverbal.
That's a massive distortion.
It is. The words carry the critical diagnostic data. Think about it. If a patient quietly says, "My chest feels like it's tearing," but their body language appears calm.
If the nurse ignores the words because the nonverbal vibe seems chill, they're making a fatal error.
A severe clinical error. Words matter immensely.
Recognizing that words matter and that communication breakdowns are literally the leading cause of adverse events and malpractice claims in hospitals, the medical field has developed tools to ensure critical data isn't lost.
Which is why we have things like SBR.
SBR, yeah. Situation, background, assessment, recommendation.
Right. SBR is a standardized structural tool used during handoffs, like when one nurse finishes a shift and passes a patient to the next nurse.
It forces the communication out of a messy, chaotic narrative and into a rigid sequence.
You state the immediate problem, the relevant history, your clinical assessment, and what you think needs to happen next. It eliminates the guesswork.
So cognitive overload doesn't cause a provider to just drop a vital piece of context.
Precisely.
Another really fascinating application of these mechanics is motivational interviewing.
Oh, I love motivational interviewing.
It's used heavily in primary care for behavior change, right?
Yeah.
Like getting a patient to quit smoking or change their diet.
Yes.
Instead of lecturing the patient on the dangers of smoking, which, as we know, triggers that defensive amygdala response.
Oh, why trigger?
Right. Instead, the provider uses open-ended questions to evoke the patient's own reasons for wanting to change.
It is explicitly designed to resolve ambivalence. By carefully guiding the conversation, the provider helps the patient articulate their own intrinsic motivations.
Because when the patient hears themselves argue for the change,
It is infinitely more effective than a doctor just wagging a finger and telling them what to do.
it's brilliant. And, the mechanics of therapeutic communication, motivational interviewing, the teach-back method, using what instead of why, and just holding space with silence, these aren't just for clinicians.
No, they apply directly to our everyday lives.
Totally. Like, if you are supporting a grieving friend, your first instinct might be to offer false reassurance. You might want to say, "At least you had so many good years together," or "Everything happens for a reason."
And in a clinical context, we know those phrases function as total conversation killers.
They shut the person down.
They invalidate the person's current distress. Applying therapeutic communication in real life means learning to just sit in the awkward silence.
Let it be awkward.
Use open-ended questions to let them narrate their grief and mirror their emotions through true empathy, rather than distancing yourself with pity and sympathy.
It really forces you to reevaluate how you handle every difficult conversation.
It does.
To close out this deep dive, the bioethics journals present a final, really provocative thought regarding how we handle information today.
This is a fascinating debate right now.
Yeah, because we discussed how paternalism and lying to patients in the 60s was highly unethical. But some modern bioethicists argue that the pendulum of informed consent may have swung way too far into blunt transparency.
Right. The current ethical discussion really centers on this concept of asking before telling.
Asking before telling.
Yes. Rather than assuming that full, unvarnished transparency is always the most therapeutic approach, clinicians are exploring whether a patient's appetite for devastating information should actually be elicited first.
It challenges the assumption that radical honesty is always the highest moral good.
It really complicates things.
It does, because sometimes the most trust-building thing you can do isn't just dropping the blunt truth on someone because you feel legally or morally obligated to. It's carefully asking them how much of the truth they actually want to carry in that exact moment.
And when they give you their answer.
You give them the 6 seconds of silence they need to process it. Because the ability to instantly put someone at ease isn't magic. It is an architecture of empathy, and now you understand the blueprints.
Welcome to this deep dive. Usually when we talk about a bodily function, we carry this expectation of simplicity.
Right, like you just do it without thinking.
Exactly. You think about breathing, for instance. Your chest rises, your chest falls.
Or a reflex, like tapping your knee with a little hammer to make your leg kick.
Yeah, we operate under the assumption that these everyday actions are just automatic, mindless processes. But then you look at the act of swallowing, and that illusion of simplicity just completely falls apart.
It really does. I mean, it is not a basic reflex at all.
No, it's a wildly complex, high-stakes mechanical sequence, and that is exactly what we are putting under the microscope today.
Because we perform this sequence, hundreds of times a day? And we do it without dedicating a single conscious thought to it?
Yeah, we rarely consider the absolute anatomical precision required to prevent our morning coffee or, our dinner from traveling down the wrong pipe and ending up in our lungs.
And when that precision fails, it goes dangerously wrong. Which brings us to the core of what we're looking at today.
Right. Our mission for this deep dive. We are looking at a massive stack of source material today. We've got medical science notes, clinical guidelines, historical texts, all to unpack a condition called dysphagia.
Which is the medical term for difficulty swallowing.
Yeah, and we're framing this strictly through a clinical and nursing lens for you today. We aren't just talking about a mild inconvenience at the dinner table.
No, not at all. We want to show you how healthcare professionals assess airway risk, how they prevent life-threatening complications, and how they navigate some surprisingly intense medical debates.
Okay, let's unpack this, starting with the word itself. Like if you break it down, dysphagia comes from the Greek roots. You've got dys meaning difficulty or disordered,
Right.
and phagein meaning to eat.
But we have to establish a crucial medical distinction for you right at the start here. Dysphagia is a symptom, or I guess you could call it a syndrome. It is not a standalone disease.
Oh, okay, so it's more of a warning sign.
Exactly. Clinicians view it as a giant red flag, signaling that an underlying problem has disrupted the swallowing pathway somewhere. And in the medical field, it's split into two main categories.
Which dictate the entire course of treatment, right?
Yeah, entirely. So first, you have esophageal dysphagia. This is the sensation that food is sticking or, moving too slowly lower down in the chest after it has already left the throat.
And based on the notes, that usually points to a structural issue in the esophagus itself, like a stricture, for example, where the tube physically narrows.
Right. Or a motility problem like achalasia.
Achalasia. That's essentially nerve damage, right?
Yeah.
Where the esophageal sphincter at the very bottom of the tube just refuses to relax.
Refuses to let the food pass into the stomach.
Yeah.
The food just sits there.
Wow. Okay, so that's esophageal. What's the second category?
The second category is oropharyngeal dysphagia. So this is the difficulty of initiating a swallow in the first place, or safely moving the food from the mouth into the throat.
And this specific area, this is the domain of nurses, speech-language pathologists, or SLPs and neurologists.
Yes. And we need to emphasize that oropharyngeal dysphagia carries the absolute highest risk of mortality.
Which makes sense when you look at how the medical understanding of the throat has evolved. I mean, for decades, swallowing was considered just a simple single reflex arc.
But modern clinical science completely reframed it.
Right.
It's actually an incredibly rapid four-phase sequence.
Right. You've got the oral preparatory, oral, pharyngeal, and esophageal phases.
And that sequence requires the coordinated timing of roughly 30 pairs of muscles and 6 different cranial nerves.
30 pairs of muscles just to swallow a bite of food.
Just for one swallow.
So if it's not a single reflex, what is actually happening physically between the moment a bite of food enters your mouth and the moment it hits your esophagus?
Well, the sequence starts with the oral preparatory phase. Your teeth chew the food, and your tongue mixes it with saliva to form a cohesive, wet ball.
Which clinicians call a bolus, right?
Right, a bolus. Then comes the oral phase, where the tongue actively propels that bolus toward the back of the throat.
And up to this point, it's completely voluntary, like you are actively controlling it.
Exactly. You control it. But once that bolus hits the back of the throat, it triggers the pharyngeal phase, which is entirely involuntary.
It's out of your hands at that point.
Completely out of your hands. Within about half a second, the airway must completely seal itself off to let the food pass safely over it.
And this is where the anatomy gets so fascinating. Instead of thinking about it like a simple reflex, it's more like a high-speed biological obstacle course.
A very precise obstacle course.
Yeah, where a series of trapdoors basically have to open and close in the exact right millisecond. Like, the soft palate lifts up to block the nasal cavity so food doesn't go up into your nose.
Nobody wants that.
Right. And then the epiglottis, which is this little flack of cartilage, it tips down like a lid over the airway.
And at the same time, the vocal folds inside the airway snap together like double doors.
And the entire larynx, the voice box, pulls physically up and forward to tuck itself out of the way of the falling food.
So if any one of those 30 muscles fires a fraction of a second too late, or if a cranial nerve fails to send the signal, those trapdoors just don't shut in time.
Which is terrifying. Swallowing is essentially a high-speed relay race where a dropped baton means food goes directly into your airway.
That's a great analogy. And because there are so many moving parts, dysphagia is rarely an all-or-nothing failure.
Right. It depends on exactly which runner drops the baton. Like someone could have the muscle control to swallow thin liquids perfectly, but entirely fail to move solid foods.
Or the reverse. They might handle solids just fine, but thin liquids move way too fast for their delayed trapdoors to catch.
And when those trapdoors fail, we arrive at the most feared concept in this field: aspiration.
Aspiration, yes.
And the source texts are incredibly strict about differentiating between aspiration and penetration. They are not interchangeable terms.
No, they are clinically distinct. That difference was actually formalized back in 1996 by Joanne Robbins and John Rosenbach.
Right. They created the penetration aspiration scale, or the PAS.
Exactly. The PAS is an 8-point grading system used to evaluate swallow studies. So penetration occurs when food or liquid enters the laryngeal vestibule.
Which is a very top opening of the airway, right?
Right. It enters the top opening, but the material stays above the vocal folds.
Okay, so it breaches the outer defenses, but it doesn't drop all the way down into the lungs.
Correct. But aspiration occurs when that material physically passes below the vocal folds and enters the trachea.
And at that point, it is heading straight down into the delicate lung tissue.
Yes, which is where it causes severe problems. The PAS scale allows clinicians to precisely grade how deep the material goes, and crucially, whether the patient makes any physical attempts to cough it out.
Because you can evaluate a patient who experiences frequent penetration but manages to clear it every time, never actually aspirating.
Right. And then you can evaluate a patient who aspirates on a single sip of water without any prior penetration warning signs whatsoever.
And the idea of coughing it out brings up, well, here's where it gets really interesting, because it's the most counterintuitive fact in this entire field.
Oh, absolutely.
Coughing is absolutely not a reliable indicator of aspiration.
No, it's not.
The sources show that roughly a third to over half of patients who aspirate show zero visible distress. No coughing, no sputtering.
No throat clearing, no watery eyes.
It is completely silent.
Silent aspiration. It happens because the sensory nerves in the throat and airway have been blunted, usually by a neurological event like a stroke.
So the brain simply doesn't receive the panic signal that food is falling into the lungs.
Right, so it never triggers the reflex to cough and expel it.
But wait, if a patient isn't coughing or choking at all, how on earth is a frontline nurse supposed to know they're aspirating?
That's a huge challenge.
Like, if someone sitting in a hospital bed looks completely fine while drinking a glass of water, how do you catch a silent failure?
Well, we use bedside screening tools. I mean, they are imperfect, but they are the first line of defense. Because silent aspiration exists, a nurse cannot just observe a patient eating a meal and declare their airway safe.
So what does a screening tool look like?
One of the most common is the 3-ounce water swallow test. It was developed in 1992, often called the Burke protocol.
Okay, the Burke protocol, how does it work?
The nurse asks the patient to drink about 90 milliliters of water continuously without stopping.
I mean, 90 milliliters is actually a substantial, challenging volume of liquid.
Yeah, it's meant to stress the swallowing mechanism. If the patient coughs, chokes, or develops a wet, gurgly-sounding voice within 1 minute of finishing, they fail the screen.
Right, a wet voice indicating that water is just sitting on top of their vocal cords.
Exactly. And if they fail, they are immediately flagged for a consult with a speech-language pathologist.
But here is the vital context for this test, according to the sources. It is a screen, not a diagnosis.
That is a very important distinction. A medical screen is designed to be cheap, fast, and highly sensitive in order to cast a wide net and catch potential risks.
Right, but it still relies on observing outward signs like voice changes or delayed coughing, so it will inevitably miss some silent aspirators.
Yeah, the purpose of the 3-ounce test is just to figure out who needs a deeper instrumental look. It is never used to universally clear a high-risk patient for a regular diet.
So to truly catch silent aspiration, clinicians realized they needed a way to literally see inside the throat in real time.
Which sparked a massive revolution in dysphagia care.
Yeah, it's wild to think that before the 1980s, swallowing problems in stroke or cancer patients were usually only diagnosed after the patient developed aspiration pneumonia.
It was treated as a downstream complication. You just waited for the lung infection to appear, and then you treated the lung infection.
But then a speech-language pathologist named Jerry A. Logman changed that reactive approach.
She was a true pioneer.
In 1983, she essentially founded dysphagia as a clinical subspecialty by popularizing the modified barium swallow study, or the VFSS.
Right. So in a VFSS, the patient is taken to a radiology suite, and they are fed different consistencies of food and liquid that have been coated in barium.
And barium is a contrast agent that glows dense black on an X-ray.
Exactly. So the clinician watches an X-ray video of the swallow happening live.
So you aren't guessing if the trapdoor closed. You can actually watch the black liquid slip past the epiglottis and drop straight into the trachea.
You see the whole thing.
And then a few years later, in 1988, Susan Langmore developed a rival diagnostic technique called FE.
FEES, which stands for fiber optic endoscopic evaluation of swallowing.
Right, and instead of using X-rays, she passed a tiny flexible camera through the patient's nose and positioned it to look directly down into the throat.
What's fascinating here is that decades later, there's still no single gold standard between these two tests.
Really? They're just used for different things.
Yeah, they are distinct tools that answer different clinical questions. The VFSS gives you the entire trajectory of the swallow. You can see the mouth, the throat, and the esophagus.
But it exposes the patient to radiation, right?
Right, and you have to physically transport a sick patient down to the radiology department, and it only captures a brief snapshot of a few swallows.
Whereas Langmore's FEAS avoids radiation entirely.
Exactly. A clinician can roll the camera cart right up to the patient's bedside, making it ideal for critically ill individuals in the ICU.
But FMEAS does have a mechanical catch. The sources describe a phenomenon called the whiteout.
Whiteout, yeah.
At the exact millisecond of the swallow, the muscles of the pharynx forcefully contract and squeeze inward.
And when they do that, the tissue wraps entirely around the camera lens. So the video screen goes completely white for a fraction of a second.
Ah, so you missed the actual event.
Right. The clinician can see everything pooling in the throat right before the swallow, and they can see any food left behind right after the swallow. But the exact instant of aspiration sometimes has to be logically inferred based on what is left in the airway once the muscles relax.
Okay, but FEE does offer one massive advantage over the X-ray study, and it ties into a persistent clinical debate regarding saliva.
Yes, there has long been an argument about whether difficulty managing your own naturally produced secretions, your saliva counts as true dysphagia.
Right, like if you aren't eating or drinking anything, can you still have a swallowing disorder?
The clinical consensus now is yes. Patients who cannot clear their own saliva face an incredibly high risk for aspiration pneumonia.
Because the human mouth is just full of bacteria.
Exactly. If you are constantly microaspirating bacteria-laden saliva into your lungs simply because gravity pulls it down and your trapdoors are weak, you will get sick.
And this happens completely independent of mealtimes.
Completely independent. And FETEAS is uniquely positioned to catch this. The camera allows the clinician to see secretions actively bubbling and pooling in the airway before the patient has even taken a bite of the test food.
Wow. Okay, so once a clinician uses these tools and formally diagnoses dysphagia, the immediate question is how to manage it. And for a very long time, the knee-jerk reaction across hospitals was to just thicken the patient's liquids.
Right, and the mechanical logic behind thickening liquids makes intuitive sense. If a patient's airway is closing too slowly, you want to slow down the speed of the liquid dropping toward that airway.
So you make it thicker.
Right. Liquids thickened to the consistency of nectar, honey, or pudding move much slower than regular water.
Which theoretically buys the compromised trapdoors more time to close and protect the lungs.
That concept became so entrenched that the clinical community codified it into the National Dysphagia Diet back in 2002.
But the sources highlight a harsh clinical reality here. Thickened liquids taste terrible.
They are notoriously unpalatable. The texture is awful, and patients simply refuse to drink them.
And when patients refuse to drink, they become severely dehydrated. I mean, if we mandate a diet that directly causes systemic dehydration or leads to severe urinary tract infections because the kidneys just don't have enough water, aren't we just swapping one life-threatening complication for another entirely different set of complications?
That is exactly what started happening. The evidence base proving that thickened liquids consistently reduce pneumonia rates turned out to be much weaker than daily hospital practice implied.
Wow.
So this tension led to a significant shift in intervention strategies, most notably the Fraser Free Water Protocol, which originated in the 1980s.
Okay, the Fraser Protocol. This allows patients to drink unthickened regular water even if they are otherwise prescribed a thickened liquid diet.
Right.
But giving thin water to a known aspirator sounds completely contradictory to everything we just covered about slowing down the liquid.
It sounds wild, but the physiological theory behind the Fraser Protocol is actually brilliant.
Yeah.
Pure, clean water is relatively benign if it enters the lungs in small amounts.
Wait, really?
Yes. The lungs can absorb pure H2O into the bloodstream without much issue. Pneumonia isn't caused by the water itself, it's caused by the bacteria carried along with the aspirated material.
Oh, that makes sense.
Right. So if a patient is given rigorous oral care to remove bacteria from their teeth and tongue, and then they're permitted supervised sips of plain water, the aspiration risk is vastly less dangerous than aspirating a food particle or contaminated saliva.
That is fascinating. But moving away from the thickened liquid dogma also exposed how chaotic hospital diets used to be. Like, a liquid labeled nectar thick in a bustling city hospital might have a completely different viscosity than a nectar thick liquid at a suburban nursing home.
And inconsistency in medical terminology is a massive safety hazard. If a patient is transferred between facilities and given the wrong liquid consistency because of a translation error, the resulting aspiration could be fatal.
And that systemic danger is why Julie Cicero helped establish IDDSI in 2013.
Yes, the International Dysphagia Diet Standardization Initiative.
Right. They basically threw out all the old subjective labels and created a unified global 8-level framework.
Ranging from level 0, which is thin water, all the way up to level 7, which is regular unmodified food.
And every level has specific syringe flow tests to objectively measure thickness. It prevents those deadly mix-ups across care transitions.
Standardizing the diet is a vital step, definitely, but we also need to examine who these safety protocols are actually protecting, because there is a pervasive public misconception that swallowing disorders solely afflict the elderly.
Yeah, that is a huge myth. The demographics in the literature are surprisingly broad. Dysphagia affects premature babies in the neonatal intensive care unit whose neurological systems haven't fully developed.
It affects young adults who have suffered traumatic brain injuries and car accidents.
It's a major factor for people of any age living with Parkinson's disease, ALS, or multiple sclerosis.
And we have to mention the COVID-19 pandemic completely dismantled the elderly-only assumption.
Oh, how so?
Intensive care units saw a massive influx of previously healthy patients requiring prolonged intubation and proning, which is lying patients flat on their stomachs to improve oxygenation.
Right.
Historically, many clinicians assumed that once a breathing tube was removed, a patient's swallowing function would naturally bounce back within a few hours.
Yeah, why doesn't it just bounce back? Like, if the tube is out, shouldn't the throat work again?
Think about it mechanically. An endotracheal tube is a piece of plastic wedged directly between the vocal folds. If it stays there for weeks, it physically props the airway open.
Oh, wow.
The delicate muscles of the pharynx undergo severe atrophy from disuse, much like a leg muscle shrinking while inside a cast.
That makes perfect sense.
Plus, the trauma of the tube rubbing against the tissue causes inflammation, and proning causes massive fluid swelling in the face and neck. We now know that post-extubation dysphagia is incredibly common and persistent. Absolutely. Clinicians can no longer pull a breathing tube and immediately hand a recovering patient a glass of ice water. A rigorous swallow screen is mandatory now.
Okay, so as we look at who is at risk, the sources are also very careful to differentiate true dysphagia from a few related conditions that often get lumped together.
That's right. Dysphagia is a mechanical failure of the swallowing process. It is not odonophagia.
Which simply means painful swallowing.
Right. Odonophagia is strictly about the sensation of pain, often caused by severe acid reflux burning the esophageal lining, or maybe inflammation from radiation therapy.
But a patient can have painful swallowing while their mechanical trapdoors work perfectly, or they can occur together.
Exactly. They aren't the same thing.
The sources also detail the globus sensation.
Yes. The globus sensation is the persistent feeling of a lump in the throat. It closely mimics the feeling of food being stuck.
But if you put these patients under a VFSS X-ray, there is no physical obstruction and no mechanical failure, right?
The bolus clears perfectly. Globus is very frequently linked to severe anxiety or stress, which causes the cricopharyngeal muscle at the top of the esophagus to involuntarily spasm or hold tension.
So it creates a very real physical sensation of a lump despite the tube being totally clear.
Yes, exactly. And finally, there is presbyphagia.
Presbyphagia? Wait, what is that one?
This one is crucial for understanding the aging population. It is the normal, expected, age-related decline in swallowing function.
Oh, so just because you're getting older.
Right. As human beings age, we lose muscle mass. Our reflexes slow down. The tissues in the throat lose elasticity.
So it's not a disorder then?
No. Presbyphagia is not a clinical disorder. It is just aging. However, it significantly lowers a person's physiological margin of safety.
Meaning an older adult might swallow adequately on a normal day, but they are much more vulnerable to developing true life-threatening dysphagia if they suffer even a minor secondary insult.
Like a small stroke, a bad urinary tract infection, or even generalized weakness from a cold.
That diminished margin of safety really highlights how we need to view swallow studies in general.
Yes. If we connect this to the bigger picture, a diagnostic test, whether it's the X-ray or the camera, is just a snapshot of a single moment in time.
Right. Swallowing function fluctuates wildly. It changes based on a patient's daily fatigue level, the natural progression of a neurological disease, their physical recovery from a stroke,
Or even the side effects of medications they took that morning.
So if a patient is given a strict diet restriction on a Tuesday, it is not necessarily a permanent life sentence.
Not at all. Their ability to swallow has to be continually reevaluated as their overall health shifts.
So what does this all mean? We have explored the intricate mechanical trapdoors of the throat, the silent threat of aspiration, and the fierce clinical debates over thickened liquids.
It's a lot to process.
It is. Why does the intricate science of dysphagia matter to you? It matters because it sits at the intersection of incredibly high everyday stakes. A simple bedside swallow screening by a nurse is one of the highest yield, lowest cost interventions in all of acute care.
It actively prevents aspiration pneumonia, which remains a leading cause of death and hospital readmission worldwide. It is the definition of frontline preventative medicine.
But beyond the mechanics and the pneumonia statistics, dysphagia carries a profound human weight.
It really does. The act of eating is deeply tied to human culture, psychological comfort, and daily autonomy. When a clinician has to write an order for NPO status nil per os, meaning absolutely nothing by mouth, it is a devastating loss for the patient.
And clinicians often have to guide families through the decision of placing a PEG tube.
Right. That is a percutaneous endoscopic gastrostomy, where a surgical feeding tube is placed directly through the abdominal wall into the stomach, bypassing the throat entirely.
Alternatively, families might choose comfort feeding for end-stage dementia patients, where the medical team accepts the high risk of aspiration pneumonia in order to preserve the patient's remaining quality of life.
And those decisions represent some of the most emotionally weighty conversations in modern healthcare.
It is absolutely not just a plumbing problem. It is a fundamental quality of life issue that alters how people interact with the world. I want to leave you with a final thought to ponder. Something derived directly from the source material's notes on saliva management and strict dietary orders.
It's a profound point.
Think about this. If a patient is placed on strict NPO status, meaning they're permitted absolutely zero food or drink by mouth in an effort to prevent aspiration, they are still generating and swallowing their own saliva every single minute of the day.
Right.
If the inability to safely manage your own bacterial secretions is its own standalone risk category, does the simple biological act of existing and producing saliva mean that NPO orders are an incomplete shield? Can we ever truly eliminate the risk of aspiration just by withholding a meal?
That dynamic forces clinicians to constantly weigh the limits of medical intervention against the reality of human physiology.
Thank you for joining us as we unpack this high-stakes mechanical sequence.
Thank you for listening to this deep dive.
Welcome to this custom deep dive. Today, we are opening up just a fascinating stack of medical and nursing sources that are entirely focused on blood pressure.
Yeah, it's a topic everyone thinks they know, right?
Exactly. I mean, the mission for this deep dive is to really get past that simple, 120/80 headline. We want to uncover the hidden story of perfusion and, well, look at the surprisingly brutal history of how we even figured out blood pressure exists in the first place.
Oh, yeah. The history it's pretty wild.
It is. And we're also going to get into why the most common measurement mistakes, which are happening like every single day, can completely change a medical diagnosis practically overnight.
Which is terrifying when you really think about it.
Right. Because, when you go to the doctor, that there's just a few things you always expect to happen. You sit on that crinkly paper, someone wraps a Velcro cuff around your arm, it inflates until it's just, slightly uncomfortable.
Yep, the classic arm squeeze.
Right. And then a machine, or sometimes a person with a stethoscope, just spits out two numbers. I mean, we get our blood pressure checked at almost every single medical encounter.
We do. It is really the ultimate medical baseline. I mean, it's so ubiquitous in healthcare that we tend to treat those two numbers like they're handed down on stone tablets or something.
Yeah, like an absolute truth.
Exactly. Like you are either 120/80 and you are fine, or you have a problem. But the sources highlight that blood pressure is not... it's just not a single true number. It's this incredibly dynamic, constantly shifting equation.
Right.
So before we can even begin to talk about what a bad blood pressure is, we really have to understand the physical mechanics of what the body is, like actively attempting to achieve every single second of your life.
So let's break that down to first principles, because the sources are actually very specific about what those two famous numbers physically represent.
Yeah, so fundamentally, blood pressure is simply the physical force that your circulating blood exerts against the inner walls of your arteries.
Okay, so just literal pressure in a pipe.
Right. It is generated by the heart pumping, and it is modulated by the resistance of your blood vessels. So the top number, your systolic pressure, is the absolute peak pressure in the arteries during ventricular contraction.
Which means?
That is the exact moment when the left ventricle of the heart forcefully ejects blood out into the aorta.
So it's the big squeeze, the absolute maximum force in the system.
Exactly, the big squeeze. And then the bottom number, the diastolic pressure, is the residual pressure that's left in the arteries when the heart relaxes and the chambers are refilling with blood.
Okay, that makes sense.
But to really grasp how this whole system works, we have to look at the foundational equation that governs it. And it's actually very similar to Ohm's law in physics.
Oh, yeah.
Yeah, so blood pressure equals cardiac output multiplied by systemic vascular resistance.
Okay, wait, let me repeat that. Blood pressure equals cardiac output times vascular resistance.
You got it.
So if we visualize this like a city's water supply system, right? The heart is the main water pump. So that's your cardiac output, which is essentially how much water is being pushed out per minute.
Right.
And then the blood vessels are the city's network of pipes. So that's the vascular resistance, meaning like how wide or narrow those pipes actually are.
That is a perfect analogy. So if we follow that water supply idea, anything that changes either the pump's output or the pipe's physical resistance is going to instantly change the pressure in the entire system.
But wait, if the main pump starts failing, or say there's a massive leak somewhere in the city, the water pressure in your house would just drop to zero almost immediately.
Right, in a rigid pipe system, yes.
But the human body obviously doesn't just crash to zero the second something goes wrong. I mean, how does the body compensate for a leak?
Well, it aggressively defends that pressure using these built-in fail-safes. And the sources give a very intense clinical example to illustrate that.
Okay, what is it?
Imagine a trauma patient who is actively hemorrhaging and loses, say, 1.5 liters of blood.
Oh, wow. That's a lot.
It's a massive amount. So because there is significantly less blood volume available to pump, the cardiac output, the pump side of that equation we talked about, drops drastically.
And mechanically, the pressure should just plummet right along with it.
It should. But within literal seconds of that volume dropping, you have these tiny pressure sensors in your body called baroreceptors, and they detect the change.
Baroreceptors? Where are those?
They're located primarily in the carotid artery in your neck and in the aortic arch.
The aortic arch, just so I have the anatomy mapped out properly in my head, that is the main, like, curved pipe leaving the very top of the heart, right?
Correct, yeah. So the baroreceptors there sound the alarm to the brain, which immediately triggers the sympathetic nervous system.
The fight or flight system.
Exactly. And the body's response is to massively constrict the peripheral arterioles. So those are the smaller branches of arteries out in your limbs. The body essentially just clamps down on the pipes in your arms and legs, drastically increasing the systemic vascular resistance to make up for all that lost volume.
Oh, I see. The body physically shrinks the container to fit the remaining blood.
It does. It's an incredible survival mechanism.
Yeah.
And this leads to a really crucial takeaway, especially in nursing and emergency medicine.
Which is?
A hemorrhaging patient can actually maintain a completely normal blood pressure reading right up until the exact moment they suddenly collapse.
Wait, really?
Yeah. The compensatory mechanism is so strong that it masks the internal bleeding until the body's reserve is completely exhausted.
So a clinician looking at a monitor could see a totally reassuring 120/80 while the patient is, like, actively in severe life-threatening danger.
Exactly. And this is why trained clinicians do not rely on blood pressure alone. Pressure is really just a means to an end.
Right.
The actual end goal is perfusion, meaning the actual delivery of oxygenated blood to the tissues. Nurses are trained to look for signs of poor perfusion rather than just blindly reading a monitor.
So what are they looking for instead?
They look for a rising heart rate as the pump tries to desperately work faster, or they check for delayed capillary refill.
Capillary refill, that's when a doctor or nurse presses down on your fingernail.
Right,
Yep.
exactly. Pressing on the nail bed turns it white by forcing the blood out of those tiny capillaries. When you let go, it should pink up again in under 2 seconds.
And if it doesn't?
If it takes longer, or if the patient has cool, really clammy skin,
Yeah.
it means the body is clamping off blood supply to the skin and the extremities to save the oxygen for vital organs like the brain and the heart.
Wow.
Yeah, the perfusion is failing, regardless of what the blood pressure cuff says.
That is, I mean, that's fascinating. But if the body's own defense mechanisms can hide what's really going on, accurately measuring that pressure becomes an incredibly high-stakes process.
Highly, highly high stakes, yeah.
And getting that measurement, historically, it was not as simple as just wrapping a Velcro cuff around an arm.
Oh, no, not at all. It
Yeah.
was significantly more invasive.
How invasive are we talking?
Well, the entire concept of actually quantifying this pressure, Dates back to 1733
Yeah.
with this English clergyman and scientist named Stephen Hales.
Okay.
He wanted to know if blood pressure could actually be measured physically. So he took a live horse, inserted a brass pipe directly into its crural artery, connected that pipe to a glass tube, and literally watched the horse's blood rise more than 8 feet up the column.
Wait, he just stuck a brass pipe into a horse and watched the blood shoot up a 9-foot glass column.
He did.
That is a rather brutal way to run an experiment. I mean, my
It
goodness.
was definitely brutal. But it proved that the pressure was a measurable physical force that was capable of pushing fluid against gravity.
Sure, but obviously we don't do that to humans.
No, thankfully.
Yeah.
It took over a century to find ways to do this without, inserting tubes directly into people's arteries.
Right.
In 1881, an Austrian physician named von Basch invented a method using a water-filled bag pressed against the wrist. Then in 1896, an Italian physician, Scipione Rivarocci, introduced the inflatable arm cuff connected to a mercury column.
Okay, so that sounds closer to what we use today.
It is, but Rivarocci's cuff could only detect that top number, the systolic pressure,
Oh, really? Wow.
because the doctor had to physically feel when the pulse in the wrist disappeared as the cuff inflated. It was completely tactile.
But we need both the top and bottom numbers to understand the whole cardiac cycle. So where did the diastolic measurement come from?
The missing piece finally arrived in 1905 from a Russian surgeon named Nikolai Korotkov.
Okay.
He realized that if you placed a stethoscope over the brachial artery just below the inflatable cuff, you could hear a very specific sequence of sounds as the pressure was slowly released.
Ah, okay.
Right. So as the cuff deflates, the precise moment the blood finally pushes through the pinched artery, you hear the sharp tapping. That's your systolic pressure.
The big squeeze breaking through the cuff's pressure.
Exactly. Then the sounds turn into kind of a swishing noise, and the exact moment those sounds completely disappear, that's your diastolic pressure.
Yeah.
And we actually still call them Korotkov sounds today.
Wait a second. We have smartwatches that can record a live ECG. We have MRI machines that can map out the neural pathways of the brain in real time. But in modern medicine, our gold standard for this absolutely vital cardiovascular metric is still a technique from 1905 where a person listens for thumps through a stethoscope.
Pretty much, yeah.
I mean, with all our advanced technology, are there not constant failures in something as basic and analog as a Velcro arm cuff?
Oh, there are constant failures. I mean, the sources detail this issue of cuff error, and it is a massive, massive problem in daily medical practice.
Really? Like how bad?
Well, improper cuff size alone, just the size of the cuff, can shift a blood pressure reading by 10 to 30 millimeters of mercury.
30 points. How does the wrong size cuff physically alter the reading by 30 points? What is the actual mechanism there?
Okay, so think about it. If a standard-sized adult cuff is used on an obese patient, which, by the way, is incredibly common in busy clinics, the cuff is simply too small to wrap properly. When the machine inflates it, the air pressure in the cuff is basically wasted trying to compress a thick layer of fat tissue before that pressure even reaches the artery deep inside.
Oh, I see.
So the gauge on the machine is registering the high amount of pressure needed to squish the fat rather than the actual pressure inside the artery itself. It systematically overestimates the patient's blood pressure.
So a perfectly healthy person could be diagnosed with hypertension and put on heavy medication entirely because the clinic just used a cuff that was too small.
Yes, it happens all the time.
That's insane. And what if a cuff is too large, like for a very thin arm?
Then it does the exact opposite.
Yeah.
It underestimates the pressure because it easily pinches the artery with very little air pressure, so it can artificially lower the reading, potentially masking a dangerous condition.
Wow.
And cuff size is really just one variable. If a nurse measures over thick clothing, that skews the numbers. If the patient is talking during the measurement, that alone can raise the reading by 10 points.
Just talking.
Just talking.
I actually tend to sit with my legs crossed on the exam table when I'm waiting. The sources say that throws off the reading too, right?
It does, yeah.
But why would crossing my legs change the blood pressure in my arm? That doesn't seem connected.
It's all connected. When you cross your legs, you are physically compressing the large veins in your lower body. That physically forces more blood back up into the central circulation.
Oh, increasing the volume.
Right. It increases the volume of blood the heart has to suddenly pump, which temporarily raises your systolic pressure by several points.
That is wild.
Yeah. And even if your arm is not supported, like if it's just hanging below heart level, gravity causes blood to pool in the arm, which changes the local pressure. Or, if the clinician deflates the cuff too quickly, they will easily just miss the exact moment Those Korotkov sounds start and stop.
So it's very operator dependent.
Extremely. Correct measurement technique is a critical patient safety issue in nursing education because, physical measurement error can lead to a completely incorrect medical diagnosis.
So if a chatty patient or a small cuff can change the numbers by 30 points, it kind of makes you wonder about the numbers themselves. I mean, the sources show that the medical establishment's definition of a normal blood pressure is entirely a moving target.
Oh, absolutely. It has shifted drastically over the years. For most of the 20th century, the prevailing medical consensus was actually that high blood pressure was just a natural, benign response to aging.
Benign, really?
Yeah, textbooks literally taught a rule.
Mm.
Your acceptable systolic pressure was 100 plus your age.
Okay, so a 70-year-old running a systolic of 170 was considered perfectly healthy.
Exactly. The belief at the time was that the human body actively needed that extra pressure to successfully push blood through aging, stiffened arteries.
Which I guess explains the incredible historical data the sources have on President Franklin D. Roosevelt.
Oh yeah, his numbers were shocking by today's standards.
The sources mention his blood pressure was routinely recorded at these astonishing levels, as high as 300 over 190, and his physicians mostly just treated him with, rest and mild sedatives.
Right. They simply did not view hypertension as a primary threat. It wasn't until the Framingham Heart Study, launched in 1948, that researchers tracked thousands of people over decades and finally proved that chronic high blood pressure was a direct causal link to heart disease, stroke, and heart failure.
So it completely overturned that 100-plus-year age rule.
Completely. It proved hypertension wasn't a symptom of aging, it was a disease itself.
But those guidelines are still shifting today, right? Look at the 2017 guideline change. The American College of Cardiology and the American Heart Association lowered the threshold for diagnosing hypertension from 140 over 90 down to 130 over 80.
That was a huge shift.
Right. So if you, or maybe your parents, went to the doctor in 2016 versus 2018, you could have walked out of the clinic with a brand new medical condition, hypertension, without a single physiological change happening in your body.
Right, just because the textbook changed.
Exactly. So are we risking overtreating people by constantly lowering the bar for what we consider a disease?
That is arguably the single most consequential debate in cardiovascular medicine right now.
Really?
Oh yeah. The core question everyone is asking is, how low should we go? Because blood pressure categories are not these biological cliffs where damage suddenly begins at a specific magic number.
Right, it's not a light switch.
Exactly. They are statistical boxes drawn on a continuous curve of risk. The truth is, the risk of arterial damage actually starts rising well below 120 over 80.
Wow, okay.
The label of hypertension is really just the statistical point where experts judge that the long-term benefits of starting medication outweigh the costs and side effects.
So what actually drove the controversy over dropping that threshold down to 130 over 80?
Well, it primarily comes down to two major conflicting clinical trials. In 2015, you had the SPRINT trial, and it pushed for really intensive blood pressure targets, aiming to get older adults under 120 systolic.
And did it work?
It was highly successful at reducing cardiovascular death. In fact, they stopped the trial early because the data was so overwhelmingly strong, it felt unethical to withhold the intensive treatment from the control group.
Oh, wow. So that seems definitive.
You'd think so. But in 2010, there was the ACCORD trial, which tested intensive control specifically on diabetics, and they found no major reduction in cardiovascular events, but they did see a big increase in side effects from the heavy medication load.
But wait, the sources mentioned the SPRINT trial had a very specific measurement protocol, right? Something that didn't mirror real-world clinics at all.
You hit the nail on the head. SPRINT used a rigorous, automated measurement protocol.
What does that mean in practice?
It meant the patient rested completely alone in a perfectly quiet room for 5 minutes. No talking, no stress. And then an automated machine took the reading without a doctor or nurse even present in the room.
Okay, well, that perfectly quiet, isolated environment is naturally going to produce a reading that is, 5 to 10 points lower than what you would get in a busy, stressful clinical environment.
Exactly. So here is the danger. If a regular, chaotic clinic tries to aggressively hit that SPRINT target of 120, but they are using flawed manual measurement techniques on an anxious patient,
then they are likely pushing the patient's actual resting blood pressure much, much lower than 120.
Right. And if you push frail, elderly patients too low with medication, you risk severe side effects like dizziness, fainting, falls, and even acute kidney injury from underperfusion.
Because the pressure isn't high enough to reach the organs.
Exactly.
So if we are aggressively pushing these numbers down to hit new targets, it seems like we're creating a massive blind spot. We are so culturally conditioned to fear the ceiling high blood pressure that we kind of forget the floor is just as dangerous, lower is not always better.
It definitely isn't.
Okay.
Symptomatic hypotension, which is low blood pressure, is incredibly dangerous. And a very common form of this is orthostatic hypotension.
Orthostatic hypotension, what is the actual physical mechanism behind that?
So when you stand up from a seated or lying position, gravity immediately pulls a large volume of your blood down into your legs.
Right, just basic physics.
Normally, those baroreceptors we talked about earlier, they detect that sudden drop and instantly clamp down on your blood vessels to maintain pressure to the brain. Okay.
But in orthostatic hypotension, the nervous system is too slow or impaired to compensate in time. So the brain loses oxygen for a brief moment, causing severe dizziness or fainting. It is actually a leading cause of falls in older adults.
And at the absolute extreme end of that,
At the extreme, sustained low blood pressure leads to shock, which is a catastrophic failure to perfuse vital organs.
so to monitor this in critical situations, like say in the ICU, the sources say clinicians rely on mean arterial pressure, or MAP. But the formula for MAP seems a bit complex.
It can look a little intimidating on paper.
Yeah, it says it is the diastolic pressure plus 1/3 of the pulse pressure. And pulse pressure is just the numerical difference between the systolic and diastolic numbers, right?
Correct. So while the math seems complex, MAP simply represents the average perfusion pressure driving blood into the organs across the entire cardiac cycle. The golden rule in the ICU is that a patient's MAP must stay above 60 to 65 millimeters of mercury.
Okay, I think I get it. I think of MAP kind of like the average speed of a long road trip.
Oh, I like that. Right, because your systolic pressure is like the top speed you hit on the highway. Your diastolic pressure is when you are stopped at a red light.
Yeah.
So those are interesting data points, but your average speed over the whole trip, your MAP, is what ultimately determines if you actually reach your destination.
That's a great way to look at it.
Yeah.
And in this physiological scenario, the destination is keeping the organs alive. If a patient's MAP drops below 60, the physical reality is that the kidneys literally begin shutting down from oxygen starvation.
Wow.
The tissue actually begins to die completely, regardless of what the top or bottom numbers individually read.
It's all about that average. Hypertension is often called the silent killer, and it remains the largest modifiable contributor to global death and disability precisely because you feel completely normal while your average speed is just slowly tearing up the plumbing of your heart and brain.
Yeah, you simply don't feel the damage occurring. It's insidious. Furthermore, blood pressure naturally fluctuates throughout the day. A patient could have white coat hypertension, where their pressure is only high in the clinic simply because they're anxious about seeing the doctor.
I think a lot of people have that.
Oh, very common. Or they might have the opposite, masked hypertension, where their reading is perfectly normal in the clinic, but it's dangerously high when they're at home just going about their daily life.
Mask hypertension sounds particularly terrifying because it completely escapes detection during a routine checkup.
Which is exactly why modern guidelines heavily emphasize averaging multiple home readings over several days, rather than relying on a single clinical snapshot.
That makes a lot of sense.
Medical science is also shifting its focus in other ways. While we used to focus almost entirely on the diastolic number, we now recognize that the pulse pressure, that gap between the top and bottom numbers, is a key independent marker of arterial stiffness as we age.
So a widening pulse pressure means the pipes are physically losing their elasticity.
Exactly. They're getting stiff.
So what does this mean for you, the listener, the next time you are sitting on that crinkly exam paper? The journey we've taken through these sources reveals that blood pressure really isn't a single, unquestionable truth that a machine just prints out on a receipt.
Not at all.
It is a highly dynamic, ever-changing equation balancing your heart's output against your vessel's resistance. It is entirely reliant on very precise physical measurement techniques that, as we've learned, are heavily prone to error. And it is constantly being judged against a shifting statistical gradient of risk rather than some biological absolute.
Right. And understanding that critical difference between the literal pressure in the pipes and the actual delivery of oxygen to your tissues, that perfusion is really the fundamental key to making sense of cardiovascular health.
Absolutely. Well, to leave you with one final fascinating thought from our sources to ponder, We've talked extensively about the wild errors caused by the wrong cuff size, or talking, or even crossing your legs.
Yeah.
But blood pressure is so inherently variable that it can actually differ depending on which arm the nurse decides to use. It's true.
If one arm has minor plaque buildup in, say, the subclavian artery, the reading on that specific side will be lower. In fact, a difference of more than 10 to 15 millimeters of mercury between your left arm and your right arm isn't just a machine error. It can be a clinically significant warning sign of cardiovascular disease all on its own.
Yeah, it's a huge red flag.
So the next time they wrap that Velcro around your arm and squeeze well, you might just wonder what the other arm has to say. I want you to imagine, just for a second, walking into a really busy emergency room.
Oh, yeah. Always a stressful place to be.
Totally.
Yeah.
And let's say you've got a visibly broken arm, like the bone is fractured.
Yeah.
It's completely obvious. You're just holding it against your chest.
Right. There is no hiding that.
Exactly.
Yeah.
So they take an x-ray, and, a few minutes later, there's that jagged white line glowing right there on the screen.
Yep, the proof.
Yeah, the doctor points to it, you look at it, and there's this immediate, unspoken mutual agreement. The problem is real. It's right there in black and white, and now the medical team is just going to fix it.
It's an incredibly comforting dynamic when you really think about it.
Right.
Because, you don't have to convince anyone that your arm is broken. You don't have to, plead your case. The machine just did all the convincing for you.
Right. But now, I want you to imagine walking into that exact same emergency room, maybe even on the exact same day, but this time, you have a mysterious, agonizing internal ache.
Ooh, okay. That's a very different scenario.
Completely different. Maybe it's radiating down your lower back, or it's a sharp, stabbing sensation deep in your abdomen, but there is no jagged line on a screen.
No obvious fracture.
Nothing. There's no scan that highlights the area in glowing red.
Yeah.
You're just sitting on that crinkly paper on the exam table, and you realize something terrifying.
Which is, how do you prove it?
Yes. How do you prove what you are feeling to the doctor? How do you actually convince them of your reality?
In that scenario right there, the burden of proof resting entirely on the patient is one of the most profound, historically complicated challenges in modern healthcare.
Which is exactly our mission for this deep dive.
Yeah.
Today, we are looking at a massive and fascinating stack of clinical sources, all centered around pain assessment in nursing.
It's a huge topic.
It really is. We're going to explore why pain is universally referred to in medicine as the fifth vital sign, and why, paradoxically, it is the absolute only vital sign that completely and totally defies objective measurement.
Yeah, and it represents a fundamental shift in how we even think about clinical data. Think about the other 4 vital signs for a second.
Okay.
If a nurse needs to check your blood pressure, they just wrap a cuff around your arm and read the dial.
Super easy.
Right. And for your heart rate, or, your respiratory rate, they can literally just count the beats or the breaths.
Just looking at the clock.
Exactly. For your body temperature, there is a thermometer. But for pain, there is no external instrument.
None at all.
There is no cuff, no thermometer, no magical probe that you can just stick on a patient's forehead to get a neat, objective number.
Okay, let's unpack this, because on paper, if you've ever been to a clinic, a pain assessment sounds like the most straightforward task in the world.
Right, you just say a number.
Yeah. The nurse asks you a question, you give them a number, they write it down on a chart, and you move on to treatment. But what you're saying, and what these clinical sources are absolutely screaming at us, is that this seemingly simple act is actually a massive subjective challenge.
Precisely. It is incredibly messy. So let's start with the baseline clinical definition that's provided in the texts.
All right, lay it on us.
Pain assessment is defined as a systematic process by which a clinician identifies, characterizes, and quantifies a patient's pain.
Sounds very professional.
It does. And the goal there is basically twofold. First, to guide the immediate medical treatment, and second, to track whether that treatment is actually working over time.
Okay, but it sounds so clinical and tidy. Without a thermometer to do the actual quantifying, how does the system not just immediately break down?
Well, it doesn't break down, but the data has to pass through this incredibly complex filter.
What do you mean by filter?
Because there is no objective tool, pain assessment depends 100% on what the patient reports.
The human element.
Exactly. And that verbal report is filtered through so many messy human variables. It's filtered through language and vocabulary.
Well, true. You don't have the words to describe it.
Right, and it's filtered through culture, like how different cultures are taught to either express or, stoically suppress discomfort.
Oh, wow. Yeah, like some people are taught to never complain.
Exactly, it's filtered through memory, through fear, and frankly, through the patient's level of trust in the person wearing the scrubs who's asking the question.
I was actually trying to think of how to describe this, and it's basically like trying to explain the exact taste of salt to someone using only words.
Oh, that is a great analogy.
Right. You know exactly what salt tastes like.
Mhm.
It is a vivid, undeniable reality to you. But conveying that specific sensory experience to someone else is almost impossible.
It really is.
Except in this clinical scenario, your medical treatment, like your literal relief from suffering, depends on how well you can describe the saltiness.
That's a lot of pressure on a patient.
But I have to push back a little here. Isn't modern medicine supposed to be driven by hard, objective, empirical science?
In theory, yes.
So how does a purely subjective symptom, something that relies entirely on a patient's vocabulary, or like their mood on a Tuesday, even fit into a rigorous scientific framework?
That is the million-dollar question. And to try and make sense of it, the sources frame the subjective challenge within a really robust landscape of clinical theory.
Okay.
To keep medicine scientific, the texts draw a very strict, definitive line between two concepts, nociception and pain.
Nociception, break that down for us, because that sounds like the hard science part.
It is. Nociception is the objective biological wiring.
Okay.
So when you accidentally touch a hot stove, nociceptors, which are these specialized sensory receptors scattered all throughout your body, they detect that extreme heat.
It's like little alarms.
Exactly. They immediately fire off an electrical signal that travels up your spinal cord to your brain, essentially shouting, "Warning, tissue damage is happening."
Gotcha.
That is nociception. It is purely biological, it's measurable, and it's objective. But pain is the conscious, emotional, and psychological experience of that signal once it reaches the brain.
Okay, so if I'm understanding this right, nociception is the computer hardware sending an error code, but pain is how the software actually experiences the crash.
That is a perfect analogy. The hardware sends the signal, but the software decides how much it hurts.
That makes so much sense.
And this concept leads directly into something called the gate control theory, which is really cool. It was proposed in 1965 by researchers Melzack and Wall. It's a foundational concept in the sources.
The outline mentions this, but how does this gate actually work in practice?
Well, think about what you instinctively do when you accidentally smash your shin against a coffee table or, you stub your toe. What is your very first reaction?
Oh, I immediately grab it and start rubbing it as hard as I can.
Exactly. Why do you do that?
I don't, it just feels like it helps.
Right, and gate control theory explains why. It proposes that the spinal cord contains this neurological gate that either blocks pain signals or allows them to continue on to the brain.
Wait, really? A literal gate?
A neurological one, yeah. So when you rub your stubbed toe, you are stimulating normal touch receptors. Those touch signals travel on fast, thick nerve fibers, and they literally reach the spinal gate first.
Beating the pain signals there.
Exactly. They effectively close the gate on the slower, thinner nerve fibers carrying the pain signals. You are physically blocking the pain by flooding the system with non-pain sensations.
That is incredible. So the pain isn't just a simple one-way street from the toe to the brain. It's like an active intersection where the body can actually modulate the traffic.
That's exactly it. And the gate can also be opened or closed by emotional factors.
Wait, emotions affect the physical gate?
Absolutely. If you are highly anxious, the gate opens wider, which amplifies the pain. If you are relaxed or distracted, the gate can actually close.
Wow.
This proves that pain is not just a biological event, it is inherently psychological as well. And because of this complexity, the sources categorize pain into distinct types.
Like acute and chronic.
Yes. There is acute pain, which is sudden and protective, like the twisted ankle that tells you to stop running.
Right, a useful warning system.
Then there is chronic pain, which persists for months or years long after the initial tissue healing is complete.
This is the warning system is broken.
Exactly. Chronic pain effectively loses its protective function. The alarm system is just stuck on. And finally, neuropathic pain, where the nerve fibers themselves are damaged and misfiring.
So that's the one that creates those burning or electric shock sensations.
Yes, even without an external injury.
So the medical field has created this incredibly dense, highly structured vocabulary. Nociception, gate control, acute, chronic, neuropathic, all
to try and put a rigid scientific fence around something they can't actually see.
That's a great way to put it.
Which brings us to a historical pivot point that completely blew my mind while reading through these sources. We have to talk about Margot McCaffrey.
We absolutely do. If you want to understand modern pain assessment, you have to travel back to 1968.
Okay, set the scene.
Margot McCaffrey was an American nurse and an absolute pioneer in the field of pain management. And she published a definition of pain that changed the entire trajectory of modern healthcare.
The quote from the text is just brilliant. She wrote, in 1968, pain is whatever the experiencing person says it is, existing whenever they say it does.
It sounds almost too simple, doesn't it?
Yeah, a bit like a philosophical bumper sticker.
Exactly. But you have to understand how radically disruptive that was at the time. Historically, the clinician was the ultimate unquestionable authority in the room.
What the doctor says goes.
Right. If a doctor or a nurse looked at a patient who claimed to be in agony and the clinician thought, well, that surgical wound doesn't look that bad, or, they were just laughing at a joke on the television, they must not be in real pain.
Right, they just dismiss it.
Yes. The clinician's visual judgment overruled the patient's verbal report. McCaffrey's definition stripped that authority away from the clinician and handed it entirely to the patient.
She basically drew a line in the sand and said, your medical degree and your eyes do not get to overrule their lived reality.
Exactly. It made the patient the sole, undisputed authority on their own suffering.
That is powerful.
It really is. It forced the entire medical establishment to actively override their own human instinct to visually judge whether pain looks real. And the impact of that is staggering.
As it's still used today, right?
Yes. The sources note that McCaffrey's definition still appears, almost word for word, in nursing textbooks today more than 50 years later.
Okay, here's where it gets really interesting. Because McCaffrey's philosophy is beautiful, right? It's deeply empathetic.
It is.
But if the patient is the absolute, undisputed authority, what happens when the clinician's eyes and their years of medical training tell them something completely contradictory?
Right.
Let's say a patient tells a nurse their pain is a 10 out of 10, the worst pain imaginable, but they're sitting comfortably in bed, scrolling on their phone, eating a turkey sandwich. Doesn't this create a massive, unspoken tension right there at the bedside?
If we connect this to the bigger picture, that bedside tension you just described is exactly what sparked decades of systemic clinical evolution and, quite frankly, massive systemic consequences. Well, the sources highlight that this patient-first philosophy was the primary engine behind a massive policy rollout between 1995 and 2001. That was the era when medical institutions and accreditation boards officially branded pain as the fifth vital sign.
Meaning that hospitals were suddenly, federally and institutionally mandated to check and treat pain as routinely as they checked a patient's pulse.
Yes, the intent was incredibly noble, to ensure that patient suffering was never again ignored, dismissed, or undertreated.
Which is a good thing.
Of course. But the sources are very clear that this well-intentioned policy, when combined with a complete lack of objective measurement tools, created a highly volatile landscape. We see this tension feeding directly into the history of the opioid crisis.
Oh, wow. Let's follow that mechanical logic because it makes terrifying sense.
Right.
If the institutional mandate is that you must treat whatever the patient says they feel, treating the pain until it reaches zero.
Yes.
And the primary, most effective tool you have in your medical arsenal is an opioid, then prescription rates are going to absolutely skyrocket.
Exactly. You had an objective, powerful medication being mass prescribed to treat a completely subjective symptom, driven by a mandate that said the provider could not question the patient.
That's a perfect storm.
It really was. The texts present this as a critical historical reality, that the absence of an objective thermometer for pain actively contributed to how pain was managed, for better and for worse.
We're talking massive societal impact here.
Yes. And the sources are careful to just impartially report this. And similarly, they highlight that this inherent subjectivity is exactly where interpretation disparities and racial biases in pain treatment take root.
Right, because if you don't have a blood test to prove the pain and you are relying entirely on a human filter to report it, you are also relying heavily on the human filter of the provider to interpret it.
Correct. When data isn't objective, subconscious assumptions fill the gaps. The sources document that because pain cannot be objectively verified, a provider's implicit biases regarding race, gender, and socioeconomic status can heavily influence their decisions.
Like whether they actually believe the patient?
Exactly. Whether they truly believe a patient's self-report or how aggressively they choose to treat it. Study after study in the sources shows that minorities, particularly Black patients, are frequently undertreated for pain compared to white patients with the exact same ailment.
That's just awful.
It is. The documents impartially report that these massive systemic issues, both the skyrocketing prescriptions of the opioid crisis and the tragic disparities in care, are inextricably linked to the structural reality that pain assessment requires trusting a subjective report.
It's incredible. It all flows downstream from the simple fact that we don't have a pain thermometer.
Yes, it all comes back to that.
Which brings us to the other major player in the sources. McCaffrey gave us the nursing philosophy, but the International Association for the Study of Pain, or the IASP, gave us the institutional definition.
Right, the official global standard.
So in 1979, the IASP defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage.
And that definition, word for word, stood unchallenged as the global medical standard for over 40 years.
But wait, I have to point out a huge logical flaw here. McCaffrey says pain is whatever the person says it is. The 1979 IASP definition relies on the experience being described in terms of tissue damage.
Right.
Both of these cornerstone definitions completely rely on the patient being able to communicate. What happens when the person literally cannot speak?
And you've just zeroed in on the exact ethical and clinical dilemma that forced the IASP to finally act.
Oh, real?
Yeah. In 2020, they took the highly unusual step of formally revising their global definition. It was only the second time in the organization's entire history that they did so.
That is a huge deal for a global medical institution. They don't just rewrite the dictionary on a whim.
No, they don't. They kept that core 1979 sentence intact, but they added 6 crucial, game-changing, clarifying notes.
Okay, what were they?
Well, 2 of those additions directly answer your question about the voiceless. The first critical note states, a person's report of an experience as pain should be respected.
Ah, so that's a formal global nod to the McCaffrey philosophy.
Exactly. But the second addition is the most vital. It states that the inability to communicate verbally does not negate the possibility that a human or a non-human animal experiences pain.
Oh, wow. So they explicitly, formally broadened the definition to protect the vulnerable. They took the burden of proof off the patient's voice.
Exactly. And the clinical impact of this cannot be overstated. The sources emphasize that this 2020 revision wasn't just some dusty academic exercise.
So it had real-world teeth.
Absolutely. It was a direct, urgently necessary response to decades of medical fields systematically undertreating pain in populations that couldn't advocate for themselves.
Because if the patient couldn't speak or couldn't accurately describe the tissue damage, the clinical assumption was often, well, they must not be in that much pain.
Tragically, yes. And we are talking about infants. For a surprisingly long time in medical history, it was incorrectly assumed that infants didn't experience pain the way adults do.
Wait, what?
Yeah, the theory was that their nervous systems were immature, so procedures were sometimes done with minimal analgesics.
That is absolutely horrifying to think about, that we just assumed a crying baby wasn't actually experiencing agony just because they didn't have the vocabulary to tell us.
It's a very dark chapter in medical history, and the 2020 revision directly combats that legacy.
I would hope so. Who else does this protect?
We're also talking about elderly people with advanced dementia. They might be suffering from a urinary tract infection or a fracture, but can't articulate what's wrong. They might just become agitated or withdrawn.
Right, because they can't say it hurts.
Exactly. And we're talking about patients in the intensive care unit who are heavily sedated or intubated with a breathing tube who physically cannot speak. The 2020 revision mandates, on a global scale, that their pain is real, it is valid, and it absolutely must be assessed, even without words.
So what does this all mean? How do we actually do that?
That's the practical challenge.
Right. If I am a nurse working a 12-hour shift, and I have a patient who is in pain, or a patient who cannot speak, how do I implement these high-level philosophical definitions? I can't just ask, how much does it hurt, and leave it at that.
No.
Yet there has to be a framework. What are the actual tools of the trade to bring form to the subjective?
To bridge that immense gap between a subjective human experience and an objective, actionable medical chart, the field created very specific methodologies. The sources highlight a foundational first principles approach known as the PQRST method.
PQRST, it's an acronym. Walk us through how a nurse actually uses this at the bedside. Let's say I come into the clinic complaining of stomach pain.
Right, so the nurse doesn't just ask if it hurts. They conduct a structured interview to extract actionable data.
Okay, let's hear it.
P stands for provocation or palliation. They will ask you, does taking a deep breath make the stomach pain worse? Does leaning forward make it better?
Ah, finding the triggers.
Yes. Q is for quality. They need you to describe the sensation. Is it a sharp stabbing pain or a dull burning ache?
Because a burning ache might mean an ulcer, but a sharp stab might mean appendicitis.
Exactly. Then R is for region and radiation. Show me exactly where it hurts. Does the pain travel up to your shoulder or down into your groin?
Mapping it out.
Right. S is for severity, which we'll talk about with the scales in a moment. And T is for timing. Did this start suddenly an hour ago, or has it been a slow build over 3 weeks? Is it constant, or does it come and go?
It's brilliant. It is essentially forcing a chaotic personal narrative into a highly structured clinical data set. You're giving the patient a standardized vocabulary test to help you understand the invisible.
That's a really good way to frame it.
But let's talk about the S severity. That's where the famous pain scales come in, right?
Yes. And because patient populations are so diverse, the texts detail several distinct pain scales. The most common one, the one you and every listener has probably encountered, is the NRS, or Numerical Rating Scale.
Okay, the classic 0 to 10.
Right, that's the classic. On a scale of 0 to 10, with 0 being no pain and 10 being the worst pain imaginable, where are you right now?
Which, again, relies on that human filter. My 7 might be your 4. A paper cut to me might be a 3, but to a carpenter, it might be a 0.
That's true, but the genius of the scale is that it establishes a baseline for you.
How so?
If you come in reporting a 7, the nurse administers medication, and an hour later you report a 4, the objective reality is that the treatment is working for your specific neurobiology.
It's relative to the individual.
Exactly. Now, for pediatric patients or adults with cognitive or language barriers, there is the FACES scale.
Oh, I know that one. That's the one you see in the pediatrician's office with the cartoon faces drawn on it, ranging from a happy, smiling face on the left to a red, crying face on the right.
Yes, exactly. The patient doesn't need to understand numbers. They just point to the face that matches how they feel inside.
Makes total sense.
But what about the patients we just talked about, the babies, the intubated, the advanced dementia patients?
The ones who can't point.
Right. That is where observational scales come in. The sources highlight the FLACC scale, which stands for face, legs, activity, cry, consolability.
Walk me through that. How do you score someone who can't speak? Let's use a 6-month-old infant recovering from surgery.
Okay, so instead of asking the infant, the nurse becomes a highly trained observer. They watch the infant for a set period.
Okay.
Face, is the baby relaxed, or are they grimacing with a furrowed brow? Legs, are the legs relaxed, or are they drawn up tight to the chest, which indicates distress?
Oh, right. Babies do that when they're upset.
Exactly. Activity, are they lying quietly, or are they thrashing around? Cry, is it a whimper or a steady screaming cry? And consolability, if the parent holds and rocks the baby, they calm down, or are they completely inconsolable?
Wow. So the nurse assigns a point value to each of those physical behaviors, tallies them up, and that generates the pain number for the chart.
Correct. There is also the pain add scale, specifically designed for pain assessment in advanced dementia. The nurse observes breathing patterns. Are they hyperventilating? They listen to vocalizations. Are they moaning or calling out?
Looking for physical cues.
Yes. They look at body language. Are their fists clenched? Even though there is no single thermometer for pain, these tools represent a rigorous, deeply scientific, and profoundly empathetic attempt to measure it anyway.
This raises an important point for you listening right now. The next time you're in a clinic or a hospital and a triage nurse asks you to rate your pain on a scale from 0 to 10, you should realize what is actually happening in that room.
It's so much more than a number.
Right. You aren't just answering a simple intake question. You are actively participating in a system that is built on over 50 years of intense philosophical debate, a highly contested history of medical evolution, and a profound shift in clinical power dynamics.
This raises an important question. How do we balance correcting historical clinical misconceptions with the real-world stakes of patient care today?
Yeah, how do we?
Well, relying on these tools, the PQRST method, the numerical scales, the observational charts, isn't just about a nurse checking a box or charting a number for insurance compliance. It's about honoring that 2020 IASP mandate.
Respecting the experience.
Yes. It is a systematic, daily attempt by the medical community to respect the patient's lived experience, whether that patient is speaking clearly, pointing at a cartoon face, or lying silently in an ICU bed.
And it really traces all the way back to people like Melzack and Wall in 1965, who first proposed that gate control theory.
They really started it all.
They were trying to prove that pain wasn't just a simple one-way street of biological hardware, but an incredibly complex intersection of mind, body, emotion, and environment.
They absolutely set the stage. Their science paved the way for Margot McCaffrey in 1968 to demand that we listen to the patient's voice, which in turn set the stage for the IASP in 2020 to demand that we listen even when the patient has no voice.
It's an incredible evolution.
It's an evolution of human empathy, practically disguised as routine medical procedure.
It really is. To briefly recap this incredible journey we've been on today, we started by looking at a vital sign that you literally cannot measure with a machine.
Nope.
We explored Margot McCaffrey's radical demand to trust the patient's truth above the clinician's eyes. We navigated the turbulent downstream effects of that subjectivity, from the well-intentioned policy shifts to the massive systemic debate surrounding opioids and care disparities.
A lot of unintended consequences there.
Definitely. And finally, we saw how the modern medical field uses specialized scales and methods like FLACC and PQRST to bridge the gap between invisible suffering and actionable science.
What's fascinating here is that nursing, at its very core, fundamentally requires operating in this ambiguous gray area.
Yeah.
It requires taking rigorous, structured, systemic assessment tools and applying them to a totally invisible, entirely human experience. At the end of the day, pain assessment is science boldly attempting to quantify suffering.
And doing so knowing full well that the tools are inherently imperfect, but absolutely necessary for compassionate care. Which leaves me with a final slightly sci-fi thought for you to chew on before we go.
All right.
Our entire current understanding of pain assessment, everything we've talked about today, relies on trusting the human report.
Mm-hmm.
We trust the voice, and we use observational tools precisely because we lack an objective thermometer.
Right.
But what happens in the near future if advanced brain imaging or AI actually does allow doctors to objectively read our pain levels?
That would change everything.
If a machine could finally map the exact severity of that invisible ache in your spine and project a definitive number on a screen, would we even want it to have the power to override our own voice?
That is a deeply unsettling, yet probably inevitable question for the future of medicine.
Think about that the next time they ask you for a number. Thanks for diving deep with us today. If you walk into literally any intensive care unit right now, you're immediately surrounded by some of the most expensive, highly engineered technology on the planet.
Oh, absolutely. It looks like a spaceship in there.
Right. I mean, you'll see million-dollar ventilators breathing for people, experimental dialysis machines filtering blood, and these crazy IV pumps delivering highly toxic, life-saving drugs just, drop by drop.
Yeah, and you naturally assume the danger in that room scales with the complexity of the machines.
Exactly. But the device responsible for one of the most massive, unkillable infection risks in that entire hospital, it isn't even plugged into the wall. It's a $3 piece of flexible tubing.
It really is.
So today we're doing a deep dive into the urinary catheter. Welcome, everyone. We're going to look beyond all the clinical jargon of insertion and care to uncover this fascinating story about infection, hospital economics, and honestly, a massive shift in how we think about the human body.
Because it really is the perfect blind spot in modern medicine. We have this deep-seated instinct to blame catastrophic outcomes on complex failures,
Right.
But the history of the urinary catheter shows us something entirely different. The greatest risk to a patient usually isn't the hardware itself, it's the human decisions.
The human decisions, right.
Yeah, the medical dogmas and just the sheer psychological momentum of how we manage that hardware on a daily basis.
Okay, let's unpack this.
Yeah.
Because when most of us hear the word catheter, we tense up a bit and we just lump everything into one very uncomfortable mental bucket.
Oh, for sure. Nobody wants to think about it.
No, they don't.
Yeah.
But to understand the stakes here, we have to separate them out. Because there are 4 main types, and they interact with your body in wildly different ways. First, you have the indwelling, or Foley catheter.
Right, the one most people are thinking of.
Exactly. That one goes up into the bladder and just stays there for hours, days, or even weeks. Second is the intermittent catheter, which is strictly an in and out situation. Inserted just to drain the bladder and immediately removed.
Just temporary fix.
Yeah. Third is the external catheter, commonly called a Texas or condom catheter. That one is worn over the penis rather than inserted inside. And finally, the suprapubic catheter, which bypasses the urethra entirely and goes straight through the lower abdomen into the bladder through a surgical incision.
And the distinction you just made, that is where so much of the confusion begins. Because while they all technically do the exact same job, draining urine, right, but the biological consequences depend entirely on how long they stay in contact with the body.
Okay.
Yeah, duration is the invisible threat here. And to really grasp why we handle these devices the way we do today, we have to look at how two vastly different medical philosophies collided over the last century.
It's basically a tug of war between adding hardware and taking it away, and the story really kicks off with the addition side of things.
Back in the early 20th century.
Right, between 1929 and 1935, a urologist in Minneapolis named Frederick Foley came up with what we now call the Foley catheter. And looking at what he was trying to solve, his design was honestly brilliant.
It was a game changer, really, because the clinical reality before Foley was a complete mechanical nightmare.
I can't even imagine.
Well, think about it. If a doctor inserted a tube into the urethra to drain the bladder, there was nothing to keep it from just sliding right back out.
Oh, yeah.
So clinicians were literally taping tubes to patients' legs.
Tape. Ouch.
Tape, external straps, or sometimes a nurse just had to stand there and physically hold the tube in place.
That sounds terribly inefficient.
It was. So Foley introduced this remarkably elegant solution. He took a standard rubber tube and added a tiny inflatable balloon near the tip.
So you slide the tube in, you inject a little sterile water to inflate that balloon inside the bladder, and boom, it acts as an anchor.
Exactly. The tube can't fall out.
It's cheap, it's effective, and it completely revolutionized nursing care. Though there is this bizarre historical twist that Foley might not have even held the official patent for it.
Yeah, the manufacturing history is a total mess of lawsuits and competing claims. It's a whole thing.
Right, but the eponym just outran the paperwork.
It totally did. The word of mouth among surgeons and nurses was just too powerful. The adoption of this balloon-anchored tube was so rapid that it universally became known as the Foley.
Because it just worked so well.
Exactly. It solved such a profound daily annoyance for hospital staff that no one cared who owned the patent. They just wanted the device.
And here's the catch. That convenience is exactly what set the trap. Because if we fast forward to 1972, we meet a urologist at the University of Michigan named Jack Lapidus.
The foil to Foley.
Yes. He represents the complete opposite philosophy. He was dealing with a deeply tragic patient population, children and adults with neurogenic bladders.
Right, patients with spinal cord injuries or conditions like spina bifida.
Yeah, where the nerve signals to the bladder simply don't work, so they couldn't pee naturally.
And you have to understand, the medical dogma at that time was entirely focused on absolute sterility.
Like keeping everything perfectly clean.
Beyond clean. The prevailing belief was that the bladder was a completely sterile sanctuary. Therefore, any time you accessed it, you had to maintain strict surgical-level sterile conditions.
Gowns, masks, all of it.
Gowns, masks, sterile drapes, the works. So for a child with spina bifida, doctors would often insert a permanent, indwelling Foley catheter to keep the bladder continuously drained. Or they would even perform major surgeries to divert the urine outside the body.
Because they were terrified that if they kept inserting and removing tubes, they'd introduce bacteria, right?
Exactly, that was the fear.
But Lapidus looked at the data and realized this permanent sterile tube was actually causing devastating chronic infections. It was causing kidney failure and death.
It was doing the exact opposite of what they intended.
Wait, so the medical establishment thought they were protecting patients with permanent sterile tubes, but they were actually causing the damage. It's like they were treating the bladder as this pristine, sealed vault. But the bladder is actually more like a self-cleaning oven, right?
What's fascinating here is that that is the exact mechanism Lapidus uncovered. Yeah. He had this radical realization that the bladder's natural rhythm, filling up, expanding, and then completely flushing itself out, that is its primary immune defense.
Because the physical rush of urine washes the bacteria away.
Precisely. And the stretching of the bladder wall actually triggers local immune responses. When you place a permanent Foley catheter, the bladder remains constantly empty and collapsed.
So you disable the physical flush and the mechanical immune triggers all at once.
You shut down the whole defense system.
Wow. So what did Lapidus tell the medical community to do? Just stop worrying about sterility?
Essentially, yes. Which, as you can imagine, sounded like absolute heresy in 1972.
Oh, I bet.
He introduced clean intermittent catheterization, or CIC. He told patients and parents that they didn't need an operating room environment. They could just wash their hands with normal soap and water, use a clean but not surgically sterile tube, insert it to drain the bladder, and pull it right back out.
And just do this several times a day to mimic the body's natural rhythm.
Exactly.
I can only imagine the pushback from other doctors. I mean, he was basically telling them to break the cardinal rule of infection control.
Oh, the resistance was massive. Surgeons literally accused him of malpractice.
Seriously. Malpractice.
Yeah, but the outcomes were undeniable. Lapides proved that periodic flushing of the bladder and removing the foreign object was vastly more protective than trying to maintain permanent sterility with an indwelling tube.
And today, clean intermittent catheterization is the global standard of care for these conditions, isn't it?
It is. It completely changed the field.
Okay, so if a permanent tube breaks the body's natural flushing system, what actually happens inside that stagnant environment?
Well, let's consider the math for a second, because this is the most important number in catheter care. The baseline daily risk of acquiring bacteriuria, which is simply the presence of bacteria in the urine while an indwelling catheter is in place, is roughly 3 to 10% per day.
Wait, 3 to 10% per day, compounded every single day.
Every single day.
So an infection isn't a roll of the dice, it's a ticking clock. If a patient is in the ICU for 3 weeks, it's not just a risk, it's a statistical certainty.
It is virtually guaranteed. By day 30, the colonization rate approaches 100%. It's a matter of when, not if.
Because the catheter basically defeats the bladder's natural flushing mechanism and offers squatters' rights to bacteria.
That's a great way to put it. But they don't just float around in the urine. Within 24 to 48 hours of that tube being inserted, bacteria attach to the plastic or silicone and begin secreting something called an extracellular polysaccharide matrix.
Okay, you're going to have to translate that for me. What on earth is an extracellular polysaccharide matrix?
Think of it as a microscopic, sugary slime shield.
A slime shield. Got it.
Yeah, the bacteria excretes this thick, sticky glue that completely coats the surface of the catheter. This creates a biofilm.
Okay.
And once the bacteria are embedded inside this slime, they undergo a behavioral shift. They start communicating with each other, they share genetic material, and they actually slow down their metabolism.
Like they're hunkering down for a siege.
Exactly.
Okay.
This slime shield is completely impermeable to the patient's immune cells. And much worse, it is highly resistant to antibiotics.
Really?
Yeah, an antibiotic concentration that would instantly kill a free-floating bacterium in a petri dish will just bounce right off a biofilm.
Which means we are dealing with a microscopic fortress.
Right.
I was reading about David Stickler's famous research on this over at Cardiff University, and he highlights a specific bacteria called Proteus mirabilis that takes this fortress building to a terrifying level.
Oh, Proteus mirabilis. It is one of the most destructive organisms you can encounter in a urinary tract, specifically because of how it alters the local environment. It produces an enzyme called urease.
And how does that affect the catheter?
Well, human urine is naturally rich in urea. The urease enzyme secreted by this bacteria breaks that urea down into ammonia.
Okay, and ammonia raises the pH, right?
Exactly. As the ammonia levels spike, the urine's pH skyrockets and becomes highly alkaline. Now, urine also contains naturally dissolved minerals, mainly magnesium and calcium.
Right, normal stuff.
Normal stuff, but those minerals only stay dissolved at a normal, slightly acidic pH. Once the ammonia makes the environment alkaline, those minerals literally crystallize and fall out of the liquid. They form a jagged rock called struvite.
Wait, so this soft, flexible silicone tube is actively turned into a calcified pipe by these bacteria?
Within days, the bacteria incorporate these struvite crystals directly into their slime shield. The biofilm becomes mineralized.
That is just wild.
So very quickly, the inside of the catheter can become completely encrusted and blocked by this bacterial concrete.
That is a plumbing nightmare. I mean, the device that was put in to drain the bladder is now a solid rock blocking the exit.
Right.
The bladder fills up, the pressure builds, and that infected, highly alkaline urine has nowhere to go but backwards, refluxing up the ureters into the kidneys.
And because of that mineralized biofilm, doctors quickly realize you cannot out-medicate this problem. You have to outsmart it. You can pump the patient full of the strongest intravenous antibiotics available, and you might kill the free-floating bacteria, but the ones entrenched in the biofilm will survive.
So if biofilms make bacteria essentially unkillable, it seems obvious we should just change the building materials. I mean, what about technological solutions? We put silver and antimicrobial coatings on everything these days. Why not catheters?
That is a major debate, and it was the biomedical industry's massive push for the last 20 years. The theory was, hey, if you embed silver alloys or antibiotics into the silicone, it will poison the bacteria before they can build their slime shield.
Makes total sense on paper.
On paper, yes, but the clinical reality has been incredibly frustrating. We now have extensive Cochrane-level reviews, which are these massive, rigorous analyses of all available clinical trials, and they show that these expensive, high-tech coatings offer little to no reduction in symptomatic CAUTI or catheter-associated urinary tract infections.
But silver kills everything. Why wouldn't a silver-coated tube stop an infection?
It all comes down to the timeline. The silver might delay colonization by a day or two, perhaps slightly reducing asymptomatic bacteria in the very short term. But biofilms are inevitable. Proteins from the patient's own urine quickly coat the silver, neutralizing its effect entirely.
Wow. So we can't medicate it, and we can't engineer our way out of it with fancy space-age materials. What is the real solution then?
If the problem is duration, the highest leverage intervention is just taking the tube out.
Just take it out.
Yeah. Look at a landmark 2010 systematic review by Jennifer Meddings and Sanjay Saint. They analyzed hospital programs that ignored the high-tech materials and focused purely on human behavior. They implemented simple nurse-driven reminders and automatic stop orders in the electronic medical records.
So, like a pop-up on the screen forcing the doctor to answer, does the patient in bed 4 still strictly require this tube?
Yes. And if the doctor didn't explicitly justify it, the nursing staff had the authority to pull the catheter out. The results were staggering. Just by asking that question daily, hospitals cut catheter days by a third, and they halved their CIUTI rates.
Have them. Here's where it gets really interesting. The biggest breakthrough wasn't a silver coating. It was essentially a sticky note asking, does this patient still need this?
Exactly.
But why did doctors need a computer pop-up to remind them? I mean, weren't they paying attention?
Well, it goes back to Foley's balloon. Indwelling catheters were deeply ingrained in hospital culture as a tool of convenience. If a patient is elderly or confused or on diuretics, having a catheter saves the nursing staff from changing soiled sheets or assisting the patient to a bedpan every 2 hours.
I see.
It makes accurately measuring urine output effortless. The device would be inserted in the emergency room and then simply fade into the background noise of the hospital stay.
So it was victim of its own success. It worked so well mechanically that nobody thought about the biological ticking clock.
Yeah.
So what finally broke that culture of convenience?
A massive financial forcing function. In October 2008, the Centers for Medicare and Medicaid Services, or CMS, completely rewrote the rules.
Oh boy, follow the money.
Always. They announced they would no longer reimburse hospitals for the extra costs associated with treating certain hospital-acquired conditions. CIUTI was placed squarely on that list.
Oh, wow. So overnight, a CIUTI shifted from being a routine clinical nuisance that the hospital actually got paid to treat to a massive financial penalty.
It was a tectonic shift. Suddenly, if a patient developed a CAUTI, the hospital had to absorb the cost of the extra days in the ICU, the infectious disease consults, and the expensive antibiotics. That single financial lever changed physician behavior faster than decades of peer-reviewed studies. Hospital administrators cracked down, demanding strict removal protocols and heavily restricting who was allowed to get a catheter in the first place.
But, whenever you tie huge amounts of money to a specific medical diagnosis, you inevitably trigger a massive turf war over how that diagnosis is defined. If I'm a hospital administrator losing thousands of dollars every time a doctor writes CAUTI in a chart, I'm going to argue about what truly constitutes an infection.
And you just hit on the great debate we are still fighting today, the difference between colonization and true infection. Because hospitals are now heavily penalized, the CDC's National Healthcare Safety Network, the NHSN, had to step in and engineer a highly specific definition for public reporting.
And they had to throw out some of the most classic signs of infection to do it, right? I know they dropped pyuria, which is the presence of white blood cells in the urine.
They did, yeah.
If I see white blood cells, my instinct is that the body is fighting an infection. Why drop that from the definition?
Because of the very nature of the device. A catheter is a piece of foreign plastic rubbing against the sensitive mucosal lining of the bladder. That friction causes constant inflammation, and the immune system naturally sends white blood cells to any inflamed area.
Oh, so it's just a physical reaction.
Right? Almost every single patient with a catheter will have pyuria within a few days, regardless of whether they are actually sick. By using white blood cells as a metric, doctors were simply diagnosing the physical presence of a tube, not a bacterial invasion of the tissue.
That makes a lot of sense.
Mm.
So what is the actual strict standard now to call it a true CIUTI?
The catheter must have been in place for more than 2 calendar days. The patient must exhibit systemic symptoms, meaning a fever, chills, or severe localized pain. And finally, you need a urine culture of 100,000 colony-forming units, or CFUs, per milliliter or more.
Meaning if you take a tiny milliliter of urine and put it in a lab dish, 100,000 distinct bacterial colonies will grow from it. That proves a massive bacterial load.
Correct. But the linchpin of that definition is the systemic symptoms, which brings us to the single hardest concept for families and even some clinicians to accept.
Okay, let's debunk the biggest misconception here. Let's paint the scenario. You're visiting your grandfather in the hospital. He has a catheter. You look at the collection bag hanging off the side of the bed, and the urine looks awful. It's cloudy, it's dark, and it smells terrible. Every human instinct screams that he has an infection and needs antibiotics immediately. It feels negligent for the doctor to just walk by and ignore that.
It feels incredibly wrong. But if we connect this to the bigger picture, the Infectious Diseases Society of America, the IDSA, is uncompromising on this point. What you are describing is asymptomatic bacteriuria.
Asymptomatic, meaning no fever, no pain.
Right. There are bacteria in the bag, creating cloudiness and odor, but they have not invaded your grandfather's tissue. The guidelines mandate that asymptomatic bacteriuria in a catheterized patient should never be treated with antibiotics.
Never. Even if the smell is clearing the room.
Even then. Cloudiness and foul odor are a guarantee when you have a biofilm converting urea into ammonia. But if you demand antibiotics based on the look of the bag, you aren't clearing the infection.
Because the biofilm protects them.
Exactly. Treating smelly or cloudy urine without systemic symptoms just breeds antibiotic resistance. You wipe out their good gut bacteria, and you train the bacteria on the catheter to become highly resistant superbugs. You treat the patient's symptoms, not the culture result or the smell.
That is such a vital reframing. Treat the patient, not the bag.
Yeah.
Okay, let's do a rapid-fire debunking of 2 more persistent myths that still cause harm on the hospital floor today. Let's talk about the balloon size. Myth. A bigger balloon, over the standard 10 milliliters, means a more secure catheter that won't leak.
Fact. That instinct consistently harms the patient. When you overinflate that balloon, it creates a massive, heavy water balloon pressing down on delicate tissue. This causes mucosal irritation and triggers violent bladder spasms as the body tries to expel it.
So it makes it worse.
Much worse. Those spasms actually squeeze urine out around the sides, causing more leakage while simultaneously causing tissue necrosis from the pressure.
Yikes. Okay, next myth. Prophylactic antibiotics protect the patient. If we know that compounding daily risk is ticking away, why not just put the patient on a low dose of antibiotics the day the catheter goes in, just in case?
Fact, they just select for resistant organisms. The biofilm still forms, but now it forms exclusively with bacteria that have already proven they can survive your antibiotic. Routine prophylaxis does not protect the patient, it actively endangers them.
Wow, okay. So, pulling all of this together for everyone listening, the narrative arc here went from Frederick Foley inventing a balloon that made it way too easy to leave a tube in out of convenience, to Jack Lapides proving that periodic clean removal is vastly superior to permanent sterility.
Because it always comes back to the ultimate lesson. CIUTI is a duration problem, not a hygiene at insertion problem.
It's the ticking clock.
Yes. The most powerful tool in preventing infection isn't a sterile drape or a fancy silver coating, it's the decision to remove the catheter.
So true. Lapides proved that our obsession with maintaining absolute sterility actually harmed patients, and modern data proves our obsession with leaving tubes in just in case causes inevitable infections.
It's a hard habit to break.
It really is. And it leaves you with a final thought to ponder based on today's sources. It makes you wonder, how many other areas of medicine, or even just our daily life, are we making worse by trying to over-control the environment, rather than just trusting the body's natural rhythms to do the work?
That is a phenomenal question to leave on.
Thanks for joining us on this deep dive. We'll catch you next time.
So if you survived a massive heart attack back in like the mid-1950s, your doctors might have prescribed you this very specific cutting-edge medication.
Right.
And it was highly effective, but it was also literal rat poison.
Which is just wild to think about.
It is, and that is exactly what happened to United States President Dwight D. Eisenhower in 1955.
Yeah.
And the crazy part, it actually saved his life. So welcome to today's deep dive. Today, we are exploring the terrifying high-wire act of anticoagulants. We're looking at heparin, warfarin, and, the modern DOACs, and how healthcare professionals walk this incredibly narrow line between preventing deadly clots and, well, causing dangerous bleeding.
It really is probably one of the most perilous tightropes in medicine. Because when we talk about anticoagulants, we aren't just looking at like a simple list of medications.
Right.
We're looking at this highly complex, highly reactive biological system inside you. And the tools we use to artificially manipulate that system, they've evolved drastically over the last century.
Especially with that massive explosion of new drugs around, 2010?
Exactly. So understanding the evolution of these therapies and why matching the right drug to the right patient is literally a matter of life and death is just fundamental.
Okay, let's unpack this right away. Because before we get to the rat poison, we have to debunk a massive, widespread myth about this entire class of drugs.
Oh, the blood thinner thing.
Yes. The colloquial phrase everyone uses is blood thinners. I mean, you hear it from patients, you hear it on TV shows, but it is entirely misleading.
Completely.
Anticoagulants do not actually thin your blood. They don't, change the viscosity of the fluid. We aren't taking a thick liquid and watering it down like you're adding paint thinner to a can of paint.
That is such a vital starting point. I mean, the fluid dynamics, the actual physical thickness of the blood in your veins, it remains exactly the same whether you're on an anticoagulant or not.
So instead of thinking about plumbing or like paint thinner, I want you to think of your body's coagulation system like a highly coordinated factory assembly line.
I like that analogy.
Yeah, so when you get injured, the factory alarm bells ring. The assembly line kicks into gear, sending proteins down the belt to build a solid temporary structure to patch the leak, which is a blood clot.
Right.
Anticoagulants don't flood the factory floor with water to thin everything out. They just change the kinetics of that assembly line. They basically throw a wrench into the machinery.
Exactly.
So if you are taking an anticoagulant and you cut your finger slicing an onion, you aren't bleeding thinner blood. Your factory is just taking way, way longer to build a robust clot. You bleed longer, not thinner.
And that distinction dictates everything about how these drugs work clinically. To really grasp how we control this complex factory today, we should probably look back at how we accidentally discovered the brakes for this assembly line in the first place.
Which brings us to the accidental discoveries. So in 1916, there was this second-year medical student at Johns Hopkins named Jay McLean. He was working in the lab of a physiologist named William Henry Howell. And McLean's assigned job was to isolate procoagulant substances from dog liver and heart tissue.
So he was explicitly looking for compounds that caused blood to clot.
Exactly. But instead of finding a clotting agent, he isolated this fat-soluble compound that did the exact opposite. It prevented clotting entirely.
Which is just a phenomenal example of scientific serendipity. I mean, Howell eventually named this mysterious compound heparin, which comes from the Greek word heper, meaning liver.
Because that was the primary tissue they were extracting it from.
Right.
But, they couldn't just inject raw dog liver extract into humans. It took a long time to refine, didn't it?
He did, yeah. It wasn't until the 1930s that chemists, specifically Charles Best, who, was already famous for his role in discovering insulin.
Oh, wow.
Yeah, he managed to purify heparin to a standard where it could actually be used safely in clinical practice.
So heparin comes from a pretty straightforward, if lucky, laboratory stumble. But warfarin's origin story is like something out of a Gothic agricultural mystery.
It really is.
Here's where it gets really interesting. In the 1920s in Alberta, Canada, a veterinary pathologist named Frank Schofield noticed a terrifying trend.
All right, the cattle.
Yes, cattle were bleeding to death from incredibly minor injuries. We're talking about like a basic nosebleed or a tiny scratch from dehorning, and the animal would simply exsanguinate.
So awful.
Yeah, and Schofield traced the cause back to their feed. They were all eating spoiled, moldy, sweet clover hay. He named it sweet clover disease, but the actual biochemical mechanism remained a total mystery.
Until the crisis hit a tipping point in the American Midwest.
So in 1933, a Wisconsin farmer named Ed Carlson was losing his herd to this exact same mysterious bleeding.
Okay.
And he was just desperate for answers, so he loads up his truck and drives through a blinding winter blizzard to the University of Wisconsin.
Wow.
He walks straight into the agricultural chemistry lab of a researcher named Carl Paul Link. And Carlson just dumps his evidence right there on the desk.
Which was what?
A dead cow, a milk can full of unclotted cow blood, and a sack of that spoiled sweet clover hay.
Just a visceral, unforgettable delivery. Literally. So Link's lab spent years tearing that moldy hay apart biochemically. And finally, around 1940, they isolated the culprit. It was a compound called decumarol.
Okay, so what did the decumarol actually do?
They discovered that this specific moldy compound was actively blocking the animal's liver from recycling vitamin K.
Oh, I see.
And without vitamin K, the liver's factory assembly line simply cannot manufacture the clotting factors it needs.
So Link's team starts synthesizing all these different variations of the compound, and variation number 2 on their list becomes warfarin.
Right.
Named for the Wisconsin Alumni Research Foundation that funded the research, combined with the arin from coumarin. But when they brought it to market in 1948, it wasn't heart medication.
No, not at all. It was rat poison.
Because it was incredibly effective at its job. Rodents would eat it, show absolutely no symptoms for a few days, and then quietly bleed out internally.
Yeah, and the lead to human medicine happened under incredibly dark circumstances. Because in 1951, a U.S. military inductee attempted suicide by swallowing a massive, lethal dose of this warfarin rat poison.
Oh.
He was rushed to the hospital, but instead of dying, the doctors managed to save him by administering huge concentrated doses of vitamin K.
It proved the rat poison was a reversible pharmaceutical.
Precisely. That single medical intervention demonstrated that the drug's effect in the human body was dose-dependent and, that it could be completely counteracted if things went wrong.
Which paved the way for FDA approval and eventually President Eisenhower taking it for his heart attack in 1955.
Yep.
So we have dog liver extract and rat poison, but how did they actually stop the factory assembly line from clotting without just, making patients bleed out completely?
To answer that, we need to look at the differences between how these drugs act on that assembly line. The coagulation cascade involves several inactive proteins, which we call factors floating in your blood. When an injury occurs, they activate in a very specific cascading sequence. Now, different drugs target very different workers in this factory. Let's start with the fast-acting one, heparin.
You mean unfractionated heparin,
Yeah,
right?
yes. Unfractionated heparin doesn't actually attack the clotting factors directly. It works by finding a naturally occurring security guard in your blood called antithrombin III.
Antithrombin III, got it.
Heparin binds to the security guard and supercharges it, accelerating its ability to neutralize two specific workers on the assembly line thrombin, which is known as factor II cria, and factor ZA.
Oh, wow.
And heparin accelerates this neutralizing process by 1,000-fold.
Wait, I'm confused about the timeline here. If it's supercharging a process that's already in the blood, how quickly does this happen?
It is essentially instantaneous. Because heparin is administered intravenously or via a shot under the skin subcutaneously, the onset is immediate.
Okay, so it's super fast.
Exactly. We use it when a patient needs their assembly line paused right this second. Like if someone hits the emergency room with a massive new pulmonary embolism, a clot in their lungs, or if they're going onto a cardiopulmonary bypass machine for open heart surgery, we use heparin.
But there's a catch, right?
A big one.
Yeah.
Monitoring it is an absolute nightmare.
Because heparin molecules are, bulky and unpredictable. They bind to plasma proteins and cell walls in totally random ways depending on the individual patient.
Yeah, that unpredictable binding means a dose that is perfectly safe for one patient might cause catastrophic bleeding in another of the exact same weight.
Which is terrifying.
It is. So nurses have to constantly draw blood to check a lab value called the APTT, the activated partial thromboplastin time. They're constantly tweaking the IV drip rate up and down hour by hour, trying to keep that lab value perfectly balanced between 1.5 and 2.5 times the patient's normal baseline.
It sounds like an exhausting minute-by-minute balancing act, which makes sense why science went looking for an upgrade. And that upgrade was low molecular weight heparin, or LMWH. Drugs like enoxaparin, which most people know as Levinox. But why does changing the weight of the molecule suddenly make it easier to deal with?
Well, they literally took the massive, clunky heparin molecule and chemically chopped it into smaller, uniform fragments.
Oh, I see.
Because these fragments are smaller and cleaner, they don't get caught up binding randomly to other proteins in the blood. They act with precision, selectively targeting just factor ZA.
So the clinical payoff must be massive.
Huge. You can give it as a simple shot under the skin, based purely on the patient's body weight.
Because it is so predictable, for the vast majority of patients, you don't need to chase those exhausting APTT lab values at all.
Okay, so heparin and Lovenox are the fast-acting, immediate breaks approach. Let's contrast that with warfarin, the slow approach. You mentioned earlier that warfarin works in the liver.
It does. It targets an enzyme called VK or RC1. Think of this enzyme as the loading dock manager for your factory. This manager's only job is to recycle vitamin K and bring it into the factory to build specific parts. Warfarin basically fires that loading dock manager.
Right.
So suddenly, the liver cannot make functional versions of 4 very specific factors. Factors 2, 7, NiX, and X.
So what does this all mean for the patient taking the pill right now? Like, if I swallow a warfarin tablet on a Monday morning, my blood doesn't instantly stop clotting, does it?
No, not at all.
Because warfarin doesn't hunt down and destroy the clotting factors that are already swimming around in my bloodstream. It only stops new ones from being built.
Exactly. And those existing factors have varying lifespans. Prothrombin, which is factor 2, has a massive 60-hour half-life.
Meaning it takes 60 hours for just half of it to naturally clear out of the system.
Yes.
So if I take the pill on Monday, it takes 3 to 5 days for the old factory workers to retire and for the warfarin to actually take full effect.
Which is exactly why we monitor it differently. Instead of the APTT, warfarin is monitored by the PT, the prothrombin time. This is standardized globally as the INR, the International Normalized Ratio.
Okay, so what's the target there?
For a typical patient with, say, atrial fibrillation, we want their INR between 2.0 and 3.0. If they have a mechanical mitral valve in their heart, which is a highly reactive piece of metal prone to clotting, we push the target higher, usually 2.5 to 3.5.
And if someone's INR shoots up to like 8.0 and they start bleeding dangerously, the reversal agents are very different from heparin, right?
Totally different.
Because for heparin, you use a drug called protamine sulfate. But for warfarin, you have to replace what's missing. You give them vitamin K to restart the loading dock.
Right.
Or if they are actively hemorrhaging, you give them fresh frozen plasma or a prothrombin complex concentrate like Kcentra, which physically replaces the missing factory workers immediately.
What's fascinating here is that mismatching the speed in the labs of these two drugs ignores the entire logic of clinical therapy. You cannot monitor warfarin with an APTT, and you cannot monitor heparin with an INR.
Because they're attacking the factory in completely different ways.
Exactly. And that 3 to 5 day delay for warfarin, it's not just a minor inconvenience. It actually creates a deadly window that leads to some of the most counterintuitive phenomena in all of medicine.
This is where the tightrope gets really wobbly. Let's talk about the paradoxes.
Yeah, so when you start a patient on warfarin, you are suppressing those 4 pro-clotting factors we mentioned, but you are also suppressing some naturally occurring anti-clotting proteins, specifically protein C and protein S.
Because they rely on that same vitamin K loading dock.
You got it.
Ah, I see where this is going. Protein C is a natural brake for the assembly line, and its half-life is incredibly short, only about 8 hours.
Right.
So the natural brake disappears in 8 hours, but the pro-clotting factor 2 takes 60 hours to disappear.
Which creates a terrifying biochemical traffic jam. For the first 24 to 72 hours on warfarin, your body's natural anti-clotting defense completely vanishes, while the pro-clotting workers are still actively building clots.
That sounds really dangerous.
It is. For a few days, the patient is paradoxically hypercoagulable. They're far more likely to form a blood clot than if they hadn't taken the medication at all.
Which can lead to a horrifying condition called warfarin-induced skin necrosis, right?
Unfortunately, yes.
It happens in about 1 in 10,000 cases. Because the patient's blood is temporarily so prone to clotting, thousands of microscopic blood clots form and clog up the tiny vessels in their skin. It causes these intensely painful purplish lesions, often on the thighs, breasts, or buttocks, leading to severe tissue death.
This physiological paradox is the entire reason the concept of bridging exists. You can never just hand a new patient a warfarin pill and send them home. You have to bridge them.
So how does that work?
You give them the slow-acting warfarin, but you also give them fast-acting heparin or Lovenox injections at the exact same time. The fast-acting heparin protects them through that dangerous 3-day startup window until the old clotting factors finally die off.
Oh, and then the warfarin fully takes over, and the INR hits that therapeutic 2.0 to 3.0 range.
Exactly.
But bridging relies on heparin, and heparin has its own terrifying paradox, doesn't it? Something called HIT heparin-induced thrombocytopenia.
It is arguably the ultimate medical betrayal. I mean, the anticoagulant itself causes massive catastrophic clots.
Wait, really?
Yeah.
Oh.
In about 1 to 5% of patients on unfractionated heparin, their immune system suddenly misidentifies the drug.
When heparin binds to a specific protein in the blood called platelet factor 4, the immune system views that complex as a foreign invader.
Okay.
And so the body creates aggressive antibodies against it.
So it's like calling the fire department and they show up with flamethrowers. The immune system's security guards start attacking the factor itself.
That's a great way to visualize it. These antibodies violently activate the patient's platelets. The overall number of free platelets in the blood drops dangerously low. That's the thrombocytopenia part.
Right.
But the platelets that remain are aggressively clumping together, forming massive clots. Patients end up with catastrophic arterial and venous blockages. We're talking debilitating strokes, loss of blood flow to their arms or legs, which we call limb ischemia, and massive pulmonary embolisms.
So if a nurse or doctor is looking at daily lab results and they see a patient's platelet count suddenly drop by like 50% a week after starting a heparin drip, what is the protocol?
The required nursing and medical action is absolute. You stop all heparin immediately. You even throw away the tiny heparin flush syringes used just to keep IV lines clear. You must switch the patient to a completely different class of anticoagulants like argatroban or fondaparinux.
Okay, so you switch them, but you don't use warfarin.
Critically, you never switch them acutely to warfarin because, as we just discussed, warfarin causes that early protein C drop. If you give warfarin to a patient actively suffering from HIT, you're throwing gasoline on a hypercoagulable fire.
It is just wild how carefully this assembly line has to be orchestrated. Every single intervention has a domino effect.
It really does.
Which really explains why the medical world was so desperate for an easier way. Chasing APTT labs, checking INRs, bridging patients with multiple drugs, constantly worrying about skin necrosis and HIT, it's exhausting for providers and patients.
Oh, absolutely.
So we inevitably got the DOAC revolution.
Right. The direct oral anticoagulants, which started emerging in the 2010s, drugs like dabigatran, rivaroxaban, apixaban.
And they were kind of pitched as a miracle, right?
Pretty much. The pharmaceutical industry marketed them as the ultimate holy grail, freedom from the constant needle sticks for blood draws, freedom from strict diets. You just take a pill and you're protected. And today, we even have specific reversal agents for them, like idarucizumab and dexanet alpha if bleeding occurs.
But we have to look at the famous DOAC failure, the 2013 REALIGN trial. Researchers wanted to see if they could use dabigatran, this shiny new DOAC, on patients who had mechanical heart valves.
And the trial was an absolute disaster.
Really?
Yeah, they had to stop it early. The data was undeniable. The patients on the new DOSC had significantly more strokes, way more clots forming directly on their mechanical valves, and far more major bleeding events compared to the patients on old-school warfarin.
Wait. The entire point of medical advancement is that the newer, more targeted drug is safer and better? Are you saying we gave them the cutting-edge DOAC and they actually got worse?
That's exactly what happened.
How does that make any sense? I mean, if a DOAC and warfarin both stop the blood from clotting, why does a piece of metal in the heart care which drug is doing the job?
It all comes down to how they shut down the factory. DOACs are highly targeted. They act like a sniper, taking out one specific worker on the assembly line, like factors AST or thrombin.
Okay, a sniper.
But warfarin is a sledgehammer. It blunts the production of multiple clotting factors simultaneously. A mechanical heart valve is a highly reactive, incredibly clot-provoking piece of foreign material inside the body. A sniper isn't enough to stop the cascade when the stimulus is that aggressive.
Ah, so you need the sledgehammer.
You do. It's a massive teaching point. Newer isn't automatically safer. DOAs are strictly contraindicated for mechanical heart valves.
That perfectly illustrates why memorizing drug names isn't enough. You really have to understand the underlying mechanisms.
Absolutely.
And speaking of understanding mechanisms, there are a lot of persistent myths surrounding anticoagulants that we should clear up. Let's start with aspirin. A lot of people assume aspirin is a blood thinner, just like warfarin, and does the exact same thing.
A very common but dangerous conflation. Aspirin is an antiplatelet. It irreversibly inhibits an enzyme called COX-1.
So going back to our factory analogy.
In the context of our factory, aspirin stops the raw materials, the platelets, from holding hands and clumping together in the first place. Anticoagulants, as we've discussed, stop the chemical factors that pour the concrete to cement that clump together.
So they're working on totally different parts of the process.
Right. Clinically, aspirin works mostly on high-pressure arterial clots, which cause heart attacks. Anticoagulants dominate the slower venous, side-deep vein thromboses, pulmonary embolisms, and atrial fibrillation. Treating one like the other leads to major clinical failures.
Okay, what about the spinach myth? The idea that if you are prescribed warfarin, you are never allowed to eat a green leafy vegetable again because they're packed with vitamin K.
The actual medical guideline is consistency, not total avoidance.
So you can eat it?
Yeah, if you love spinach, eat the exact same amount of spinach every single week. Your doctor will simply adjust your baseline warfarin dose to match your steady spinach intake.
That makes sense.
The real danger is eating zero vitamin K for a month, letting your body acclimate to that, and then suddenly eating 3 massive kale salads over a weekend. That sudden flood of vitamin K overwhelms the loading dock and sends your INR swinging wildly out of control.
And for patients who switch to the DOACs, it's often said they require absolutely zero monitoring. Just prescribe it and forget it.
Well, they don't need INR checks, which is a relief,
Yeah.
but they absolutely do require renal function monitoring.
Because of the kidneys.
Right. Drugs like dabigatran are cleared from the body heavily by the kidneys. If an elderly patient's kidney function starts to silently decline over a few years, the DOAC isn't filtered out. It builds up in their system, leading to dangerous, spontaneous bleeding, even though their daily dose never changed.
Which ties perfectly into a massive misconception about labs in general. You know, this idea that if a patient's INR is perfectly within the normal target range, they are completely safe from bleeding to death.
That is an incredibly dangerous assumption. A perfectly therapeutic INR just tells you the chemical speed of the clotting cascade in the blood. It doesn't mean the patient's physical anatomy is safe.
What do you mean?
If they have a structural lesion, like a deeply bleeding peptic ulcer in their stomach, they can easily hemorrhage to death even with a perfect INR. The drug isn't causing the bleed, it's just preventing the body from stopping it.
Wow. So we've tracked the history from lucky dog liver extracts to the isolation of literal rat poison in a blizzard. We've mapped the mechanic, you know, the fast-acting heparin wrench versus the slow-acting warfarin supply chain disruption, and the sniper-like modern DOACs.
We covered a lot.
We did. But why does walking this incredibly complex tightrope matter so much to the broader medical system today?
Well, if we connect this to the bigger picture, the stakes couldn't be higher. Take atrial fibrillation, an irregular heartbeat. It affects millions of adults worldwide. Because the blood pools in the heart, it is prone to clotting. If left untreated, AFib multiplies your risk of a devastating stroke by 5. Meanwhile, deep vein thrombosis and pulmonary embolisms are among the leading preventable causes of death in hospitalized patients.
That is why almost every single patient admitted to a hospital today gets a risk assessment and usually a preventative weight-based shot of Lovenox.
Exactly. And because that therapeutic window between fatal clotting and fatal bleeding is so incredibly narrow, anticoagulants are consistently ranked among the top drug classes responsible for serious adverse events and hospital readmissions.
So every single time a nurse double-checks a heparin drip rate against an APT lab or questions a physician's warfarin dose because the INR is creeping up to 4.8, they're literally holding a life in their hands.
They absolutely are. And this science is highly active. I mean, during the COVID-19 pandemic, the medical community realized the virus was triggering massive atypical clotting complications.
Right, that was a huge issue.
Suddenly, manipulating this assembly line became the absolute center of clinical trials and intense medical debate globally in 2020 and 2021. We are constantly searching for better ways to manage this biological system.
Which brings me to a final thought I want to leave you with. We spend so much time and billions of dollars fighting the coagulation cascade in medicine, but we have to remember that clotting is a profound evolutionary safety net.
It really is.
The exact same biological assembly line that saves us from bleeding to death when we get a tiny paper cut is the one that can kill us through a stroke. Right now, drugs like heparin and warfarin are brilliant life-saving tools, but they are incredibly blunt instruments.
Very blunt.
They don't actually cure the underlying disease. In medicine, we talk about Virchow's triad, the actual root causes of a clot. Those causes are stagnant blood flow, physical injury to the blood vessel wall, or a systemic hypercoagulable state in the body, like cancer or an infection. Anticoagulants don't fix any of those root causes. All these drugs do is artificially hold the assembly line workers apart so they can't finish the job. So the question is, as medical science advances far beyond the DOACs, will we eventually find a way to target the true root cause of the clot?
That's the million-dollar question.
Will we ever learn to actually fix the conditions on the factory floor rather than just disabling the human body's natural life-saving safety net? It's something to think about the next time you see a tiny scratch stop bleeding all on its own. Thanks for joining us on this deep dive. We'll catch you next time.
If you go into a clinic with a nasty cough, the protocol is pretty straightforward.
Right, they know exactly what to look for.
Exactly. The doctor pulls out a stethoscope, they listen to your lungs, and they search for a physical clue.
Yeah.
But what happens when the thing they need to examine is your mind?
Yeah, that's the big question.
I mean, how does a medical professional actually look at something completely invisible? There's no X-ray for a thought process. You can't, put a fractured mood in a cast.
It really is one of the most unique challenges in medicine. With a physical ailment, we like things to be visible, right? To be categorized.
Broken or not broken.
Exactly. Broken or not broken. But assessing the mind requires a completely different kind of tool set. It demands a framework that is highly structured, yet deeply reliant on human observation.
Well, today, we're doing a deep dive into a fascinating stack of sources. We've got historical psychiatric journals, modern nursing curricula, clinical case studies, and we're using all of it to explore the mental status exam, or the MSE.
It's a huge topic.
It is. We are going to systematically unpack how medical professionals assess the mind, the history behind these methods, and some of the surprising challenges in how we observe human behavior. So, okay, let's unpack this. What exactly are we talking about when we say mental status exam?
So to define it simply, the MSE is a systematic assessment of a patient's current cognitive, emotional, and behavioral functioning. And importantly, it's at a single point in time.
A single point in time.
Right. It's arguably the single most frequently used structured assessment in all of clinical practice. It is essentially the psychiatric equivalent of that physical exam you mentioned earlier.
So instead of checking reflexes, they're checking behaviors.
Exactly. Instead of palpating an abdomen or tapping a knee with a reflex hammer, the clinician is systematically observing things like a patient's appearance, their speech mechanics, mood, and their thought process.
I think it's really helpful to contrast it with a psychiatric history. Because the history asks, well, what has happened to this person over time?
Right, the background context.
Yeah, it's like a feature-length documentary of their life.
Yeah.
Capturing all the background. But the MSE is asking, what is happening with this person right now in this room? It's not a documentary. It's just a single Polaroid snapshot of the current moment.
That Polaroid analogy captures it perfectly. And the origins of that snapshot approach, they actually go back to a Swiss-American psychiatrist named Adolf Meyer.
Oh, okay. When was this?
This was in 1913. He was chairing the psychiatry department at Johns Hopkins, and he championed this concept called psychobiology.
Psychobiology. Sounds intense.
It was a big deal. He wanted to bring the same rigor and structured observation used in physical illnesses to mental health, which at the time really lacked that kind of standardization.
I mean, I can only imagine what psychiatric notes looked like before 1913. Just a total mess, probably.
They were caught between two extremes, really. On one side, you had these incredibly vague, narrative-only notes that were impossible to compare across different visits.
Like what?
A doctor might just write, patient seems melancholy today.
Wow. Very scientific.
Right, which tells the next doctor almost nothing. But on the other side, you had the system created by Emil Kraepelin in the 1890s in Germany, which basically forced patients into very rigid diagnostic boxes. Meyer wanted a middle path.
So he wanted detailed notes, but structured.
Exactly. He trained his residents to write detailed, organized notes, documenting exactly what was observed and said in the room. He wanted to respect the individual case, but keep it systematic.
But wait, if Meyer wanted this to be as rigorous as a physical exam, I have to ask, is this just entirely objective observation, or do clinicians have to rely on the patient's own words?
That's a great question.
Because, a patient can lie. Or they might just lack insight into their own condition. Right.
This raises an important point, and it's actually a core tension that remains unresolved in nursing and medical training even today.
Really? Still unresolved?
Yeah. Some textbooks treat the MSE as a purely observational exercise. So, built entirely from what the examiner sees and hears, like posture, eye contact, and tone of voice.
Just the raw data of observation.
Right. But others fold in patient self-reports, like suicidal ideation or hallucinatory experiences, which inherently depend on the patient's own words.
Because you can't observe a hallucination.
Exactly. And because these two traditions have never fully reconciled, you'll actually see MSE templates in hospitals that vary in what they include and in what order.
Okay, so you have this invisible thing, the human mind, and Meyer says we need to observe it systematically. How did the medical field actually go about dividing the mind into observable behavioral pieces?
They broke it down into specific domains, moving from the outside in.
Outside in. makes sense.
The first domain is appearance and behavior. When you walk into a room, before anyone even speaks, what do you see? This looks at grooming, hygiene, eye contact, and psychomotor activity.
Right, because a patient who is completely disheveled, malodorous, and won't make eye contact is conveying entirely different clinical information than a patient who is, say, meticulously groomed but pacing the room, wringing their hands, and agitated.
Oh, absolutely. And from there, the clinician moves to the next logical step, which is speech. But importantly, this domain is about the mechanics of speech, not the content of what they are saying.
So not the actual words.
No, we're looking at rate, volume, tone, and fluency.
So kind of like how fast the engine is running.
Exactly that. For example, pressured, rapid speech that's physically hard to interrupt, that's a classic hallmark of mania.
Oh, I see.
Conversely, slow, halting, quiet speech might indicate severe depression, or it could even point to a physical neurological issue like Parkinsonian bradykinesia.
Parkinsonian bradykinesia.
Yeah, which is that characteristic slowness of movement and speech you see in Parkinson's disease.
Okay, so we've looked at their clothes, their eye contact, we've listened to the rhythm of their voice. Then comes a domain that I really want to jump in on, because people confuse these two terms all the time in daily life.
I know exactly where you're going.
Mood versus affect. I like to think of it this way. Mood is the Yelp review the patient gives themselves. Affect is the health inspector's objective report.
That is a brilliant way to put it.
Right. You can say you feel fine, that's your mood, your subjective self-report, but you might look completely flat or tearful or inappropriately giddy. That's the affect, the objective observation by the clinician.
What's fascinating here is that a mismatch between those two things, what clinicians call incongruence, is actually a highly significant clinical finding.
Incongruence.
Yes. If a patient tells you their mood is depressed, but their affect is inappropriately cheerful, laughing while discussing something tragic, that mismatch tells the clinician something crucial about their neurological or psychological state.
The Yelp review does not match the kitchen conditions.
Precisely.
That is such a vivid way to look at it. But eventually you have to decode what's actually happening inside their head. I mean, how do you assess a thought you can't hear?
You assess it through the next domain, which is thought process. This isn't about what the ideas are, but how the ideas connect.
Okay, how they connect.
Right. A normal thought process is called linear or goal-directed, but then you have variations. For instance, a circumstantial thought process.
Circumstantial.
That's when someone gives you an excessive amount of unnecessary detail before finally reaching the point.
Oh, we all know someone who tells stories circumstantially. My uncle is definitely circumstantial. But why does that happen clinically?
Mechanically, the brain is either struggling to filter out irrelevant stimuli or it's hyper-focusing on chronological accuracy. Then there's tangential thought process, where they drift off point and never return to the original question.
They just keep drifting.
Yeah. And if the brain is firing even faster, you get a flight of ideas, which is rapid topic jumping. The connections are loose, but you can still vaguely follow the thread. This is classic in mania.
Okay, so there's still a thread.
Barely, but yes. And finally, you have loose associations, or word salad, where there is little to no logical connection between words at all. The underlying cognitive structure has completely broken down, which is classically seen in schizophrenia.
Now, if you're listening to this and thinking, wait, I definitely talk in a tangential way when I'm tired, the key difference here is severity, right?
Yes, absolutely.
We're talking about a level of disruption that actively impairs functioning. So that's how they think. The next domain is thought content, which is the actual substance.
Right, the what instead of the how.
Exactly. This is where clinicians look for delusions which are fixed, false beliefs not shared by the person's culture. And critically, this is where they explicitly screen for suicidal or homicidal ideation, documenting the plan, the intent, and the means.
And it goes even deeper into how the patient interacts with reality. Closely related to thought content is perception, which is how the patient is experiencing the sensory world. Here, we differentiate between hallucinations and illusions.
There's a difference.
A big one. A hallucination is a sensory experience without any external stimulus, like hearing a voice when the room is totally silent. An illusion is a misinterpretation of a real stimulus.
Oh, like mistaking a coat hanging on a chair in a dark room for a person standing there. There's an actual code. The brain just misreads it.
Precisely. And the final standard domain before we get to cognition is insight and judgment.
Insight and judgment.
Yeah. Insight is whether the patient recognizes they have a medical problem at all. Judgment is whether they can reason sensibly about it. There's actually a classic generation-spanning nursing exam question used to test judgment.
Oh, what is it?
It goes like this. What would you do if you found a stamped, addressed envelope on the sidewalk?
You put it in the mailbox.
Right. But if a patient says, I'd open it and look for cash, you note poor judgment.
That's wild. It's amazing how much data you can gather just by observing and asking a few structured questions. But we held back one major domain, which is cognition.
Yes, the cognitive domain.
This includes things like orientation to person, place, and time, as well as memory and attention. This used to just be an art, right? A clinician just writing, patient seems confused. But it shifted into a scored psychometric science. Why did that shift happen?
It happened because, seems a little confused, is a dangerously subjective phrase. In 1975, Marshall Fulstein, Susan Fulstein, and Paul McHugh, also at Johns Hopkins, continuing that Meyer tradition, they published the Mini Mental State Examination, or the MMSE.
EMMSE.
They built it explicitly as a 10-minute bedside tool. Busy clinicians didn't have time for hour-long neuropsychological testing, so early cognitive impairment was routinely being missed.
They just didn't have the time to catch it.
Exactly. The MMSE gave them a rough reproducible number out of 30 points, with 23 or 24 generally serving as a cutoff for cognitive impairment.
But then, decades later in the late 1990s, a Montreal-based neurologist named Ziad Nasruddin developed the Montreal Cognitive Assessment, the MoCA, which was published in 2005.
MoCA, yes.
If we already had the MMSE, why did we need a new test?
Because the MMSE had a significant blind spot. It was known to miss milder cognitive impairment, particularly in executive function and visuospatial tasks.
Visuospatial tasks, like drawing.
Exactly. For example, the MMSE barely probes drawing skills. It just asks you to copy a simple intersecting pentagon. The MoCA was designed as a direct rebuttal to catch the subtle deficits that the 30-year-old tool was missing.
That makes sense.
But this shift sparked a massive debate about art versus science in medicine. Does turning a complex human being into a 30-point score grant us vital objectivity, or do we lose the nuance of clinical judgment?
Here's where it gets really interesting, though, because you'd think the medical evidence, the science of which test caught dementia better, is what determined which test hospitals decided to use.
You would think so.
But according to our sources, there was this massive copyright drama. Unlike most clinical scales, the MMSE was aggressively copyrighted. In 2001, a company called Psychological Assessment Resources, or PAR, began enforcing licensing fees for using the MMSE.
It genuinely shocks most medical and nursing students today when they learn that.
I bet.
They assume a decades-old bedside screening tool, a fundamental part of the exam, would just be free and in the public domain.
Right. The idea that a tool for assessing basic human cognition could be aggressively paywalled is wild. And because of those fees, it drove clinicians and hospitals en masse to the MoCA, which its developer had made freely available for clinical use at the time.
It's crazy.
It's a stark reminder that copyright law and financial access, not just medical evidence, actively shape the standard of care.
It's a prime example of how external factors influence medical practice. But there is a deeper structural flaw in these standardized cognitive tools beyond just copyright.
Deeper than copyright.
Oh, yeah. Cultural and educational bias. The cognitive domain often tests attention with tasks like subtracting serial sevens from 100 or spelling the word world backward. It involves copying geometric shapes.
Okay, I see where this is going.
All of this assumes a baseline of formal education and English literacy.
So a patient with limited formal schooling might score artificially low and be labeled as cognitively impaired just because they struggle to spell world backward.
Yes, the test might flag them for dementia when really it's just a reflection of their educational background. And conversely, we see what's called a ceiling effect. Highly educated patients with genuine early-stage dementia might score artificially high on the MMSE or the MoCA.
The ceiling effect is almost like testing a professional athlete's fitness by asking them to walk up a single flight of stairs.
That's a great analogy.
They might have a sprained ankle, but they're so fit overall they can easily hide it. Highly educated patients can mask their cognitive decline on these basic tests.
That's a perfect way to conceptualize it. They use their high cognitive reserve to power through the basic questions, masking the deficit. This is why geriatric specialists argue these scores should never be interpreted in a vacuum.
If even our mathematically standardized cognitive tools have these built-in vulnerabilities, what happens when our purely observational judgments, the way we look at someone's affect or behavior, are clouded by pre-existing labels?
That brings us to one of the most famous cautionary tales in psychiatry, which really underscores the stakes of the mental status exam.
The Rosenhan study.
Yes. David Rosenhan's 1973 study on being sane in insane places, published in the journal Science. Rosenhan and 7 Confederates acting as pseudo-patients went to psychiatric hospitals with a single complaint. They reported hearing a voice saying the words empty, hollow, and thud.
Just those 3 words.
Just those 3 words. And based on that alone, all of them were admitted, most with a diagnosis of schizophrenia.
Unbelievable.
Now, once they were admitted to the psychiatric wards, they dropped the symptom entirely. They behaved completely normally, they were friendly, cooperative, and reported no further voices.
And surely the trained medical staff noticed they were totally fine. I mean, they were observing them constantly, right?
They didn't. In fact, the staff continued to interpret their ordinary, everyday behavior through a pathological lens.
How is that possible?
Well, one of the pseudo-patients was a researcher who would sit and take notes on the ward. The nursing staff charted this not as someone writing a letter or taking notes, but as patient engages in writing behavior.
Writing behavior.
They took a mundane activity and forced it to fit the symptom profile of their diagnosis.
Writing behavior. That is genuinely horrifying. We're laughing, but it's terrifying. If highly trained medical staff can look at someone simply taking notes and call it writing behavior, how can we ever trust the so-called objective affect and behavior observations we talked about in the earlier domains?
It's a huge problem.
How does a clinician stop their own expectations from creeping in?
If we connect this to the bigger picture, the Rosenhan study is the ultimate warning against confirmation bias in clinical observation. It proves that once a diagnostic label is attached to a patient, it can hopelessly distort real-time mental status observation.
It just colors everything.
Completely. These pseudo-patients were hospitalized for an average of 19 days, one was kept for 52 days, and when they were finally discharged, it wasn't because they were deemed sane.
Wait, what did the discharge paper say?
Their charts read schizophrenia, in remission.
Wow. They never shook the label. The label became the lens for every single observation. Even their sanity was just categorized as a temporary pause in their insanity.
It's a sobering reality, and it reinforces the core takeaway of this entire framework. The MSE is just a snapshot, a description of current functioning. A chart's history must never override present moment observation.
Before we wrap up, I think this is a really good time to clear up some neighboring terms in the medical world. Because if you watch medical dramas or read hospital charts, there are a lot of acronyms that sound similar but do very different things.
Oh, definitely. Alphabet soup.
For instance, the GCS or the Glasgow Coma Scale. Is that part of the mental status exam?
It's a related but distinct tool developed in 1974. The GCS measures something that happens prior to a full mental status exam.
Prior to it.
Right. It measures basic arousal and the level of consciousness, like eye-opening and motor response, usually after a brain injury. The EMT in the ambulance might use the GCS. The MSE assumes you're already awake and alert enough to have the actual content of your thought assessed.
Right, because you simply can't assess the thought process of someone in a coma.
Exactly.
Okay, so GCS is the EMT in the ambulance. What about the CAM, the Confusion Assessment Method? Where does that fit in?
The CAM was created by Sharon Inouye in 1990, and it's brilliant because it takes specific domains from the MSE, like inattention and disorganized thinking, and operationalizes them into a fast algorithm for bedside nurses.
So it's like a quicker version?
Sort of. It helps them rapidly distinguish delirium from dementia.
Which is incredibly important, right? Because delirium is a sudden, acute state often caused by a physical illness, whereas dementia is a chronic progressive decline.
Exactly. The treatment for those two conditions is entirely different, so the CAM uses mental status observations to quickly point the clinician down the right diagnostic path.
That makes a lot of sense.
Also, just a quick note for our international listeners in the UK and Commonwealth countries, you'll often hear it called the mental state examination. Same content, just a slightly different name that occasionally trips up medical students studying abroad.
State versus status. Good to know. Let's also clear up some common misconceptions about the MSE as a whole. First of all, it's not just for psychiatric patients.
Not at all. It is used constantly in emergency departments, medical surgical units, and ICUs. It's used to catch conditions with no psychiatric cause whatsoever.
Like what?
For instance, hepatic encephalopathy, which is when liver failure causes toxins to build up in the bloodstream and affect the brain. The first sign of that physical failure is often a change in the patient's mental status.
Wow, so the liver fails and the brain shows the first symptoms. And it's not a one-and-done test either.
No, it requires serial testing. Doing an MSE once doesn't tell you much about a trajectory. Repeating it shift after shift is what reveals the fluctuating course of delirium, catching changes from a patient's baseline.
Because you had to see the movement over time.
Exactly. And most importantly, as we mentioned earlier, the MSE does not produce a diagnosis. It produces a description. A diagnosis requires that description, plus history, collateral information, and time.
So what does this all mean? Why should you, the listener, care about the intricacies of the mental status exam?
It's a valid question.
It matters because this structured observation is the exact tool that catches a stroke when it's masquerading as someone just being tired. It's what catches a urinary tract infection in an elderly patient when it looks exactly like sudden onset dementia.
It's life-saving.
It is the frontline defense for making sure the invisible mind gets the same rigorous life-saving care as the physical body.
And it is a field that is still actively evolving. Right now, telehealth is completely disrupting mental status assessments.
Oh, I bet. Doing this over Zoom has to be hard.
It's incredibly difficult. Think about the domains we discussed. Clinicians now have to assess psychomotor activity, affect, and subtle eye contact over a video screen, often dealing with internet lag and poor lighting.
It's totally different.
It's an active, unresolved debate in the medical community about what can and cannot be reliably assessed when you aren't sharing a physical room with the patient.
It's the MSE trying to adapt to the digital age. But I want to leave you with a final thought to mull over. Building on the sheer horror of that Rosenhan study and the danger of diagnostic labels.
The writing behavior.
Yes, the writing behavior. In our daily lives, outside of hospitals and clinics, how often do we perform an informal, deeply flawed mental status exam on our friends, our coworkers, or our family members?
That's a great point.
How often do we filter their completely normal behavior through the pre-existing labels we've already assigned to them? We assume we're observing them clearly, like looking at a clean X-ray. But maybe we're just seeing the fractures we expect to find. 4 million years ago, in this cave system in New Mexico, perfectly sealed off from the surface of the earth, bacteria were just thriving.
Yeah, Lechugiet Cave.
Right, Lechugiet Cave, completely isolated. I mean, never touched by human hands, never exposed to human medicine at all.
Right.
Yet, when researchers recently went down into that cave and swabbed the bacteria they found, those microbes were, already completely immune to synthetic antibiotics. Drugs that humans wouldn't even invent until the 1990s.
It's wild. It completely upends the way we, traditionally think about medicine.
Totally.
Because we tend to view antibiotic resistance as this very modern 20th century disaster. Like we accidentally created it in our hospitals.
And today, we're unpacking why that assumption is just fundamentally wrong. Welcome to the Deep Dive. Today, we're looking at a massive stack of clinical notes, microbiology research, and nursing texts to really understand the reality of antibiotic resistance for you.
It's such an important topic.
It really is. We are going to explore how superbugs actually fight back, the mechanics behind why the pharmaceutical market is fundamentally broken, and what antimicrobial stewardship really means for you, and, well, the healthcare workers trying to keep us safe.
Because the truth is, we didn't invent antibiotic resistance.
No. We really didn't. We just accidentally escalated an ancient war.
Exactly. And to understand the scale of that escalation, you really have to look at the very beginning of the antibiotic era.
Right.
When we picture the origin of these drugs, the default image is always Alexander Fleming, right? In 1928, discovering penicillin by accident on a dirty Petri dish.
Yeah, the classic science class story.
Right, and we treat it as the ultimate triumph of modern science over nature.
But, the clinical history shows a much darker follow-up to that discovery. Because here's where it gets really interesting. If you read the transcript of Fleming's 1945 Nobel Prize acceptance speech, he doesn't take a victory lap.
Not at all.
The founding father of antibiotics uses his moment on the world stage to predict their undoing.
It's haunting, honestly. He describes an experiment where he deliberately exposed bacteria to non-lethal doses of penicillin and just watched them adapt to survive it.
Wow.
Yeah, he warned everyone in 1945 that public demand would lead to underdosing and, casual use, and that would inevitably breed resistant strains.
He saw the underlying biology for exactly what it was, and his timeline was incredibly accurate, too.
It really was. Within 3 years of that speech, resistant staph strains became a documented, life-threatening problem in British hospitals.
3 years.
Yeah. He forecast the crisis before the crisis even had a name.
Which I think raises a foundational question about what we are actually measuring here. When a doctor says an infection is resistant, we tend to think of it like a binary switch.
Right, like the bug is wearing a bulletproof vest and is just completely immune.
Exactly. But the clinical sources suggest it's a lot more complicated than a simple yes or no.
It is highly nuanced. In a microbiology lab, resistance is defined by something called a breakpoint. They use a measurement known as the minimum inhibitory concentration, or MIC.
MIC.
Basically, lab technicians expose the bacteria in a petri dish to increasing concentrations of an antibiotic. The MIC is the lowest concentration of the drug that successfully stops the bacteria from visibly growing.
So there is a specific measurable line in the sand then.
Exactly. International committees look at that MIC data and establish a breakpoint dosage. If the bacteria can survive a dose higher than that breakpoint, the lab report classifies them as resistant.
And if they die at a lower dose?
Then they are classified as susceptible.
But, I mean, if I'm understanding the clinical notes correctly, what happens in a pristine, perfectly controlled petri dish doesn't always translate to the absolute chaos of a human body.
Oh, not at all.
Because you could have a lab report that says, this bug is susceptible to this drug, but when the patient actually takes the pill, nothing happens, they just stay sick.
That is the absolute nightmare scenario for clinicians. We call it the difference between microbiological resistance and clinical resistance.
Oh, okay. Break that down for me.
Well, in a lab, the drug has direct, unimpeded access to the bacteria. But in a patient's body, the drug has to navigate a very messy environment. Let's say the infection is deep inside a lung abscess.
Right.
The antibiotic physically might not be able to penetrate the tissue to even reach the bacteria. Or the bacteria might have formed a biofilm.
Oh, right. A biofilm is like a protective, slimy fortress they build on surfaces, right? Like on a catheter or, I don't know, an artificial joint implant.
Precisely. The bacteria secrete this sticky matrix that acts like a physical shield. The antibiotic molecules just bounce right off the outer layer.
Wow.
Yeah, so inside that fortress, the bacteria are technically susceptible to the drug. I mean, if you took them out and put them in a petri dish, the drug would kill them easily.
But clinically, because of the biofilm, they are acting resistant.
Exactly.
Right.
It makes diagnosing and treating these infections an incredibly murky process.
Okay, so if microbiological resistance is like a criminal escaping a trap in a controlled laboratory, clinical resistance is whether they survive in the wild.
Like a patient's body. Exactly.
Right. But if these bacteria are navigating complex human biology and building literal fortresses, how are they adapting so quickly? We spend billions of dollars and decades of research designing a single synthetic chemical to kill them, and they just figure out a loophole in a matter of years.
It's staggering.
What is the actual mechanism driving that speed?
Well, it is Darwinian natural selection, but running at a speed we can barely comprehend. Under the right conditions, a bacterial population can reproduce every 20 to 30 minutes.
Wait, really?
Sure.
So in the time it takes to eat lunch, an entire generation has lived and reproduced?
Yes, and every single time they replicate their DNA, there is a tiny chance for a random mutation. Now imagine a patient with a billion bacteria in their system.
Okay.
They take an antibiotic. Almost all of those bacteria die. But just one of them happens to have a random genetic mutation that allows it to survive the drug. Suddenly, that single survivor has zero competition for nutrients. Within a day or two, that one mutant strain reproduces and completely repopulates the space. And now the entire infection is resistant.
That's terrifying. The research points out that they don't just rely on waiting for random mutations.
Yeah.
They are actively trading genetic information with each other, which, accelerates the process exponentially.
Right. This is a mechanism called horizontal gene transfer. Bacteria have these small circular loops of DNA called plasmids, which exist totally separately from their main chromosome.
Right.
And these plasmids often carry the specific genes that provide antibiotic resistance.
It's like a biological USB drive loaded with a survival manual.
That is a perfect analogy. And through a process called conjugation, two bacteria can physically connect to each other and pass a copy of that plasmid across.
That's so creepy.
It gets worse. What makes this truly dangerous is that they don't even have to be the same species.
Wait, really?
Yeah. A harmless strain of E. coli living in your gut could theoretically possess a resistance plasmid and hand it directly over to a deadly Klebsiella bacterium just passing through.
So they are literally crowdsourcing their own survival.
Exactly.
And the specific tools they're trading on those plasmids are fascinating. The sources highlight 4 primary mechanisms of defense, and I really want to walk through the actual biochemistry of how they work because it's wild. Defense number 1 is enzymatic destruction.
Right. This is essentially chemical warfare. The bacteria produce an enzyme that acts like a pair of molecular scissors.
Okay.
Before the antibiotic can even reach its target on the bacterial cell, this enzyme intercepts it, snips the chemical structure of the drug apart, and just renders it completely harmless.
The classic example is beta-lactamase, which destroys penicillin. But the one that really stood out in the research is an enzyme called NDM1.
Yes.
It was first identified around, I think, 2008, and it specifically destroys a class of antibiotics called carbapenems.
And carbapenems are crucial. They are broad-spectrum, incredibly potent intravenous drugs that hospitals keep locked behind figurative glass.
Like the big guns.
Exactly. We only use them as an absolute last resort when every other drug has failed.
Yeah.
The fact that bacteria can trade a plasmid carrying the NDM1 enzyme, an enzyme that effortlessly shreds our last line of defense, that's why public health officials view horizontal gene transfer as a literal global security threat.
That makes total sense. Okay, so defense number 2 is target modification. If the enzyme is like intercepting the drug, target modification is like changing the locks on the door, right?
Right. The bacteria alter the physical shape of the receptor site on their cell wall.
So the antibiotic still arrives, but its molecular key no longer fits the lock, so it just bounces off.
Exactly. And then defense number 3 is arguably the most resource-intensive for the bacteria, but highly effective. efflux pumps.
This one is wild. The bacteria literally build microscopic vacuum pumps into their cell membranes.
Yeah.
The antibiotic enters the cell, and before it can do any damage, the pump catches it and spits it right back out into the environment.
Yeah.
It is exactly like bailing water out of a sinking boat faster than it fills up.
It's a great visual, and it requires a massive amount of cellular energy to run those pumps constantly, but, it keeps the organism alive.
Right.
And the 4th mechanism is simply reduced permeability. The bacteria just shut down the microscopic pores, or porins, that the drug normally uses to enter the cell.
They just close the door.
Yeah.
So knowing that bacteria possess this highly sophisticated, tradable arsenal of scissors, pumps, and changing locks, we have to go back to that cave in New Mexico, because it completely recontextualizes where these weapons came from.
If we connect this to the bigger picture, yeah, it really does. When you see a bacterium destroy a modern synthetic drug, the intuitive thought is that we invented the medicine, and the bacteria reacted by inventing the defense.
Right, but the bacteria in La Shugia cave, isolated for 4 million years, they already had the efflux pumps and the beta-lactamase enzymes. Humans didn't invent antibiotic resistance.
We absolutely did not. Fungi and bacteria have been fighting a microscopic turf war over nutrients in the soil for millions of years.
Wow.
Fungi naturally evolved to secrete antibiotics to kill competing bacteria, and bacteria evolved these enzymes and pumps to survive the fungi. All human medicine did was borrow the fungi's weapons.
So the crisis isn't that we created these defenses.
No, the crisis is that by dumping thousands of tons of antibiotics into our bodies and our agricultural systems, we applied a massive, unnatural selective pressure. We killed off all the susceptible, undefended bacteria on the planet, leaving only the ones holding the ancient survival manuals to inherit the earth.
We took a million-year-old local arms race and turned it into a global biological world war.
That's one way to put it, yeah.
And when you realize how primed they are to survive, the speed of modern superbugs makes terrifying sense. Let's look at the poster child for this issue. MRSA, methicillin-resistant Staphylococcus aureus.
Right, so Staphylococcus aureus is a very common bacterium. It lives harmlessly on the skin or in the noses of about 1/3 of the human population.
Okay.
But if it gets into a wound or the bloodstream, it can be lethal. And in the mid-20th century, staph quickly became resistant to standard penicillin.
So pharmaceutical scientists went back to the lab and developed a tougher, semi-synthetic drug called methicillin, which was explicitly designed to bypass the staph's enzymatic scissors, right?
Exactly. They introduced it in 1959.
And in 1961, just 2 years later, a microbiologist in the UK named Patricia Jevons isolated the first strain of staph that had adapted to survive it.
MRSA was born in 24 months.
That's just incredibly fast. And reading the clinical notes, there is a major shift in how MRSA operates today compared to a few decades ago. It used to be strictly a nosocomial infection, meaning you really only caught it inside a hospital if you had an IV line, a surgical wound, or like a severely compromised immune system.
Yeah, that is no longer the case. We are now dealing with community-acquired MRSA or CA-MRSA.
Right.
These strains have evolved to infect completely healthy individuals out in the general public. We see outbreaks among athletes sharing gym equipment, military recruits in barracks, or inmates in crowded prisons.
Just healthy people living their lives.
Yeah. It causes severe, rapidly spreading skin infections that can easily turn systemic. The bacteria have broken out of the hospital environment.
While MRSA is the classic example of a superbug ignoring a drug, the sources also highlight a totally different kind of threat, Clostridioides difficile, or C. diff.
Yes.
And this one completely flips the script on how we view infections, because it acts more like an opportunistic ecological disaster than a direct attack.
C. diff perfectly illustrates how delicate the human microbiome really is. A healthy human gut is a densely packed ecosystem containing billions of beneficial bacteria. It operates like a highly competitive, old-growth forest.
Right.
There might be a few C. diff spores naturally present in that forest, but they are harmless because the beneficial bacteria are consuming all the nutrients and physically taking up all the space on the intestinal walls.
But then, a patient goes to the doctor for something completely unrelated, say a severe urinary tract infection, or even a dental procedure.
Yeah.
And they are prescribed a broad-spectrum antibiotic.
And that antibiotic enters the digestive tract, and because it is broad spectrum, it doesn't just kill the bacteria causing the UTI, it acts like a wildfire ripping through the gut, indiscriminately wiping out the entire protective forest of beneficial flora.
But the C. diff survives.
It survives because C. diff has the ability to form incredibly hardy, resilient spores that can withstand both the antibiotic and harsh stomach acids. Once the antibiotic course is finished, and the chemical wildfire dies down, those C. diff spores wake up. They look around and find an entirely empty landscape with zero competition and unlimited food.
So they just take over.
They multiply exponentially and begin releasing toxins that attack the lining of the colon.
This leads to colitis, which is a severe, life-threatening inflammation of the colon. The clinical descriptions of the resulting diarrhea and tissue damage are just harrowing, and it hit me reading this. C. diff is an infection that is essentially caused by the very antibiotics meant to heal us.
Exactly.
It's clinical collateral damage.
It is the ultimate paradox of modern medicine. In the early 2000s, a specific hyper-aggressive strain of C. diff mutated and swept through hospitals in Quebec. Patients were coming in for routine, low-risk surgeries, receiving standard preventative antibiotics, and ending up with catastrophic colon damage simply because the drug cleared the path for the C. diff to take over.
That's awful. Now, if bugs like MRSA are outsmarting our drugs in 2 years, and broad-spectrum antibiotics are causing collateral disasters like C. diff, the logical question any listener would ask is, why don't we just invent new, highly targeted drugs?
It's a fair question.
Right. Why aren't pharmaceutical companies working around the clock to stay ahead of this?
Well, the science is certainly challenging, but the real barrier is economics. The market for antibiotics is fundamentally structurally broken.
How does a drug that literally saves lives end up being a bad business model?
Think about the incentives from a pharmaceutical executive's perspective. It costs upwards of $1 billion and takes a decade to bring a new drug through clinical trials to FDA approval.
A huge investment.
Right. Now, if you invent a new medication for a chronic condition like high blood pressure, diabetes, or cholesterol, a patient is going to take that pill every single day for the rest of their life. That guarantees decades of steady revenue to recoup the research costs.
But an antibiotic course is incredibly short. A patient takes it for 7 to 10 days, and at the end of that week, they are either cured or they are dead.
Exactly. The volume of sales is inherently low, but it gets worse.
How could it get worse?
If your company manages to invent a truly revolutionary, highly effective last resort antibiotic, the medical community will actively suppress your sales.
Wow.
Good hospital policy dictates that we lock that new drug away and say, do not prescribe this unless every other cheaper, older drug has failed. We have to hold it in reserve to prevent the bacteria from developing resistance to it.
So you spend $1 billion making a perfect product, and your primary customers are ethically obligated not to buy it.
Pretty much.
The sources provided a devastating real-world example of this mechanism in action with a company called Acaergen in 2019.
Acaergen is the ultimate cautionary tale for antibiotic development. They did everything right. They spent years developing a vital new antibiotic called plazomicin, designed specifically to target highly resistant, life-threatening urinary tract infections.
And the science was solid.
The science was brilliant. The FDA enthusiastically approved it.
And they filed for bankruptcy just months later.
Because the medical community appropriately held plasmamycin in reserve, Achaogen couldn't generate enough revenue from the minimal sales to keep their laboratories open.
That is tragic.
When they collapsed, it sent a massive chilling effect through the industry. Most major pharmaceutical giants have completely abandoned antibiotic research because it basically guarantees a financial loss.
Which is why public health experts are now desperately arguing for pull incentives to artificially fix the market.
Right. If the free market won't pay for antibiotics, governments have to step in. The United Kingdom's National Health Service is currently testing a subscription model, often called the Netflix model for antibiotics.
I love that name.
Yeah, instead of paying the pharmaceutical company per pill sold, the government pays them a massive, flat annual subscription fee just to have the drug available in their national arsenal.
So it completely severs the link between the volume of drugs sold and the company's profit. It pays for the value of the drug's existence, not its usage.
Exactly. It's like maintaining a fire department. You don't pay the firefighters per fire they extinguish. You pay them to be fully funded and ready when the alarm rings.
That makes perfect sense. But economics isn't the only deeply ingrained system being challenged right now. The sources show that some of the most fundamental behavioral rules of medicine are under intense scrutiny. And one of them directly challenges the agricultural industry.
Oh, this is a big one.
Yeah, if we're this worried about human prescriptions, how does agriculture fit into this selective pressure equation?
It is a massive piece of the puzzle. Historically, well over half of all antibiotics manufactured globally didn't go to human hospitals. They went to livestock.
More than half.
Yes, and they weren't just used to treat sick animals. They were routinely mixed into the daily feed and water of perfectly healthy chickens, pigs, and cows to artificially promote faster physical growth and prevent disease in tightly packed factory farms.
But how does a resistant bug inside a chicken actually reach a human being living in a city who, I don't know, maybe doesn't even eat meat? What is the actual mechanism of transfer?
The biological bridge is environmental. When millions of animals are fed antibiotics daily, their guts become breeding grounds for resistant bacteria. Those resistant bugs are excreted in massive amounts of manure.
Oh, I see where this is going.
Right. That manure is often used to fertilize crops, or it runs off into the local soil and groundwater. The resistant bacteria enter the human food chain through contaminated produce, or enter the water supply directly.
Wow.
Once a human ingests them, those agricultural bacteria can use horizontal gene transfer, like we talked about earlier, to pass their resistance plasmids directly to the human's normal gut flora.
It's a continuous invisible loop. And I should note, we are just reporting on what the clinical texts outline here. While the European Union banned the use of antibiotics for growth promotion in 2006, and the US FDA eventually tightened rules around 2017, the global economic incentives for cheap meat mean this remains a deeply contentious and ongoing driver of resistance worldwide.
It is heavily debated. Which brings us to the debates happening on the human side of the equation. One of the most controversial topics in the clinical texts right now centers around a 2017 paper published in the British Medical Journal challenging the oldest rule in the book.
The rule to always finish your antibiotic course.
Yes.
Hang on. My entire life, every doctor and pharmacist has drilled this into my head. Even if fever drops on day 3 and you feel totally fine, you have to finish all 10 days of the pills or you will create a superbug. It is medical gospel.
It has been the gospel for decades. But Martin Llewellyn and his colleagues published this BMJ paper arguing that for many common infections, the evidence supporting that rule is actually incredibly weak. In fact, they proposed the exact opposite. They argued that taking antibiotics for longer than clinically necessary might actually increase the selective pressure that breeds resistance because you are keeping the surviving bacteria exposed to the drug for a longer period, forcing them to adapt.
Wait, but if I start taking my pills on day 3 just because I feel better, aren't there still bacteria left in my system? Won't they just multiply and come back stronger? That feels incredibly dangerous to advise.
And that is exactly the pushback they received, and we have to view this impartially because it is fiercely debated. Many clinicians strongly oppose changing the messaging. Their primary fear is exactly what you just described: undertreatment.
Right.
If a patient stops too early without medical supervision, the infection could relapse, and a relapsed infection is often much harder to clear. The BMJ authors counter that we need highly individualized, shorter treatment durations based on clinical recovery rather than arbitrary 10-day rules.
It is a terrifying tightrope for a doctor to walk.
You are balancing the immediate survival of the patient in front of you against the long-term survival of the drugs globally.
It is. And for anyone listening, this remains an active area of research. Guidelines are slowly changing for specific infections, but it requires strict medical guidance, not a decision a patient should ever make on their own.
With the pharmaceutical pipeline stalling, the agricultural loop constantly feeding resistance, and the basic rules of prescription under debate. What is the actual defense strategy for healthcare workers today?
The vanguard of our defense right now is antimicrobial stewardship.
So, what does this all mean for you? Before we break down how stewardship works, we need to clear up the single biggest misconception that the general public holds about this entire topic.
The tolerance myth.
Yes, the idea that if I take too many antibiotics, my body will eventually become resistant to them.
We have to completely erase that idea from our minds. The human body does not become resistant to antibiotics. You do not build up a physiological tolerance to penicillin the way your brain builds up a tolerance to caffeine or alcohol.
Right.
The drug targets the biology of the bacteria, not the biology of the human.
The bug evolves, not you.
Exactly. When you take an unnecessary antibiotic, you are selectively breeding the toughest, most genetically fortified bacteria inside your own microbiome. Those superbugs are what stick around to infect you later or spread to your family.
Wow.
That is the core of antimicrobial stewardship, preventing that selective breeding. It is the organized, hospital-wide effort to ensure that a patient receives the right drug at the exact right dose for the right duration, targeting a specifically identified bug.
And reading the nursing literature, you realize stewardship isn't just a top-down policy for doctors. It is a grueling, daily operational reality for nurses on the floor.
It absolutely is.
It is a nurse practicing relentless hand hygiene and contact isolation to ensure a patient's MRSA doesn't physically travel on a stethoscope to the susceptible patient in the next room.
It is a nurse monitoring a patient on broad-spectrum antibiotics, noticing the onset of diarrhea, and instead of just writing it off as a routine side effect, advocating for a C. diff test before the spores can spread.
It's the frontline workers having the clinical courage to look at a doctor's chart and ask, does this patient really still need this IV antibiotic, or can we step them down? Because every single unnecessary dose is a microevolutionary event.
Every prescription alters the biological landscape.
So to summarize where we have been today, we started with Alexander Fleming's haunting warning that human behavior would rapidly undo his miracle discovery. We explored how bacteria leverage their 20-minute life cycles and tradable plasmids to deploy ancient weapons like NDM1 and efflux pumps.
Yep.
We looked at how fast MRSA breaks out of hospitals and how the collateral damage of broad-spectrum drugs essentially creates the devastation of C. diff. And we unpacked why fixing this requires massive interventions like the UK subscription model to repair a pharmaceutical market that actively punishes innovation.
It is a deeply interconnected web. And that brings up a crucial concept from the sources that I want to leave you with. The One Health framework.
The idea that human health doesn't exist in a vacuum.
Exactly. Everything we covered today, the isolated caves, the factory farms, the hospital wards, they are all linked. The One Health framework dictates that you simply cannot solve antibiotic resistance by strictly regulating a hospital in London or New York.
Right.
The resistant plasmids moving through the gut of livestock eventually end up in the soil, which washes into the agricultural runoff, which enters the human food supply, which walks through the front door of the hospital. We share a single, fluid, microscopic ecosystem.
It fundamentally changes how you view a trip to the pharmacy. The next time you are handed a prescription for an antibiotic, you aren't just taking a pill to clear up a cough. You are physically interacting with 4 million years of evolutionary history, and the choices we make with those drugs ripple through a global biological network.
It really puts it in perspective.
It does. The expectation of a clean, perfectly predictable medical diagnosis is just a comforting illusion.
We are navigating incredibly muddy waters. But by understanding the biology, the economics, and the history beneath the surface, at least we finally know which way the currents are pulling us.
Well said. Thank you for joining us on this deep dive. Stay curious, and we'll catch you next time. Imagine waking up tomorrow and being told you will never take another bite of food for the rest of your life.
Which is just a terrifying thought for most people.
Right, like no sandwiches, no chewing, no swallowing, no sitting around a dinner table. Yet you are going to survive.
Yeah, completely survive.
Your body will get every single calorie, every vitamin, and every gram of protein, and it needs to keep going. Today we are looking at how modern medicine pulls off this impossible magic trick.
It really does feel like magic.
It does. Because we're talking about completely bypassing one of the most fundamental biological processes we have. Welcome to the deep dive.
Glad to be here for this one.
So we are exploring a stack of medical and nursing sources centered on an incredible high-stakes intervention called total parenteral nutrition, or TPN.
Which is a massive topic.
Huge. We are going to explore how doctors and nurses manage to keep human beings alive by feeding them entirely through their veins. We'll get into the intense chemical engineering required to make that happen.
And the complications, too.
Exactly. The highly counterintuitive reasons why the medical community actually hates using this miracle technology unless they have absolutely no other choice.
Yeah. The journey to making this work is, it's a perfect example of a medical advancement that solves one massive fatal problem only to introduce a dozen complex new biological challenges.
Right.
Because bypassing the human digestive system completely is not something the body accepts without a fight.
Okay, let's unpack this. Because on the surface, feeding someone a full diet through an IV sounds like pure science fiction.
Oh, absolutely.
But it happens every single day in intensive care units and even in people's homes. So let's ground ourselves in the terminology first, total parenteral nutrition.
Right. So the word parenteral is really the key here. It comes from the Greek para, meaning beside or outside of, and enteron, which refers to the intestine.
Got it, outside the intestine.
Exactly.
Yeah.
So parenteral means nutrition delivered outside of the gut. You are bypassing the gastrointestinal tract entirely. And, the word total is doing incredibly heavy lifting there.
Oh.
It mandates that this therapy is providing 100% of a patient's caloric and protein needs. Absolutely nothing is crossing the mouth or going into the stomach.
See, that feels like a distinction that probably gets blurred a lot in a busy hospital setting. Like if someone has an IV with some nutrients, people might just call it TPN out of habit.
Oh, that clinical slippage happens constantly. I mean, a charting system or a rushed physician might casually refer to any IV nutrition as TPN.
Even if they're eating a little bit.
Right. Even if the patient is still eating a few crackers or getting a low-calorie formula through an arm vein while receiving some tube feeding. But in strict clinical terms, TPN means it is the sole source of nutrition.
Okay, so if they are using their gut even a little bit, what's it called?
That is categorized as PPN, or parenteral nutrition. And if you are a nursing student staring down a licensing exam, you absolutely have to know this difference. The physical and chemical requirements between the two are vastly different.
I bet. And, the history of how we even figured out how to do this is fascinating. We have to go back to the mid-1960s at the University of Pennsylvania.
Yeah, with Stanley Dudrick.
Right. You had this surgical resident named Stanley Dudrick working alongside researchers like Dr. Jonathan Rhodes. And they were facing this stark, horrifying reality in their surgical wards.
It was a heartbreaking crisis in surgery at the time.
Yeah, because you had patients with massive bowel resections, severe Crohn's disease, or even infants born with catastrophic bowel defects. They were surviving their complex surgeries. Their wounds were healing.
But they were starving.
Literally starving to death in their hospital beds because their intestines could no longer absorb food.
Right. You could fix the anatomy, but you could not keep the patient fueled to recover. And, I mean, physicians had been trying to infuse nutrients into veins for centuries, which is disastrous result.
What were they trying to use back then?
Well, back in the 19th and early 20th centuries, they tried infusing sugar water, saline, and even raw emulsions of olive oil.
Wait, olive oil into a vein? That sounds like a fast track to a fatal blood clot.
It was incredibly dangerous. Historically, all of these early attempts ran into a two-sided trap.
Okay, what was the first side?
Well, if you made the nutrient solution dilute enough that the small peripheral veins in the arm could actually handle it, the mixture was mostly just water.
So you're basically just hydrating them.
Exactly. You would end up drowning the patient in excess fluid, causing fluid overload and heart failure, long before you ever gave them enough actual calories to survive.
Wow. And the other side of the trap is, what? Trying to pack all those necessary calories into a smaller amount of fluid, making it highly concentrated.
Right, but doing that makes the solution so so incredibly dense that it physically destroys those same peripheral veins within days.
Because it's too harsh for the small veins.
Yeah, it causes severe phlebitis, which is painful inflammation, and sclerosis, where the veins just collapse and harden into useless cords.
That's horrible.
So you either underfeed the patient or you destroy their blood vessels trying to feed them.
So Dudrick and his team realized they were simply looking at the wrong blood vessels. Right. The breakthrough, which they published in 1968, was recognizing that they had to bypass those small, fragile arm veins entirely.
Exactly.
Instead, they routed a catheter deep into the chest, directly into the superior vena cava.
Which is a massive vessel.
Right. Since they routed it directly into the superior vena cava, you get that massive, immediate volume of blood dumping into the right atrium of the heart to dilute the mix.
That's the secret right there.
I always think of it this way. It's like dumping a bucket of toxic concentrated dye into a tiny creek versus dumping it into the roaring rapids of the Colorado River.
Oh, that's a great way to picture it.
Right. In the creek, it coats the rocks, it destroys the banks, it ruins the ecosystem. But if you dump that same bucket into the roaring rapids of the Colorado River, the sheer volume and speed of the water dilutes it instantly before it can do any damage to the riverbanks.
That visual captures the exact physical dynamics at play. By placing the tip of the catheter right at the entrance to the heart, that incredibly harsh, concentrated nutritional solution is diluted into the massive volume of central blood the very second it leaves the plastic tube.
So it never has the chance to burn the vessel walls.
Exactly. And the way they initially proved this worked is legendary in medical history.
The beagle puppies.
The beagle puppies.
Yeah.
Between 1966 and 1968, Dodrick and his team took a group of beagle puppies and gave them zero oral intake. Nothing by mouth.
None at all.
Right, and they sustained them entirely on this concentrated intravenous formula delivered through a central catheter. And the puppies didn't just survive, they thrived.
They grew normally.
Totally normally. Normal adult size and weight, normal bone development. They looked completely identical to their litter mates who were eating regular dog food.
That is wild.
What's fascinating here is that TPN wasn't discovered by accident. It was aggressively, deliberately engineered to bypass human biology. And we cannot overlook the other half of this engineering marvel, which came out of Sweden around the exact same time.
Right, the fat emulsion.
Yes. In 1961, a researcher named Arvid Retland invented Intralipid, which was the first clinically usable intravenous fat emulsion.
Which goes back to the olive oil problem. How did he figure out how to inject fat into a vein without causing an embolism?
Well, Retland solved the biological puzzle by basically mimicking nature. He figured out how to use egg yolk phospholipids to emulsify soybean oil.
Oh, fascinating.
Yeah, this process broke the fat down into microscopic droplets that were practically identical in size to chylomicrons, which are, they're the natural fat-carrying particles our own bodies produce after a meal.
So the body just accepted them as natural.
Exactly. Because the droplets were so small and stabilized, they could travel safely through the bloodstream without clumping together and blocking blood vessels.
So Dudrick gave us the concentrated sugar and protein through the central line, and Retland gave us the dense, safe calories from fat.
A perfect combination.
And you combine those, and in 1968, Dudrick's team treated a human infant born with intestinal atresia. She was missing almost her entire small bowel.
Which is normally a fatal diagnosis.
Right. But they kept her alive and growing on TPN for months.
And that infant proved that the physiological substitution could work in humans, setting the stage for everything that followed.
So, okay, if we are dumping this powerful nutrition directly into that roaring river of a central vein, what actually goes into the bag, you obviously can't just blend up a turkey sandwich and put it in an IV.
Definitely not. You are taking everything the digestive tract would normally do, breaking down a complex meal into its microscopic chemical components, and you're having a pharmacy laboratory do it beforehand.
Right.
There are 4 highly refined building blocks in that bag. First, you have dextrose. This provides the carbohydrates and the bulk of the calories. But we are talking about concentrated sugar water, sometimes up to 70% concentration before it is diluted.
That is basically syrup.
Pretty much. Second, you have amino acids. These are the pre-broken down building blocks of protein. The body needs these instantly for tissue repair, so the patient doesn't start consuming their own muscle mass for energy.
So you don't have to digest a steak. You just get the chemical output of the steak injected directly.
Exactly. Third, you have the intravenous lipid emulsion we just discussed, providing incredibly dense calories and essential fatty acids.
And the fourth block.
Fourth, you have a highly customized, exactingly calculated cocktail of electrolytes, vitamins, and trace elements. The pharmacy measures out exact milligrams of sodium, potassium, calcium, magnesium, phosphate, zinc, and selenium.
All based on their daily labs, right?
Right, all tailored perfectly to whatever the patient's morning blood lab results showed.
Wait, I have to push back here. If everything is already broken down into its absolute purest building blocks, shouldn't that make it easier and gentler on the body? Like, why is it considered so harsh that it requires that central line? I mean, you're doing the digestive system a massive favor, aren't you?
This raises an important question about how the body actually reacts when we completely remove its natural digestive safeguards.
Okay.
See, the human gut doesn't just digest food, it regulates the entire process. It acts as a gatekeeper, slowly absorbing nutrients over hours, adding water from the body to balance things out, and buffering the chemical load.
Ah, so it paces everything.
Yes. When you bypass the gut, you are dropping an incredibly dense fluid directly into the blood all at once. We measure this chemical density in something called osmolarity.
Let's translate that for everyone.
Yeah.
Osmolarity essentially just means the sheer amount of chemical particles,
Right.
the sugars, the salts, the proteins, crowded into a single drop of water, right?
That is exactly it. A normal peripheral vein in your arm can comfortably handle fluid with an osmolarity of about 600 to 900 millimoles per liter.
Okay, 600 to 900.
Right. But a standard TPN solution runs at 1,500 to well over 2,000 millimoles per liter.
Wow, it's massively overcrowded with particles.
Okay.
That's more than double what a normal vein can handle.
Easily double. If a nurse were to accidentally connect a bag of true TPN to a standard FUV in a patient's hand, that high osmolarity fluid would chemically burn the inside of the vein.
Just destroy it.
Completely. Because there are so many particles in the IV fluid, it violently pulls water out of the surrounding cells through osmosis. The vein rapidly becomes inflamed, hardens, and gets destroyed. TPN is not just gentle IV food. It is a highly volatile, highly concentrated chemical therapy.
And because we are bypassing those natural anatomical safeguards and pumping pure concentrated fuel directly into the bloodstream, introducing TPN to a starving body actually creates a massive, potentially fatal chain reaction.
It does.
The medical term for this is refeeding syndrome, and the history behind how we discovered it is incredibly heavy.
It is one of the most sobering chapters in medical history, honestly. The origins of our clinical understanding of refeeding syndrome go back to the aftermath of World War II.
Right.
Allied physicians were liberating prisoners of war and survivors of concentration camps. These were individuals who had been subjected to horrific, prolonged starvation.
Yeah.
Naturally, the immediate medical impulse, deeply human impulse, was to feed them, to give them rich caloric food to save their lives.
But the opposite happened. They documented this terrifying pattern where severely malnourished survivors would be rapidly fed, and within days, they would die of sudden cardiac arrhythmias and acute heart failure.
Exactly.
It's just tragic. They survived the worst horrors imaginable. They were finally rescued, and the cure is what ultimately killed them. What was actually happening inside their bodies.
Well, it took years of physiological research to fully unravel the mechanism, but it comes down to a silent, hidden deficiency.
Yeah.
When a human body is starving, it survives by cannibalizing itself, consuming its own fat and muscles.
Right, to stay alive.
During this prolonged process, the body severely depletes its total stores of intracellular phosphate. The trick here is that if you drew their blood, the phosphate levels might look totally normal because the body meticulously maintains the blood levels to keep the heart beating.
So the blood looks fine.
Right, but the cells themselves are essentially empty, just running on fumes.
Their cells are entirely depleted of phosphate.
Mm-hmm.
Then the doctors give them a massive influx of food, specifically carbohydrates.
Exactly. You reintroduce carbohydrate calories, whether that is a rich meal in a 1945 recovery camp or a TPN infusion in a modern hospital.
And what does the body do?
The body immediately recognizes the sudden rush of sugar, and the pancreas secretes a massive surge of insulin to process it. Now, insulin is a transport hormone. It grabs that glucose and shoves it into the starving cells.
Okay, that sounds normal so far.
But it also grabs electrolytes. It forcefully drives phosphate, potassium, and magnesium out of the bloodstream and into the cells all at once.
Here's where it gets really interesting, because I think about it like, it's exactly like turning on a massive city power grid after a week-long blackout.
That's a good analogy.
Right. If you try to flip every single switch in the city back on at the exact same second, you don't get light, You blow out the transformers, you overwhelm the lines, and the whole system crashes harder than before.
That's exactly what happens. Because the starving cells are so empty, they act like a dry sponge. The insulin opens the cellular doors, and all the available phosphate in the blood violently rushes into the cells, leaving the bloodstream completely devoid of it.
So the blood levels plummet.
Serum phosphate levels crash to critically low levels. And because phosphate is biologically required to make ATP, which is the basic cellular energy currency that allows the heart muscle to contract the heart, simply runs out of energy and stops beating.
Wow. So this tragic 1940s medical observation of war survivors is the direct reason why modern hospital protocols for feeding malnourished patients are so strict today.
It is a direct, traceable line. Today, in 2026, if a nurse or a doctor is starting TPN on a severely malnourished patient, the protocol demands a painstakingly slow, staged caloric ramp-up.
You don't just give them a full bag on day one.
Absolutely not. You deliberately give them far fewer calories than they actually need for the first few days. You start low, you go incredibly slow, and you check their blood for phosphate, potassium, and magnesium every few hours, replacing those electrolytes before you increase the food.
So the misconception that more calories, faster, is better for a starving patient is completely backward.
It is lethal. You have to wake the metabolism up gently.
So we have this miracle cure that brings starving people back from the brink, but we know it's dangerous if done too fast. But eventually, the medical community realized it was also incredibly dangerous if used too often. Let's talk about the 1970s and 80s, when TPN became widely available in hospitals. It essentially became a reflex, right?
It did. Doctors were completely enamored by the ability to feed patients intravenously. It felt like solving a massive variable in patient care. So it was ordered for almost any hospitalized patient who simply wasn't eating well.
Just as a default.
Yeah, if a patient hadn't finished their dinner tray in 3 days, instead of trying a simple feeding tube down their nose or just giving them high-calorie shakes, doctors would hook them up to TPN.
And this overuse drove up massive complication rates. Hospitals saw huge spikes in catheter-related bloodstream infections.
Makes sense.
Yeah, because a central line coated in pure sugar water is a perfect breeding ground for bacteria. But they also saw alarming spikes in TPN-associated liver disease known as cholestasis. Why does bypassing the gut suddenly damage the liver?
Well, it comes down to cellular signaling. The liver's job in digestion is to produce bile, which helps break down fats. Normally, when food enters the gut releases hormones that signal the gallbladder and liver to release that bile into the intestines.
Okay, a natural feedback loop.
Right. But when you use TPN, the gut is completely empty. Those chemical signals are never sent. So the liver continues to produce bile, but it just sits there. It backs up, sludges inside the liver ducts, and over time, that stagnant bile causes severe inflammation and liver damage.
And on top of the liver damage, the gut itself begins to physically break down.
Yeah.
So if we bypass the gut, does it essentially forget how to work? Is it literally a case of use it or lose it for our own intestines?
It quite literally is. The intestinal lining, the mucosa, it requires the physical mechanical action of food passing over it to stay thick and healthy.
Oh, wow.
Yeah, it also relies on the massive population of protective gut bacteria, the microbiome, which, needs food to survive. If you bypass the gut for even a few days, that intestinal mucosa begins to physically atrophy. It thins out, and the protective bacteria die off.
And when that barrier thins out, things can cross over, right?
Exactly. Yeah. A weakened, atrophied gut barrier becomes porous. It allows the bacteria that naturally live inside your intestines to cross over the lining and enter your bloodstream.
That's terrifying.
It is. Ironically, by trying to feed the patient safely through a sterile IV bag, doctors were actually increasing the patient's risk of a massive life-threatening systemic infection because the gut barrier physically broke down from disuse.
And this realization sparked massive debates in critical care, pitting enteral feeding through the gut with a tube against parenteral feeding.
Huge debates.
Yeah. Large ICU trials, led by prominent researchers like Jean Charles Prizer, looked at the data, and they repeatedly found that early TPN in critically ill patients who could have tolerated at least some tube feeding actually caused worse outcomes.
Much worse.
More infections, longer stays in the ICU, higher mortality.
And those trials fundamentally changed modern medicine. They proved that delaying TPN and pushing enteral feeding was much safer. It gave birth to the modern medical mantra, if the gut works, use it.
I love that. If the gut works, use it.
Exactly. Enteral and parenteral are not interchangeable options. A feeding tube is always preferred. TPN is the absolute last resort.
Now, there was also a quieter debate alongside this regarding glycemic control, right? Like how tightly they should manage the patient's blood sugar,
Yeah, early on, doctors believed they needed to use intensive insulin drips to keep a TPN patient's blood sugar perfectly normal, tightly controlled at all times.
which sounds logical.
It does, but subsequent landmark ICU trials eventually showed that aggressively trying to force near-normal glucose levels caused dangerous, unpredictable bouts of hypoglycemia or severely low blood sugar, which damages the brain.
Oh, so they were overcorrecting.
Exactly. Modern practice shifted to targeting a moderate, slightly elevated glucose level rather than aggressive normalization.
So, since TPN is reserved strictly as a last resort, the nurses managing it at the bedside are executing an incredibly precarious high-wire balancing act. For nursing students, TPN is a massive high-yield topic on licensing exams. And looking at everything we've just discussed, it's obvious why. It braids together so many critical skills.
Bedside nurses have to maintain absolute sterile technique when handling the central line to prevent those catastrophic bloodstream infections we talked about. They have to understand complex pharmacology, fluid dynamics, and monitor the delicate electrolyte balances with refeeding syndrome.
But perhaps the most critical nursing rule of all when it comes to bedside reality is the rule of discontinuation. You never, ever abruptly stop a TPN infusion.
Never.
Like you can't just turn the pump off when the bag is empty or if the patient needs to go for a quick scan down the hall.
Right. Standard practice requires that a TPN infusion must be tapered down slowly, usually over 1 to 2 hours before it is fully disconnected.
And why is that?
The reason goes back to the pancreas. TPN is a continuous, highly concentrated glucose load. The patient's pancreas has adapted to this heavy, nonstop stream of sugar by producing a high, steady volume of insulin to process it.
So if you abruptly shut off the sugar supply, the pancreas doesn't just instantly stop making insulin. It has momentum.
It takes time for the endocrine system to adjust. If the TPN is suddenly stopped, you suddenly have all this excess insulin swimming around in the blood, but no sugar coming in to meet it.
Which means the blood sugar crashes.
Right. The extra insulin aggressively drops the patient's blood sugar, causing severe, rapid rebound hypoglycemia. The patient can become confused, start sweating profusely, lose consciousness, or even have seizures.
Wow.
So tapering the rate down slowly gives the pancreas time to realize the sugar load is decreasing and safely reduce its insulin output.
So what does this all mean? It means the sheer responsibility placed on the bedside nurse is staggering. They aren't just changing a food bag. They are manually operating the patient's endocrine and digestive systems through a plastic tube.
That's a great way to frame it.
They're balancing the pancreas, the liver, the heart, and the immune system all at once, constantly reading the biological feedback.
If we connect this to the bigger picture, this precise bedside care, the slow tapers, the rigorous sterile line changes, the relentless electrolyte checks for refeeding syndrome, it is the direct legacy of decades of trial, error, famous historical failures, and incredible optimization.
To bring our journey full circle, we started with Stanley Dudrick and Jonathan Rhodes in the 1960s, proving with beagle puppies and a newborn infant that we could bypass the gut entirely and sustain life by dumping nutrition into the roaring river of a central vein.
Right.
We explored the intense chemical engineering of emulsified lipids and hypertonic dextrose and uncovered the deadly paradox of refeeding syndrome discovered after World War II.
Which is such a vital lesson.
We cover the hard-learned biological lesson that the gut will literally waste away if you don't use it, making TPN a strictly guarded last resort. And we finished at the bedside, where nurses meticulously taper these infusions to prevent the pancreas from crashing the patient's blood sugar.
It is a phenomenal chain of medical evolution. Today, TPN sustains premature infants whose intestines haven't fully matured. It keeps cancer fighters nourished when radiation severely damages their bowels. It is a vital lifeline for Crohn's disease patients resting their gut during severe flares.
And for some people, those with conditions like short bowel syndrome, it is a permanent reality. They live with this therapy at home, administering it every single night while they sleep, just to survive.
And, based on the fact that some patients with short bowel syndrome rely on home TPN for decades, it introduces a really profound psychological angle to consider.
What do you mean?
Imagine what happens to the human psyche when you remove the physical act of eating from survival entirely.
Oh, wow.
Yeah. For a patient living on lifelong home TPN, they never feel true physiological hunger. They never feel physically full or satiated from a meal. They lose the communal, deeply human aspect of breaking bread with family and friends.
I hadn't even thought of that.
We have brilliantly solved the biological math of starvation, but what does it mean to live a long, full life where food is just a clear liquid humming through a mechanical pump in your backpack?
That is a heavy, fascinating thought to leave on. We take the simple baseline of taking a bite of food so completely for granted, but for some, survival looks entirely different, requiring a miraculous feat of daily engineering. Thank you for joining us on this deep dive. Keep asking questions, keep looking beneath the surface, and we will catch you on the next one.
If you hear the word pneumonia, you probably picture a bad cough, right? Like a week of antibiotics, maybe a few days stuck in bed.
Yeah, people tend to think of it as just this one straightforward illness.
Exactly. A simple illness with a highly predictable fix. But if you think that, you would be entirely wrong.
Completely wrong, yeah.
Because what we're looking at today is a condition that is actually this complex, constantly shifting target. It's basically a microscopic crime scene that has, baffled and driven medical science for literally centuries.
I like to call the ultimate medical chameleon. I mean, the way we define it, the way we classify it, and even the way we treat it at the bedside, it is still fiercely debated today.
It really is. So today we are taking this massive stack of sources. We've got nursing texts, historical accounts, medical journals, and our mission for this deep dive is to travel deep down into the microscopic air sacs of the lungs.
Right down to the cellular level.
Yep.
We're going to figure out the actual mechanics of pneumonia, why bedside assessments happen the way they do, and the critical nursing care that goes into fighting it. Joining me to help make sense of all this is our resident expert. And our goal today for you, the listener, is to get past rote memorization. We want to understand the actual why behind what a nurse sees at the bedside.
Right. The intention is to move way beyond just checking boxes on an assessment form. Because if you understand the underlying the actual physics and biology of what is happening inside those lungs, every single symptom makes sense.
Yeah.
Every crackle you hear through a stethoscope suddenly just has a perfectly logical explanation.
Okay, let's unpack this, because before we can talk about treating pneumonia, we have to understand the anatomy of where this is all going down, right?
Doing.
We are talking about an infection of the lung parenchyma, specifically the alveoli.